Jai and Mahir Taneja. Yeah, please come forward. And the fourth and the last qualifying team is RIMS Ranchi. Dr. Sana Naz and Dr. Surbhi Baghel. Correct? Okay. So, thank you. So all these four teams, okay, listen to me. All the four teams, there will be the lottery system for allotment of team A, B, C, and D. So you have to just pick up that lottery, and then you will be sitting on the dais as per team A, B, C, and D. Okay.
Hello. Hello.
I believe the lottery system has been done by the assistant quiz master. So team A will be PMCH Patna. Am I right? Is it team A? Okay, team A PMCH Patna. Can you
Yes.
please introduce yourself?
Sir, I am Dr. Divya Singh. I am from PMCH Patna.
Okay,
I am Dr. Neha Nidhi from PMCH Patna.
fantastic. Okay. Second team is from ANMMCH Gaya. B, team B.
Sir, I'm Dr. Mahir from ANMCH Gaya.
Okay,
I'm Dr. Sumit Shaw. I'm from NMCH Gaya.
excellent. Team C is from RIMC Ranchi.
I am Dr. Sana Nas from RIMS Ranchi.
I am Dr. Surbhi Baghel from RIMS Ranchi.
Excellent. Team D is from Kishanganj MGM.
Uh, Good morning. I'm Dr. Sarabjit Singh from MGMMC Kishanganj.
Are you comfortable in seeing the screen? No, there is a screen in front of you.
थोड़ा फ्लैश आ रहा है यहाँ पे.
Okay. Is there anything coming? हाँ, just let me know. ठीक है. Now is it fine?
Yes, okay.
Because there are some IHC image and there are some histopath image also. So it should not happen that I am not able to see and all that. Are you comfortable now? ऊपर वाला light. You can come forward if you want. You can adjust it. No, because this was the practical problem I had faced when I was a finalist in IGQNP Dermacon. So we were not able to see some histopath images. I don't want the same thing to happen with you. नहीं अभी भी अगर कंफर्टेबल नहीं हो तो यू कैन जस्ट पाइप अप. अभी ठीक है. टीम ए बी सी डी कंफर्टेबल. Okay, so let's go to the rule position. Okay. So I will just introduce myself. I am Dr. Gopal Rajput. As you can see, I have been at your stage at multiple times point of times. So CUTICON के time पे we are the winner. We are runner up with the 2019 Dermacon, then dermoscopy quiz and everything. So whatever I had faced the difficulties as a participant, I had tried to nullify or neutralize the same. Okay. That's why this lottery system has been introduced, so that there should be no question of biasness. My question sets are already prepared. Second thing is I had tried to rotate the round. Okay. and try to plug the loophole as much as possible. Okay. Now this quiz is not to what we can say test your knowledge. It is just to give you the little bit of reality check as a residents. Okay, and just enjoy the journey. Okay, you are already on the podium, so consider yourself as a winner itself. Okay, so don't worry about the results. Just अभी हम श्री जगन्नाथ पुरी में हैं, तो कृष्णा का कहना है कि live in the present moment, don't think about the future. Okay. So let's go on the rule position first. Okay.
Sure.
So the guidelines. The first round will be from the basic science. Second round is for the clinical dermatology. Third is pediatric. Fourth is cosmetology. Fifth round is for clinical dermatology again. Sixth is dermatopathology. Seventh is leprosy tropical disease and STD and include HIV. Okay. Fifth round is dermoscopy. Sorry, not clinical pathology. So now have a look at this. Each correct answer will carry 10 marks. Okay. 1 minute will be given for that team. Moment that 1 minute has been passed, it will automatically jump to the next team. Okay, and the next team, the past question will get 5 marks. अगर A ने आंसर नहीं किया, B ने कर दिया तो 5, B ने भी नहीं किया, C ने किया तो 5, इस तरह से. Okay. Sorry, it's a 10 second, not 1 minute. Now, if you answer a wrong question, there will be no negative marking, but be careful because if you answer one wrong question, so the next, अगर वो गलत हो जाता है तो next team को पता चल जाएगा कि ये गलत आंसर था, मुझे ये नहीं करना है. So the point will be awarded to the next team if you do the job of negating everything. So be careful while you are answering. I am not saying that don't answer at all, please attempt it. And the questions are such that if you had seen the patient in your OPD, you will be come to a nearby answer. Okay. Even if you don't give me the very dot answer, that's fine. Okay. Even if you comes the nearby, I will grant the marks. Okay, that is clear in your mind. So जब आपस में डिस्कस करोगे तो बिकॉज द डिस्टेंस बिटवीन टू टीम्स इज वेरी क्लोज वन, अगर उसने सुन लिया और उसने आंसर कर दिया तो आई एम नॉट रिस्पॉन्सिबल फॉर दैट. बी केयरफुल इन दैट ऑल्सो. दैट हैज हैपेंड विथ मी फॉर वन क्वेश्चन इन द बैंगलोर. नाउ राउंड 1 विल स्टार्ट फ्रॉम टीम ए, राउंड 2 विल स्टार्ट फ्रॉम टीम बी, round 3 will start from team C and round 4 from the team D, and then it will reverse. Round 6 from D, 7 is from C and so forth. And the passing of the question will be also in the same fashion. Okay, so from 1 to 4 it is clockwise, from 6 to 8 it is anti-clockwise. Okay, understood? किसी के दिमाग में doubt है? Sure? And then comes the final rapid fire questions. Each team will get 1 minute. There are 10 questions. Question doesn't pass. आप मतलब पास मतलब नेक्स्ट टीम को पास नहीं होंगे, लेकिन you have to say please pass. If you are not having answer to that rapid fire question, you have to say pass. Then only I will flash the next question. Okay. So be careful in this round. Each correct answer will carry 3 marks for that. ठीक है, and no negative marking for rapid fire also. Okay. So whatever the dispute is there, you know the quiz master decision is final. ठीक है, हम करें सो कायदा, ऐसा ही है. अगर टाई ब्रेक हो जाता है तो आई गॉट अ सेपरेट सेट ऑफ क्वेश्चन. ठीक है. सो टीम्स ए बी सी डी यू हैड गिन आउट एवरीथिंग. ठीक है. सो लेट्स स्टार्ट. 10 सेकंड्स का टाइमर लगाएंगे प्लीज. यू आर देयर? ठीक है. ओके ओके फाइन फाइन. सो या फाइन. शुड वी स्टार्ट? अरे यस और नो? यस सर. जोर से यार. यस. ओके चलो लेट्स स्टार्ट. ओके. सो फर्स्ट राउंड, let's take the name of Sri Jagannath Maharaj. First round is the basic science. Okay, I will just flash the cue and then I will tell you. ठीक है. So team A has got, you have to identify the compound based on these figures wherein it has been a catalyst in conversion of tyrosine to dopa, dopa to dopaquinone, and the one melasma, anti-melasma treatment which is derived from Aspergillus oryzae has a mechanism of action embedded in this. So you have to identify this catalyst compound. So there are 3 figures. Your time starts now. For team A.
Sir, hydroquinone?
No. Team B?
Kojic acid?
No. Team C. I am asking about the compound. Okay. Kojic acid? No. Team C?
Azelaic acid.
No, I am asking about the compound. I am not asking about the chemical name. Compound that is catalyzing this L-tyrosine to dopa, dopa to dopaquinone. Okay, next. Have a look at all these two also. Team D?
Pass.
No? Answer is copper. As so, my point is you just listen to the question carefully. Okay? You are almost near to that, but it is a past question. Had it been your first question, I would have given the marks, but it's a past question. Okay? So, it's a copper because Aspergillus oryzae, the kojic acid is derived from that. It chelates the copper iron. You see the clue in these two figures. Okay, the Wilson disease, if you see the fourth one, ceruloplasmin is written there over there, or ceruloplasmin also written over there. So, that was the clue for the diagnosis, for the answer of this question. So, again I am reiterating, have a look at that slide carefully. Don't jump to the conclusion. Don't worry about the 10 seconds. I will give you much more time also. Okay? Okay, it's not that we are in much of rush. Matlab, zyada. So, next question to team B. Now, these are the three figures which has been given over here. One is the acne, second is the BCC, and third is one of the larva. Okay. So, there are three biologists and physicists who has got Nobel Prize for discovery of a particular structure, or we can say receptors in the body. Now, one of the FDA approved medication for this BCC, FDA approved medication of this BCC has its mechanism of action into that invented structure or receptors. Okay, and the same thing has responsible for dorsoventral development of some fly whose larva has been displayed over here. So, what is that structure or receptor that I am talking about? You can take wild guess, no problem. There is no negative marking.
So we have to tell the name of receptor.
Yeah. Your time is running out. No? Team C?
Sir, interleukin 31 receptor.
No. No. Team D? No? Not now. Once you pass. Team A? No? अच्छा वाइल्ड गेस ले लो, मार्क्स नहीं दूंगा, बताओ.
Imiquimod receptor.
You are right. You are absolutely right. Your TLR. Imiquimod acts on TLR. So that larva was of Drosophila melanogaster. I told you dorsoventral development. It comes in only one or two places. Okay. So it was a larva of Drosophila melanogaster, for which TLR has been implicated. Second thing is acne. TLR 2 and 4 has been implicated in acne. There are three biologists and physicists who has got the Nobel Prize for the same in 1992. It was first described by the German physicist, the lady which is on top, and she had just exclaimed that das war jo doll. Okay. So take a guess. That's what I am telling you. So the questions are very simple. Don't get bogged down. Okay. Don't get bogged down. You will get each and everything on the slide itself.
Sir, by merely speaking Imiquimod receptor, would I have given a marks?
Yeah. That's what I am telling you. No? I am being a generous enough. If you are the first team, if you have taken a guess something, I will give the marks. But second team has to be precise. Okay? Understood now? Are we friends? Chalo, team C. So now this is the pathway wherein there are two things that I had given. Look at the pathway very carefully, how it is connecting itself, and the antagonist of this pathway was invented in 2012, which is used and FDA approved in skin cancer. Chalo, I will just make it more simpler. It is used in basal cell carcinoma. So what is that, the thing which has I mask? What is the name of this pathway? टीम सी के लिए है ये. So focus on two things: skin cancer, 2012 FDA approved in BCC. So what is this pathway? Even if you tell me the name of the drug, I will give the mark. Team C, your time is running out. Take a wild guess. No? Yeah, so I think you are not. Are you going to answer? नहीं? अरे कोई नहीं हंसेगा. ठीक है, we are on the same boat.
Sir, Jack start pathway.
No, it is not Jackstat. Come on. Team D. No, that's okay, fine.
So fluoxetine.
No, Team A.
Sir, sonic hedgehog pathway?
Huh?
Sonic hedgehog pathway?
Absolutely correct. Very good, fantastic. Please have a round of applause for them. Good. It's sonic hedgehog pathway. The antagonist is vismodegib, which has been approved for the BCC in 2012. Excellent. Okay. Now for Team D. Okay, it's a relatively simple question. Have a look at this. So it is a chromosome, which has the translation product of this is 4061 amino acid. Okay. When you degrade the product, finally you get 25% of the serine, 15% glycine, 10% arginine, 12% histidine. Now you identify this chromosome. It is chromosome 1, 2, 3, 5, 10. Even if you give me the name of that particular product that is coming out of the translation of this chromosome, I will give the mark. For Team D. It's very simple. The round का नाम है basic science. The clues are there. In the, I want them to win, yeah. Team D? हाँ? अरे बोलो.
Chromosome 9.
Chromosome 9. ना. Yeah. Team A?
So chromosome 1.
Yeah. Absolutely correct. It's chromosome 1. It's filaggrin, clofilaggrin or epidermal differentiation complex chromosome which is situated in 1, and this one is simple ना. आपका filaggrin जब breakdown होता है तो you get all this glycine, serine, arginine, histidine. ठीक है, simple. So that's why I told you basic science. Take a wild guess, no problem. So Team A has given, I believe, 2 passes. Very good. So now this is audience question. ज़्यादा है नहीं, but whatever are there, can we have this? What is the half life of circulating eosinophils? Sir? Yeah, the AIMS Patna. Okay, it's 6 to 18 hours. The half-life of eosinophil is 6 to 18 hours. That's why we say, moment you take the steroid, the first thing to vanish from the bloodstream or from the site of action is the eosinophil. Okay, round 2 is clinical dermatology. It will start from Team B. Okay, again, I am telling you, take a wild guess. Hear me properly, have a look at the screen. It's the name is clinical dermatology. So whatever you are seen in your clinics, whatever you are read, will be given will give you the clue. You are not comfortable seeing the screen. कुछ flash हो रहा है क्या वहाँ पे? You are seeing? हाँ?
So it is not, the images are not clear, sir.
Images are not clear.
Much more clear in this.
अच्छा ऐसा है? तो you can just see toward this time. ठीक है ना? आप arrange कर लो. ठीक है. आप पीछे ले लीजिए, आप पीछे ले. You can have a back at the audience, no problem. ठीक है ना, कोई बात. Barua sir, I had lost my 20 marks because of this in Dermacon 2019. ठीक है, because I was not able to see the pictures. And I ended up the first runner-up, and we lost by the margin of 10 marks. That's fine? Okay, now, so Team B, okay. So this is the gentleman who was 55-year-old, running helter-skelter with some swelling which was recurrent in a lip as well as in the maxillary space. Okay, so that was the MRI image where there is a effacement of the muscles, fat and everything on the right side, and this is the fat. This is the buccal fat pad biopsy that we had taken, and we have sent it for histopath, which shows the rimming pattern with multiple lymphocytes. Now the clue to this is the survival rate of this condition. 2-year survival rate is 80%, 5-year survival rate is 60%. There are two variants of this. The second variant has the 2-year survival rate less than 20%. So identify the condition. It is for team B. The name of the round is clinical dermatology. So correlate this histopath with MRI and whatever the history I told you along with this picture. Team B, any guess?
Glomus tumor.
No, glomus tumor occurring. No problem. Okay, team C.
So we will pass.
Pass. Team D. Bolo. No. Team D. No.
So mucormycosis?
Huh?
Mucormycosis?
No. It's a survival rate. Na? We are talking something about the cancer. Team A.
Sir, Rosenthal Wilkinson syndrome?
Huh?
Rosenthal Wilkinson syndrome?
No. Rosenthal Wilkinson syndrome doesn't. This is the subcutaneous SPTCL. Subcutaneous panniculitis like T-cell lymphoma. Okay. So there was a clue of buccal fat pad. So it is something related with the panniculus. Survival rate. So which are the dreaded cancers in the skin that you can diagnose is there are very few. Gamma delta variant that I was talking about has a very poor prognosis. Alpha beta variant has an excellent prognosis. Okay? So have a look at those clues. Okay? As I told you, even if you are nearby this one, I will give the marks. Okay? But now what I am emphasizing this one is on this gentleman was running helter-skelter for 5 years. Nobody has diagnosed him. Okay? And he once landed up in ICU also, wherein he was put on ventilator also by some godforsaken clinician कि नहीं ये तो कुछ अलग ही लग रहा है, ठीक है. But moment we added a steroid 60 milligram, he started responding, ठीक है. And then we landed up in chemotherapy and he is very good now, ठीक है. So that's how the dermatologist can make a difference, ठीक है. So this is the team C. For the team C, this is the girl, 22-year-old girl. She has got a band-like or what we can say a dermatomal-like lesion on her thigh, an outer aspect. There are two images. One is dermoscopy, wherein there is some little bit crust and clot formation, and there is a histopath image, wherein there is a collection, or what we can say is a blood collection or blood channels, but in the deep dermis, not superficially. So identify this condition. It is absolutely benign condition. Okay, this was present in her body since the birth, but she attained the puberty, and then she started developing the complications like increase in the size and everything. So for team C, please. It is not an infection. Okay. It was present since birth. Puberty has given a growth stimulus. No, team C. अरे हिस्टोपैथ देखो ना, कुछ तो बोलो. No? Yes, please tell me. Absolutely right. It's angiokeratoma. Yes, it is. Very good. So it's angiokeratoma neviformis. Very good. Okay. So it is the condition which presents since birth. Puberty, the hormonal spurts give you epidermal changes, and there are other types like maybe fordyces, corpus diffusum, and everything. But it's the angiokeratoma neviformis. Good, excellent. So please don't. मतलब डर के क्यों आंसर दे रहे हो? I told you ना. मतलब हम सब एक ही बोट में हैं. किसी को कुछ पता नहीं होता है. ठीक है. Just have a confident. Question number 3. Okay, it is for team D. Now again, this gentleman has came to my OPD with he applied a hair dye and he started developing a lot of things in his hair, and he used to develop this with the hair dye. But this time the episode was so severe that it got diffuse plaque all across the scalp, which was not responding to the steroid, not responding to anything. We had taken a biopsy also, and day by day his condition was deteriorating. Okay, he developed the fever, he developed headache, he was not responding to steroid. So the diagnosis of pigmented cosmetic dermatitis or contact dermatitis was discarded. So what we decided, to take a biopsy, and this is the biopsy result. Okay, there are multiple vascular channels on the biopsy. We had done the IHC marking wherein Ki67 was diffusely positive, but simultaneously it was having CD31 and 34 positivity also. So what is the name of this condition? Team D. Again, this is the classic case. Had it been diagnosed much more earlier, the person would have survived. This person has succumbed. He died. Team D. Multiple vascular channels, CD31, 34 positivity. Have a look at the clinical, that is erythematous lesion on the scalp in the elderly individual, 60s में. Team D, no? Take a guess. Should we pass? Team D.
Pass.
Team A.
Sir, Langerhans cell histiocytosis?
No. The age. Team B.
Dermatofibrosarcoma protuberans.
No. Team C. Chalo, at least you attempted all people. Good. Team C. नहीं? हाँ? Lymphoma नहीं है unfortunately. CD31, 34 ISC उसमें नहीं आता है. ठीक है? There is anastomotic vascular channel. So let's go to the answer. It's angiosarcoma. ठीक है? The sarcomas always have a very low 5-year survival rate, and angio component comes with CD31, 34. There are multiple vascular channels were there. ठीक है? So this is all. So we tried to do, we had given a diagnosis to the onco people. They had tried to do all this surgery plus chemo plus radiotherapy, but subsequently patient has succumbed within the span of 8 months. Now the problem is he was running with this kind of symptom for last 2 years. Okay, team, question number 4 for team A. So there are clues wherein there is a dermoscope kept there. There are some picture flash on the right hand column, and this condition is treated by the physics law that I had displayed on the right lower corner. So identify the condition. It's simple question. Team A. Team A, please. Team A, take a guess. No? Okay. Team B.
Mycosis fungoides.
Excellent. Good. Can you please tell me what are the clues?
On dermoscopy.
Ah, dermoscopy. Okay. Spermatozoa like this one. Good. But what about this picture?
We couldn't guess those.
Huh?
We
Yeah,
couldn't
guess.
guess those.
Huh?
We couldn't guess those.
You can guess those. This is the electron beam therapy principle. ठीक है? Okay. So it's a mycosis fungoides. The spermatozoa-like blood vessels are seen on dermoscopy, and electron beam therapy is a treatment of choice for mycosis fungoides. I am sure team C, team D को भी आता होगा ये, नहीं? ऐसा हमेशा लगता है. Audience questions? Okay, sorry again. So this gentleman is John James Pringle, and one eponymously associated condition, skin disorder, is related with him. Can somebody tell me? नहीं, कोई नहीं. Pringles. Okay. This is adenoma sebaceum of Pringle. Okay, that is what has been given the name of that gentleman there. Okay, he recorded a case of adenoma sebaceum. That's why his name is attached with this. For Pringles के साथ में एक बहुत ही महंगा वाला chips भी आता है. Okay, so round 3 pediatric dermatology. Start from team C. Okay, this is again my patient. This was the infant, basically 2-3 months old individual, 2-3 months old boy, repeatedly brought to the OPD by the mother by the complaint कि ये जब भी दूध पीता है there is some starts oozing from that place. So he has got multiple papule and plaque which is present on the back, on the hand, also on the thigh. So the mother used to say कि whenever he have feed, the size increases and oozing occurs. Also oozing occurs intermittently. So what is this condition? Even if you don't name me the condition, even if you tell me कि what exactly it is, sir, यहाँ पे ये हो सकता है, I will give the marks. Yeah, third. Now we will try. We will pace it. Team C, take a guess. Don't be afraid. No? Pass. Team D? Take a guess, please. They're simple. This is very simple. Just apply the logic. No? Pass?
Sir, EBS?
No. Team A? No? Team B? No? No. Simple, yeah. It's a hematoma. ठीक है ना? It's a aberrant salivary gland. It's a name as a choristoma, wherein there is the salivary gland traverse here and there, and whenever they feed, as such, feeding is a mechanism for the saliva to come out. That's why this name is there. ठीक है? Okay, so it's a hematoma called as a choristoma. As I told you, take a wild guess, यार. Feeding में बढ़ रहा है. Even if you give me some hint about that, I will give the marks. Okay. So this is for question 2. Very simple, very stacked. Team D, identify the condition. I want the name of this condition. Okay. And I want the exact name because this is very common condition. ये सारे book में है, सब कुछ है. So there is a boy with some dental missing. There are some nail changes. There is some palmar changes, and there are some tufting of the phalanx is happening. So, Team D, it's a direct question to you. Yeah, Team D, please. नहीं? हाँ बोलो. This picture I had taken from the textbook. So अगर तुमने textbook flip भी किया होगा तो तुम्हें आ जाना चाहिए.
Netherton syndrome?
Netherton नहीं. Okay. Team A.
Sir, child syndrome?
Child नहीं. Team B.
Pachyonychia congenita?
नहीं. नहीं. Team C. You were also thinking pachyonychia congenita? Nah. It's a Clauston syndrome. Hydrotic ectodermal dysplasia. Clauston syndrome. Come on. Pachyonychia congenita teeth problem नहीं होते हैं, hair problem नहीं होते हैं, नहीं? Tufting happens, hyperhidrosis with palmar plantar. चलो anyways, no problem. At least you started answering. That's good thing. Okay. So round 3 हो गया. Round 3 चल रहा है. हाँ. Team A. Question number 3. Okay. So these are the clues for you. Identify the condition wherein there is some missing teeth. Okay. There are two answers to this. Particular question. Okay. Even if you answer one of them, I will give the marks. Okay. There is some condition called blueberry rubber lip syndrome, sort of blueberry syndrome. वो भी है. उसके बाद में there is some humerus changes are there, and there is something which is like something which is happening on the right side. ठीक है, that is the stain that we had given. So answer me, what is the condition?
Sir, congenital rubella syndrome?
हाँ?
Congenital rubella syndrome?
नहीं, congenital rubella I will not give you. ठीक है, no, that is not. Okay, there are multiple plethora of causes for the blue baby syndrome, but there are few clues that are specific. ठीक है ना? There are two things that you have to focus it on. One is the जो bluish color का जो है ना वो नीचे, and humerus में. ठीक है? Okay, team B.
Papillon Lefevre syndrome?
हाँ?
Papillon Lefevre syndrome?
No. Team C. Team C? ना ना. Team D?
H syndrome.
हाँ?
H syndrome.
नहीं नहीं, H syndrome नहीं है, ठीक है. It's a histiocytosis. Histiocytosis gives are featured in the blue blubber syndrome. Second thing is there is a missing tooth, ठीक है. Third thing, histiocytosis occurs in sebaceous areas. Sebaceous areas has multiple Malassezia furfura. That is that. Okay. Second answer was also syphilis. Even if you have given the syphilis answer, I would have given to you. ठीक है. Okay. So this is the one, floating tooth, purpura or blueberry, sorry, not rubber, blueberry muffin syndrome, osteolytic femoral region, and Malassezia furfura in seborrheic areas. ठीक है. Okay. For round 3, question number 4, team B, name the condition. I want exact name. I want exact name. This is very common condition. I will not give you marks if I don't get the exact name. Team B.
Pyloric atresia.
हाँ?
Pyloric atresia.
नहीं, I want the name of condition. Pyloric atresia तो हमें दिख रहा है वहाँ पे शायद से, पर pyloric atresia है नहीं है वैसे, ठीक है ना. कुछ तो इंटेस्टाइन में है. I want a condition name, जैसे क्लाउस्टन सिंड्रोम था ना, उसी तरह से इसका नेम का कंडीशन का नाम चाहिए मेरे को.
Giant megacolon.
अरे यार सुनो, क्वेश्चन तुम आराम से सुनो. देखो इसमें एक लड़की है जिसके कुछ फीचर्स दिखाई दिए हैं, है ना. उसी लड़की का और एक फीचर दिखाई दिया है, उसी लड़की का एक्सरे लिया हुआ है या बेरियम. तो ये 3 जो है या 3-4 जो आपको दिख रहे हैं वो किस कंडीशन में दिखते हैं. नाउ गॉट द क्वेश्चन. ओके. नो, चलो योर टाइम इज अप. टीम बी. टीम सी. टीम सी प्लीज. नो. टीम डी. टीम ए.
What
टीम ए. हाँ.
EB pyloric atresia.
नहीं. टीम.
Wardenburg syndrome.
नो, आई विल नॉट गिव इट टू यू. ठीक है. आई वॉन्ट एग्जैक्ट नेम. इट्स शाह वार्डनबर्ग सिंड्रोम टाइप 4. ठीक है. इट्स टाइप 4 वेर इन the congenital megacolon is seen and there is a loss of hearing occurs. ठीक है. In Waardenburg syndrome in type 1, that is classical, the intestinal features are not there. ठीक है. Okay, you were close, but because I initially only I told I want exact name, that's why. ठीक है. Okay, so audience question, can you identify the condition? Simple है. Sir, please. Huh? Yes, sir, absolutely. You are right. Please have a big hand for this gentleman. It's a Sturge-Weber syndrome. Yes. Okay. It's reported first by Dr. Sherman. And there are 2 gentlemen, that is Parkes-Weber and William Sturge, who had described this. The Parkes-Weber was a radiologist who has given the radiological feature, and William Sturge was a surgeon, I believe. He had described it in 1879. Okay. But very first it was reported by the Sherman in 1860. Okay. So round 4, leprosy and tropical dermatology. We will just थोड़ा सा हमें pedal push करना पड़ेगा because our time is running out. Okay. Leprosy and tropical dermatology, very stat question, इसमें ज़्यादा कोई दिमाग लगाने की जरूरत है नहीं. Team D से start करेंगे. Okay. The question is, name the protein molecule which is responsible for attachment of Mycobacterium lepribacilli through PGL1 to plasma membrane of skin cell. I want the protein molecule name or the receptor name. अगर तुम आसपास भी हो तो मैं आंसर will give it to the marks. सो बेसिकली लेप्रेसी बैसिलाई जो है वो किसको अटैच करता है हमारे स्केल्स में या फिर न्यूरॉन्स में, उसका नाम बताया आपने. बेसिक है, बहुत बेसिक है, हम पहले ही पढ़ते हैं इसको. चलो डी, टाइम अप बिकॉज दिस इज वेरी स्टैट क्वेश्चन. टीम ए. डजंट लुक लाइक. टीम बी. तुमने हरियाली डाल दिया तुम लोगों ने. टीम सी. बेसिक. नो. It attaches to laminin alpha 2 of extracellular basal lamina. This is the protein. It is the GPCR type. G domain of laminin alpha 2 chain of extracellular basal lamina. It is exactly the first point of contact between the leprosy bacilli with the neurons or the cells. इसके बाद ही वो internalize होना शुरू होता है. This is the starting point. Okay. Team 2. Question number 2 for team A. This is FDA approved. It is a lice, anti-lice treatment, just recently approved in June, July by 2020, in 2020. Okay, and it blocks the MMPs. Okay. So what is this compound name, or what is the name of this drug? Team A? No? Time up. Okay, team B?
Lotilaner.
Huh?
Lotilaner.
No. Team B, team C? No. Team D?
Permethrin.
No. तो 2020 में. Okay. Anyways, it's abametapir. ठीक है? It chelates the zinc and copper. Okay, and it is used in pediculosis capitis. Okay. So let's go to question number 3. ये screen बंद हो गया है. Check करेंगे please. Till the time team. Question number 3 for team B. What is DESCAB? Okay, it is a questionnaire which has been invented in I believe Congo or something like that. Now this is only 4 questions are there. 4 questions. If you this 4 question, they are used in the schools where the school teachers has been given कि ये बच्चों से 4 question पूछ लेना, आप diagnosis पे आ जाओगे. The sensitivity and specificity of this question is hovering above 90%. मतलब इस कंडीशन को डायग्नोज करने के लिए बस वो 4 ही क्वेश्चन की जरूरत है जो स्कूल टीचर भी डायग्नोज कर सकते हैं. It is used in the African countries to diagnose some condition. The name of this round is leprosy and tropical disease. So tell me what is DESCAB. Even if you tell me कि ये किससे related है, किस disease से, तो I will give the marks. It's for team B. Yes, your time starts now. So I had given you enough of clues.
Schistosomiasis.
No, schistosomiasis नहीं है. Next. It is used in Indonesia. Okay, next. Team C. Even if you give me the condition name, that's okay. Disease name. Team C, right? हाँ, Team D. स्कूल चिल्ड्रंस में क्या कॉमन होता है जो टीचर को दे दिया आपने, वो डायग्नोज कर लिया उसने. टीम बी नहीं, टीम बी टीम डी नहीं, टीम ए
Scabies.
absolutely correct. Good. Telling you, take a guess. So it is the screening checklist which has been implemented by the Indonesian government. Only 4 questions are there. Sensitivity is as compared. हम skin specialist कभी कभी diagnose नहीं कर पाते उतने अच्छे से वो DESCAB diagnose कर पाता है. So go and search it on the internet कि उसके क्या क्या question है. ठीक है? So this is the questionnaire which is be given to the student. There is an epidemic occurs in the Indonesian countries where they had utilized this DESCAB to reduce the incidence as well as prevalence of the scabies. Okay? Okay. It's for question number 4, team C. Identify the condition. बहुत ही simple है. Team C. It occurs in Seoul, history of travel. After that, they develop a painful ulcerative nodule. So what are the causative pathogen? Or if you give me the name of the condition, that's fine. Team C.
So rickettsial infection.
No. Team D. तुम लास्ट राउंड में मार्क्स लूज कर गया ना, स्केबीज तुम्हारे दिमाग में था, तुमने बोला नहीं शायद से. टीम ए.
So buruli ulcer.
हाँ?
Buruli ulcer.
नो. टीम बी.
Schistosomiasis.
नहीं. लास्ट का क्वेश्चन भी तुमने शिस्टोसोमियासिस बोला था क्या? नहीं. इट इज टंगियासिस. इट्स अ टुंगा पेनिट्रेंस एंड टुंगा ट्राइमेमिलिटा. ठीक है ना? ये दिस इज द क्लासिकल डर्मोस्कोपिक इमेज ना कमिंग आउट. So it's a tungiasis. Okay, fine. Chalo. So this is the audience question. Sorry, no, that's the information. The first case was occurred in 1526, and it is said that it has been carried from the Paraguay to other continent by this gentleman. They were carrying the sandbags, okay, in their ship as a ballast weight, and from there it has been carried to all over the world. Okay. Audience question: what was the stain used by the Hansen for staining leprosy? तब तक आप मास कैलकुलेट कर लो. Anyone? It was not modified Zdenstein. It was not modified Zdenstein. Anyone? PG? Or it was osmic acid. Okay. And you will not believe, ये हैंसन जो है ना, ये नॉर्वे का है, लेकिन फ्रांस ने इसके नाम से टिकट्स निकाले हुए हैं, पोस्टल टिकट्स. ठीक है. These are the French postal tickets. And जो कलर दिख रहा है ना, वो थोड़ा सा the first color that he has published, it was looking like that, osmic acid का. ठीक है. You see this one, na? That one. ठीक है. Okay. So before proceeding on round 5, let's have a marks, please. Okay. Don't dishearten by the marks. Okay. As I told you, in Bangalore CUTICON, we were at the position of 4th. ठीक है. At the end of this round. ठीक है. Yeah. So team A is at 15, team B as 5, team C at 10, and team D is yet to open their account. No problem. So team A 15, team B 5, team C 10. Okay. So no problem. Okay. Round 5. So it will be starting from team D now. Okay. So the sequence will be in the reverse. Okay. The past question will be to the team C, then team B, and team A. It's like that. Okay. So it's HIV and STI. Okay. So just focus on HIV and STIs. Okay. So this is the drug which has been invented recently in 2024, which is used for the condition whose genome is there on the right side. It is invented in Louisiana, somewhere around in Frederick National Laboratory of Cancer. Okay, and there are 2 calendar things has been given. Okay, these are the clue. So it's an injection. There is a calendar written January, July. For the condition, उसका जीनोम वहाँ पे लिखा हुआ है और यहाँ पे इन्वेंट हुआ है. तो tell me the name of the drug. Team D. Pass? Okay, team C. I want name of drug. Team C. No. Team B. Want to answer? Bolo? No. Team B.
Lenacapavir.
Excellent. Fantastic. It's lenacapavir. Okay, you tell me how you came up the diagnosis.
Sir, actually I took a guess. It is a capsid inhibitor and it is recently FDA approved. So I took a guess.
Fine. So it is a subcutaneous injection given once in 6 months.
Okay,
It's very easy here. That's why January and July.
Yes.
Okay. Good. Fantastic. Please clap for them. Please. I want you to improve their, appreciate their efforts. Please. Okay. So it's a lenacapavir, which is capsid inhibitor. It is available in 300 milligram and as well as 463.5 milligram, 1.5 ml injection mein. And this is the Baltimore, sorry, not Louisiana. It is invented in Frederick National Laboratory of Cancer Institute. It is given subcutaneously and every 6 monthly. Very convenient. Okay. So let's move on to the question number 2 for team C. Now, when was the last survivor of study participant died who was receiving the medical aid under THBP? What is THBP? What is THBP? Tuskegee Health Benefit Program. Okay. So there was huge human cry in the Tuskegee study. So when was the last survivor died? Even if you tell me the decade, ना चलेगा कि कब उसकी death हो गई थी. Because these are the important things you must read while reading the syphilis and all that. इस पे question भी आता है. Yeah, team C.
Sir, in 1930s.
नहीं. Last survivor of study participant died of THBP. ये जो है ना THBP, okay, Tuskegee Health Benefit Program was started in 1960s के बाद में, जब पता चला कि ये abnormal है. अब बिल क्लिंटन ने पूरे अपने सभा में उठ के सबसे माफ़ी मांगी थी और उसके लिए एक लॉ सूट भी हुआ था. ओके, उनके जो बच्चे हैं और ग्रैंड चिल्ड्रंस हैं जो डायरेक्टली अफेक्टेड थे उससे, उनको बेनिफिट दिया गया था. ठीक है, फ्री राशन, फ्री का सब कुछ. लेकिन उसका जो लास्ट सर्वाइवर है वो किस साल में मरा है उस बेनिफिट प्रोग्राम का? सो नाउ अंडरस्टैंड द क्वेश्चन. कैन यू रीअटेम्प्ट इट? बोलो. Right?
Sir, we have to mention the year.
Year. चलो next. B.
decade you were saying.
Decade. चलो ठीक है, decade
Just a
mention.
wild guess.
हाँ हाँ बोलो.
2010 to 2020.
2010 to 2020 गलत है. ना ना, टीम ए. पास टू डी.
So 1992 2000.
अरे क्या तुम पकड़ लेते ना एक एक डिकेड. ठीक है ना, 2009 यू आर जस्ट मिस बाय 1 ईयर. 2010 से लेके 2010. The last survivor died in January 2009. Okay, so as I told you, there was a NACE lawsuit which has been done in New York, and the settlement was done in 1974, and at that point of time also it was running in the billions of dollars. Okay, and in 1997 when Bill Clinton was a president, he has publicly apologized in their Rajya Sabha, Lok Sabha, कि yes, we had done a wrong with these people. Okay, and this is the whistleblower person. ठीक है ना, ये था वो विसल ब्लोअर जिसकी वजह से टस्कजी स्टडी जो है वो बहुत, सॉरी, लॉयर एंड विसल ब्लोअर जो हैज़ फॉट, इज अ वाइट लॉयर हु हैड फॉट फॉर द ब्लैक पीपल इन 1974. इट वाज अ रेयर केस. ओके, फॉर टीम बी, आइडेंटिफाई द टेस्ट. ओके, देयर इज समथिंग रिटन ऑन द राइट साइड एंड देयर इज वन बॉटल विच इज शोन ऑन द लेफ्ट साइड. सो आइडेंटिफाई द टेस्ट. व्हाट इज द नेम ऑफ द टेस्ट? इट इज फॉर टीम बी, प्लीज. Okay, pass. Team A. We are running out of time. No? You want to attempt it, please? Quick.
FDA test.
Huh?
FDA.
No, it is not FDA. Team D.
TPHA.
No, amino imidazole. This is amino benzimidazole. No. Team C. No. Okay. It is a trust. Okay, so that was the dye that has been used in the trust test. Okay, it is used for syphilis. No ko. Chalo, next move to forward. Question number 4, team A. Which gene is responsible for genome amplification and interaction with keratin and cytoskeleton? So this is the HPV genome for team A. Now there are multiple genes, E1, E2, E3, E4, L1, L2 and those. So which gene is responsible for the cytokeratin interaction, keratin and cytoskeleton interaction? Team A. Team A. Team D. Sorry. It's reverse, na? हाँ. Team D.
So KRT5.
Yeah, which?
KRT5.
नहीं, उसमें देखो ना तुम, उसमें ऑप्शन है ही नहीं. E6, E7, E8, E1, E2, E3, E5, L1, L2. These are the genome, na? Okay, team C?
So E6.
No. Team B?
E7.
No. E4, E5. E4, E5 is responsible for genome amplification interaction with cytoskeleton and keratin. E6, E7 are oncoproteins. Okay, they are most commonly implicated in cancer, but for attachment of cytoskeleton, it is E4, E5. Okay. Okay. Audience question. Name the controversy. Can someone please? Anyone? कि controversy का नाम क्या था exactly? Sir? Yes, sir. It is related to dermatology, sir. It is related to round actually. ये HIV इन्वेंशन का कंट्रोवर्सी था सर. ठीक है. सो हाँ सर. सर यस एग्जैक्टली. द फ्रेंच वाज सेइंग कि हमने ये किया है एंड अमेरिकन वाज सेइंग कि हमने किया है. ये लड़ाई झगड़ा चलता रहा कम से कम 20 साल तक. उसके बाद देन इट वाज टर्न आउट टू वेरी डिप्लोमेटिक डिजास्टर. उसके बाद ऐसा हो गया कि मतलब दोनों के रिलेशन बहुत स्ट्रेन हो गए. सो फाइनली द बोथ प्रेसिडेंट्स हैज टू पिच इन एंड कॉल बोथ द साइंटिस्ट टुगेदर. ओके, हम आप दोनों को देंगे इसका क्रेडिट. एंड उसके बाद जाने के बाद ये कंट्रोवर्सी सेटल हुई थी. वन हैज गिवन द नेम ऑफ LAV, लिम्फोट्रोपिक एडिनोवायरस, एंड सम अनदर हैज गिवन द नेम ऑफ HTLV3. उसके बाद ये हुआ कि हम दोनों नाम यूज नहीं करेंगे, हम इसका नाम रखेंगे HIV टाइप्स. ठीक है. ओके, सो राउंड 6 इज डर्मेटोपैथोलॉजी. ओके, so team question number 1 for team C. Okay, this is the 27-year-old male Again, the round name is dermatopathology. Okay, so remember, 27-year-old male came with the asymptomatic warty pinkish growth over the lower leg, which was progressively increasing. This was the dermoscopic image. Okay, there is some crust formation is there, erythematous background is there, there is some dot like blood vessels are there, and this is the clinical picture. Okay, and this is the this is the histopath picture, wherein there is a hyalinization or eosinophilic deposition in the epidermis, and there is a clefting around the melanocyte nest. This epidermal जो ये है, मैं आपको क्लू दे देता हूँ, टीम सी, इसको कम्युनो बॉडीज कहते हैं. ठीक है, व्हाट इज द कंडीशन? टीम सी. टीम बी? नो. टीम ए? These are called as the comino bodies. Team D? No? Okay, let's move on to the answer. It's a Spitz nevus. So these are the very typical of the Spitz nevus. Ki homogeneous material deposition in epidermis called as the comino bodies. There is a spindle cell structure and clefting around melanocyte occurs in the Spitz nevus. Okay. Team B. Okay. This is 24-year-old male, came with a translucent asymptomatic progressively increasing nodule on the face. Okay, on this. And if you see the histopath, there are multiple branching occurring. It's a glandular, it's a adnexal tumor. Okay, so and there is a clefting occurring and there are multiple branching occurring. So what is this condition? This is the adnexal tumor, benign tumor. Team B?
Chondroid syringoma?
No. Okay. Team A, it's an adnexal tumor, benign tumor with multiple clefting and pseudopod-like extensions below. Team A, take a guess, adnexal tumor जो भी आता है वो.
So trichoepithelioma?
No, no. तुम थोड़ा close थे but नहीं. हाँ, trichoepithelioma ऐसे नहीं दिखता है. Okay. Team D. Good that you attempted. Good. Team D. Okay. Problem. Team C. No? Okay, it's a fibrofolliculoma. Okay, they are centered around the follicular mass and multiple epithelial strands are passed down. So, it's very simple and most of the time we tend to miss this. ठीक है, ये छोटे स्वरूप में आता है but हम बहुत बार मिस कर देते हैं इसको. सिरिंगोमा, ट्राइको एपिथेलियोमा लेबल कर देते हैं. ठीक है, सिंपल इज एक्सरसाइज करो, छोड़ दो. Team A. So she is a lady, 23-year-old female. She developed an acute purpuric lesion in her groin area. And that purpuric lesion was progressing very fast, and she landed up, her hemoglobin was somewhere around 12. वो एडमिट हुई, एक दो हफ्ते में hemoglobin has came down to almost 5 to 6. Her CRP was shooting to the roof. Her parathyroid hormone was showing some abnormal trend. We had taken a biopsy. If you see the panel C जो है वो biopsy करने के बाद इतना खराब हो गया कि you have to debride it. The patient was very acute and severely ill. Got the history? History सबको पता चल गई क्या है? Young female landed up with a purpuric lesion, very severely ill, tried to take a biopsy, developed a very necrosis, landed up in complications, anemia हो गया, parathyroid hormone इसका abnormal था. The biopsy का जो है हमने एक stain कराया था. You have to identify this stain. This stain is a deposit in the blood vessel as well as in the muscle. Even if you tell me the compound, that's fine. This was for Team A, na? Team A. Yeah. Identify the stain. Team A. तुम्हारा इधर से. Team A. No?
Von Cossa stain?
Excellent. Absolutely right. Good. It's a von Cossa stain. Please give a round of applause, please. So this condition is a calcemic uremic sort of condition. Calciphylaxis. Thank you. It's a calciphylaxis. It was my published case only. So this lady came and she landed up in some other department. So other department में हमने call भेजा उन्होंने हमारे लिए कि यार ICU में admit है, please have a look at it, purpuric lesion है. She was admitted under onco. We had taken a biopsy, but biopsy के बाद she got deteriorated very fast. Then we thought somehow it can be a calciphylaxis. We stained a von Cossa stain. And she was like the survival rate that other have predicted कि ये चली जाएगी ICU में ही. But then we had advised for a parathyroidectomy. and she got improved. Now she is very happy. Okay, question number 4 for team D. So this is the condition wherein there is a scarring alopecia is there in the middle. There is a histopath has been given. Okay, if you see there is some clefting occurring around the follicular areas. Okay, देख लिया team D. Okay, और ये इसका हमने stain किया. So you have to identify the stain. या मुझे तुम बता दो कि कंडीशन क्या है, मैं उसमें भी मार्क्स दे दूंगा.
LPP, like in Panopylorus.
No, not LPP. Team C. नहीं.
Sudan O stain.
नहीं सूडान नहीं है. ओके, टीम बी. सूडान ब्लैक होता है ना, तो ये ब्लैक है क्या? टीम बी. टीम बी नहीं.
Oil red stain.
हाँ,
Oil red O stain.
अरे सिंपल सोचो ना यार, इतना क्यों कॉम्प्लिकेट कर रहे हो. टीम ए. कंडीशन अगर बता दोगे तो भी चलेगा, मैं बताया था. टीम ए, पहले वाला स्लाइड. ओके, दिस इज द स्लाइड. So tell me the stain or the condition.
So congenital triangular alopecia.
Huh?
Congenital triangular alopecia.
No. Simple condition is alopecia mucinosa, and it's a mucicarmine stain. Okay. See here, na, there are clefting is occurring over this. It occurs in long-standing cicatricial alopecia or alopecia mucinosa as a manifestation of MF also. So this is the mucicarmine stain. Okay. So audience question: folded coin appearance is characteristic of which condition? Anyone? Folded coin appearance? Sir? It's a granuloma fissuratum, adenoma fissuratum. This is how it occurs. It generally occurs in the flexures, and if it occurs in the groin or in the vaginal region, it is very commonly confused with the STIs. Okay. So it's a granuloma fissuratum. Okay. So round 7 dermoscopy. So team B identify the condition. ये dermoscopy दे दी गई आपको. See there is a team B के लिए question है, direct question. Yellow lacunas are there, septas are there. Then there is some hypopyon sign is there. So can you please tell me now? It's abundantly clear. I want name of conditions, name exact. No?
DLE.
पकड़ के मारूंगा तुमको भी. Team A. There is a lacunar there. There is a hypopyon sign is there. Team A. नहीं. Team D. Team D. Team C. It's lymphangioma circumscriptum. There are lacunas are there. There is a hypopyon sign are there. ठीक है ना? So simple. It's staring at your face. Anyways, चलो कोई बात नहीं. So this is a child. ठीक है, बहुत ही सिंपल डायग्नोसिस है. डायग्नोसिस नहीं देना है, रुको. टीम ए. सो दिस इज द चाइल्ड. ये इसका क्लिनिकल फीचर है, एंड दिस इज द डर्मोस्कोपी फीचर. यू हैव टू टेल मी द नेम ऑफ दिस स्ट्रक्चर. डर्मोस्कोपी टर्म में इसको क्या डिस्क्राइब किया जाता है? टीम ए? नो. टीम डी? नो. टीम सी? No. Team B?
Crown vessels.
No, it's not vessel, no? Team B. Okay. If audience permit, can I give them the marks if they identify the condition? ठीक है sir? Barwa sir, you are the senior most. So I will again restart the round. Can you identify the condition? Team A? Because I don't want them to lose. Okay? ये ऐसा बच्चा है, एक पैप्यूल है उसके ऊपर, और इसका डर्मोस्कोपी है. मुझे आप, यू विल कम लास्ट. आइडेंटिफाई द कंडीशन. अरे बोलो ना. वॉट एवर, आई विल नॉट लाफ, नो बडी विल लाफ. चलो बोलो. नो. टीम डी?
So odontogenic cyst.
हाँ?
Odontogenic cyst.
नो. टीम सी? मॉलस्कम. इट्स मॉलस्कम यार, इट्स मॉलस्कम. इसने बोल भी दिया था क्राउड वेसल्स उसमें. चलो गुड. चलो It's called as a rosette. Rosettes are seen in lichen planus hypertropicus also, in molluscum also, and it is seen in DLE also. Okay, team D, question number 3 for team D. Okay, this is the clinical condition. Okay, this is the clinical condition wherein there is some scarring happening, there is some hypertrophy happening, and there is some peripheral rim of hyperpigmentation is there. Okay, and these are the dermoscopic features. मैंने उसको राउंड राउंड गोला गोला किया है. Now जैसे रोसेट था ना, वैसे इसका भी एक नाम है. क्या कहते हैं इसको? It's direct question to team D. Team D.
So apple jelly nodules.
No. Team C.
Onion ring appearance.
No. Team B.
Red starboard sign.
No. Team A.
Follicular plucking
Excellent.
Tamplak sign
Yes, it's follicular plug.
in DLE.
This is the follicular plug seen in DLE. Okay, please give a round of applause to them. These are the follicular plugs. This condition is not TBVC. जो तुम सोच रहे थे वो TBVC नहीं है. This is the DLE. Okay, and these are the follicular plugs. Okay. So this is to team C. Question number 4. This is the clinical condition. There is some linear lesion over the hand, and this is the dermoscopy. Now you tell me what is the diagnosis. It's very simple.
So linear lichen planus.
नहीं. Okay, team B.
Ilven.
हाँ?
Ilven.
इल्वन ना. इल्वन की स्टोरी बताऊंगा, पर आंसर गलत है. ओके, टीम ए.
Sir, linear variant of incontinentia pigmenti.
नो, लीनियर. टीम डी.
So linear porokeratosis.
Excellent, very good. It's a linear porokeratosis. Okay, so for team B, I will tell you, this was diagnosed as a Ilven as well as for multiple number of time by multiple dermatologists, और बहुत सारे लोगों ने इस पे कोशिश भी किया है उसको निकालने का with dermabrasion and all that, and they had wrong in their diagnosis. ठीक है, and linear porokeratosis has a propensity to turn into the cancer in the long run. ठीक है, so dermoscopy gives the keratin rim appearance there, and that clinches the diagnosis. ठीक है, this is reflected as a conoid lamina on the histopath. Linear porokeratosis. Excellent. Please give them a round of applause. ठीक है, very good. ठीक है, so these are the changes. Aesthetic and dermatosurgery. Next round. Okay. Yeah, this is the last round. Last round. Yeah. Okay. So it is for team A. What is the name of this curve? Team A. This curve is very much talked about in Angelina Jolie. ये उसको बहुत परफेक्ट कर्व है ये. टीम ए. नो. टीम डी. नो. टीम सी. अरे मूवी देखे नहीं. टीम ए. टीम बी. नो, इट्स ओजी कर्व. It's called as a OG curve. Okay, this is the S-shaped curve of the cheek that creates a smooth transition. Okay, and it says that जितना ये acute होता है females में, the females are looking more good, and जितना ये थोड़ा सा obtuse होता है males में, they are good. So it says that the Angelina Jolie has got perfect OG curve. That is the benchmark they are set. Okay, question number 2 for team D. Name the flap. ये all or none principle है. Name the flap. आता है नहीं? Team D. हाँ. Direct question to you.
So VY flap.
No. Team question number team C. No. Okay. Question number sorry. Team B. नहीं. Team A. नहीं. Okay. It's a pedicle flap called as a iliac flap. Okay. It is used for people. Erstwhile, it is used to use for reconstruction of hair. Okay. They used to transfer from here to here. So it's a pedicle flap based on this vessel. Question number 3. Now this gentleman is from Tehran. Okay, and he invented something in 1960. 1960 में इसने invent किया था ये. तो ये क्या invent किया था इसने? What is the name of this laser? and he invented it in the America. मतलब अमेरिका और ईरान के रिलेशन इतने अच्छे थे उस टाइम पे 1960s में कि they were allowing the scientists to invent something at their soil. Now they are arch enemies. Team C, direct question to you. Which laser I am talking about? No? Chalo. Team B?
Diode laser.
Diode? No. Here you see the laser का ना, उसमें lasing material क्या है? छोड़ो. Team A?
Excimer laser.
No. Team D? It's a gaseous laser, na? There is a gas reservoir is there. It's a helium. It's a helium and neon laser with 633 nanometer, and it's biostimulator used for pain and wound healing. The name of the individual is Ali Jawan from Tehran. Okay. So question number 4 for team B. Identify the suture type. Team B, suture type.
Vertical mattress.
Vertical?
Mattress.
No, I want exact name. There is something into that. Dekho jara. You want to reattempt it? Don't rush.
Figure of 8.
No. Team A?
Purse string suture.
No. Team D?
So far, near.
But वो तो vertical matters में आता है, but ये अलग है थोड़ा सा. I want exact answer because this is very basic. Team C? No? It's a pulley stitch modification of vertical matters. ठीक है. Okay, so it is used in tension areas. नहीं. ठीक है. So we are end of all the rounds now. ठीक है. Next will be the rapid fire. It will start from team A, team B, team C, team D. Mark बता दो please. So don't worry, you people are doing excellent. Very good, fantastic. ठीक है. So the team A is leading with 30 marks. Please give a round of applause, please. Okay. Then comes the team C with 15 marks. Then the team B. Ten marks, and then team D 5 marks. Okay, so difference is not much. If you see team A is 30 marks, that's it. अगर वो एक भी गलत होते हैं और एक कोई और टीम जो है वो सारे रैपिड फायर सही करते हैं तो still the winning chances are there. Okay, so please don't give up. This can make or break the winner also. Okay, चलो. So rapid fire for team A. Let's start. देखो ये 1 मिनट का राउंड है, उससे ज़्यादा टाइम नहीं मिलेगा, एंड जब तक आप पास नहीं बोलोगे मैं नेक्स्ट क्वेश्चन फ्लैश नहीं करूँगा. अंडरस्टूड? ओके ओके, लेट्स स्टार्ट. टीम ए, टाइम स्टार्ट्स नाउ. Concentration of TCA in blue Obagi peel?
Pass.
Is 15%. AR-CAG gene is situated on which chromosome? Autosomal recessive CAG genes. Alopecia related है?
Chromosome 14.
No. Okay. Amplify measure?
Pass.
Ideal time to remove the suture at neck?
5 to 7 days.
Excellent, given 3 marks. Okay. What is the most common group of drug that produce AGAP?
Steroid.
No.
Methotrexate.
Cephalosporin. Okay. Name the causative organism of fifth disease?
Roseoline phantom.
No, I want name. Optimum laser wavelength for green color tattoo?
670.
6?
670.
678. No, it's wrong. 600, 694. Okay. Botulinum toxin A act in Raynaud's phenomena by blocking which receptors? Your time is up. Okay, fine. Only one question. Okay, they are attempting only one question. It's alpha 2. Okay. Angiosarcoma in the setting of chronic lymphedema is called as a Stewart-Travis. National Leprosy Control Program was launched in 1953. Team B. So again I am telling you, जब तक तुम पास नहीं बोलोगे मैं अगला क्वेश्चन नहीं फ्लैश करूंगा. ठीक है? अगर नहीं आता है तो पास बोलना ताकि पूरे क्वेश्चन आप अटेम्प्ट कर सको. Team A has only given one correct answer. Okay. Team B. What is the other active component of ferulic acid peel in addition to ferulic acid?
Pass.
It's fluoridine. How many grades are there in Ludwig scale of APHL?
4.
Excellent, correct. Which agent is added to this species to stabilize it? It's phosphatidylcholine to stabilize it.
Pass.
Okay, sodium deoxycholate. Who proposed the measure theory?
Pass.
Charles Tobin. Original Ferryman Galloway has how many body areas? Original.
Pass.
Okay. Next is patient with eruptive xanthomas are susceptible to which systemic condition?
Pass.
In which year was the leprosy bacillus discovered?
1873.
Excellent. Optimum laser wavelength of sky blue color tattoo?
106.
No, it's 585. Time is up. Okay. Muscle injection in Mona Lisa smile defect? ऐसे ही बता दो.
नहीं बता सकता.
नहीं है. Okay, it's LLSN. Okay, ideal time to remove suture at the face and ear is 5 to 7 days. Team C. Black pill is made up of fermentation of.
Pass.
According to Rasman and Burston, how much percent of scalp is considered as a safe donor area?
40%.
It's 25%. What is the effective skin temperature achieved after cryo slush technique?
Pass.
Who invented IPL?
Pass.
Dr. Shimon. Okay. Pinch purpura occurs in which condition?
Pass.
Ideal time to remove suture at scalp?
4 days.
No. What is the earliest cutaneous sign of lignocaine toxicity?
Oral, perioral.
Given circumoral tingling and numbness. Optimum laser wavelength for purple color?
1064 nanometers.
No, 755. Who first isolated pure crystalline form of botulinum toxin?
Pass.
The equivalent of Bose line in the nail in the hair is called? Paul Pincus construction. Okay, your time was up. Team D. अगर तुम सारे क्वेश्चन आंसर करते हो ना, यू विल बी विनर. आई एम टेलिंग यू. ठीक है. एंजाइम बी लैक्टिनिन derived from?
Pass.
How many grafts are extracted in giga session?
कितना? 100.
Oh. Who first reported fat grafting?
Pass.
It's Neuber. Who invented excimer laser?
Pass.
Which drug is used prophylactically in patient with hereditary angioedema prior to surgery?
Pass.
Ideal time to remove suture at eyelid?
7 days.
No, 3 to 5 days. Which species of organism causes hand foot mouth disease?
Pass.
Which is the other name of ORF?
Pass.
Optimum laser wavelength for red color?
1064.
No, it's 532. Which commercial type of botulinum toxin A can be safely stored at 25 degree?
Pass.
It's Xeomin. Okay, thank you very much. Please have a round of applause for all these participants and contestants, please. ठीक है, very good, fantastic. Now you can face this side. Just for your contestants, okay. This is not to demoralize you, okay. This is to pass you the message that we dermatologists are the owner of largest organ of the body, okay. None of the other specialty has that leeway, okay. And we can diagnose the cases that they cannot even think of. Like there are the multiple cases I showed you, angiosarcoma or SPTCL. There were dermatomyositis preceded by the breast cancer. We are running from pillar to post. कोई MD medicine के पास जा रहा है, कोई surgeon के पास जा रहा है. But they were just doing a superficial work. But when they finally landed up in the dermatologist, if you connect the clues, you can diagnose the cases as early as in their earlier phases, and you can actually change the outcome of their life as well as their survival rate. So just don't be what we can say कि यार टीनिया आ गया, हमने प्रिस्क्राइब कर दिया, या ये आ नहीं रहा है, 4-5 टाइम से अगर आ रहा है. If any patient is coming to you for 4 to 5 times without any relief, think something is not all right, which is not fitting in the picture, and I should give more due diligence and investigate it. That was the point of my question in clinical round as well as in the dermoscopy round. Understood? It is not to demoralize you or not to show off कि हम कितना काम करते हैं. No. You should always think out of the box for the patient who are repeatedly following up without any relief. Okay? And please embrace the new technologies like dermoscopy and all that. Okay? So it is not to demoralize you at all. Chalo, good. So let's announce the results, sir. Yes, sir, please. So at fourth position is team D. Please have a round of applause, please. At third position is team B with 16 marks. Please give them a round of applause. At second position, it's team C, RIMS. Okay, and the winner of this today is a team A from PMCH Patna with 33 marks. Okay. Chalo, good. I hope you all enjoyed the quiz. Okay, I hope audience has enjoyed the quiz. Thank you very much. Thank you so much, sir. Thank you, sir. Thank you. Yes. Thank you very much. I will just have a customary photo with all these people. I will just 5 minutes because I have to post it to the IDVL group. Okay.
साइंटिफिक मांग रहे थे, छोड़ दो ना, हम इसमें से देख लेते हैं. हम क्यूटिकॉन का मांग रहे थे या फिर से डिसेंट, जो भी डिसेंट पेज हुए. हाँ, साइंटिफिक जो लिस्ट है. So good morning everyone, good morning delegates. Let's start with the second day of our 39 CUTICON Bihar. For the first session of the day, I would like to invite Dr. Rajat Sarkar sir and Dr. Shankar sir to please chair the session.
Hello. Good morning, everybody. I'm going to start today's program. Today's speaker is Dr. China Langer. Please come, ma'am. I'm going to introduce her qualification: MBBS, MD Dermatology, Leprology, Venerology, Fellowship in Surgical and Cosmetic Dermatology, Faenza University, Rome, Italy. Designation: Director and Consultant Dermatologist. Institute is Asta Skin and Dermatology Cosmetic Center, Jambu. Aesthetic presentation 43. Publication 16. Author of 4th chapter of IDBL textbook of AI. Brief biodata. Served as President of IDBL Jammu and Kashmir 2023. Organizing Chairperson 4th, Co-Chair 5th and 6th Annual CUTICON GK. Attended 8th Congress in Dermatology Poland IADVL Scholarship. Member of ISA. Member of Pediatric Practicing Management Committee 2024. Past Convener and Member of Past Management 2024. IDVL Appreciation Award of Best Small State Branch 2024. IDVL Appreciation Award of Dermo Zone North and Annual CUTICON DSB 2024. AIDVL Appreciation Award of 4th CUTICON JK24 and 6th CUTICON JK 2025. Thank you.
Thank you, sir. At the outset, congratulations to the organizing team for such a great event and making me a part. So from a great quiz to my talk, which is basics of laser hair reduction. Nowadays, it's like bread and butter of our all the dermatologists. So let's start with the basics of the laser hair reduction. We have been given terms like temporary and permanent hair reduction. We say temporary when there is delay in the hair growth for around 1 to 3 months, and permanent when there is stable decrease in the number of terminal hair for a period longer than the complete hair growth cycle at a given site after the treatment. Why it is so popular? Because it gives selective hair damage, it is less time consuming, gives longer hair-free interval with fewer or no side effects. A single session may reduces 10 to 40% of the hair, and repeated session may goes up to 90%. But there are certain factors which affect its outcome. They are related to laser or the machine, which include wavelength, flints, pulse duration, spot size, and the cooling mechanism. And there are factors associated with the patient like skin type, hair color, hair growth cycle, site, and the hormonal influences. So talking about first thing, wavelength. The common wavelength which are being used here in the laser hair reduction are the wavelength which are absorbed by the chromophore, which is the melanin hair. So we have 695, 755, 810 and 1064, which give the maximum effect. The basic is extended selective photothermolysis, which earlier used to be only selective photothermolysis, which is like when you pass on these laser pass on these wavelength on the hair, they act at different level, and the melanin which is present in the hair root, they absorb the heat and get destroyed. But later on it was seen that it is not only the heating up of the melanin which is required to have the laser hair reduction permanent result, but it is the extended selective photothermolysis, that is once the heat is absorbed by the melanin, but it is important to pass on that heat to the stem cells present in the bulge area so as to have the permanent hair reduction. So here comes the role of pulse width, which I am talking about later in my talk. So coming back to wavelength, if we say we are using different wavelengths because they are working at different depth at the different hair types which are present at the different depth in the skin. If you talk about the villus hair, it is superficially placed, and you can see in the slide that 755 is acting maximally on the villus hair here, not on the terminal hair. So it is best suited for the villus hair. As compared to this, if we talk about 1064, it is acting maximum on this area, on the terminal hair. It is destroying the bulge and the bulb area of the terminal hair. So best suited for the terminal hair growth. And if you talk about 810, it has results on the villus as well as the terminal hair, so working over a wide range. Also, it is important to mention here that with increasing wavelength, the penetration increases and the affinity for the melanin decreases, which makes 1064 the safest one for the black people. So if you do comparison between the different laser technologies, alexandrite, it works best when you have the high melanin absorption, and it is safe and effective for the lighter skin and hair. Whereas the diode, it has moderate penetration and it is used over a variety of skin and hair types. Long pulse Nd:YAG penetrates the deepest, and it is ideal for darker skin types, coarser hair with least side effects. Now, when we found this thing, some of the doctors, they started with the rotational laser therapy. Like first they used to do laser with the Nd:YAG or the diode, and when the hair become thin, they put the patient on the alexandrite lasers. And also the company started with the lasers with the triple wavelength, which include alexandrite, diode and the Nd:YAG wavelengths, so as to give the maximum result to the patient. Because a single wavelength, it targets the part of hair follicle, whereas if we combine the triple, all the three wavelength, we can target the whole hair follicle, including bulge, bulb and papilla. Single wavelength has limited mechanical, more thermal effect as compared to the triple one. Single wavelength limits the usage of fluence due to single point of absorption, and also limit its usage in the darker skin type. And it is associated with intense pricking sensation when it is used. So in the market, you can see a evolution starting from the diode and now coming to the triple or the quadruple wavelengths. Talking about the spot size, it is the area over which the laser beam is delivered in a single shot. The larger the spot size, deeper the laser penetrates. Here you can see that smaller spot size is good for the superficial area, superficial target, and the larger spot size are good for the deeper targets. And also the larger spot size are used to treat the larger body areas. Fluence is the amount of energy which is delivered per unit area, measured in joules per square centimeter. And the right fluence is the highest tolerable energy which generates perifollicular erythema and edema. In diode laser, 30 to 35 joules per square centimeter is used for the type 1 to 3 skin, and low fluences are used for the darker skin type. It is very important to note that higher fluences increases the efficacy but at the cost of side effects, and lower fluence, they causes the transition of the anagen follicles to catagen, thereby can have impact on the outcome. So, talking about these days is pulse width. It is the duration of the laser pulse, how long the laser energy interact with the largest, with the target tissue, which is the hair follicle. So thermal relaxation time of the hair, it rounds about 100 to 10 to 100 milliseconds, and that of the epidermis is 3 to 10 milliseconds. And the pulse width should be shorter or equal to thermal relaxation time of the hair and longer than that of the epidermis. So also one thing to note is for permanent hair reduction, we have to heat the follicle to 65 to 70 degrees Celsius, ensuring irreversible damage. And if you have fine hairs, they heat up very quickly. They are unable to hold the heat, so they require shorter pulse width, which should be less than 30 milliseconds. As compared to this, the thicker hairs, they heat slowly, they require longer pulse width, which should be between 40 to 80 milliseconds. And also, as a course of laser hair removal progresses, the follicle, they miniaturize, they become finer, and then they require a reduction in pulse width to ensure continued effective treatment. So the gold standard is for short pulse duration, high peak power for small hair follicles, longer pulse duration, low peak power to slowly heat the larger hair follicles. Also, taking care of the skin and the hair color, if you have light skin and fine hair, the choice of parameters should be short wavelength, short pulse, and high fluence. Light skin, dark hair, relatively we should go for relatively short wavelength. And if you have dark skin, dark hair, low fluence, long wavelength, and long pulse duration. And if the hairs are light or white hair, should look for other modalities. So talking about the cooling mechanism, earlier we used to use ice packs, cold jellies, cryosprays, zymers, and now there are machines with inbuilt cooling devices which have chilled sapphire window integrated in their handpiece. So talking about the basic is methodology. Whenever a patient comes to you, you have to take a detailed history, thorough clinical examination, and then you can do the scoring, and if required can go for the hormonal assay or the ultrasonography. Then a written informed consent is taken, the hair counts and photographs before treatment, and then once in every 3 months required, very important for the patient and for you. And you have to start the fluence and the pulse duration according to the skin type and hair type. And every time when patient come, fluence is to be increased by 10%. The laser treatment sessions should be performed at 4-week interval, and at least 6 to 8 laser sessions to be performed. These are few of my photographs before and after. Thank you for patient hearing.
Thank you. It was a nice presentation. Any question from the audience? Thank you.
Thank you so much, ma'am, for such an enticing session. I would like our speaker and chairperson to please collect their memento near the registration counter. For the next session, I would like to invite Dr. Birender Kumar Singh sir and Dr. Uttam Banerjee sir to please chair the session.
Hello, good morning to everybody. I invite Dr. Dharmender Karn to deliver a lecture on innovative applications of microneedling radiofrequency in dermatology beyond the horizon. Thank you.
Good morning, respected chairperson, dear friend. It's privileged and honored to stand in front of you as a speaker all the way from Kathmandu, Nepal. As I've been invited to speak on something interventional dermatology. So I thought of the topics I'm choosing is a crazy of these days. Just I want to ask few questions to the audience, though the audience is number of audience is very low. How many of you are practicing injectable? Can you raise your hand, please? How many of you are practicing injectables? 3, 4, 5, okay. So, whenever you are counseling your client for the injectable, you must have come across some people, they don't like to go for injectables for the wrinkle or sagginess, rejuvenations. So what the next option? Anything non-invasive. Earlier there was fractional CO2. Now the new concept has been come up. New technology has coming up. MNRF, micro needling radiofrequency. So when I was doing residency PG program 20 years back, that time we used to use needling treatment. That's a tissue cross technique. Then concept came as a micro needling. And that time we used to use 26 gauge needle, 30 gauge needle for the peri-lesional micro needling. You can pierce, you can control the depth, then you can do the puncture around the tissues where you want to go for, like a vitiligo patch, a stable vitiligo patch, sometimes alopecia areata. But in 1990s, Dr. Andre, he experimented on a scar with color-free tattooing, and he observed there's improvement in scar. With that theory, 1997, Dr. Des Fernandez made innovations of derma roller. Then we used to use derma roller, rolling method. After that, concept of radio frequency. And radio frequency in 2002, USA FDA approved for the peri-orbital wrinkling. In 2004, radio frequency was approved for the facial rejuvenation. But later, in 2009, there's innovation of technology of microneedling and radio frequency. There's a fusion of these two technologies came with the name as MNRF, microneedling radio frequency. So what is it? It's a minimally invasive technique. It's a combination of microneedling and radio frequency. As I mentioned earlier, when you are practicing injectables, like I'm practicing all the injectables, those clients were afraid of for the injections, like fillers, threads, botulism toxins, or PDRN, exosomes. There is a non-invasive method is come up, and microneedling radio frequency is a growing popularity because of hardly any downtime. So what is the MNRF? How it differs with the laser, fractional lasers? See, MNRF is produce the area of coagulation with selected depth of the dermis. You can select the depth with non-coagulative volumetric heat, whereas in laser, there is a photothermic reaction. And laser is always depend on the chromophore, whereas MNRF is not depends on the chromophore. It has got electrothermical tissue reactions. So what is there? What is the tissue reaction with the MNRF? Whenever we do the MNRF, there are 3 zones of, let's talk about a little bit physics of the MNRF. There are 3 zones of effect in the MNRF. First zone, central, is a zone of ablation. Middle zone, zone of coagulation. And third, outermost is the thermal zone, thermal damage. So in first 24 hours, there will be infiltration of neutrophil, followed by, in the coagulative phase, coagulative area, there will be infiltration of lymphocytes, histiocytes, and surrounding unaffected tissue serve as a reservoir of these cells which promote the accelerated wound healing. And that activates as the dermal remodeling, immediate collagen contractions and shrinkage. So as a whole, it gives us activation of fibroblast and increased expression of several cytokines for the remodeling of the collagens. So there are various type of words you come across in innovations of application of MNRF. One is monopolar and bipolar. You must be using, electrical radio frequency. In monopolar, there is a, uncontrolled heat damage to the tissue. Whereas in bipolar, there is a controlled depth. And that's being used in MNRF. Similarly, about the needle, there are two types of needle available in the MNRF. One is insulated, another is non-insulated. Most of the latest technology of MNRF we use insulated. The advantage of insulated needle is it does not damage the epidermis and surrounding tissue. It only affects the deeper layer. So what is the effect of MNRF on the epidermis? It acts on the dermis only, hardly any damage to the epidermis, but it's rearrangement of the stratum corneum, and that causes increased keratinization, increase the epidermolysis. So regarding the parameters, depends on your machine, indications, and skin color type. So pass depends upon, like in the bony prominence area, single pass is enough. Pulse duration, again the lower pulse. Energy depends on the tolerability of the patient. Needle, again, for the 12 peri-orbital wrinkling, we used 12 needle. For face, 24. For body, 40. Passes, again, depends on the machine. In my center, I have 3 MNRF machines. Korean old version, I use 2-3 pass, but latest version is the Morpheus 8. I use 2 pass for the lower face, wherever there is a sagginess, or our target is a subdermal or subdermal fat. Those area we do double pass, otherwise single pass is enough. So advantage of MNRF is adjustable needle depth. We can set the parameter and easy to use. Regarding the depth, again, depth of the needle is advisable as per the company protocol, but the standard is peri-orbital 0.5 to 1 mm, forehead again 0.8 to 1 mm, chin 1 mm, temple area 1 mm, cheek 2 mm, but in Morpheus we use 3 to 4. Depends on the how thick of the cheek tissues. Abdomen is maximum is 7 7 mm. Submental area 4. So what are the novel technology of the MNRF is like, it comes with a cooling system, bilateral handpiece, impedance sensitive, temperature, pressure sensing tips. These are the modifications. There are different companies has own USP, unique selling point. But what I'm using is the Morpheus currently is a special sense with the temperature and pressure sensing tips. So there's several types of micro needling in the market. As I mentioned earlier, we started the history with the 26 gauge or 36 gauge needling, then manual dermaroller, then it comes with the motorized automatic pen. MNRF again, adjustable needle open depth, then combined modalities. With the MNRF, advantage of MNRF, you can combine with the other boosters, like again the boost, dermatology markers flood of the boosters, exosomes, PDRN, PN, as we see in dermatology, cocktail is always gives the better result, whether it's a dermatology therapeutic or aesthetics. So if you combine the MNRF with these skin boosters, it gives you the better result. So what are the indications in dermatology? Acne scar, post-traumatic burn scar, wrinkles, skin rejuvenation. In dermatology, hydra-hydrogen is wonderful. Senile purpura, hyperpigmentation melasma, hyperhidrosis. I do use in some cases stable vitiligo who are undergoing phototherapy, not responding. I do MNR sometimes with the exosomes. So patient selection, again, like any sort of aesthetic procedures, we should take the consent, informed consent, and treatment area should be cleaned with the anesthetic solutions and antiseptic solutions. So acne scar, again, acne scar is how it gives you the result with the acne. Yes, it damages the whole unit of pyrosis unit, and that's how it improves the acne. At the same time, is a collagen remodeling that gives you the betterment of acne scar. This is the client after one session of MNRF, is a Morpheus after 2 months of treatment. Again, second case, acne scars, is pre-treatment and post-treatment acne scars. Again, acne scars in post-burn scar after 3 sessions of MNRF. Post-traumatic scar. So, what are the advantages of MNRF over fractional CO2? MNRF can be used all type of skin, whereas in fractional laser, you have to be careful if your skin type is type 5 and 6. It's MNR is very less injury to the epidermis. And why MNR is preferable in the deeper scars? Because you can go the deeper. Minimum 0.5 to maximum 4 mm for the face, for the body 7 mm. Whereas in fractional lasers, no matter which type of fractional CO2 you are using, the maximum energy can be reached up to 1.5 millimeter. So there is the limitation of fractional laser these days. Again, MNRF in Estrella, after 2 sessions, loose pore again, senile purpura, skin rejuvenation. As I mentioned earlier, MNRF is the other non-invasive option for those patients who are scared of injectables like fillers and thread. And you can see noticeable changes in just 1 session of one MNRF with PRP. You can see the periorbital rejuvenations and NFL fold going higher up. Sagginess also improved. In melasma, you should be careful doing the MNRF in melasma, because if you damage the dermoepidermal junction, it increases the hyperpigmentation. So what I do is lower depth, like maximum 0.5 millimeter, along with skin boosters or tranexamic acid, I combine, it gives the better result. Again, therapeutic, dermatology therapeutic axillary hyperhidrosis is a wonderful result. One session, it gives you more than 50% result. Downtime is very less, 24 hours, 36 hours. Complication, I do not come across any complications. Only thing is you have to be careful during the setting the parameter and doing over the bony prominence area, because there will be nerves running superficially. That causes, it can damage the nerves. So what the real world experience with a high satisfaction rate, long-term improvements, and it's a versatile clinical practice. So against Morpheus technology, so conclusion is MNRF is very versatile and safe modalities, effective for the skin rejuvenation, wrinkle, and other therapeutic condition, and high patient satisfaction with a positive clinical outcome. I would like to invite you all to join us 20th National Conference of Dermatology Society of Nepal, which is going to be held in Janakpur, Sita's birthplace, where I belongs to, and the date is 20 and 21st of February. So I look forward to see you all. Thank you very much. Thank you.
Thank you, Dr. Dharmender Karn, for your nice lecture on the very useful topic, MNRF. It will be very useful to us all, which is very useful in very common problems. So thank you.
Thank you, sir.
Now I invite Dr. Amit Tiwari for his lecture on chemical pills in 2025, Science, Molecules and Protocol.
Good morning, everyone. Thank you, organizer, for having me on this podium. So we'll start on chemical peel, science, molecule, and protocol. So what is chemical peel? The chemical peel is a kind of resurfacing procedure where we are using chemical solution on skin to exfoliate, that is chemo exfoliation of outer layer of skin, that will result in controlled wound healing and improvement of the skin appearance and texture. The concept is not new. From ancient time, people are using different type of home products and chemicals to exfoliate and having youthful skin. This Cleopatra was a very famous Greek princess who are using sour milk, and other countries like French women are using old wine which contain tartaric acid for as a beauty bath to rejuvenate their skin. So why this procedure, chemical peel, is gaining popularity in aesthetic practice? Because it's a simple office procedure, easy to learn and practice. There is minimally invasive with little downtime, which is suits to today's busy lifestyle. And unlike laser, they don't require any costly equipment and any other major complications. So, science of chemical peel, its process involves controlled destruction of outer layers of skin with exfoliation. Hence, after that, the controlled wound healing process and regeneration of new skin. The key steps, the first one is exfoliation or keratolysis, where the acid solution loses the dermal bond desmosome between keratinocyte, and that allows the shade off or peel off these keratinocyte more faster than natural shading cycle. The second step is controlled wound healing, which causes cell renewal, production of newer and healthier keratinocyte, and the collagen and elastin production by fibroblast, which is in medium depth or deeper peel. After that, this wound healing initiates skin remodeling. Over the time, this regeneration process keeps going on, and that will land up with a good, beautiful skin with reduces hyperpigmentation and diminishes fine line and scarring. So in the depth of peel, we'll discuss superficial, medium, and deep. In superficial peel, mainly there is exfoliation of stratum corneum without epidermal necrosis, which can happen in the superficial peel in a very minimal quantity. In medium depth peel, we have this epidermal necrosis followed by regeneration of collagen, and in few content we have this modification in elastin content also. But in deep peel, the main is long-lasting epidermal and dermal thickening with increased collagen content and the improvement the elastin tissue quantity and increased glycosaminoglycan, that is extracellular substance which hydrate or give strength to our skin and control cell cycle. So this is diagrammatic representation where you can see this after application of chemical solution, there is a partial thickness chemical burn, and then regeneration then start from the perifollicular and the area which around the eccrine duct, and this completed the new and fresh skin that is more organized. So in support of this, there is a recent published article in Dermatology Surgery in 2025. They conducted a meta-analysis of 39 studies of 13 each in superficial, medium, and deep peel. In superficial peel, they denote that histological improvement of epidermis is only with the equivocal dermal changes. In medium depth peel, the result shows that they increase the epidermal and dermal thickness with collagen content with variable improvement in the elastin quality. And third one, in deep peel, there is significant improvement in the elastic quality. So what are the molecules we are using? We are using mainly alpha hydroxy acid, which derived from natural product like glycolic acid from sugarcane, lactic acid for sow milk, malic acid, tartaric acid, and citric acid. They are water soluble. Then beta hydroxy acid, they include mainly salicylic acid, which we are using in beta hydroxy acid. They are more lipid soluble, so better for oily skin. Now trichloroacetic acid, alpha keto acid like pyruvic acid, resorcinol, retinoic acid, and phenol. So types of peel, we'll discuss a type of peel. They are monopeels and they are combination peel. Monopeel, the classical monopeels we are using is salicylic acid, glycolic acid, and trichloroacetic acid with variable concentration. Now newer monopeel, we are having mandelic salicylic combination. We are having pyruvic acid, lactic acid, ferrolic acid, retinoic acid, and polyhydroxy acid and lipohydroxy acid, which is a modification of salicylic acid, which is more lipid soluble. In combination peel, we have classical combination peel, including jasners, which contain lactic acid, salicylic acid, and resorcinol, and this phenol or Baker-Gordon solution, which is a combination of phenol and croton oil. In newer combination peel, we have modified jasner, in which this resorcinol is replaced by citric acid, salicylic mandelic peel, VI peel, which contain TCA, salicylic acid, tretinoin, phenol, and combination of citric acid. So now mostly the peels are classified according to the depth of penetration, the very superficial, medium, and deep. In very superficial, the depth of penetration is up to stratum corneum. Glycolic acid in 30 to 50% concentration, TCA 10%, jasner solution in 1 to 3 quart of jasner solution, salicylic acid 20 to 30%, and lactic acid and tretinoin 1 to 5% is coming under the very superficial peel. If we increase the concentration of glycolic acid up to 50 to 70%, or TCA concentration up to 10 to 30%, and the repeated coating of jasner solution, it will give a superficial peel. In medium depth peel, again the concentration is higher, 70% and more in glycolic acid, and 35 to 50% in TCA, and phenol 88%, and pyruvic acid. And deep peel, which penetrate up to mid-reticular dermis, the Baker-Gordon phenol formula, which contain phenol, croton oil, septisol, and distilled water. So what are the indication of chemical peel? The first indication of first and foremost, and we are mainly using hyperpigmentation like melasma, post-inflammatory hyperpigmentation, freckles, lentigines, periocular melanosis, and lip melanosis. In acne, we are having comedal acne, papulopustular acne with PIH, superficial acne with acne scarring, skin rejuvenation for photoaging, skin glow, mild and moderate static wrinkles, and dilated pores. In medical condition, few medical condition we are using peel like keratosis pilaris, acanthosis nigricans, macular amyloidosis, and now people are using peels in onychomycosis and nail surface abnormalities as well. So what are the contraindications? There are absolute and relative contraindication. So absolute contraindication is allergy to the peeling ingredient. There are signs of active infection like particularly herpes. There are open wounds or open cuts on the area which we are going to peel. The relative contraindication is recent sun tanning, photosensitizing medicine like tetracycline or quinolones, pre-existing inflammatory dermatosis like psoriasis or atopic dermatitis, pregnancy, radiation therapy, or most importantly, unreliable patient. So you choose your patient wisely. What are the protocol? So you should have proper history, including general medical history, exposure of sun, recent infection, or any medication like isotretinoin if you are planning for for a deep or a medium depth peel. Patient is having keloidal or tendency or any current medication, photosensitizing medicine. If you are planning for phenol peel, just evaluate cardiac profile of patient, detailed medical examination, including general physical examination, cutaneous examination, including the sign of any sign of previous infection, any sign of that photoaging, or what are the texture of skin, sebaceous activity, oily or dry skin, or is there any sign of keloid or hypertrophic scarring or pre-existing inflammation. Biopsy sometime may needed to confirm your diagnosis, or if you want to know the melanin content, the depth of melanin content. If you are planning for deep field, just go for hemogram, urine analysis, LFT, RFT, or especially ECG, complete cardiac evaluation. Now documentation, informed consent after counseling, and photographic records must be, because now in this area, the medical legal complication is on boom. Counseling is a very important part in any aesthetic procedure. Choose your patient wisely. The patient who is having realistic expectation, discuss about the expected outcomes, time taken for recovery, and likely or unlikely side effect with the patient. So that will create a rapport between you and your patient. So what are the priming or pre-pale care? Priming is the procedure aimed to thinning the stratum corneum for deep penetration of a chemical agent or evenly penetration of a chemical agent that accelerate wound healing and reduce the incidence of PIH. It's particularly important for darker skin, if it's skin type 3rd to 6th, and sunscreen should be ideally started 3 months before. So sunscreen is a very important part of any cosmetic procedure on face we are using. The procedure equipment should be there: glass cup and beaker, handband, and gloves, cotton tipped applicator or gauge piece, fan for cooling, and time for alpha hydroxy acid peel. Anesthesia routinely not required. And safety precaution, you should check label on your bottle, and head should be elevated at 45 degree to stop the spillage, and syringe filled with saline or normal water at the, for any accidental spillage into eyes. Skin preparation. Nowadays, every peel having this own pre-peel cleanser, so you can use, if you are not having, just ask patient to wash face and clean with the alcohol and degrease with the acetone. Now the required strength of peeling agent poured into glass, and then paint with the help of brush, cotton tip applicator, or gauge piece in the manner of from forehead, from left to right, then right cheek, then nose, then left cheek, and then chin. And then border, you have to give a feathering stroke to reduce the demarcation line. And for glycolic acid, we need a peel neutralizer which mainly contain 10 to 15% sodium bicarbonate. So post-procedure care, recovery from, essential for recovery from complication. So mild soap-free cleanser, blend emollient, sunscreen, that should be right, or if erythema and intense burning is there, so you should use ice packs and topical steroid. What are the complications? They are mild, moderate, and severe. In mild complications, we have early and delayed complication, irritation, burning. In delayed pruritus, we have moderate complication like textural or atrophic changes. In salicylic acid patient, we have the salicylism, delayed hypertrophic scarring, and severe we have toxic shock syndrome from, or cardiac toxicity from phenol, or that dreaded complication, lower lid atrophy on corneal damage, significant scarring, and permanent dyspigmentation. So what is new in chemical peel? The new agents introduce new indications, new ways to peel, and new site. We have already discussed newer combination peel and newer mono peels. New indications are adjuvant therapy for keratosis pilaris, striatum extensis, acanthosis nigricans, macular amyloidosis, as well as lichen amyloidosis, rhinophyma, and surface nail abnormality. So newer method are sequential peel, where more than one peel at a time is used to sequential manner. Example are salicylic acid peel followed by TSCA, that will increase the penetration of second peel. Segmental peel, different peeling agent on different cosmetic site, like your T-joint oily, so you can use this alcohol-based salicylic acid peel for T-zone, and this gel-based peel for your cheeks. Newer sites like periocular, lips, body peel, and for nails, surface abnormality and onychomycosis. And we can combine peels with other procedure like laser, microneedling, microdermabrasion, botulinum toxin, and fillers. The beauty of combining of chemical peel with laser is that it reduces the chances of post-inflammatory hyperpigmentation. There is a study published, this comparison of 1064 Q-Stage Andiag versus Jasner's peel. The results are equivocal. The Jasner's peel and 1064 Q-Stage Andiag laser are equally effective in treatment of melasma. And if you are using this peel, there is another study, when you are using a peel pre and post laser, the chances of post-inflammatory hyperpigmentation is less, especially in darker skin type. So there are a few, my patients of acne, there is a salicylic acid, after 3 sittings of salicylic acid peel, there is a melasma, Jasner solution, after 4 sittings of Jasner solution, there is marked improvement in melasma. Another patient of acne in salicylic acid, after 2 sittings of salicylic acid peel, there is a nodular cystic patient where we applied this black peel which contained black acetic acid, and after 3 sessions of black acetic acid peel, you can visible marked improvement. So what is the take-home message? Chemical peel are ideal for patients looking for improved skin texture and tone. They are simple and cost-effective office procedure with little downtime. Patient selection is key. That is very important. Always have courage to say no to your patient. If you are choosing a patient for aesthetic procedure, newer peels, newer ways to peel, and combination of other procedures like chemical peel among the top minimal invasive aesthetic procedures performed globally. This is the chemical peel is the ideal procedure to start your aesthetic practice. Thank you. Thank you.
Thank you, Dr. Amit Tiwari,
Thank you,
for your very simplified and easy description of the chemical peels.
Thank you, sir. Thank you.
It will be a revision for those who are already doing peels, and also it will be advantageous for those who are going to start peels. Thank you.
Thank you, sir. Thank you.
Thank you so much, sir. I would like our speakers and chairpersons to please collect their memento. Progressing forward for the next session, I would like to invite Dr. Devesh Sinha sir and Dr. Rohit Sharma sir to please chair the session. Dr. Devesh Sinha sir and Dr. Rohit Sharma sir.
May I please invite Dr. Rasmi Singh on the dais. Our topic is From Concept to Clinics, Innovations that Matter in Dermatology. Dr. Rasmi, please.
Good afternoon, everyone. So the topic is actually very vast, so I have tried to make it short, and we already have many presentations on lasers, peels, etc. I have done I have combined both the innovation, all the kinds of innovations like therapeutics and procedural dermatology, diagnostics, etc. So we fall and rise, make mistakes and learn. This is how we innovate. The progress of dermatology in the past 1 decade is exceptional. It is on the rise. This growth is driven by the advancements in the therapeutics, technology, and better understanding of the societal needs. The key highlights of this session would be therapeutic advancements, updates in the melanoma management, integration of artificial intelligence, quantum medicine, and procedural dermatology. So let's start with the therapeutic advances first. If you look at the therapeutic advances, all the autoimmune conditions are at benefit, as many treatment options have come up in the past 1 decade. Right from steroids, which used to cause a lot of atrophy and telangiectasia, etc., we switched to retinoids, then to calcineurin inhibitors or the vitamin D analogs, and presently we are using JAK-STAT inhibitors in case of mild psoriasis. Now we have one more molecule that is which has been isolated from Sphaeranthus indicus. It is available in cream form, which is known to inhibit release of the TNF-alpha, IL-1 beta, IL-6 and IL-8. Then we also have tapinarof 1% cream, which has been FDA approved for topical application in mild psoriasis. Then we have systemic options for moderate to severe psoriasis and atopic dermatitis. As there is a lot of overlap in the pathogenesis of psoriasis and atopic dermatitis, we use more or less same molecule for both the conditions, and some of the targeting cytokines such as IL-4, IL-13, IL-31, as well as the downstream signaling via the JAK-STAT pathway, it provides sustained relief not only in the disease but also the itch in psoriasis and atopic dermatitis. This further improves the quality of life, sleep quality as well as the quality of life. Further therapeutic advances include in psoriasis, we have moved from TNF-alpha inhibitors, which has lot of side effects, to IL-20, to IL-17, then pan-JAK inhibitors came like tofacitinib, tyrosine kinase inhibitors came. Then a recent introduction is of biostandardized extract, as I mentioned, Sphaeranthus indicus. It is available in oral and topical form, both for psoriasis. It is still under research. It is being used. It is in the market. It is being used by some of us. Atopic dermatitis, we have moved from dupilumab to JAK inhibitors, IL-13 inhibitors like lebrikizumab, and now we have two chicks. That is JAK1, which is a specific targeted inhibitor of JAK1, abrocitinib and upadacitinib. Among topicals, besides older ones, for atopic dermatitis, we have tofacitinib gel ointment and crisaborole ointment. The benefits of these therapeutic advances are rapid clearance and tailored therapy. Challenges are cost and long-term safety. Similarly, for vitiligo, with the as we now know that there are multiple factors involved in the pathogenesis of vitiligo, including the environmental stress, genetic background leading to altered cadherin expression, and DMPS, and then its antigen presentation to T cells. And via JAK-STAT, again, there is release of CXCL9 and 10. So recruitment of melanocyte-specific CD8 T cell to the skin. So all this again involves the JAK-STAT pathway. So JAK-STAT inhibitors are equally good for vitiligo treatment. These are few of the my own patients' pictures. Some of has been published also, like psoriasis pre and post tofacitinib. For localized psoriasis, tofacitinib is excellent. Again, for alopecia areata, pre and post oral tofacitinib. The results are so good with JAK inhibitors that patients are quite satisfied because the results are early. Similarly, in lichen planus pigmentosus, pre and post tofacitinib pictures you can see. Then we have similarly in vitiligo, and then in IL-1, the crisaborole I mentioned for atopic dermatitis can also be used in inflammatory linear verrucous epidermal nevus, and it is again equally good for this condition. Then for oral minoxidil came for hair treatment. It is 2.5 milligram pre and post I have used, and these are the dermoscopic pictures with excellent results. Now we know that malignant melanoma is one of the most responsive tumors to immunotherapy. So with the advent of the checkpoint inhibitors like PD-1 inhibitor, PD-L1 inhibitor, CTLA-4 inhibitors, there is a shift in the survival outcomes in the malignant melanoma. Then AI came. It is a giant, there is emergence of this giant artificial intelligence which is standing equal to us in the diagnosis of melanoma, classification of inflammatory conditions, skin hydration analysis, and it is a great support for the clinical decision making. These are pictures, just a comparison that when we take pictures, there is a lot of bias when we take pictures from short and long distance, but AI reduces this imaging bias too. So diagnostic and consultation innovations, teledermatology, which has evolved since the COVID times, though it was present initially also, but it has evolved since the COVID times. And it has two important benefits, that is increased reach of consultants among the peripheral patients and easy record keeping. But yes, one major drawback is the privacy of the patient. Then among diagnostic, we have reflectance confocal microscopy. Though not as accurate as histopathological examination, it is a non-invasive, excellent tool for disease diagnosis if we cannot do histopathological examination in some patients. There are some computer-aided diagnostic devices which have also come up. One important one being mole analyzer expert system. Many smartphone apps are also there, like Skin Vision, Derma LD, Skin 10, etc. So this is mole scope, which is being increasingly used for the screening of skin cancer, tracking changes in the moles on skin, and identification of the basic skin lesions. We also have robot-assisted automated laser hair removal system, which actually does not, there is no need of the consultant being actually present all the time with the patient for hair reduction. ARTAS is a well-known robotic system for hair restoration for the follicular unit extraction type of hair restoration surgery. It consists of robotic system with a stereoscopic camera with high resolution to identify hair follicles for harvesting and implantation. So these are some of the wearable digital health devices like smart bandages with continuous evaluation of temperature, pH sensors which have been used and tested for monitoring of the healing of chronic wounds. As we know that pH changes from alkaline to acidic when this wound heals, so it will help us to monitor the wound healing. These are some of the future devices which can be used. Some of these are being still used, and some can be incorporated in future into the wearable technologies to measure the disease severity, like actigraphy, which can measure sleep disturbance, hence each severity. Vascular flow assessment can help with the assessment of inflammation, erythema, etc. Skin capacitance for edema and papillation. Microbiome assessment, which is increasingly being discussed nowadays for various autoimmune conditions. Can also be assessed. Similarly, lichenifications and cirrhosis. This is how a biosensor works. There is an analyte which can be an antigen, toxin, virus, bacteria, protein, DNA, RNA, or heavy metals, and it can be recognized by the biorecognition element. Then a transducer converts it to some kind of energy like electrochemical light, pH, heat, charge, and mass variations. And then it is amplified by the readout technology, converted to signals, converting the signals to the digital form which appears on the display, which can be a mobile screen or a computer screen. Let's embrace the quantum medicine. It investigates the interaction of photons with the biological system. It has opened new frontiers in the dermatology. QMR is one important quantum medicine-based technology which has been incorporated in the laser system, and it exhibits anti-inflammatory properties by generating the radio frequency resonance waves, helping with the regeneration in the skin aging and also helpful in melasma. Near and dear infrared, because of its abundance in the environment, due to limited absorption by the plant chlorophyll, they have the ability to penetrate deep into the skin, enhance the mitochondrial function, and promote the tissue repair, hence helpful in photobiomodulation. Also, it is helpful in wound healing and inflammatory skin conditions. So these are some of the light-based devices which we are using, blue LED lights. Like blue light, which induces endogenous photodynamic therapy via photoactivation of endogenous porphyrines, resulting in free radical formation and damage to the bacterial cell membrane. Also, it reduces the sebum secretion from the sebaceous glands and deprive the P. acne of its growth medium, and decreasing the inflammation, thus contributing to the therapeutic effects. Blue light irradiation can also stimulate the wound closure and increase the opsonin 3. So it is helpful in acne vulgaris. This is one of the important indications for this light. Red light, similarly, it exerts anti-fibrotic effect. So it is helpful in male pattern hair loss and post-op scarring. Then yellow light reduces melanin synthesis, hence it is helpful in melasma. Similarly, near infrared light is also helpful in melasma and aging. ALA PDT, which has been used since long time, it induces photochemical reaction that generates reactive oxygen species and other cytotoxic substances, leading to cell or tissue destruction. So helpful in actinic keratosis. So these are some of the light-based LED lights which we use in dermatology. Scar tissue, if we look at, we have hypertrophic, atrophic, keloid, and hypertrophic, atrophic scars and papillary scars, and then we have keloids. And there is increased production of collagen 3 in hypertrophic scar. Similarly, in keloid also there is excessive production of collagen type 1 and 3. And then in atrophic, there is imbalance between the T helper cells which contributes to the pathological scars via the secretion of IL-4 and IL-13 and the pro-inflammatory factors. So the imbalance between these two leads to atrophic scars. Similarly, there is papillary scar formation too. So these are the medications which work on different mechanisms of scar formation. Most of them, like retinoids, botulinum toxin. Retinoids, it works by inhibiting the fibroblast proliferation and reduce the collagen fiber production. So it is both preventive as well as it helps to treat the scars too. Botulinum toxin, it inhibits the glandular secretion. Also, it reduces the local tension, down-regulating the TGF-beta-1 expression, inhibiting the fibroblast proliferation and regulate the collagen deposition. Similarly, we have cytotoxic drugs like 5-fluorouracil, which again improves the onset of acne by inhibiting the thymidylate synthase. There are, as I said, light-based therapies we have already discussed, like photodynamic therapy. PDL is very important because it acts on hemoglobin, improving the scar erythema. Fractional CO2 laser can cause photothermolysis of sebaceous glands, hence breaks down the abnormal scars and release tension and upregulate the MMPs. Pathophysiology, after scars we have aging. Aging has mainly the main contributor is the UV rays, and then the environmental factors, they lead to ROS formation, that is reactive oxygen species, with telomere shortening, activation of MAP kinase pathway, and then finally downregulating the production of collagen and elastin, with leading to detachment of fibroblast to from collagen fibrils, and then wrinkling and sagging is there. So treatment of aging skin can be done with topical retinoids, hyaluronic acid, which provides hydration, then chemical peels we have which can cause exfoliation and decrease of pigmentation. Injectables we have like Botox, fillers, threads, lasers, where we have moved from non-specific to from the non-selective to selective lasers. Then we have some regenerative treatments also. Like botulinum toxin I mentioned, for dynamic wrinkles we have been using since long time. Dermal fillers to restore the volume, biostimulators for collagen induction, skin boosters, etc. These are some of the procedural innovations where chemical peels are used. TC on hemangioma, TC on post-traumatic hair loss, Ancudi Sabre, it help to improve the scar, as well as some hair growth can also be seen. Phenol with MDA on the deep wrinkles help to cure the wrinkles in a single session. Improvement in acne during the diode laser hair reduction. It was a discovery by serendipity. One patient we did diode laser hair reduction, and there was improvement in the acne too. So this is one patient who presented with acne scars as well as erythema, and the patient got cured with, patient was more concerned about erythema than the scar, and I used mono threads in this patient, and the patient's erythema as well as the scar improved. Similarly, one patient approached for cork thread removal. I did that cork thread removal by anti-clockwise movement. And regenerative dermatology, we have PRP, stem cells, exosomes, PDRN. It is a new molecule which is being used for in the regenerative medicine. Hair restoration device called, one hair restoration device has also come up, where we use the patient's scalp tissue for the injection in the scalp for male pattern hair loss. These are the polymers like hyaluronic acid, natural and synthetic polymers. Among natural, we have the polysaccharides like HA, hyaluronic acid, PDRN, which have just come up. Then we have PDO threads. So these are various polymers which are being used for the skin regeneration. These are the future directions: innovate, innovate, and innovate, but validate it too. So research and publish. We have to find safer and more affordable biologics. We need to standardize the regenerative therapies too. So these are my references. Thank you.
Thank you, Dr. Rashmi, for a very nice talk on innovations that matter. Yes, they do matter. We were privileged to listen to you. We are open to questions from the audience. Any questions from the audience, please? If there is no question, we can end the session. Thank you so much again.
Thank you so much, ma'am. Thank you so much, sir. I would like to request our speakers and chairpersons to please collect their memento. For the next session, we are having the first panel of the day. We are going to delve into the black hole of biologics in psoriasis. For this, I would like to invite as moderator a very dear colleague of mine, Dr. Mohammad Mubarak Hussain, currently doing his senior residency in ANMMCH, Gaya.
Good morning, everyone. So I am here to moderate this first panel discussion of the day on psoriasis, and we will be dealing with biologics switching and various combination therapies, their evidence and experiences of our esteemed panelists. So I would like to invite the panelists for my session, Dr. Manoj Ram sir from SCB Medical College and Hospital, Cuttack, Odisha. Dr. Rajiv Thakur sir, he is consultant dermatologist from Jamshedpur. Dr. Ram Gyan Yadav sir, assistant professor, Madhesh Institute of Health Sciences, Nepal. And Dr. Sanya Kumari, consultant dermatologist from Gaya. Since we are running late on our sessions, I will try and request our panelists also that will be very crisp and rapid to answering all the questions. So, coming to my first question. So, if a patient on conventional therapy has good clearance, except for recalcitrant scalp or palmoplantar plaques, which are the difficult to treat sites, would you prefer to switch to biologics or add the combination therapies first? So any one of you can take the question, sir.
If the patient is on conventional therapy, but some patches are not getting resistant, before biologics we should start some combination therapy. It can be topical, or systemic topical. In this particular case, if allowed, then acetatin with NBV is good, topical steroid, salicylic acid with NBV will good. So before switching on to expensive therapies like biologics, we should try combination.
Yes, combination therapy is always preferred before switching to biologics. And here, especially in palmoplantar, in my experience, apremilast works best. So if we can combine methotrexate and apremilast, we can get good results in this.
Definitely, I completely agree with respected panelist. And as biologics are more expensive, it is not easily available. So first we have to try combination therapy with topicals like super potent corticosteroid with salicylic acid, keratolytics like urea around 10 to 15%, along with phototherapy, and as said, sir said, apremilast, tofacitinib, those can be combined in recalcitrant cases like this.
Sanya?
I agree with sir. Before switching to biologics, I think we should continue with that conventional therapy if there is a good clearance.
Thank you. Yes, most guidelines recommend optimizing or adding the combination therapy first for isolated recalcitrant sites before switching to biologics, unless the patient has functional disabling palmoplantar disease, poor quality of life, or contraindication to conventional add-on therapies. The AAD National Psoriasis Foundation guidelines also recommend the same, that is optimizing the topical or phototherapy adjuncts in patients with partial response to systemic therapy, especially for difficult to treat sites like scalp and palmoplantar plaques. So moving on to the next question. She is a 28-year-old female with chronic plaque psoriasis for 17 years. She is obese. The cumulative dose of methotrexate is 3.84 grams. She is having a winter exacerbation with PASI 11.2. She wants to conceive. So what are the treatment options, the various combination therapies that we can use, and the biologics that we can use, sir?
In the female who want to conceive, especially in those cases, the commonly prescribed drugs are contraindicated, especially methotrexate. Those are contraindicated. In those cases, the phototherapy is one of the options which is safe in pregnancy, along with topical therapies like corticosteroid, mid-potent, similarly moisturizer and keratolytic agents. And in biologics, cetrizumab is safest because it doesn't have FC portion in that, which leads to decreased penetration through the placenta. So it is safe in pregnancy and lactation. Especially in pregnancy, the TNF alpha inhibitors are safe in those cases.
Thank you, sir. Manoj, sir?
As the information shows, she already has a lot of methotrexate. So first to
Yes.
withdraw from her methotrexate.
Yes, sir, the disease
give
history
her
is
a
of
three-
17 years already.
Give to 3 to 6 months gap if she wants for a pregnancy. Then PASI is 11.2, that's quite high.
Yes.
So if, as sir said, if it is available, cetrizumab is the best option. But if not available, we can always go for NBB, UVB therapy. But again, that's a bit difficult for a pregnant female to stand up, get irradiated and all that. We can try etanercept if that's available.
If she is my patient, then first I will advise that please don't conceive in winter. Plan actually in summer, because it will give 6 months, minimum 3 to 6 months gap for methotrexate, as boss has said. She is already on a high dose of methotrexate.
Yes.
So before conceiving, she should at least withdraw the drug for at least 3 months. And then if she wants to conceive, then we have very limited options. In this topical, we cannot give high potent steroid. We have to give mild or low potent. Salicylic acid, coal tars are safe. Phototherapy is best in pregnancy, narrowband UVB, not UVA. And other than biologics, as Dr. Ram Gyan Yadav has suggested, secukinumab, it's best for pregnancy. But yes, first we should advise that you give, at least don't conceive in winter so that it cannot exacerbate more. At least wait for 6 months, 3 to 6 months, then she should conceive.
Thank you, sir. Thank you. So, I think everything has been discussed by our panelists, but I am just summing it up. In the topical options, as we all know, the emollients, low potency steroids, tacrolimus are the safe options, and high potency steroids, coal tar and salicylic acid, and vitamin D analogs are to be used with caution, and the topical tazarotene is contraindicated. In systemic agents, the narrowband UVB phototherapy is safe. The PUVA, cyclosporine, apremilast are to be avoided, and methotrexate and acetratine are contraindicated. The safest biologic, as sir has told, the pegylated form of certolizumab lacks the FC fragment, so it is the safest biologic. The etanercept, Adalimumab and infliximab, the TNF alpha inhibitors are acceptable in early pregnancy, that is first trimester, but ustekinumab, the interleukin 17 inhibitors and 23 inhibitors are to be avoided because they lack the sufficient data. So coming to the next question, that he is a 55-year-old male with joint pain and deformity, progressive for 5 years. He has developed psoriatic plaques with nail changes for 1 year. The RF factor is negative. There is pain, swelling, deformity in the PIP, DIP, wrist, elbow and hip joints with reduced range of mobility and difficulty walking. The PASI is 7.4 and DLQI is 18. What combination therapies or biologics would you prefer, or would you like to combine both? The therapy, the conventional therapies with biologics, sir?
So as informed, it's a 55-year-old male with a lot of joint involvement. The PASI 7.4 is a bit low. DLQI is very high, 18. That means the quality of life needs to be improved. He has a lot of deformities and thereby different operational difficulties he must be having. So before going to biologic side, to like if allowed methotrexate plus leflunomide, methotrexate plus sulfasalazine, then if it's available, then biologics may be used.
Thank you, sir. Ramgan, sir.
As it has been seen that in these cases where there is associated psoriatic arthritis, then biologics will be best choice along with combination therapy. The biologics, like TNF alpha inhibitors, can be combined with methotrexate, which increases the efficacy, and also that ADA formation, anti-drug formation is also decreased, and survival has increased of TNF alpha inhibitors. But as the pathology has seen that in pathogenesis, interleukin 17 is the main interleukin that is causing psoriatic arthritis. So interleukin 17 inhibitors are best in these cases. And currently the trial has been done on bimekizumab that acts on both interleukin 17A and F, the two cytokines simultaneously. So that is coming off as a good therapy. And other interleukin 23 inhibitors are also very good in these cases.
Thank you, sir.
For psoriatic arthritis, still methotrexate I think is the gold standard. Yeah. We should prefer first methotrexate. Yeah, if we have to combine, then JAK inhibitors is also working good in arthritis, not in psoriasis, but yes, it shows some good results in arthritis. And if biologics is added, as Dr. Ram has mentioned, adalimumab, TNF alpha inhibitors, works well in joint pains.
Dr. Sanya?
Yes, as sir told, methotrexate will be preferred, and in combination with biologics like interleukin 17 inhibitor will be best, or TNF alpha inhibitor will also be.
Thank you, thank you.
Even tofacitinib is preferred by orthopedic surgeons. They also give for long time treatment for these arthritis and pains.
So firstly, I am decoding this case. It's a polyarticular disease with deformity leading to structural damage, and the patient is also having nail involvement, which is a predictor of worse prognosis with high impact on quality of life. As per the group for research and assessment of psoriasis and psoriatic arthritis guidelines, the combination therapy options are the conventional DMRDs with biologics. Why do we need to combine these therapies? The combination would be methotrexate with a biologic, especially TNF alpha inhibitors. It improves the joint outcomes, and it is useful when patient has peripheral arthritis with psoriasis and nail involvement. The combination would be the TNF alpha inhibitors can be combined with methotrexate, and with other biologics like interleukin 17, 23 inhibitors, methotrexate is optional, and JAK inhibitors, as Rajiv sir has told, they are also effective as monotherapy and used after biologic failure and in cases of severe diseases. So based on the phenotype of this case, the best choice would be an interleukin 17 inhibitor, that is secukinumab or exekizumab. It has the strongest evidence for peripheral arthritis with nail disease and DRP arthritis with skin disease. The EXCEED and SPIRIT trials have shown excellent joint outcomes with interleukin 17 inhibitors, and the other options are TNF alpha inhibitors and interleukin 23 inhibitors. So moving ahead, so a middle-aged obese male with BMI 33 has a partial response to secukinumab after 6 months. Is dose escalation justified, or should we switch to an interleukin 23 inhibitor considering obesity's effect on response?
Yes, obesity usually lead to increased interleukin 17, and I think we should first increase the dose of secukinumab to 300 g, and if not, then we can switch to interleukin 23 inhibitors.
Thank you.
Is that obesity usually affect the effect of secukinumab. If the person is more obese, like more than 90 kg, and still we are using 150 mg of secukinumab, then we have to increase it to the maximum optimal dose of 300 mg, and even if that is not working, or if we are not getting response with even 300 mg, then we can change to shift to interleukin 23 inhibitors.
Manoj, sir?
If I would have been treating this patient, taking into account the factor of obesity, I would like to switch over to secukinumab or an IL-23 inhibitor like guselkumab.
Thank you, sir.
Other than increasing the dose of secukinumab.
So the question here is, does obesity affect interleukin 17 inhibitor response? Yes. The multiple real-world studies show reduced efficacy of interleukin 17 inhibitors in patients with high BMI. The obesity causes increased interleukin 17 production from adipose tissue, high drug clearance due to larger volume of distribution, and more severe baseline inflammation. So obesity predicts suboptimal response to interleukin 17A inhibitors. Next question was, is secukinumab dose escalation justified in obesity? Yes. If the current dose is 150 milligram, then the secukinumab has two doses, that is 150 and 300. For high body weight, more than 90 kgs, and for partial responders and for difficult to treat sites, escalating to 300 milligram is evidence-based and commonly effective. If the patient is already on 300 milligram, the dose escalation beyond 300 milligram is not recommended, then we can consider switching. For switching, the best option would be interleukin 23 inhibitor. Why interleukin 23 inhibitors? Because it does not significantly, the obesity does not significantly reduce the interleukin 23 inhibitors efficacy. When to switch? If the patient is already on secukinumab higher dose, and if PASI 75 is less than 75 and there are persistent plaques even after 5 to 6 months of therapy, then we can consider switching. Now coming to my last question, sir, a patient is stabilized on biologics, asks for longer dosing intervals due to travel or financial constraints. When is the interval extension reasonable, and what clinical indicators suggest this will risk the disease rebound while prolonging the duration, sir?
If we are to encounter the patient who requests for a longer dosing interval spacing, then we have to see if the patient is already stable on the current therapy or not. If the patient is having added features like scalp psoriasis, nail psoriasis, psoriatic arthritis, what is the PASI score? Is it 0, 1 or more than 5? So basically a patient who is well maintained, is not having any extra features of psoriasis, and is on a longer half-life based molecule like guselkumab or IL-23 inhibitors, then we can go for this interval spacing, in my opinion.
Thank you, sir.
See, usually in our field it happens that when patients get cured, they automatically switch the doses.
Yes.
So it's not, we have to counsel that don't switch, and if he is traveling or there is financial constraints, then we can think to increase for say 2-3 months maximum, not more than that.
Thank
but
you, sir.
it happens in our field, patients only, they don't turn up when they get cured.
Ram, sir, in your opinion?
Yes, as sir said, the first we have to see the disease severity, whether it has completely normalized or not. The PASI has decreased to less than 2, or there is other site like scalp, palm and sole, those sites are involved or not. And also we have to see the history of reboundness, like recurrence in those cases. If those things are there, then we should not advise the longer duration of treatment. But if everything is fine, then we can ask the patient, we can increase the duration of dosing for the biologics.
Thank you.
Yes, as I said, if the disease is controlled, we can, we will not switch, but we can increase the interval extension if cost is the issue for the patient. But
Thank you. So I'm discussing the stepwise guidelines of extension or prolonging the duration. So the first step is to know whether the disease is well controlled after 6 to 12 months of therapy or not. By being well controlled, I mean PASI less than 2, body surface area less than 3%, and dual QI less than 5. In cases of psoriatic arthritis, the minimum dose, minimum disease activity has been achieved. If yes, we can proceed. If no, then we cannot extend the interval. If for step 2, we have to see is the biologic the patient is taking is suitable for dosing extension or not. The best choices are the one with longer half-life, that is the interleukin-23 inhibitors. The moderately acceptable ones are interleukin-17 inhibitors and etanercept, whereas the poor choice with faster rebounds are adalimumab, infliximab, and certolizumab. If the biologics is suitable, then we can proceed for interval extension. In step 3, we have to see the high-risk domains of the disease. As sir has discussed, are they active or not? The high-risk disease domains are nail psoriasis, scalp psoriasis, palmoplantar disease, recent onset microlesions, enthesitis or axial symptoms. If these symptoms are not present, then we can go for interval extension. Then in step 4, we look for the patient level risk factors for rebound of the disease. If the patient has a history of early relapse or delayed dose, and the patient is irregular or adherent, then the risk for rebound is higher. And also if the patient is obese, has a high baseline PASI, is a smoker having metabolic syndrome, then also the risk for rebound is higher. In step 5, if all the checks are favorable, then safe interval extension can be done. How it is meant to be done? So adalimumab can be prolonged from 2 weeks to 3 weeks. The secukinumab can be prolonged from 4 weeks to 5 to 6 weeks. The guselkumab from 10 to 12 weeks. And we have to reassess the patient every 8 to 12 weeks. If there is flare, we have to return immediately to the standard dosing. Thank you, everyone. Evidence grows as experience guides. I would like to thank all my panelists, respected Manoj sir, Rajiv sir, Ramgyan sir, and Dr. Sania for their valuable inputs in this panel discussion. Thank you, everyone.
That was a very short and crisp panel. Thank you, Dr. Mohammad Mubarak Hussain, for such a fabulous panel on biologics. I would request our moderator and panelists to please collect their memento. Moving forward, for the next session, I would like to invite Dr. Deepak Kumar Patel sir and Dr. Manoj Kumar Chaudhary sir to please chair the next session.
So without delaying the sessions, since we are running late in fact, on being on times. That is our prime objectives. And I would be liking to call that same means Dr. Sri Chandan and requesting him to be precise on time also. And in his decorations, he is a postgraduate and consultant skin BD in skin and BD, and he is from Bhubaneswar itself, and academically presented 10 plus presentations and publication, 2 publications gone in his name, and a brief bios case is that in say reviewer of Indian Journal of Dermatology, life member of IADL, ASIs, and so and so. Sri Chandra.
Respected Chair and friends, my topic is triggers, relapse and remissions predicting the course of autoimmune bullous diseases in a real world practice. So autoimmune bullous disease is blistering skin diseases that are a heterogeneous group of disorders associated with autoantibodies that are directed against one, desmosomal structures as in pemphigus, hemidesmosomal ones in pemphigoid diseases, and epidermal or tissue transglutins in dermatitis herpetiformis. So these are the target antigens of pemphigus vulgaris, foliaceus, paraneoplastic pemphigus, and IgA pemphigus, the pemphigus group, desmoglein 3 and 1 mostly. And in the pemphigoid group, BP 180, BP 130, and allied antigens, hemidesmosomal structures. And in other diseases in the group, bullous SLE, type 1 and type 2, type 1 and type 7 collagens, LP pemphigoidis, BP 180, and dermatitis herpetiformis, TG both epidermal and tissue type. So the targets may be desmosomal and hemidesmosomal, as we said, and proposed mechanism for most accepted pemphigus trigger factors is sulfhydryl group, phenol group among food and drugs, and estrogen level during levels tilt TH1 and TH2 balance towards TH2, and an immune response targeting microbial agents, infections or vaccinations that cross react, that is molecular mimicry, and ionizing radiations could alter skin antigen expression, unmasking hidden epitopes and inducing an autoimmune response in predisposed skins. So these are the proposed mechanisms of how autoimmune blistering happens. And what are the predisposing factors? Patients with pemphigus vulgaris have marked increase of the frequency of class 2 MSC antigens like HLA DQ1, HLA DQ4. And this International Pemphigus and Pemphigoid Foundation says certain populations such as people of Jewish ancestry, inhabitants of India, Southeast Europe, Middle East are at greater risk of pemphigus vulgaris. And again, continuing with the triggers in pemphigus vulgaris, triggers such as drugs, infections, etc. could induce pemphigus in the presence or absence of predisposing factors. However, in the majority, no conclusive trigger can be evaluated. In fact, most triggers reported in this particular review that you see on the screen did not mechanistically confirmed. And in Fitzpatrick, we'll find that association with penicillamine and perhaps captopril is most significant. In which case, pemphigus, affects more pemphigus foliaceus than vulgaris. And again, in International Pemphigus and Pemphigoid Foundation says UV and ionizing radiation, electrical injury, burns, and pesticides could be significant trigger factors. So continuing with the triggers, that garlic, leek, and onions can act as in rare anecdotal reports. And interestingly, Fitzpatrick mentions cigarette smoking improves pemphigus vulgaris in anecdotal cases. As I was discussing in the hall with Dr. Bikas, I mean, at some point of time, nicotinamide tablets were available for treatment of pemphigus also. So people will naturally ask about the food association of different diseases. No consultation is complete without a food question. So there will be lot of foods, and the popular villains are garlic, onion, baingan, red chilies, tomato, and all that. So those who want those things, there is a review one can go through. And regarding triggers, can act as a triggering, Koebner phenomenon has been reported in pemphigus vulgaris also, and pemphigus as a post-herpetic isotope response has been reported too. So herpetiform pemphigus developing after herpes zoster may represent a rare manifestation of isotopic response. Clinicians should consider immune-related bullous diseases in the post-herpetic skin lesions. So even air pollution. So yes, there has been papers produced, published, which says that air pollution may impact disease activity in bullous pemphigoid to a greater extent than in pemphigus. So what is the relapse mechanism? Pemphigus develops due to the production of anti-DSG1 and DSG3 antibodies by errant autoreactive B cells. Rituximab acts by removing such B cell clonal populations. So risk factors and agents, greater than 50% pemphigus patients experience relapse. Risk factors include high body surface area involvement, high body mass index, high severity according to pemphigus disease area index, PDAI, and treatment delay, high DSG1, DSG3 titers post-treatments. So rituximab is gold standard treatment for moderate to severe pemphigus. Relapse rates range in the area of 11 to 44%, with a mean relapse rate at 6 to 36 months following treatment of rituximab. More frequent dosing, earlier treatment, and higher cumulative dosing were associated with lower relapse rates. Alternative agents that have clinically efficacy include corticosteroid monotherapy, mycophenolate mofetil, azathioprine, and intravenous immunoglobulin. So relapse with corticosteroids said that in the long run, whether high dose or moderate dose, the prognosis, long-term prognosis remains the same. And among the adjuvants, it was, there are the, you can see in the table, prednisone alone 30%, prednisolone plus azathioprine 32%, prednisolone with mycophenolate mofetil 29%, prednisolone and cyclophosphamide 35%. It is not prudent to compare the percentages on their own because the studies were different and it was just a meta-analysis. So you can say that they are more or less same. And predicting the relapse in pemphigus, higher baseline pruritus and longer remission predict pemphigus relapse. Anti-DSG1, anti-IgG at remission onset indicates relapse risk. This is a very important paper. Interestingly, from PGI, and positive anti-DSG1 and anti-DSG3 plus DIF after remission predicts relapse. So this is a very important paper and relevant to our topic today. This underscores regular monitoring of anti-DSG1 and 3 during disease course, especially after remission. They say our data suggests a performance of DIF before complete tapering up of immunosuppressive. So DIF being an invasive process, sometimes difficult to arrange. So in another publication, they have suggested DIF on plugged hair outer root sheath can predict relapse in pemphigus vulgaris because biopsy DIF is cumbersome. Can it be replaced by plugged hair? So that was the question they asked, and their conclusion is outer root sheath DIF is reliable predictor of pemphigus vulgaris clinical relapse and demonstrated robust correlations with skin biopsy DIF and anti-DSG antibody titers. Periodic assessment of outer root sheath DIF aids in determining new onset positivity that heralds clinical relapse. So this paper from PGI Chandigarh. And there was a discussion in a group. Many of my friends in the audience may be the member of that group. And I thought whether I'll put them on a public platform. But again, the participants were authors themselves, whose paper I am citing. So I went ahead. The AIM study said anti-DSG to be better predictor of relapse. Anti-DSG1 correlates better with disease activity. Anti-DSG to be a better predictor of relapse than anti-DSG1. So this is the AIMS findings. And then there was an interaction between the PGI team and the AIMS team, and the consensus was, AIMS says, we don't rely on any biomarkers now, just close follow-up. PGI answers, yes, close clinical follow-up, that is the key. For patients treated with prednisolone and oral adjuvant, ORS DIF after 3 months of steroid withdrawal to decide adjuvant withdrawal, repeated every 3 months. This is very important. And again they say, for patients treated with prednisolone and rituximab, no immunological follow-up. We do not use maintenance rituximab. We use 500 milligram rituximab for induction of remission in mild to moderate relapses, as and when they happen. So this is the consensus, Indian consensus, you can say. So bullous pemphigoid, it's a group of subepidermal blistering autoimmune disease that primarily affect the skin. Localized variants of the condition have been reported. Autoantibodies, anti-BP180 and BP230 are directed against the basal cell of the epidermal mucosa. And the disease tends to be chronic, lasting months and years, with the relapse rate being 73% and followed by remissions. A serious condition in the elderly, BP can undergo self-cure in 2 to 5 years. Two main types of pemphigoid, bullous pemphigoid and mucous membrane pemphigoid, also known as psychiatrical pemphigoid. Scar formation in, psychiatrical pemphigoid can lead to major disability. Relapse mechanisms include incomplete beta cell depletion by treatments like rituximab, allowing residential autoreactive cells to persist, and the re-emergence of autoreactive clones, same as pemphigus, exactly same as what happens in pemphigus. And relapse in bullous pemphigoid was studied in a study which says that the propensity for relapse in bullous pemphigoid considered a poor prognostic indicator. Previous research has reported 1-year relapse rate of bullous pemphigoid ranging from 28% to 53%. In this study, it was 22%, which is lower. Most relapse attributed to patients self-adjusting their medications. And this underscores the importance of counseling, that patients should not adjust their doses themselves. Furthermore, anti-BP180 antibody, comorbidities, and disease severity, that is, more than 10% of body surface area involvement at baseline were identified as risk factor for relapse in bullous pemphigoid. Among the relapse patients, approximately 31% experienced recurrences after achieving total, CROT, that is, somebody being without any symptoms, without any drugs. So I'm not getting the actual full form right now, indicating that attention should also be paid to those individuals who are free of BP. That means once you become symptom free, even without drugs. So relapse in BP, the relapse rate of BP ranges from 28 to 53%. Aging, disease severity, neurological disorders like Alzheimer's disease, and different serum markers levels have shown to be related to relapse. Confirmation studies are needed before using them as relapse in the relapse prevention. We propose to select optimal treatment options with low dose corticosteroid adherence for relapse prevention, and current evidence has demonstrated the longer usage of corticosteroid with a low dose, combination of immunosuppressive suppressants and IVIG helpful in lowering relapse rate. Treatment approach of pemphigus and pemphigoid, corticosteroids, particularly prednisolone, remains still the most important pharmacological agent for pemphigoid and pemphigus. However, rituximab is an effective pharmacological alternative for pemphigus, while the use of clobetasol propionate is increasing and becoming as one of the preferred treatments of pemphigoid. And in certain studies, they have found to be equal to oral steroids if properly used. And among the newer treatments, there is tofacitinib. As a steroid-sparing agent in pemphigus, it can be used. And dupilumab has been used in, treatment-resistant pemphigus and has been successful, that in recalcitrant pemphigus vulgaris. Adjuvants used in bullous pemphigoid include azathioprine, doxycycline, mycophenolate mofetil, methotrexate, dapsone, cyclosporin, and rituximab. And regarding biologics in pemphigoid, rituximab and dupilumab both have been used and found to be useful. And JAK inhibitors used in bullous pemphigoid, upadacitinib and tofacitinib both have been found to be useful in bullous pemphigoid. So in dermatitis herpetiformis, gluten-free, lifelong gluten-free diet and dapsone are the useful therapeutic interventions. So summing up, autoimmune blistering skin diseases are a heterogeneous group of disorders associated with autoantibodies that are directed against cell wall components. AIDB have prolonged course lasting years and even decades marked by remissions and relapses. It is important to understand triggers, risk factors to prevent and manage flares. Markers in pemphigus are both clinical as well as serological that they have to be monitored to anticipate flares and institute therapeutic responses. So that brings to the end of my presentation. Thank you.
Okay. Thank you, Dr. Sri Chandan. It was a nice presentation with very informative session as well. I hope this session must be very informative to all the attending delegates out here. Thank you. Any queries about the session? Now the forum is open for discussion. If any queries from audiences.
Thank you.
Now as time is going on, Swastika Suviria is the next speaker. He is a professor and head King George Medical University, Lucknow, and he has having a good academic scenario also, presented 42 presentations and publications, gone to be 74. And in bias case, he is having, very long listed, biomarkers particularly. So it's a better, Suviria, you start.
Thank you, chairpersons, for the kind introduction. My topic, I'll be deliberating on the topic today, autoimmune bullous dermatosis, expanding the clinical horizon. So the previous speaker has made my job easy. Sir has already covered the pathogenesis and types of pemphigus. So AIBD, we all know, is a diverse group of blistering diseases caused by autoantibodies against structural skin components. And the spectrum as such for AIBD, they were expanding with the discovery of new antigens, overlap syndrome, and drug-induced forms. So, but we often ignore the common diseases with uncommon presentations, which are often overlooked or misdiagnosed. Through my presentation, I'll be running few case scenarios of these uncommon presentations. So we all know we classify AIBD depending on whether the blister level is intraepidermal, the pemphigus group, including vulgaris, foliaceous, IgA pemphigus, IgG/IgA pemphigus, paraneoplastic pemphigus or pemphigus herpetiformis, the subepidermal group, which includes bullous pemphigoid, MMP, linear IgA, and the others. So there are some uncommon and unusual variants of AIBDs, which are less frequently reported, like PNP, the IgG or IgA pemphigus, oral lichenoid pigmentation, and for the pemphigoid, we have some other uncommon presentations like acral purpura in dermatitis herpetiformis, the mixed linear IgG or IgA pemphigoid, the granular C3 pemphigoid, and others. So pathogenesis, we all know in AIBD, the key mechanism is cutaneous immune dysregulation. The IgG antibodies are directed against desmosomal proteins in pemphigus and hemidesmosomal in pemphigoid group. It results in blisters and erosions of the skin and mucous membrane. So if you look at the diagnostic workflow, we all know, depending on the clinical features, we do a HE or direct immunofluorescence, and depending on the pattern seen there, we further go on to do IIF or immunoassays to know the main antigen, and accordingly, we come at, by amalgamation of these, all these clinical and these detailed workflow, we come at the final diagnosis, whether the disease would fit into BP, DH, PF, or PV. So I'd be running through some uncommon presentations of intraepidermal AIBDs. So my first case scenario relates to a 44-year-old female. She presented with annular pustular plaques on the body for 2 years, extremely itchy, along with some oral erosions. As is visualized in the picture, she also had some pustular lesions on the palms as well as the soles. So what could be the diagnosis here? So anybody? Okay. Anybody, the diagnosis here could be guessed? The patient is presenting with annular pustular plaques for last 1 year, yes? Linear IgA. Any other diagnosis? Okay. So we did a HE. The blister here reported was subepidermal. Bulla was reported. And we could get IgA, the fishnet pattern of IgG. And the diagnosis here was annular pemphigus vulgaris. What was happening, the old lesions were all healing, and around the old lesions, the new lesions were forming, and somehow the lesions were acquiring an annular shape. So looking at the patient, the first thing that we could think of was the IgA pemphigus. But yes, on a detailed workup, and we looked into the literature, yes, this annular presentation of pemphigus vulgaris per se has been reported in pregnant patients. This has been published in Dermatology Online Journal. And here the disease was primarily pustular. It was not vesicular. Now this presentation has also been reported. The pustules here were all sterile. We didn't need antibiotics. We did repeated pus culture sensitivity. The patient did respond nicely to low-dose steroids and rituximab. So pemphigus could also present primarily as a pustular disorder. So this was case scenario 2. Now this patient was a case of chronic recalcitrant dermatophytosis for 1 year. She was a little non-compliant with the therapy, but she had florid tinea on the body, including tinea cruri, corporis, and onychomycosis of the finger as well as the toenail. What happens is she returns to us with oral erosions for 2 months, and she was getting some, if you could see, she was getting some erosive lesions on the border of the tinea plaque here, and also they were present discretely other than the plaque also. So what was happening? Again, we did a HE. We got a suprabasal blister. A pars in QH mount was positive for fungal hyphae. In the blister also, pars positive hyphae was seen. I haven't put that picture. And again, the DIF is so characteristic, is the fishnet pattern seen in pemphigus vulgaris. So the diagnosis here was coexistent dermatophytosis with pemphigus vulgaris. The patient was managed with rituximab, azathioprine, and itraconazole. We tried avoiding oral steroid, which was used only for 1 to 2 weeks, and then that was tapered off in view of profound tinea. So what is unusual about the lesions occurring at the site of tinea? Again, we looked into the literature. Now, is this Keebnerization? Because the patient reported for the new onset of AIBD after the diagnosis of dermatophytosis. So it does not really fit into the diagnosis of dermatophytosis. So this paper was reported from PGI Chandigarh. And in their series, they have reported 4 out of 6 cases of PV occurring like this, 1 case of cicatricial pemphigoid or MMP, and 1 case of bullous pemphigoid occurring simultaneously along with on the tinea plaque and other than the tinea plaque. So the hypothesis that they proposed is that fungi probably release some proteases which exposes some cryptic skin antigens and leads to the new autoantibody formation and hence the blisters, some molecular mimicry because of the increased expression of IgG or IgE4 and IgE, which cross-react with the epidermal antigens, or increased expression of TLR2 and 4, which again would lead to a trigger pemphigus-like response. But yes, there is more research that is still required, what was occurring here in this patient, and this is much more than a mere coincidence, and it cannot be labeled as Keebner's. Now this was again very interesting case. If you look at only the first picture, she had this crusting on the lips, lichenoid pigmentation here. And other than that, the patient had no complaints. Then we did a routine examination, examined her body all over. We could see some erosions here in the labia minora, some cervical erosions as well, and profound cervical discharge. So looking at the first picture, if you don't look at the genital pics, what could be the diagnosis? This patient landing into the OPD, the first thing, and she complained of extreme weight loss. So what could be the probable diagnosis we think of? With this lichenoid hue, this crusting on the lips, We thought of PNP, paraneoplastic pemphigus, but yes, we took other history. She had no loss of appetite, but because of the extensive oral erosions, probably the intake was so low that she has extensive weight loss. And again, a suprabasal blister was seen along with a fishnet pattern on IgG pemphigus. We did an ELISA as well. The desmoglein 3 titers were higher than desmoglein 1. So we all know a mucosal predominant form of pemphigus is there. We always see the oral cases. We forget to examine the patient completely. So genital mucosa is the second most common site involved after the oral cavity. Highlights the need for a thoropelvic examination. And what was the need for, what was the reason for the cervical discharge in this patient? Again, it was non-infective. It was just an exudate because of pemphigus. So in this series, what they reported is 51% patients had genital PV, labia minora was involved in 92%, vagina in 35% and cervix in 15%. We also did a pap smear which showed inflammatory changes, and the same has been reported. The majority would show inflammatory changes, and the dysplastic pathology is noted only in 6%. So this variant of PV mainly limited to the mucosa, and genital mucosa is the second commonest site, should be thoroughly examined. Another interesting case would be dismissed in your routine OPD as a case of pomphylix. A 24-year-old female, she was actually not responding to the treatment, topical steroid, and that's why the resident got this patient to me. She had a 2-year history of vesiculopustular lesion when we took a detailed history, forming annular plaques. As you can see, the lesions are all annular. But compared to the first case, if you look at this case and the case 1, the picture looks similar. So the lesions were annular pustular plaques. We did a HE again. Subcorneal blisters were identified. And IgA was found only in the upper intraepidermal layers. IAF and ELISA was negative for desmoglein 1 and 3. Desmocolin could not be tested. And hence, we made a diagnosis of dyshydrosiform SPD type of IgA pemphigus. We know these are of 2 types, IgA pemphigus, SPD and IED. So patient was started on dapsone and she had a good improvement. There was marked improvement in 2 months. We didn't need to add any other thing. So dapsone worked wonderfully. So a systematic review has been published in JAD in 20 by Credin et al. On IgA pemphigus, which shows that palmoplantar involvement, though uncommon in IgA pemphigus, is possible in around 3% of the patient. And these patients, you need to diagnose them basically mostly on DIF. The pattern is almost universal intercellular IgA on DIF as in our case. And the IAF is generally has low positivity. The circulating antibodies are low. So IAF won't be of much yield. But yes, you need to investigate them for other associated IgA gammopathy and ulcerative colitis in a minority of patients. Another interesting case, this was a homeopathic doctor. He's referred to us. He was on treatment for renal cell carcinoma. And for the last RCC with pulmonary meds for 3 years, he had developed oral mucositis for 3 months. And on examination, he gave history of some bullae which were erupting. Presently, there were no bullae when we examined, only PIH. And there were some plaques, you could see, with lichenoid hue on the palms, some mucositis which was here. The lips as such were not involved. And what the oncologist has suspected it to be a drug reaction, a suspected ADR, his chemo had been stopped. So we made a diagnosis of PNP, possible PNP, and we proceeded with the investigations for this patient. Biopsy, we could get lichenoid interface dermatitis, and DIF here was negative. So once this is the guideline by the S2K guidelines on the management of PNP, published in JEADV, which says, if you have a clinical suspicion of PNP, you need to perform HE, DIF, ELISA. If it is positive for anti-envoplakin antibodies by ELISA and or positive on rat bladder epithelium, PNP is confirmed. Still, it's negative, go in for desmoplakin, periplakin. AML2, positive is confirmed. No, you go for desmoglein, desmocolin or BP antibodies, yes, then PNP is possible. So if on HE, you're getting acantholysis and interface dermatitis at light microscopy, but a DIF is negative, still you can keep a diagnosis of PNP possible. So PNP is rarely associated with solid malignancy, but yes, cases have been reported, that one by Dr. Deepika Pandey, renal cell carcinoma induced PNP, and DIF or serology may be negative in PNP due to extensive tissue damage, low antibody titer, or when the T cell could be the dominant immune response. So this was another interesting case admitted during COVID time, so the pictures are not very nice. What you can see, these were areolar plaques here in the flexural areas. Then again one near the hand, and here this is a typical crusted plaques, what we see. So anybody, what could be the diagnosis here, looking at the clinical scenario? What could be the diagnosis here? We have two kinds of lesions, one the annular, and one is the typical crusted plaques. And yes, the patient did have some oral erosions. So this was a 40-year-old male. Again, HE showed suprabasal split with acantholysis. DIF was positive both for IgG and IgA. So this is classical for IgG pemphigus, and these annular plaques, these are classical for IgA pemphigus. You're getting both IgG and IgA positive in a fishnet pattern. IgG/IgA pemphigus again is a rare entity. We need to know about this entity because dapsone will have a good effect along with steroids. So diagnosis was IgG-IgA overlap. Treatment were given was oral steroids with rituximab. So less literature has been published on IgG and IgA pemphigus. I could come across this paper where they made a table comparing their study with others. The number of patients in all these studies has been low, you see, 22, 13, and 30. The presentation is generally in the form of annular erythema or mucosal lesions. You should know how to differentiate it. Dapsone would be a good drug, though it's commonly misdiagnosed, and dapsone would be a good choice of drug. And yes, in DIF you get the dual IgG and IgA deposition. So again, some say it could be pemphigus herpetiformis, it could, why not IgA pemphigus? So these are some key features. You need to differentiate. Mucosal involvement is more common in IgG/IgA pemphigus. The annular lesions are more common. The acantholysis again is 17.4 to 100% in IgG/IgA pemphigus. Intraepidermal neutrophils are again more common this side, 40 to 80% around. Eosinophils, intraepidermal eosinophils will be more common in herpetiformis. And DIF will show the IgG pattern 100% along with IgA, and here the response can be variable in herpetiformis as compared to 20% positivity in IgA pemphigus. And what is the antibody you get? It's the IgG predominant disease, herpetiformis. In IgA pemphigus is IgA, and IgG/IgA pemphigus would have both positivity. Now we'd quickly run through some uncommon presentation of subepidermal AIBDs. So anybody, what's the diagnosis here? Again, extensive cutaneous erosions, all crusted plaques, and the oral erosions were also severe. Just looking at this picture, anybody, what could be the diagnosis? We thought of pemphigus vulgaris unless we looked here at the eyes. We tried to pull the eyes, there was snaky formation. This was a 28-year-old male who presented with large cutaneous crusted plaques. The HT showed subepidermal bulla, DIF showed a linear pattern. There was flow blinding seen on salt split skin. On knockout substrate skin testing, it was positive on collagen 7 deficient skin. So the diagnosis was anti-laminin 332 MMP. And the patient was treated with oral steroids and cyclophosphamide, and there was a good response. Generally, in MMP, you don't get such extensive cutaneous erosions. This patient was also unusual. So it tells you about the importance of a thorough clinical examination as well. So anti-laminin 332 MMP is generally associated with tumors, in solid tumors in 25 to 30% of the cases. So you need to investigate your patient thoroughly. We did the same for our patient. A CT neck for the base of the bladder was done. PET CT was not available at that time, which was negative. So accordingly, we treated the patient. Another interesting case came recently, a case of MMP who had reported with recent onset hoarseness of voice, new onset hoarseness of voice, and she was very dyspneic when she came to us. Again, we did a detailed workup, and here the knockout skin substrate testing on the antigen deficient skin suggested type C7 collagen as the antigen. So again, the treatment protocol remains the same, but now what the latest guidelines says that the 2021 S3 guidelines classify collagen 7 positive mucosal disease as MMP. So the moment we see collagen 7, we try to label our patient as EBA. So if it is mucosal predominant disease, collagen 7 is there. It has been reported even in MMP in a minority of cases, around 4%. So these variants require early aggressive systemic therapy. Again, laryngeal MMP is uncommon. Because of high risk, it can cause airway scarring, stenosis, and voice compromise. So the patient should be managed very aggressively.
Dr. Subiria.
Yeah, I just wind up.
So just you try to make it fast.
Yeah. This is the second case, again with laryngeal involvement. What is highlighted here is the unusual paronychia. Paronychia is rarely reported with MMP. What could be the reason is BNZ targeting the MMP autoantibodies here. This is the last case. Now again, he was a case of CA stomach, recently diagnosed, and after the diagnosis, he is presenting with this concentric pattern of bullae. The middle is hemorrhagic, the surrounding is clear fluid, probably because of the different age of the bullae. There's the old one, there's the new one. So finally, a diagnosis after HE and DIF was a targetoid variety of paraneoplastic BP. BP as such is associated with malignancy only in 11% of the cases. And anti-laminin 332 BP is the one which is strongly associated. Targetoid BP is generally drug-induced, but it could be idiopathic as well. In this case also, the chemo was stopped by the oncologist. We started him on doxy, and the patient was suggested to return to the oncologist to continue his treatment. It was just a paraneoplastic phenomenon, BP presenting in an unusual morphological pattern. So the take-home message is AIBDs form a biological continuum with overlap phenotypes, and accurate diagnosis requires integrated assessment, depending on your clinical morphology, histology, DIF, and antigen-specific assays. And you need to stratify this patient exactly to enable targeted therapy and hence reduce morbidity for the AIBDs. So thank you. Thank you, the organizers, for giving me this opportunity.
Thank you, Dr. Subriya. It was very informative, and you have compiled so much of atypical cases, which many of us working daily has thought and making us think out of the box to clinically diagnose a case and work it out properly so that we can reach to a diagnosis and treat the patient properly. Thank you for the presentation. And any queries in these cases from the audiences? Okay, there's none. Thank you.
Good morning, all of you. So, at the outset, thanks to team IDWL Bihar for letting me this chance to moderate. So, let me be inviting my panelist of the day, Dr. Rakhi Gupta, Associate Professor, Department of Dermatology from AIIMS Patna. Ma'am, please. My second panelist would be Dr. Pankaj Tiwari. Sir is an Associate Professor from PMCH Patna. Dr. Deepayan Pandey, who is a Consultant Dermatologist from Nepal. Sir, please. And final panelist of the day would be Dr. Akanksha Singh. Ma'am is a Consultant Dermatologist from Patna. So that was too exciting to know about a lot of atypical presentations of autoimmune bullous disorder. I must congratulate ma'am. And but here now we'll discuss only typical cases with more focus on the management. Hope my panelists are comfortably seated. Shall we begin, sir? So I request to be very brief so that we can finish in time. We have only 3 cases, and mostly the focus will be on the management part. So to begin with, so this first case is an 86-year-old female diabetic with lot of comorbidities. She is hypertensive, she is hypothyroid as well, and she is on polypharmacy, termicertin 80, thyroxine, antihypertensives, and the clinical picture is quite clear. She has urticated plaques with tense blistering, and the distribution of the lesions over the body is quite high. So we worked upon her, and this is the DIF. There is a linear deposit of C3 along the dermoepidermal junction, and this is the histopathology. We can see there is a clefting here, subepidermal, with lot of neutrophils and eosinophils. Now, hope the diagnosis is pretty clear to all of you. Sir, this is bullous pemphigoid, right?
Yeah.
So now we shall be discussing how to manage this. Mostly bullous pemphigoid is a disease of the elderly, and they come with a lot of comorbidities, and they are on polypharmacies. This particular lady had a disease area index of 120, quite severe, and anemic. She had a raised IgE. So with this background, my first question would be, so we are clear with the diagnosis and the comorbidities and the conditions prevailing with her. So what do you feel are the poor prognostic factors in this case? To begin with, Dr. Pankaj?
Yeah. All cases of bullous pemphigoid, they usually come to us in the higher age group side, like in this case also. And age, higher you go, the poorer prognosis will be there. So age is the first important factor. Then any other comorbidity, if there is any kind of neurological involvement, high BPDI, the bullous pemphigoid disease activity score, the higher you go, the poorer will be the prognosis. Serum IgE level, the higher side gives you a good chance to explore other biologics like omalizumab. But age and neurological manifestation and severity, these 3 things, in my opinion, are the most important for prognosis part.
So do you consider raised IgE as a poor prognostic?
No, not poor. No, I was saying that raised IgE
That
will give you
a
more option in your treatment part.
Any other panelists would like
Yes,
to
sir.
add?
In my view, the most important that we consider for prognostic factor is the severity index, because bullous pemphigoid is the mostly seen as the advanced stage. That is also important, but the most important should be the severity, because bullous pemphigoid disease activity index is so much high. And next, yes, there is comorbidity, hypertensive also. And the next, if you consider about the IgE level, then I think that is not so much. But the most important should be the severity index.
And do you believe, ma'am, the antibody, is it working? It's not working. Hello? Huh. And do you believe, ma'am, the quantity, the titer of the antibody, anti-BPAG 1 or 2, is that a poor prognostic factor?
Yeah, that may be, because if the level will be high, then there will be more chances of severity.
Absolutely, well said. So these are the prognostic factors which are associated with a poorer outcome. Concomitant neurological diseases also indicate a poor outcome, poor general condition, and long-term use. If the patient has a long-term use of high-dose corticosteroids, that also implies
that prone to immunosuppression.
That immunosuppression, and that implies that they will not respond to.
Exactly. And also prone to the secondary infection, chances of secondary infection.
At this age, osteoporosis, glaucoma.
Yeah, osteoporosis.
And I'd like to add whether the patient has been on any drugs, concomitant drugs he has been taking or not.
We'll come to that, sir.
Yeah.
We'll come to that. Okay. So in this case, pertaining to this case, Dr. Akanksha, please, what would be your therapeutic armamentarium?
Taking in consideration the concomitant conditions like hypertension and diabetes also the patient is having, we can consider dapsone, but some short course of steroid is compulsory, I think, for remission.
So you would like to add dapsone? No doubt you have to use short course of steroids because they won't respond faster.
Yes, sir.
My question to all the panelists, do you find dapsone as a monotherapy effective in your cases of bullous pemphigoid?
No, sir, I think dapsone as a monotherapy, as we saw, it's not so much effective. We can give, but not so much effective. Because there is also chances of saturation fall or hemolysis. So it's not so much used as a monotherapy.
As a matter of fact, dapsone has been tried as a co-therapy, adjuvant therapy.
As a co-therapy.
High potent
As a
corticosteroids.
co-therapy.
So would you consider mycophenolate MMF mycophenolate, methotrexate, omalizumab, any of these in this particular case? Anyone
I
can take up
think
this
in
question.
this particular, first we should plan to stop the progression of disease. In that condition, I think we can start the short course of systemic steroid under coverage of considering the BP, and then we can plan for other drug like mycophenolate. We can also plan for rituximab.
She has anemia, ma'am. She
Yes.
has anemia.
Yeah,
No doubt we have to give steroids, but question is what next? What next will be ideally suitable for this patient, 86-year-old? In fact, this is our own patient.
Maybe omalizumab.
A combination of prednisolone and mycophenolate would be my first choice in this case. And as IgE level was higher, so omalizumab will definitely give some kind of, and it's safer also.
Would you like to consider IVIG as a rescue therapy?
That is reserved drug, sir. We will put for reserve.
We have to discuss all options. Yes. But if there is a concomitant infection, then IVIG definitely
IVIG
stands.
we have given in a number of patients in severe bullous pemphigoid as well as severe pemphigus vulgaris, because at that time we don't have much options. IVIG give you a rapid response. So if it is available in your hospital or in that kind of setting, fortunately we have that. So we used to give, and we get very good results. Initial remission, the control of disease. So IVIG is always...
Particularly IVIG will be a suitable drug if there is a conconcomitant infection and no other immunosuppressives.
No other options you have, then you can go
for
to
that
IVIG.
matter, omalizumab is also an ideal drug in this case because it is
If
not
the
an
IgE level is
immunosuppressive.
not very much raised, then we have seen that omalizumab doesn't give such
dramatic results.
response in high IgE compared to high IgE level cases.
In this case, we can consider because hemoglobin is also low.
In fact, we have
IgG is high,
treated this case with steroids, methotrexate and omalizumab, and the lady is recovered and doing well.
Yes.
But have you explored methotrexate? If you go through the S2K guidelines, the highest evidence, in fact, all the clinical trials, what do you see, the best evidence among all immunosuppressives is with methotrexate. I feel many of us, how many of you are using methotrexate for bullous pemphigoid? Can we have a raise of hand? Of course, sir. But for long term, my personal experience
maintenance phase, methotrexate can be used in the maintenance phase because it takes time for the initial.
Of course, of course. All these bullous disease, all these autoimmune bullous diseases require a longer therapy to maintain. So as far as my experience goes, I am finding methotrexate as a very nice steroid sparing agent with bullous pemphigoid.
And along with that, I would like to add, in this old age group, since we have to also monitor the renal function test.
Of course.
Yes, and the amount of the methotrexate that you have been giving, whether it is which dose you have been started, and initial disease activity has been controlled or not.
Yes, yes, of course. We have to particularly look at the creatinine and the albumin.
Yes.
There where methotrexate does some problem. Any particular drug history, sir, would you like to obtain in this case? Dr.
Yes,
Deepayan, please.
Mainly in the old age, usually these anti-diabetic medications, this vildagliptin and linagliptin, they are more found to be associated with this bullous pemphigoid. And even you have, the research has found that before using even the 6 months prior, if there is drug history of taking vildagliptin or linagliptin, there may be chance of having bullous pemphigoid. So
yes, the latency is as long as even 1 year also.
So but also look for this furosemide, the diuretics, and AC inhibitors. They are more commonly used, particularly in elderly. So these two are very notorious to precipitate bullous pemphigoid.
The causality association has been best established with these molecules. The recent ones, anti-PD1 immunotherapies, like nivolumab.
They are very uncommon. They are very uncommon.
But the strength of association is high in these cases. Anyways, we have to move faster, sir.
But nowadays we are getting the same.
Of course, gliptins are the most common nowadays. Sir, if at all there is a drug history, would you like to consider stopping these drugs? These two classes of drugs?
Yes, yes, sir. Because by stopping the drug, patient get good result. We saw in our institute, we saw the cases. And after stopping the medicine, he got the good result.
Sir, please.
We switch over the alternative, another anti-diabetic medicine.
With the initial management, we have to observe it, whether it has been under control or not. And then only if the cases get more severe, and if she or he is under that medications, then we have to think about that stopping that drug.
Well, the thing is, as far as gliptins are considered, we can stop. But for other drugs like PD-1, you have to think the risk-benefit ratio has to be judged. If the disease is severe, then you can consider with your oncologist to stop PD-1 inhibitors. So this is the recent S2K guideline. And our patient, this is the response. We have given her 4 doses of injection omalizumab. She is on a tapering prednisolone, and she is maintained on a methotrexate 10 milligram, of course with monitoring. So I have already discussed. Quick remark from Dr. Akanksha, please. What is your remark on doxycycline and dapsone as monotherapy? Already we have discussed, so please be brief.
So definitely in monotherapy, we haven't seen much clearance. So we have to add a short course of steroid with it. But then doxy and
As
dapsone,
maintenance? As maintenance?
As maintenance, we have used dapsone for a while.
Dapsone, of course. But the trials on which these 2 drugs have been included, recent recommendation place them very low in the list, because you have to use doxycycline 200 milligram per day along with nicotinamide, and dapsone again, it's still an adjuvant. Monotherapy doesn't even help in maintenance. Any other take from anyone from the audience? Quick. Fine, we'll move on, sir. This we have discussed only when you are planning for omalizumab. Sure, sir. Sir. Then you. Of course. Yes, sir. Okay, sir. Thank you, sir. That's a good thing to learn from sir's experience. So, in fact, now it's said that even if IgE is not raised, still omalizumab helps in some cases. So, we'll move on to case 2. We are running short of time.
Tofacitinib also you have used in some cases of bullous pemphigoid.
Sorry, sir?
Tofacitinib in combination with low dose steroid, and that has also given good results. So this is one option, and the forthcoming option.
Again,
we can keep
any
in
drug
mind.
you consider that old age thing comes to your mind, giving a JAK inhibitor at such an old age. Anyway, sir.
I'm not saying about this particular patient, about bullous pemphigoid and options. Tofacitinib should be kept in mind.
Fine, sir. Thank you. So this is a case, itchy lesions, excoriations, vesicles, on bilaterally symmetrical on elbow, 35-year-old man. So these are the disease distribution and lesions. Any differentials? Dr. Akanksha, please.
By clearly seeing the scratch marks showing severe pruritus and the site of involvement, it looks like a case of dermatitis herpetiformis. And other than that, we can rule out some other
Vesicular pemphigoid would be our second differential.
Yes,
okay. So basically the provisional diagnosis will be a dermatitis herpetiformis.
Yes.
Ma'am, anything else you want to add? Because we have seen so many atypical presentations.
Yes, sir, because there is eczematous lesion, vesicles is present, erosion is also present. So if you other differential diagnosis, there may be pemphigus, or there may be eczematous dermatitis, because vesicles is present, that is in favor of pemphigus, and erosions and eczematous bilateral presentation, there may be endogenous eczematous form.
Of course. Need not be necessarily a immunobullous disease. So this is the histopathology. We see a good collection of neutrophils right at the tip of the dermal papillae. So, and you see the higher magnification, and this was the DIF. You see granular deposits. This is IgA. This is IgA. They are granular deposit along the DJ. So diagnosis is pretty obvious. Dermatitis herpetiformis. My question to Dr. Pankaj would be, sir, what screening or ancillary investigations would you would like to do?
Two things for DH patients, we have to go for the enteropathy part, and another thing, since we have to plan for dapsone, so I'd go for G6PD level. These two investigations are important: anti-endomysial antibodies, if possible.
So very aptly said.
And taking a opinion of a gastroenterologist. Yeah.
So almost most of the cases have an enteropathy associated.
Yeah.
Sir, one more thing, there may be association with other autoimmune disease.
Of course, ma'am.
Yeah, maybe there may be association with other like vitiligo and type 1 diabetes or thyroid. And there may be also chances of family history.
So these are the, and what we did is we walked upon this case and we saw the biopsy was suggestive of celiac disease. This is a biopsy from the endoscopic specimen, and we also did an anti-TTG, though it is not TTG3 specifically, it was also raised. So we have to, as sir said, we have to screen for enteropathy and we have to estimate the G6PD levels and rule out other autoimmune diseases associated, as ma'am said. So we established the diagnosis as dermatitis herpetiformis. And Dr. Dipayan, please, any key history in assessing these patients?
Yes, whether they have been taking any gluten diets that is more associated with.
So their dietary habits we have to check.
Dietary habits should be assessed. And what the study has shown is the lifelong remission, it actually depends upon the type of diet they have taken.
Of course.
And after stopping the drug also, if we have started the drug, like if you have started Dapsone, that will act on the clinical part of the skin, but not on the bowel part.
Yeah.
So avoiding the drugs, that has been
So most important is the gluten-free diet is most important. That will give a lifelong remission.
Yes,
Very correctly said by sir.
That will be lifelong.
Of course,
Yes,
yeah, lifelong.
And
Patients, gluten-free diet comes at a very high price.
Yeah.
It's very costly. Because they usually order it online, and because routinely you cannot screen everything at your home. It's very difficult. But I wanted to know that each part in DH is very important. That history is very important, and that usually causes sleep disturbance and triggering factors. Ma'am, would you like any small bedside test is there? Or my professor used to tell us that you apply betadine, povidone iodine on the lesions, even on the unaffected area, and they'll start scratching. That's because iodine exacerbates the itch in the DH patients. Family history of celiac disease or DH is very important. So we'll move very faster. Dr. Akanksha, please, what will be your first line of management?
Dapsone again here is the
Of
first
course,
line of
this
management.
here we don't have any doubt. Does short course of steroid is useful?
So sometimes for the pruritus thing.
But Dapsone here acts very fast, along with a gluten-free diet. Ma'am, could you tell us, Dr. Rakhi, what will you tell the patient to avoid?
The first and most important is the counsel of the patient regarding the gluten-free diet, because that will be lifelong, and for maintenance, Dapsone therapy. And if there is severe condition but in that condition, we can add short period of systemic corticosteroids.
Ma'am, would you advise to take oats? Oats. We have learned, we have remember this mnemonic barley, rye, oat and wheat. No, the thing is, oats are gluten-free.
Yeah.
It is a contaminated oat. While preparing this oat, we eat commercially. The oat we eat commercially, that is contaminated. Otherwise, oat is naturally gluten-free. How do you check
That's
for Dr.
called steel-cut oats.
Sorry?
Steel-cut oats.
That's a name?
Yeah.
Oh, it's new. Okay. How do you check for compliance of a gluten-free diet? If the person doesn't respond to Dapsone, would you go for a compliance testing, and what would be that?
Testing a kind of thing like you have to go for this antibody testing, that is difficult. You have to see the response. If patient is not responding on your medicine, then you have to go.
How do you check that whether he's...
Then you have to check his dietary habits, and then you have to go for this.
You can't check the dietary habit, you check the antibody levels. They should fall. If the person is on a gluten-free diet, check the serial antibody, anti-TTG3 antibodies.
And it has been also postulated that whenever the patient is diagnosed with dermatitis herpetiformis and he has been taking or not, whether dietitian, proper dietitian consultation.
Yeah, of course.
And regarding his dietary habit, that can be made.
So diary maintaining.
Yeah, diary maintaining, that will be more helpful.
Dr. Rakhi, any role of JAK inhibitor, or this question to Dr. Pankaj? Have you tried JAK inhibitors?
I have not tried, but DH is not so common.
Very common, right?
Yeah, but this JAK state pathway has been postulated in this recalcitrant celiac disease. So, theoretically, this tofacitinib and upadacitinib can be used.
In fact, there are few case reports, but sir, I'm interrupting you. We have to finish. But these tinibs are also associated with some refractory celiac disease. They develop a refractory celiac disease by themselves. And again, there is a chance of lymphoma. So that is the gray zone. TNFs are known to cause malignancies, and this disease per se is also has a risk for malignant conversion. So we'll come down to our last case. This is a clear-cut, out and out case. So you see the histopathology. There is a cleft at the suprabasal level with a row of tombstone appearance. There are acantholytic cells lying in the cavity, and there are erosions. Of course, blistering is not seen here, but there are erosions, painful erosions with mucosal involvement. But the jinx in this case is patient, while evaluating, we use rituximab as first line, so everybody would be doing that. Patient came out to be Gram positive. So what is your take on this?
Nothing to worry, in my opinion. Patient is a very severe case of, so first we have to take the amount of this disease control in the main account should be on disease control, and Gram positivity, there are remote chances of tuberculosis reactivation with rituximab, but they are very less. So the rituximab should be given in this patient.
Any other panelists would like to take this question?
Under coverage of isoniazid agent, we can give a short period of.
So you mean to say, ma'am, you can give a TPT,
So we can
preventive
go
therapy.
Other test for tuberculosis.
No, the Gram positive means, ma'am, he's a case of latent tuberculosis. So if we go by this recommendation, the chances of TB reactivation with rituximab is literally nil. So now the recommendation says they're green. You can go ahead, but getting a respiratory medicine clearance means that he or she is not likely to develop some other pulmonary infections with retux like pneumocystis jirovecii. Any background compromised lungs are there or not, but as far as tuberculosis is considered, we can go ahead with retux. But having said this, still we need a clearance from our respiratory physician. So this case, our physician wrote that TPT de do. So he took 2 drugs for 3 months. And after 2 months of isoniazid and rifampicin, not monotherapy, in this case what we did is isoniazid and rifampicin. After 2 months we gave him a rituximab infusion, and this is what we got. He is maintained. Yeah, Dr. Deepan, you would like to add something?
Even if tuberculosis is diagnosed while he is on rituximab, we can add on the anti-tubercular drug for some period of time and evaluate the case.
Yes, that's what we did.
Yeah.
So there are different TPT regimens, 2 drug, single drug, different recommendations. But I feel the most commonly practiced is 2 drug regimen for 3 months for other biologics, for antipsoriatic biologics, and start at least 2 months after you giving the anti-tubercular drug. Any biologic, particularly the anti-TNFs or the IL-17 ones, should be given. For that matter, IL-17, the real world scenario is there is no risk of TB reactivation. So, do you consider PCP prophylaxis with retux? Dr. Akanksha, please.
So, usually in routine, we do not do it, but in case the patient looks emaciated or he has some concomitant such lung respiratory infection, definitely we would consider giving cotrimoxazole or something.
Any other panelists would like to take this question?
The recommendation is mainly for lymphoma and cholangitis patients, not for routinely for pemphigus patients.
The dose and the duration of use of rituximab is high in those malignant cases. So their PCP prophylaxis is more useful. As far as the retux in pemphigus is considered, we routinely do not give in PCP prophylaxis. But I am sure anybody but I saw many of my patients who had been to CMC Vellore, they use a cotrimoxazole prophylaxis with retux.
Even in the trials, so there were the trials where many number of cases were having rituximab, but out of them only 2 cases came to be positive.
Yeah, there are trials. Out of 52 cases, only 2 cases had a reactivation.
In one arm they were giving rituximab, in the other arm.
And more so, those 2 cases were some other immunosuppressives also.
Yes,
that's the trial says.
Yes.
Okay, sir. So, Dr. Haki ma'am, how do you start or how do you consider retux if the patient comes out to be HBs positive or anti-HBC antibody positive? The first question is, ma'am, do you do an anti-HBC antibody before infusing retux?
Sir, in this condition, first we will go for a patient comes with the HBs positive or HBC positive. Then first we will go for the viral load.
My question is, ma'am, do we carry out this investigation of anti-HBC antibody in cases before planning for retux routinely?
It's not necessary, sir. It's not necessary.
In fact, you go through all clinical trials, they do it. We do not do at But ideal situation is we have to do.
SAG and anti-SCB are the part of routine investigations in all patients.
नहीं आप करते हैं सर?
हाँ, every patient.
Anti-HBC antibody.
Anti-HCV and HBsAg.
Okay.
So
Yeah,
while
routine.
so while giving rituximab, the chances of viral reactivation is very high. That's why even after HBsAg, after we doing HBsAg, we do the core antibody test.
Yeah, that is it.
So that it will reduce the chance of whether it's having later it will be appearing or
But
not.
I feel many of us would agree with me. We do not do routinely an anti-HBC antibody. Sir, we do. Triple. That is a screening. But see, there are instances where you might get a anti-HBs negative, and this might come. So here, see, if 3 are negative anti-HBs antibody, this 3 means you have to vaccinate the individual. And here, how do you vaccinate, sir? Any particular recommendation? How do you vaccinate? Supposingly, the person is neither immune nor protected, not immune, never infected and not protected. So in that case, we have to vaccinate. So any particular recommendation or regimen to vaccinate?
Before infusion, we don't advise for this.
No, in this case, we have to vaccinate in an accelerated dose, 0, 7 and 21. You have to vaccinate with anti-hepatitis B vaccine. And these are the scenarios. See, here, in these cases, you have to vaccinate. Here, nothing is required. But if this comes positive, here this lower case infected and could be infected, there you have to consider your, you have to consult your virologist or hepatologist. They might start an antiviral prophylaxis.
And before starting antiviral prophylaxis, we have to detect the anti-core antibody
Of
level.
course, of course.
And if it's positive, then we go for the
Viral load.
Viral load. And after looking for the viral load, then we go on antiviral.
What I meant to say is, हम लोग यहाँ तक कर सकते हैं. Viral load करके what we can do, right? We can screen in this method and refer to our colleague. Yeah. So your take, I need a quick answer. Low dose versus conventional protocol. Dr. Rakhi ma'am.
Sir, no personal experience, only in theoretical, because we are using the conventional protocol.
The person who is asking question also doesn't have any experience with low dose retux. But anybody else? Dr. Deepayan?
We are using 500 milligram at 14 days interval.
Okay, instead of the 1 gram infusions.
Yeah, 4 doses. And we are getting good results, and safety profile is also very good.
Safety to of course hoga, you are using low dose. Yeah.
Cost effective also in this case.
And in number of cases, more than
okay, sir. Okay.
But in the long run, the chance of remission is more higher in the higher dose compared to the lower dose.
Okay.
The longer period of remission.
Long period means the disease control, but in this recently concluded meta-analysis, they have concluded that no statistical significant differences in disease clearance or relapse rate, and the low dose this cohort did not prolong the this time to complete remission, nor it did increase the overall cumulative this corticosteroid dose. So they are at par. This is the latest meta-analysis that it shows. So what is new in pharmacotherapeutics? Dr. Akanksha, please.
As per studies, like I don't have any experience, but
nobody has experience. Don't worry.
So dupilumab has recently been approved, so that can be considered.
Well, any other panelists will take.
Some omanituzumab, some newer anti-CD20, that's in pipeline. But
so the non-chimeric one, sir? The non-chimeric retux ka congener.
The newer anti-CD20 antibodies, like which are humanized, more humanized one.
Humanized. That's what we.
It's a chimeric one. That's why the more humanized may have the side effects.
So the chances of infusion reaction antibodies will go down. Yeah.
And in other cases, like it's a more focused one, CAR-T,
CAR
therapy,
CAR-T.
and then anti-CD19 antibodies like inebilumab, which have been, anti-CD19 is present in the plasma cells as well, and in the pro-B lymphocytes to all the ranges.
So the entire cascade of B lymphocyte can be targeted if we target anti-CD19.
And in the memory cells as well.
So the remission time will be high.
Yeah, so the longer period of remission and the chance of near cure has been postulated.
So now we have Bruton kinase inhibitors, and we have these drugs which are in trial which will target the neonatal Fc receptor. These are new in the basket, and Bruton kinase, I feel one particular company has come up for urticaria. Maybe we'll try that in pemphigus as well. So do you see this is a hypothetical question, do you see the end of DCP? How many of are using DCP as a first line? You're not even considering retux.
not at first line, but at our setup, as a resource poor setup, it is in first line in some patient who cannot afford retux. Then DCP, of course, the efficacy is very good. The safety, we all have very large time experience. So that's
So
why
still there is a room
in
for
resource,
DCP.
yeah, resource poor
Last-
settings, we have.
Okay, resource poor. All conferences, all panel discussions, they come to an end with resource poor wala excuse. Anyways,
Sir, but still
last
DCPs
comment.
have some indication because all biologics take some time.
Okay, ma'am.
But DCP gives fast results, sir.
Steroids. D part is important.
In our scenarios, DCP is still, I guess,
Still prevalent.
it can be followed.
Right now we have so many options, but still DCP has.
So that was very good of my panelists. Thank you all. We come to an end with this question. Thank you all.
That was a wondrous session. I would request our moderator and panelists to please collect their memento. For the next session, I would like to invite Dr. Shankar sir to please chair the session.
Good afternoon, everybody. I would like to invite next speaker, Dr. R.R. Madhukar. Qualification MBBS, MD, designation consultant dermatologist and aesthetician, institute, completed MBBS from Ranchi, postgraduate from PMCH, academic presentation 6, brief fellowship in ACDI, ex-national trainer VLCC and ex-consultation dermatologist VLCC, Patna, national treasurer ACDI, special interests clinical dermatology and aesthetic. Thank you, sir.
Thank you for the introduction, sir. Good afternoon, all delegates, and Jai Jagannath to start with. As my topic is off-label uses of Botox, rather it should be botulinum toxin type A. What is Botox? Everyone is very familiar with this. It's a purified form of botulinum toxin type A, and it has been approved by the FDA for various cosmetic conditions and also a few of the non-aesthetic conditions. And its major mechanism of action is by blocking the acetylcholine release and causing temporary muscle paralysis. Now, off-label use, what do we mean by it? It is the use of any drug or any molecule where it has not achieved or not got FDA approval, and the dose has not been defined of what the exact dose to be administered, and it is used for conditions due to the efficacy and due to, as we know, the mechanism of action of the particular molecule or drug. It can be used in various other settings, but the standardization is still under studies. Many studies are going on to use it where and when. And of course, ethical and legal bindings remain. So we need to go ahead with further studies, prospective studies, to get a final mode of administration and the dose of administration for various other indications. I think this is what I wanted to say, that we need to use the molecules which we have in hand and in other conditions. So we need to give in other situations where there's lack of effective treatment or achieving effective symptom relief at least. And it should be where there are many studies going on which give support to the evidence of consensus of using it in various conditions. Now, the indications can be divided into aesthetic and non-aesthetic, and us dermatologists, we also practice aesthetic medicine. So more of the points I'll be covering will be of the aesthetic indications. Especially of when we are dealing with facial contouring. Now, masseter reduction, that is the slimming of the jawline to give a more ovalish or slimming down effect by injecting into the masseter. Now, while injecting into the masseter, again, it depends on the bulk of the muscle mass. The various doses depend. It can range from 15 units to 25 units. And we need to be very careful not to cross the anterior border of the masseter and hit the ressorius, or we'll get a drooping or angulation of the angle of the lip. The muscle can be injected at 2 to 3 points depending on the muscle mass and achieving a slimming of the jawline. The gummy smile correction is when the upper lip shows the upper gum due to excessive pull of the muscle, levator labii superioris, aliquot nasi. And by injecting it either from the oral route, that is below the upper lip, along that angle, into the muscle to achieve a drooping of the upper lip and reduce the show of the gums, giving it a more aesthetic look. Now, all these results, they usually vary from 3 to 4 months, and we can claim that you will receive these improvement in the symptoms for about 3 to 4 months. Usually, the results show their activity within a week. Similarly, the nasal flare or the ella of the nose, where they dilate either during respiration or during excessive smile, if people having bigger smiles. So there, the flares have become more prominent, and it creates a refined nasal appearance, or even we can give it a name of medical rhinoplasty, which is temporary again. Now, the next indication is the brow lift, or the Spock sign as we call it, and this is given to weaken the depressor muscles below the eyebrow, and this should be ideally given intradermally because the muscles are very superficial, and given to relax the orbicularis oculi, quadrata, and procerus muscles. This helps elevation of the eyebrow due to the pull of the frontalis muscle, and it gives improvement in the eye opening, or even the lowering the hooding of the upper eyelid. Now, acne control and rosacea control, both are basically taking into account the anticholinergic effects, which help in reducing the secretion of the glands. So, in a very diluted form, like 1:10 dilution, we can give it intradermally 1 centimeter apart. So with a BD syringe, this achieves acne control by reducing the sebum activity temporarily again, and it can be used even to lower the pores, giving a smoother appearance to the skin. Similarly, for rosacea, it helps in reducing the flares, flushing, and causing less irritation and burning sensation associated with rosacea, and also the acne due to rosacea. And it can be used in conjunction with the first-line therapies of acne and rosacea control. Now, these are a few indications which are non-aesthetic, but more or less they become aesthetic. For sialorrhea, they are injected directly into the parotid and submandibular glands to prevent the saliva drooling and giving it a more aesthetic look. And here again the duration of activity is symptom relief is variable. It also, the dose of Botox being given is very variable. In hyperhidrosis of the palms and soles, usually we can inject up to 50 to 100 units per hand. I prefer 50 units, otherwise we can cause anhidrosis over there. Soles you can use more, and it has been being practiced for long. They have given after using that starch iodine test, etc. And results again 4 to 6 months, maybe even less. A word of caution here is that if we inject inadvertently or the nerves are denervated, causing chemical denervation, then there will be there's leakage of the medicine away from the wanted area. Then the temporary muscle weakness can be encountered. So we need to counsel the patients beforehand that if this will be temporary. Now, blowout preservation is under-eye puffiness basically, and under-eye puffiness, if it is mainly due to either overactivity of the muscle or due to tear troughs also, then we need to dilute the Botox in 1:2, at least 1:2, and give multiple small 0.05 units at a gap of 5 millimeters or 10 millimeters, 1 centimeter gap. And this helps in reducing the puffiness for a temporary time and giving a more aesthetic look. Botox can be given again for dynamic wrinkles appearing on the hands, on the dorsum of the hands, giving it relaxing the muscles and giving it a more aesthetic look. It can even be combined with fillers to give a more fuller and plumpy hand aesthetic look. Then for neck rejuvenation, they can be given into the platysmal bands to reduce the appear of what we call goose legs or chicken legs. And also in reducing the platysmal pull, it will help in giving a more defined jawline, giving a Nefertiti lift. Non-aesthetic uses can also be given into the detrusor muscle, where it is there's incontinency due to the overactivity of the detrusor muscle. And there are many trials which have been given, which are going on, and many reports have been also cited that it helps in patients with detrusor muscle instability. This is a hypothetical condition where due to the relaxation of the glabular muscles, when injected into the glabella, the neurogenic pathway, vascular neuro pathway is disturbed, and due to also the expression lines reducing, the patient feels psychologically better, and since depression is a psychological condition, it helps in preventing the feedback loop between facial expression and mood. So this can be given along with the first line treatment, or where the treatment is very resistant to first line therapy. This is a documented, well-documented condition, temporomandibular joint disorders, where either injecting into the temporalis muscle or into the masseter, the extra tension caused by the pull of these two muscles causes bruxism. This is useful because of its relaxation of the muscle and reducing the bruxism and relieving the pain of due to this bruxism. It has been, few case reports are there citing giving directly into the digital arteries or near the digital neurovascular bundle at the base of the fingers, that is the proximal end of the proximal phalanx. There, where we are facing resistant cases for Raynaud's phenomena, it has been, sorry, it has been given in both for fingers and toes. Case reports have been cited, but further trials are needed and to confirm or to get it approved. Now, some chronic pain syndromes like the myofascial pain syndrome and neuropathic pain associated with, you can say, postherpetic neuralgia also, it can be given to relax, but the exact mechanism or the exact dose still needs to be tested, and case trials should be done so that we can benefit the patient with these neuralgic or neuralgia syndromes. It has been given, there have been reports citing it to be given directly into the prostrate muscle, where it causes relaxation of the muscle and helps the symptoms, especially the lower urinary tract symptoms of urgency and frequency, which helps in a better quality of life, improving the quality of life. And it has been also given in cases of vaginismus and pelvic floor spasticity syndromes to help relieve the pain. Now, this is one slide I did just to make it more interesting if it is not up till now, that it is being used for, there have been some reports not cited in literature, but we can give it for premature ejaculation also into the bulbospongiosus muscle or the tip of the frenulum, even directly into the glans to reduce premature, giving it for premature ejaculation, preventing premature ejaculation. So, since the molecule is generally well tolerated and with very less side effects, we have been using it, knowing the various mechanisms of action, and the common side effects are, as we all know, local muscle weakness, injection site pain, flu-like symptoms. But serious, these are not serious, but can become serious if given when giving into the neck, they are the molecule disperses and causing dysphagia. These are the legal and ethical considerations that we must inform the patient and take consent, and more studies are needed to justify the use. So in conclusion, numerous off-label applications show promising results. Physicians should weigh benefits and risk ratio. Thank you so much. These are a few references from where I've taken my slides. Thank you so much.
It was a nice and informative presentation. Any question from the audience? No. Thank you.
Thank you.
That was a very good session, sir, indeed, on Botox. I would request our speaker, sir, to please collect his memento. For the next session, I would like to invite Dr. R.R.K. Rahul, sir, Dr. Raj Kishore, sir, and Dr. Nipen Karmakar, sir, to please chair the session.
Welcome Dr. Seema Hussain ma'am. She is HOD Dermatology Department, Katihar Medical College, and she did MBBS in dermatology as well as MS in Obs Gynae, and has various publications, author of 3 books, 2 on tinea and 1 on partogram, and she is editor-in-chief of Journal of Katihar Medical College. So welcome ma'am.
Thank you for my introduction, and good afternoon everybody, to the chairperson and the audience. The Hansen's disease is a chronic infection disease caused by the Mycobacterium leprae, and in some studies, Mycobacterium lepromatosis that primarily affects the skin and the peripheral nervous system. The disease shows a variable clinical spectrum from a single lesion or nerve thickness to widespread skin and nerve involvement. The most accepted mechanism of transmission is via nasal droplets from untreated multibacillary cases over prolonged close contact. After the completion of the multi-drug therapy, my topic comes in action. It aims at clinical follow-up, which helps. This is done. Number one is a regular monitoring every 6 to 12 months, clinical evaluation that includes examination for new skin lesions, assessment of nerve tenderness and function, and early identification of any signs of relapse or activity. Patient self-education for self-examination is the most effective way of treatment for follow-up cases. The Government of India has made the following recommendations for treatment of leprosy for control eradication purposes to be adopted uniformly throughout the country. And for PB leprosy, all leprosy cases including single skin lesions will be treated with 6 months of standard WHO PB MDT and thereafter released from the treatment. They should be under surveillance for 2 years. Now for the multibacillary, all patients with MB leprosy, patients with more than 5 lesions, irrespective of skin smear positivity, may be put on 12 months of standard WHO. These patients, after release from the treatment, will be general surveillance for 5 years. All patients with MB leprosy who have received 12 months or more months of MDT should be released from treatment. The management of reactions. It aims, leprosy reactions can occur even after the therapy. It is advised to continue effective anti-leprosy therapy without interruption. Goal is to rapidly suppress the immune inflammatory reaction to prevent nerve function and impairment and permanent damage. Earlier the neuritis is treated, the better chance of recovery of nerve function, delays increased risk of permanent damage. Now type 1 reaction, usually it is of oral steroid. And a common dose is 0.1 to 1 milligram per kg per day of the steroid. Duration tapering gradually over many weeks with what we call as a pulse therapy. For milder reaction, NSAIDs may be suffice. For type 2 reactions include rest, NSAIDs, analgesic, and that is for only symptomatic relief. For moderate ENL reactions, we aim at starting the steroid, and sometimes additional agents like clofazimine at a higher dose, 300 milligram daily as a steroid-sparing adjunct in moderate severe chronic ENL. If available and no contradiction, then start thalidomide. Previously, it was used, but slowly as the days develop, it has shown that it has teratogenic effect on the human body. For severe reactions, it includes thalidomide will work better. एक सेकेंड. स्लाइड शिफ्ट हो गया था. नहीं उसके पहले हाँ. Now, disability prevention and rehabilitation, physiotherapy and occupational therapy. Regular physiotherapy helps maintain joint mobility, muscle strength, and prevents contractures, while occupational therapy trains patients to adapt daily activities safely and efficiently. Protective footwear. Customized footwear protects anesthetic feet for trauma, burns, and ulcers, reducing the risk of secondary infection and deformities. Reconstructive surgery, if needed, like claw hand or foot drop, restores function and appearance, improve mobility and quality of life. social and psychological rehabilitation, counseling, community reintegration, and vocational support helps overcome stigma, rebuild confidence, and promote independent living. This is a photograph showing the rubber footwear, what we recommend. These are the various deformities. Relapse monitoring. Relapse is rare with MDT, but possible. Through multi-drug therapy ensures a cure rate. A smaller number of patients may still experience relapse due to dormant bacilli or inadequate treatment. Now, how to define relapse? It is identified by appearance of new skin lesions, nodules, or nerve involvement in a patient previously declared cured after MDT completion. Time of occurrence. Relapse usually appears 5 to 10 years after treatment and of the completion. Hence, long-term follow-up is essential for early detection and management. Retreatment with MDT. Reappearance of disease should be managed with full course of standard or modified MDT regimen as per WHO protocol. Patient counseling and education. Cure, MDT completion is cure, not infectious anymore. Educate patients like completing the full MDT course eliminates infection, making them non-infectious and safe to live with family and community. Importance of self-care to prevent disabilities. Teach daily inspection, skin and limb care, and protection of aesthetic areas to prevent ulcer, deformities, and secondary infection. Awareness of relapse reaction symptoms. Inform patients about early warning signs like new lesions, pain, or swelling in the nerves, and redness or tenderness to ensure prompt medical attention. Reducing stigma and encouraging social reintegration. Counseling should promote confidence, dispel myths about contagion, and encourage participation in work, education, and community life. Thank you. And in my clinical practice, what I have found, patient, once the MDT course is complete, he or she feels good enough. And if that patient, he sees or she sees any deformity, they will directly go to an orthopedics doctor. They forget, and in fact, they don't want to remember that they have been suffering from leprosy in the previous years. Thank you.
Thank you, ma'am, for the enlightening session. Thank you to the chairpersons. I would like to invite you all to collect your mementos. For the next session, we have a panel discussion on clinical challenges in leprosy. To moderate this session, I would like to invite Dr. Shivani Shekhar. She is doing her senior residency from Nalanda Medical College and Hospital, Patna.
Thank you for the introduction. Now I would like to invite my panelists on the stage. Dr. Y.A. Lal sir, ex-associate professor, RIMS Ranchi and senior consultant dermatologist. Dr. Ramavtar Singh sir, professor and HOD Department of Skin, NMCH Patna. Dr. P.C. Das sir, consultant dermatologist from Purnia. Dr. Prabhat Kumar sir, associate professor at RIMS Ranchi. And Dr. Piyush Kumar sir, consultant dermatologist from Katihar and Darbhanga. Since our panelists are here, I would like to initiate the session. So here is our first case. This is a 15-year-old male who has presented to us in our derma OPD. He had a hyperpigmented macule on the lateral aspect of his right foot just proximal to the ankle, as you can see. This macule had irregular border and was slightly scaly with central clearing and atrophy. When we examined the patient, there was diminished sensation to cold temperature in the lesion. So he was started on MDT. 1 month later, he came with no improvement and slight progression in the area of involvement. So I would like to ask our panelists, how will you proceed? Dr. Ramavatar Singh sir, how will you proceed?
Hello. You go for histopathology, actinic test. Even you can do nerve NCS, and so this lesion looks like the morphea, localized patch, central atrophy. I think.
Yes, sir, you are quite correct. So I would like to just proceed with this. So after the patient came to us with no improvement after MDT, he was thoroughly examined. So there was no nerve enlargement or tenderness in any of the peripheral nerves. There was no any other hypopigmented or anesthetic patch anywhere on the body. And there was no any infiltration of ears or any other suggestive lesions of Hansen's disease. So we ordered some very routine investigations, slit skin smear for AFB, biopsy and NCS. So slit skin smear turned out to be negative and NCS was normal. However, histopathological exam showed dermal sclerosis with scattered infiltration of lymphocytes, and there was no AFB seen. So a diagnosis of plaque type morphea was made, and we initiated the patient on oral methotrexate along with topical tacrolimus, and we saw some progression in 6 weeks. The progression of clinically the progression had stopped and the patient reported improvement. So in this case I would like to just pinpoint this part that leprosy is the new syphilis. It can mimic many types of other clinical dermatological diseases. So as sir has rightly said, we should be very thorough with examination and we should not make a haste in initiating MDT, MB only on making clinical examination. In difficult cases, we should also go for investigations. So next question to Dr. Prabhat Kumar sir. What are some of the atypical or difficult to diagnose clinical presentations of Hansen's disease that you have come across in your clinical practice?
There are many things we should look for come to the diagnosis of the leprosy. First is the patch, the lesion, then the supplying nerve, and then the sensation is there or not. That is the important thing. But if you don't get the diagnosis, then you will go for the SSS. That is important. That will help us to diagnose whether it is a leprosy or not.
Dr. PC Das sir, what are some of the atypical cases that you have come across in your clinical practice? मतलब देख के लगा कि ये तो Hansen's नहीं हो सकता, but then it turned out to be Hansen's.
Sometimes we face with situations where cardinal signs of leprosy are not there, and we have to depend upon our clinical judgment. Like few of the situations I want to just mention. Case of erythematous patch over the face, which is photosensitive in nature. No hyposthesia, no other feature of Hansen's disease. A short trial of anti-leprosy drug clears of ameliorates those symptoms. There is no smear positivity, no regional nerve involvement, no hypothesia, other cardinal signs are absent. One another atypical situation, nowadays we come up with first instance of lepra reaction. They are often being referred by physicians or admitted somewhere in the medical departments. They are being treated as typhoid, septicemia, or some other conditions, medical conditions. And there is no subjective hyposthesia or any skin lesion to suggest at per se that should be taken as leprosy. But we are facing such cases, we are finding such cases. For some duration of treatment, then some features are obvious, some hypostatic areas are visualized or xerosis and something like that. And then difficult to diagnose clinical situation is long duration diabetic patients with mononeuritis multiplex. There also it is quite challenging how to disprove or rule out. Generally the cases are being referred to rule out leprosy in such cases. It is very difficult. These are few of the atypical situations that we come across more so.
Dr. Piyush Kumar sir, would you like to add any atypical cases that you have come across of Hansen's?
Apart from the what Pizza sir and others have mentioned, I would like to add a few other scenarios. Like sometimes, very rarely though, lepromatous leprosy patients have presented with 1 or 2 lesions, either plaque or nodule, but 1 or 2 lesions that only after HP could be diagnosed as lepromatous leprosy. One scenario is that. Second time, as sir was saying, sometimes lepra reaction patients present for the first time without any prior history of leprosy treatment or leprosy diagnosis. And especially when they are ulcerative in nature, that poses a good diagnostic challenge. And third scenario that I have observed is, these are the sequelae of nerve damage. Patient has ignored or not been treated for leprosy, so the nerve damage has set in, and after that patient presents with either hypercalcity or trophic ulcer. These are the presentations where diagnosing leprosy can be a bit challenging or atypical.
Thank you, sir. So yes, there are n number of atypical presentations of leprosy, some of which I have seen in my in the OPDs, but some of them I have come across in various journals. Erythema annulare-like lesions, urticarial vasculitis-like lesions, even some cases have presented as erythromelalgia, spontaneous ulceration on both hands, intermittent pain in limbs, especially of pure neuritic leprosy, neutrophilic dermatosis-like lesions, as sir has already told about photodermatitis-like lesions, molluscum contagiosum-like lesions, xanthoma-like lesion, and connective tissue nevus-like lesions. There are some very rare case reports about these type of presentations of leprosy in various journals. So moving on to our second case. This is a 65-year-old male patient who has been released from treatment 1 year ago. He has been suffering from recurrent episodes of type 2 reaction during his treatment and after that as well. He was not consistent in his follow-ups and reported of taking thalidomide 100 mg single dose for last 2 years, and he used to increase it to twice daily by himself whenever disease activity used to exacerbate. He complains now of pain, burning and tingling sensation in both lower limbs for last 3 months. Currently he is on thalidomide 100 mg OD for last 6 months and have not suffered from any reactionary episode. This is a very common case that we come across in our OPDs, patient not giving proper follow-ups. So now I would like to ask, how will you manage this case? Dr. Ramavtar Singh sir. A case of thalidomide abuse.
Hello. Patient is having thalidomide. Thalidomide is also causes peripheral neuropathy. Yes. And so you have to give simple, nothing to do. Stop the MDT, give the vitamin B. Even you can give the gabapentin or methyltoluenes, B templates, and give calcium iron simply.
Dr. Prabhat sir, sir, in this case, how do you think NCS will be useful?
The patient might have the diabetes also. That can also cause, and the second thing is that the long use of the thalidomide that can cause the tingling and the tingling sensation in the lobe. So the best thing to manage give that B1, B6, B12, that is, and then methylcobalamin we can give. That will help in elevating the things.
Anything more any of my panelists want to add?
Here I think we have to differentiate between at least three scenarios. One is disease relapse, one is late onset paralysis which can even persist or progress even after completion of treatment, and third is thalidomide induced neuropathy. These three will be our considerations. Other than that, if there is any comorbidity like diabetes or vitamin B12 deficiency, that too needs to be considered. Most likely from the given history, thalidomide induced neuropathy seems to be likely, and that needs to be confirmed with clinical and NCS.
Thank you, sir. So yes, when the patient was examined, he was not having currently any active patches of Hansen's disease, or there was no active reactionary episode. His nerves were enlarged, but they were non-tender. So yes, again confirming the patient was not in reaction, but he was having glove and stocking anesthesia, but motor examination was normal. NCS was ordered, and it came out to be that there was a significant reduction in snap amplitude in bilateral common peroneal nerves, but there was only marginal slowing of conduction velocities in both of them. Motor involvement of any nerve was not seen. So if there was reduction in snap, that is action potential and conduction velocity, so there can be a possibility of lepra neuropathy, but we cannot rule out that there is a symmetrical length dependent manner of affection of nerves. So it is quite characteristic of thalidomide induced neuropathy as well. So in this case, since conduction velocity was also marginally reduced, we cannot rule out lepra neuropathy. So we stopped the thalidomide, we gradually tapered off fastly in 1 month, and there was mild recurrences of reactionary episode which was managed with NSAIDs and short course oral steroid. As sir had already told, we started him on B complex tablets and amitriptyline to reduce his symptoms. 3 months later, he didn't report of much improvement, but his symptoms have not worsened too. So here I would like to highlight that in thalidomide induced neuropathy, there is a phenomenon known as coasting. Even after stopping thalidomide, the symptoms can go on progressing. So this is something which will indicate towards thalidomide induced neuropathy. And one of the main important points which differentiate between lepra neuropathy and thalidomide neuropathy is the conduction velocity. If it is reduced, it is lepra neuropathy. If it is not reduced, we will think of thalidomide induced neuropathy. Moving on to our next question. We had a 30-year-old male patient who has presented with multiple pustules on his body, which were generalized in distribution all over his body, along with fever and joint pains. He denies of similar episodes, but reports of suffering from recurrent episodes of fever and arthralgia for past 1 year. He was taking antipyretics and analgesics for the same and has presented in our OPD, but he has not taken any specific treatment for any specific disease. So how will you proceed? Dr. Piyush Kumar sir, how will you proceed in such a case? What are the other differential diagnoses that you will think about in such a presentation?
Just given from the clinical picture, it could be generalized pustular psoriasis, and other than that, we can think of pustular inal, since it's leprosy session. So I will keep that in DD. And sometimes septic conditions like deep fungal infection or disseminated septicemia can give rise to pustular and joint symptoms.
Yes, sir. Rightly said. I would request Dr. Y. Lal sir to also add his expertise. A patient with pustules, fever and joint pain, sir, presented in your OPD.
The picture resembles with that of a case of lepra reaction, of course, type 2. So we should go for the general whole body checkup from the leprosy point of view, that is sensation, nerves, all like that. And as he is having recurrent episodes of fever and arthralgia for the past 1 year, so we should go for other tests of leprosy like HP, SSS, and also we can go for these days for the newer tests like PCR, mixed PCR, and serological tests. Now there is a skin, GSN skin app, WHO supported. So all these things will come to help for the correct diagnosis of this case.
Thank you, sir. So yes, when we examine the patient...
Hello.
Yes,
You
sir.
have to think that the neutrophilic dermatosis, Sweet
Yes.
syndrome,
Yes, sir.
Pattern, you have to think Sweet syndrome, or even radiation. You
Yes.
have to think radiation.
As rightly pointed out by our panelists, there are multiple n number of DDs of generalized pustule presentation on body with joint involvement and fever. So, but when the patient was examined, he had enlarged tender ulnar and common peroneal nerves bilaterally. There was no loss of sensation on any of the extremities, and there was no any hypoanesthetic lesions all over his body. One of the other common presentations that we can think about, we have to rule out, is AGEP, because there was generalized pustules, but there was no any drug history 1 to 3 months prior to the episode. So we ordered the lab investigations. Routine investigations were CBC, LFT, KFT we ordered. Also we ordered for serum ESR, CRP and RA factor. Slit skin smear and biopsy was ordered along with pus culture and sensitivity. So when results came out, routine examination was normal, RA factor was normal, ESR and CRP was significantly raised, slit skin smear was positive, and histopathological examination showed dermal edema, fibrinoid necrosis of vessels along with dense neutrophilic infiltrate suggestive of type 2 reaction. Pus culture came out to be positive for Staph aureus and it was sensitive to piperacillin and tazobactam. So we initiated the patient on Pibzo TDS, to which he didn't respond because we got the result of the culture earlier. So we started on antibiotics, but he didn't respond until we added the MDT to the patient. And for management for fever, we added him on paracetamol, and within 7 days, patient responded, fever subsided and lesions began to heal. So this was patient 7 days after adding MDT and initiated on injection Pibzo. So this is very common nowadays that leprosy is presenting firstly as the reactionary episodes. So I would like to ask Dr. Prabhat Kumar sir, do you use any newer test apart from slit skin smear and histopathological examination to diagnose atypical cases of leprosy?
I don't have any experience with the other than the SSS and the SP.
Any of our panelists, have you gone for any newer tests apart from slit skin smear and histopathological molecular tests, or like PCRs, or like anything you have experience with ELISA or kit tests?
Apart from nerve conduction study and some indirect tests like high resolution ultrasonography. In
For
few
ELISA,
situations-
ELISA for PGL, PGL1.
So yes, they actually leprosy is a disease which has there are so many newer tests, but we are not using it in a regular basis. I typically put this question for the PGs sitting out there, because they should know about the newer tests which have come in this much time. So molecular diagnosis, we have PCR for RLEP, which can be used in all types of samples. It comes out to be positive in contacts, and we need to be monitored for disease development. There are several types of PCR. As sir has already told, we are doing ELISA for anti-PGL1, and there are, apart from ELISA, dipstick tests and lateral flow immunotographic tests which are faster and handy. UCP LFA test, this is a newer test which is low cost and portable. This has been discovered to be useful in endemic areas. It identifies cytokines and anti-PGL1 antibody, and it uses phosphoreceptor techniques. Second is NAT-HANS test, which detects some genes by emission of fluorescence. There is newer test, BioMeme test. This is a gadget. This is a battery-powered gadget which can do PCR and produce result in 30 to 45 minutes without any need of electricity, centrifugation or cold chain. Skin app, this is a very recent thing. Skin app developed by WHO to be used for neglected tropical diseases by interactive mobile app, and artificial intelligence also has been, the research is going on in the field of artificial intelligence. So moving on to our case 4. 45-year-old diabetic patient with good control. He is having good control, develops intermittent pain, burning and tingling sensation in bilateral lower limbs 3 months ago. He visited his endocrinologist, who prescribed him supplements and gabapentin 100 mg for it. His symptoms worsened, and now he developed similar complaints in his right upper limb as well. So then he was referred to the dermatological OPD. How will you proceed? Dr. PC Das sir, how will you proceed in such a case? A diabetic with good control, have developed neuropathy, not responding, how will you proceed?
Although long-term diabetics with good control is not immune to any peripheral damage, it is there. That can be there in diabetic patients with good control also. I will have benefit of doubt to freshly assess the case, thoroughly examine for any, if any, signs of Hansen's disease, and at the worst, although it is difficult to disprove and rule out Hansen's disease, at the worst you have a therapeutic trial.
Dr. Piyush Kumar sir, would you like to add? So generally we are getting these cases that neuro OPDs are sending to us that please rule out Hansen's for us.
Here the main dilemma is differentiating between diabetic neuropathy or if there is leprosy involvement. So there are some clinical clues, some other investigation can be helpful. Clinical clues in diabetic cases, the deep tendon reflexes will be lost. In leprosy cases, at least for the very long time, DTR are preserved. That could be one clue. Then second is nerve trunk examination. If there are nerve trunk thickening, that will go in favor of leprosy. Other than that, we can order ultrasonography of the nerve to assess the nerve thickness, function, and vascularity. So these things, and if that doesn't settle, then we can go for sural nerve biopsy. That can conclusively prove if this is a Hansen case.
Thank you, sir, for your valuable input. Sir has very rightly pointed out, this is a very common case coming to dermatological OPD sent to by neuro OPDs or medicinal OPDs that please rule out Hansen's disease for us. This patient is not responding on our therapies. So yes, as Sir PC Das sir has already told, if you are even having a good controlled diabetic, that does not rule out progressive neuropathy because it is microangiopathic in changes and it does not respond to good control. So when patient was examined by us, there was common peroneal and ulnar nerve were enlarged bilaterally without any tenderness. There were no area of hyposthesia, neither any hypoanesthetic lesions on his body, and his voluntary muscle test was normal. So we ordered routine investigations for seeing his blood sugar control, slit skin smear by taking samples from bilateral ear lobes, and histopathological examination was taken by taking sample from skin from dorsal aspect of left upper limb overlying ulnar nerve. So in pure neuritic cases, if nerves are involved, it is said that either you should take the histopathological cases from the skin which is just proximal to the area of nerve involvement. So eventually both came out to be negative, everything was negative. So we ordered NCS and high resolution ultrasound of bilateral common peroneal nerve along with Doppler study. So NCS came out to be sensory motor nerve involvement with mild slowing of conduction velocity and decrease in SNAP and CMAP, that is sensory nerve action potential and motor action potential, both were decreased along with conduction velocity. And on high resolution ultrasound, as Piyush sir has already told, there was a diffuse increase in cross-sectional areas of both nerves along with increased perineural activity on Doppler. There was loss of the normal honeycombing pattern and fibrosis was absent. So this was an early involvement. If fibrosis would be present, that would be a late involvement. So a diagnosis of pure neural leprosy was made and we started the patient on MDT and he responded. So we should understand that NCS and HRUS we are generally neglecting, but this is what differentiates us from the from the physicians or neurology. We must know the findings of NCS and ultrasound to make our diagnosis, to make them clear that this is Hansen's or this is not a case of Hansen's disease.
Yes, in this case, early cases, this nowadays mixed PCR, and PCR is very valuable, which can detect even 2 or 3 bacilli or like that. And serological tests, the newer ones, are very much helpful in these cases.
Yes,
especially.
yes, rightly told, sir. So this is our last case. She was a 35-year-old female patient who had earlier came to us with erythematous infiltrated plaque with well to ill-defined margin on hand with satellite lesions, as we can see. At that time, her bilateral ulnar nerves were enlarged and non-tender. Her initial bacillary index was 2+. She was diagnosed with BT Hansen's at that time. That time, we initiated her on MDT-MB adult, which she completed in 15 months. So she has been RFT 1 year ago. 2 months ago, That means after around 8 months, she developed some anesthetic erythematous nodules on her lower back. She didn't complain of any new lesions in between or any episode of reaction in between. But she said she didn't take clofazimine in last 3 months as she was misinformed about the skin discoloration. So she had omitted clofazimine in the last 3 months of completing her MDT. So how will you proceed? This is a case who has presented with newer lesions. There was no reactionary episode in between, and she is also saying that she had not taken her MDT properly. So how will you proceed? Dr. Piyush Kumar sir, how will you proceed in such a case? Patient has been RFT 1 year ago.
We have to examine the nodule and biopsy it, or one correction, she was not misinformed. Clofazimine do cause pigmentation, so she got apprehensive and quit the...
Yes sir, exactly. She was apprehensive, so she stopped.
This may be the case of relapse.
Yes sir. The post-RFT cases, post-RFT, we can think of, mostly we think of 3 conditions: relapse, reactivation or reinfection. So sir, how will you proceed in such
this case is doubtful of default, but here 1 year MDT is completed. Only 3 months out of the 15 months, 3 months of clofazimine was ignored. So 1 year is sufficient for MB leprosy, but there is a possibility that it is downgrading. 2 nerves were involved, it was multibacillary. Although the lesion looks as BT, maybe it is actually case of high bacillary index. And once the MDT has been discontinued, it has again progressed. The lesions described over the lower back may be new Hansen's lesions, may be of lepromatous type. That we have to rule out through investigations as rightly suggested by Dr. Piyush.
Thank you, sir. So yes, when we examined the patient, bilateral ulnar and peroneal nerves now were enlarged. Initially only ulnar nerves were enlarged, but now both of them were enlarged. Both our limbs were involved. There were similar erythematous infiltrated nodules on bilateral buttocks as well. We ordered routine investigation, slit skin smear with BI and biopsy. Basic metabolic panel was normal. Slit skin smear was slightly increased, being 3+. And on histopathological examination, there were foamy macrophages with solid staining bacilli seen in dermis. Polymorphs were absent. So we made a diagnosis of relapse. However, this is not a very common time period for diagnosing relapse. She had been only 8 months off her treatment. But since she has downgraded and her BI has increased, so we made a diagnosis of relapse with downgrading. A PCR sample was also sent because because she has downgraded just after completing her treatment. We will think of drug resistance testing in such cases. And she was initiated again on MDT-MB. She was counseled about clofazimine discoloration. Her resistance report finally came out to be negative. She was sensitive to all 3 drugs. 1 month later, she came with her neighbors who had features of LL Hansen's since 5 years, who was initiated on MDT. So on basis of this, we could not rule out reinfection in such cases. It can be a possibility. But we cannot rule out because we have not taken her gene examination was not done initially. So this is the last question. To Dr. P.C. Das sir, in which clinical scenarios do you choose to extend MDT administration for more than 1 year? In which cases do you extend it for more than 1 year?
The guidelines can only guide us, but the final decision depends upon the leprologist who is caring the patient. Persistent infiltration of nerve despite completion of the regular course of MDT, the doubt of default, progression of lesion beyond 1 year of MDT. These are the scenarios where we may consider MDT for period more than 1 year.
Any one of my panelists, they want to add?
Leprosy. In hysteroid leprosy, we give for the more than 1 year, one condition, and then the not responding, not taking compliance to the treatment, then we can extend to more than the 1 year.
In case of leprosy, rifampicin or dapsone resistance, you can extend. We are giving 18 months or 24 months, alternate drugs.
Yes.
And even in immunocompromised patient, you have to give the long test for long duration.
In some cases where BI is more than 4+, then in those cases also we go on giving it and extend it for more than 1 year.
When there is doubt regarding duration of treatment, and if we suspect judgment of error, we should err towards the side of over-treatment rather than under-treatment, so far as leprosy as well as tuberculosis and HIV disease is concerned.
Thank you, sir. Yes, as most of the points have been covered, when initial BI is high, generally if it is more than 4+, we tend to extend the MDT. If signs of clinical activity is there towards the end of therapy, then also we tend to increase the doses of the time period of MDT. If there is clinically or bacteriologically proven relapse cases, we tend to extend it. If organ involvement is present, deep organs such as eye, testis or liver is involved, we tend to extend it. If patient is drug resistant, as already sir has told, rifampicin resistance is present, then alternative medicines need to be given for 2 years. And in immunocompromised patient, we tend to extend MDT. So this was my last question. I would like to thank all my panelists for such a special insight about leprosy. Leprosy is something we are still dealing with, and I loved to interact with my panelists. Thank you all for being patient. Thank you.
Thank you, Dr. Shivani. Thanks to all the panelists for the session. I would invite you to collect your mementos. Moving ahead, we have a lunch break of 30 minutes and we will resume our session sharp at 2 p.m.
Publication 132, Professor R.K. Panja Memorial Oration, Professor Dhanpati Panja Memorial Oration. So please, sir, draw.
Verrucous plaques over the trunk and the limbs for the last 4 months. Lesions had thick oyster shell-like scales. You look at the picture below. With atrophic scars. Mucosa, palms and soles were normal. So DD, differential diagnosis, lupus vulgaris, rheumatoid psoriasis, cutaneous leishmaniasis, pemphigus vegetans. Can any one of you guess what is the diagnosis? I would like a live, because the hall is almost empty, I would like an interactive session. This is the HP, shows pseudoepitheliomatous hyperplasia with lymphoplasmacytic infiltrate. RPR was 1:332 dilution, MAN2 test was negative. You can see in the picture, you can see the plasma cells and you can see this thing important. So what is the diagnosis? The diagnosis is a rare rheumatoid syphilis. There are 2 case reports, one in 2016 in JART case reports, and this is in the last published JART case report, a rare malignant form of secondary syphilis, often seen in immunocompromised and malnourished, mimics ostraceous syphilis, psoriasis, cutaneous lymphoma, and pemphigus vegetans. Excellent response with benzathine penicillin. This is taken from JART case reports. This is not my own case. Now these are my own cases. The unusual cluster when genital is not the venereal cause. You can see a boy with these penile lesions, penile warts you can diagnose, and also you can see the penile molluscum lesion. Her mother had also similar lesions on the genitals. So not always it can be close contact. Not everything cannot be genital. So it can be, you should always apply your mind before diagnosis. Husband, 32-year, wife, 20-year child, multiple asymptomatic dome-shaped papules in the genital region. So when you share your tiles, fomite bone infections can occur. The wife was affected first, the husband, then the child over 4 months. The diagnosis was genital molluscum contagiosum, initially suspected STI. Obviously for the reasons of now, some of the cases may be otherwise. I'll show you on picture later. Genital molluscum contagiosum, suspected STI. Genital lesions are always thought to be always sexually transmitted unless proven otherwise. But what is important is contact tracing within the families, not just the sexual partners. That is the take-home message. Now MSM is on the rise, we all know that. So redefining the landscape of the MSMs. 27-year-old male spa masseur with perianal verrucous growth for the 4 months. VDRL and HIV lesions were negative. Diagnosis of perianal condyloma acuminata. MSM cases are on the rise and highlighting the changing in the face of the STIs, the need of the focused awareness. Now we'll show you some pictures also, other MSMs. There is a comparison of the performance of the STI screening services for the gay and the bisexual men across 40 European cities. And results from the European MSM Internet Survey, they showed that there is also in the last, particularly in the COVID era, particularly in the pre-COVID era, there has been a massive increase in the MSM as well as the genital these lesions. Now this is one of my patients with passive warts on the perianal area. I had done 2 sessions of cryo, one session of even I tried it with podovert and somewhat reduced, but not all. Now on the right side, the MSM it might have multiple lesions. That is there's a picture which shows a small ulcer, a nauseous looking ulcer with warts on the genital. Now, when I investigated, the patient had warts, patient came for the warts. Patient actually does not tell me of the ulcer, but when I investigated, I find slightly indurated ulcer there. Then I went on to the history that the patient was having MSM and as positive in 1:32 titer VDRL. So changing pattern of the sex, that is the important thing. This is another case of patient had regional lymphadenopathy, firm rubbery discrete tendon nodules, bilateral firm, lesions spontaneously with 6 weeks, even without but infection persists. Now, this is a case which I would like you to see. This is a bank officer with his wife. Lesion on the penis, initially the wife came to me. So when I suspected something, I took the husband's history, took him to a separate room and started him quizzing. He admitted to going to spa parlors and had oral sex. So that was the cause. He had oral sex with his wife, and the reason was this primary development of the extragenital chancre on the lips. So both had lesions. So primary syphilis is incubation period 10 to 90, average of 21 days. Classical lesion of chancre is a hallmark. Usually solitary painless, ulcer with indurated base, raised well-defined edge. The clean base, non-purulent, highly infectious. Predominant location is the genital lesion, the penis, vulva, cervix, and the perianal region. The extragenital lesions, the lips, tongue, tonsils, fingers, the nipples, depending on the exposure area. This is one of the cases, the nuances of the STI and the HIV. This is one of the cases on the left side. This case was presented when I was taking an examination in SCB Cuttack. So it was diagnosed as a granuloma annulare. The initial diagnosis of them, it was presented to me as a granuloma annulare. But I found that probably I immediately had something suspicious. I stripped the patient. When the examinee was presenting the case, I took him inside and stripped the case. I found the lesions on the genitula. So there are multiple lesions on the multiple chancres on the genital. Whenever you have multiple chancres on the genitula and this lesion, the diagnosis becomes obvious that it is a case of a granuloma annulare like presentation of a secondary syphilis. And the patient was an MSM. This is the classical presentation of ST which we commonly found. This is the classical, these lesions on the palms, and you have this roseola like rash on the papilla syphilis lash on the trunk. This is what we normally find in an S2 patient. Now this leaves my skin boiling. This was done by a tutor of the elder sister to a 3.5 years old girl. And this is nothing but condyloma lata on the perianal area. And now you can see the mucous patches also on the child. I immediately put the POSCO Act, and I sent this is the tragedy in our case, I put the man behind the bar. I was able to do that, but the family withdrew the case after 14 days, saying that his girl will be stigmatized, and he will not find a groom in future. So his family withdrew the case, and the accused got scot-free. This is then the officer on duty, he told me that, see, this is the condition in our setup. So as a doctor, it is your duty to slam this act. There is an act of New Delhi on the 14th November 2012, the parliament passed this POXO Act. You should be always looking for, if you are not doing your duty, you yourself will land up in 6 months jail punishment. That is as a physician, it is your duty to important them. Let the courts decide what they do. But we should always do this thing. This is the act which you should always do whenever you see such case. Now 2013 to 17, the primary and the secondary syphilis was almost surged by 72.2%, alone 12.5% in 2017 alone, 9% in men, 21.2% in women. And whenever women syphilis are increasing, what is the danger? The danger is congenital syphilis. So rising cases in women fueled a rising case of congenital syphilis. In 2018 to 22, pre-COVID and COVID era, the cases of primary and rose steadily, increased 80% overall since 2018. COVID-19 cases continued climbing, 21 cases, 74% higher than 2017. So in 4 years, you had 74% rise. 2022, it was all stage syphilis rise, 207,000 cases. It was a multi-decade high. So what we are dreaming of was eradication of syphilis turned to be a nightmare for us. 3-year-old infant with palm and sole, mostly perianal plaques, featured split papules, oral commissions, maternal history, no antenatal screening, asymptomatic, lymphadenopathy, hepatosmegaly, VDR reactive in the mother, infant 1:32 dilution. So this is another picture that is I am showing. Syphilis is reemerging, that is important, congenital syphilis. This is the congenital syphilis picture. So what are the findings you can find in congenital syphilis? You can find this early disease and the late disease phase. These are the multiple things that you can see, from snuffles to radiographic images of the periostitis and metaphyseal dystrophy, to osteochondritis, to pseudoparalysis, and even the late disease, prominence of the Olympian brow, scaphoid scapula, tibial burrowing, Hutchinson's teeth, mulberry molars, saddle nose trees, ragged linear curves, Glatton's joints, all these things can occur, 8th cranial deafness, all these are part of your congenital syphilis. Now this is another hidden clues of an uncommon STI. Can you tell what is this? The patient had lesions there, lesions on the leg, and I noticed some lesions on the genital lesions. The lesions were, so what I immediately did, and this is another thing, I told the diagnosis sarcinate balanitis. Now you can diagnose the case. You can diagnose the case of the genital lesions. The classical lesion is on the right side, the left side is not that classical. So 32-year mild migrant liver present with psoriasiform plaques over the lower abdomen, groin on the axilla, a history of annular plaque on the glans penis, recent history of diarrhea and joint pain, palm and soles were uninvolved, no eye involvement, investigations revealed HIV negative, VDRL non-reactive, HLA-B27 positive. The diagnoses were reactive arthritis or Rita's disease. So the take-home message is extensive psoriasiform plaques can mask an underlying STI triggered dermatosis. Sarcinate balanitis is a crucial diagnostic clue, but it is not sacrosanct. It can be found in many other conditions. Genital examination should never be skipped. Rare dermatoses like this highlight the non-classical presentation of the STIs. High clinical suspicions ensures early recognition and management, avoiding the misdiagnosis. This is another thing. Old infection, new circle of disguise. A 39-year-old male taxi driver presented with us to painful genital ulcer for 1 week. He also had diabetes. On examination, there were multiple painful superficial ulcers on important. Initially diagnosed by some as candidal balanopostitis. I don't think he was wrong. But if you look at the lesions very closely, you will find that there are ulcers on the 6 o'clock position and also on the 5 o'clock positions, rather than the positions. You can see there are ulcers there. You can see the lesions there, and there are also lesions there. So these were, what are these lesions? There was absent lymphadenopathy. Gram stain from the ulcer edge revealed gram-negative coccobacilli in a school of fish arrangement. So it was a case of double pathology. A chancroid with this candidal balanopostitis. Again, on history, it revealed that it was an MSM. So diagnosis chancroid, and with this diabetic, so he has also had this other disease. Even rare STIs can manifest in clinical differentiate the changing face in their unexpected presentation. Annular ulcers of chancroid encircling the glands represent a non-classical pattern mimicking the ulcerative pattern. The lack of bubo or the classic undermined ulcers can mislead the class clinicians. Now I will show you a rare diagnosis disease which you do not see here, but in Bhumesh's area you find a lot of them. So what are there? Husband 35, wife 33 present with beefy red genital lesions with rolled edges and bleed easily on touch. Ulcers are painless, slowly progressive, non-healing with no lymphadenopathy and systemic complaints. Donovenosis is now extremely rare but can still occur sporadically. It is endemic in Papua New Guinea, Brazil and parts of Africa. Variants into classical ulcerogranulomatous hypertrophic verrucous plaque. Diagnosis conferred with the detection of Donovan bodies, septip in appearance in Gymsharite basis or smear of biopsy. Now look at closer. Not all papillates are HPV. A 44-year-old presented with multiple soft fleshy lesions on the genitalia. Lesions were symmetrically arranged. Pain, discharge, pruritus absent. Papillae separated at the base, uniform in size and spool. No coilocytes on cytology. So what were they? These are vestibular papillomatosis. So take home message, vestibular papillomatosis are symmetrical soft filiform papillae with smooth surface, most commonly seen in premenopausal females. Acetic acid test is negative. Absence of coilocytes confirms the non-viral nature. As true STIs decline, benign variants increase being mistaken for a diagnostic pitfall. Careful examination prevents a mislabeling of normal anatomical variant as an STI. This was a normal anatomical variant. Now this is another case which I will present. My resident came to me running, sir, I got a case of bubo. So he presented to me as a bubo. Then I only told him do a biopsy. And the biopsy revealed that is squamous cell carcinoma. So yes, squamous cell carcinoma can reveal like this presentation. You can see that this was turned out to be squamous cell carcinoma. What is it? Differentials? Any? It is definitely, you all know, obviously in all these cases you have to keep plasma cell balanitis, and obviously you have to also keep erythroplasia of curate in the same breath. So both diagnoses should be kept in the same breath. This is another diagnosis, not an STI, but treatment with the broad spectrum antibiotics. Treated associated diabetes, mortality rate is high or higher in sepsis and diabetes. Just 2 more minutes. Just benign, this is case 10, this is a benign in malignancy in cells, but malignant in behavior, the deceptive phase of HPV. So 35-year-old security guard with slowly enlarging growth over the scrotum, and showed me with this lesion. Examination revealed salmon pink, clean looking verrucous mass over the scrotal skin with the papillated surface, minimum discharge, non-tender. Occasional local discomfort, no systemic complaints. Biopsy shows pseudoepidermolysis hyperplasia, no malignant changes. So impression is Bushkill-Winston tumor, large locally invasive verrucous tumor with HPV 6 and 11, histologically benign but clinically aggressive, wide surgical excision with clear margins, good prognosis, complete excision. And the last, probably the last case, a case of newly married girl reporting to me 3 days after the intercourse. This is on the right side is her picture. Immediately she came with slight of dyspareunia, fever and all this thing. Immediately I asked her husband to be examined, and the husband had these lesions on the plans penis. So it was complete herpes simplex. And this is the classical bubo, which I think Shubhesh will be taking up in the next discussion, the clinical findings. So what's new epidemiology? US trends show 80% rise in syphilis over the case 5 years, with the male to female ratio dropping to 3:1. and from around 12.21 in 2013, highlighting increased female risk and high risk of congenital syphilis. Case reports among women of reproductive age group jumped from 12.5 to 78 per lakh. And 2013 to 22, the large stage syphilis rising over 45% annually after 20. That is the COVID era. So rising neurological, ocular and otic involvement, that is the new dangers of syphilis. That is, these symptoms are now present in primary syphilis also. Be careful, you do not need a neurological neurosyphilis only in secondary or tertiary syphilis. Not only in primary, late primary, you can have it in primary syphilis also. So, 2023 report from Chicago noted that 68% of neuroocular syphilis cases in individuals without HIV, a sharp rise from 44% in 2019 to 55%, not among S1, but broader demographic risk. And this is the last thing you should know, that this is the new NACO guidelines. Syphilis has increased 3 doses of benzathine penicillin into 3 for confirmed cases in maternal risk. They have now modified their own recommendation to 3 doses. If a mother is positive, you should give 3 doses, not 1 doses. That is a modified NACO guidelines. Thank you. This is my book. I'll ask you to read, Clinical Focus on STD. This is under the IWB Academy. And I dedicate this lecture to Dr. Rathin Datta, who we all know. He was a pioneer in the field of this STI and past president of ISTD and one of my very close persons. Thank you. And particularly I thank all those from Bihar and others who have voted for me, have not voted for me. So I thank all those who are important. Thank you and big thank you.
Thank you, Dr. Das, for your nice presentation. Although only one question from me. Suppose one patient is having sensitive to penicillin. What is your drug of choice, second line? And what is its cure rate?
Penicillin desensitization should be attempted. That is the only answer.
That is the only answer.
Penicillin, there is no other alternative of penicillin. Penicillin desensitization is a very easy way. Only thing you have to admit the patient. That is the only thing. Yeah. So penicillin desensitization stands the treatment of choice.
Okay. Thank you. Thank you very much.
Thank you so much, sir, for highlighting such a difficult topic of STD. Now for the next session, I would like to invite Dr. Swosti Singh as the moderator. He is currently Assistant Professor NMCH Sasaram, Bihar. He has more than 15 presentations to his name and more than 20 plus publication. He has area of interests in vitiligo, dermatosurgery, STD, phototherapy and leprosy. He is Assistant Editor of Indian Journal of Pediatric Dermatology. Over to you, sir.
Yeah. Good afternoon, everyone. I'd like to invite my panelists. Dr. Anil Kumar Jha sir, and Dr. Dipti Biswai ma'am, Dr. Kailash Jha sir, and Dr. Pradeep sir, and Dr. Raju sir. Please, just. Yeah, very good afternoon. See, STI is a very important topic, and currently the tradition of STI treatment protocols that are to be very extensive. We have seen a lot of guidelines that are to be recently, for example, CDC 21, then we have NACO 2024, CDC 2024, WHO 2024. So according to the guidelines, we are following the common diseases that we get, are we treating them? So this will be my main focus, how certain clinical cases that we are encountering in our daily practices, how are we going to approach that? So first of all, we know the 5 major strategies in STI cases, like risk management, pre-exposure prophylaxis, diagnosis, assessment, and evaluation. So just STI, as we know that it is different from the common clinical setup. So I would like to ask my panelists whether they follow any different setup for STI patients when they come to visit. Dr. Raju sir, can you please highlight on this? Do you have
Hello,
in your
sir.
class?
Yes, yes. Actually, you know, the patient of STI, we should provide a private room. So we appoint a STI counselor. She or he will ask all the STI related questions. They are very trained. We can also provide some kit for knowing what was the cause, what was the reason behind that. We can also give some STI related to investigation, bedside investigation we can do. Thank you.
So there are different guidelines that we follow, either in a private setup or in a government setup, sir. Dipti ma'am, can you just say what is your setup means in the government sector? What do you have this, any additional like performa or?
Actually, it should have a different setup because
Yes.
in STI we need to examine the patient very properly because now the syphilis is rising trend, so we have to examine whole body, and we have to counsel the patient. Counseling center must be there, and the examination center, because the microscopy is very important in these cases. So we can do the microscopy immediately because few cells or few organisms we have to see immediately. So if you train our residents with the microscopic examination like the Gram-Stains and GIMSA, all these things we can do at the bedside.
Right.
So collections of sample and also the Gram-staining setup should be there with a microscope, and the Cusco speculum should be there, and
Yes,
a
yes.
extra just however how we are taking the pap smear. So
Yes,
you should
sir.
have a light. So for a different room we need actually,
Yes.
and for counseling also one extra room. So STD
Extra.
clinics should have a different.
Yes, so definitely well said, ma'am and sir. But since many of us are practicing in a private setup, we have to play all this same role by individual person. So we need to address on this focus aspect areas also. And since patients, we need to give more time, and most important thing is the data generation. Because this data we have to report, and the more number of cases that we report and the individual rare cases we report, that is going to help to build more epidemiological data and to frame more guidelines. So 5 P's that we have to take, all this is well known regarding the partner, practice, protections, past history, and some pregnancy intentions. This all has to be asked to the patient. Now coming to the diagnosis that we are going to focus by case wise. So patient coming to a genital ulcer, sir, how do you approach such cases? Anyone, my panelist, anyone can approach. Any specific clues that you look towards the diagnosis?
First of all, we will see the lesion.
Yes.
Yeah. In first case, I am seeing the only one lesion. It is undermined lesion.
Yes, sir.
In second cases, there is multiple papules. So it may be herpes. And the
Yes,
third
sir.
cases, I see the undermined and the multiple ulcer is there. It may be lymphogranuloma.
Yes, sir. So obviously STIs, genital ulcers, when we focus commonly on the STI, we have the common infections that comes to our mind is the herpes, followed by then syphilis, which is an increasing trend. Many of the cases are being reported from US in the rising trend, as sir has also mentioned. Then we have donovanosis, which is rare now. LGV, rarely we see the ulcers. Now coming to most common, that is herpes. We know herpes, how to treat it. We generally prescribe acyclovir irrespective of going detail into the history. So I wanted to ask, whenever case of herpes comes, which investigations do you preferably do in that patient?
Jank smear.
Jank smear. Sir, anyone, please.
Mostly we clinically diagnosing it, but sometimes
Right.
it poses problem where they have applied some kind of irritant, like Dettol or anything, any wipes. So at that time we can send the Jank smear, as sir said, and we can send also, we can do the serology also for IgM and IgG.
IgG and IgM. See, one most important thing is that the highly most effective diagnosis is NAT, but still NAT is not that available. So commonly what we do in our PG graduation, that was Jank smear, that was commonly we used to do, but the specificity is very high, but sensitivity is very low for this test. And second thing is that type specific IgG is most commonly preferred than IgM, because IgM is not going to say any serotype. So IgG serotyping that we commonly prefer. But certain times we don't have an ulcer. So in that situation, IgG type specific can be more helpful for the diagnosis, as well as the titer. If there is a sudden rise in the titer, we can say that there can be an increasing. For example, IgM titer is if it increasing. Second thing, sir, which drug do you prefer? Many of the time, I get the patients, sir, we are on valcyclovir, someone on acyclovir.
Acyclovir.
Acyclovir, sir. Which agent do you prefer, sir?
Acyclovir is good, there is no doubt in that. And recommendation-wise, everywhere acyclovir has been recommended.
Yes,
but it has to be taken for herpetic
multiple doses, 5 doses maybe.
200 mg 5 times a day. But due to convenience, I prefer valacyclovir or famciclovir, in which case either I can give 500 milligram thrice a day for 7 days, or 1 gram twice a day for 7 days. That way the convenience part is covered up.
All right, sir. So acyclovir is usually most preferred in children as well as in pregnancy stage. Valcyclovir, because the viability is much more, so and the dosing schedule is very less. So valcyclovir is generally preferred, but the cost is very high. Famciclovir, only the suppression of herpes, that is not as good as valcyclovir. And even for the recurrent stages, famciclovir, the suppression of the herpes virus, that has not been that effective. Although the bioavailability is more, but the dose, the bioavailability, the time it reaches, it takes longer time. That's why the doses are very high. Next, coming to suppressive therapy. This is also another, because patients are, when they do come, we have to take a decision whether we need to start a suppressive therapy or not. So what are the indications when you start suppressive therapy?
When there is more episode, more than 6 in a year,
right,
or in a 6 months. Then
sometimes 2 to 3 episodes. Do you think to start suppressive therapy?
Repeat again.
2 to 3 episodes, suppose, if the patient has.
More than 6.
More than 6.
More than 6.
Any conditions do you think where you can start suppressive therapy with 2 to 3 episodes too?
Yeah, that is there, because normally herpes simplex type 1, its recurrence is less.
Yes.
That is 2 to 3 times. But herpes simplex type 2, herpes progenitalis, which is sexually transmitted, its recurrence rate is more. It is more than 5 to 6 a year.
Yes, sir.
In those cases, we have to give the suppressive therapy for at least a year, at least 1 year.
Yes, sir.
Yeah.
So do you think the severity also does matter to start suppressive therapy? If suppose HSV infection has occurred and the patient has a severe erythema multiforme like lesions or severe reaction to HSV, so in that situation, do you think to reconsider suppressive therapy as with 1 to 2 episodes only?
You are telling that if herpetic lesion is leading to erythema multiforme eruption.
Yeah, severe reaction if you are saying.
Yeah. In those cases also, there is some confusion between the two, because for controlling erythema multiforme, it's oral antihistaminic and a topical steroid. It is not going to control. You have
Yes,
to give
sir.
steroid in low
Definitely.
doses.
Yes.
In those cases, concurrently, we have to give the both. That is systemic steroid in low doses, as well as the suppressive treatment has to be continued. We can't stop it.
Yes.
Because at times what we have observed in practice, that I have got so many cases, post-herpetic erythema multiforme, along with vitiliginous patches.
Yes, sir.
So we have to give suppressive therapy along with the low dosage corticosteroid, but for longer period.
Right, sir. Any psychological, if the patient is very psychologically distressed, in that situation also we can consider suppressive therapy as an with 1 to 2 episodes or 3 episodes.
To be very frank, for any of the dermatoses, mostly chronic or the stigma part like vitiligo or psoriasis or STD, once we ask the patient to visit a counselor or psychiatrist, it fires back.
Yes.
So since very long, I will practice since 35 years, and during those time, I was using this imipramine or amitriptyline as a mood stabilizer all day. You can tell the mild antidepressant. Right now, I am using one of the safest antidepressant like escitalopram in low doses.
Yes.
And after discussing the dosing schedule, which I can manage along with my psychiatrist friend or partner.
Yeah.
I am using escitalopram left and right. If there is no issue of sleep, once there is issue of sleep, I combine with clonazepam along with escitalopram.
Right, sir. So very well said, sir. I only just wanted to add these few scenarios where we usually can consider suppressive therapy, even in HIV, where the HSV manifestation cannot be there, but the shedding is always throughout it can occur for a prolonged period of time. So there also suppressive therapy can also be indicated for with few episodes of herpes. So right, so any topicals or acyclovir do you prescribe in your clinical practice, sir?
Never seen the good result of topical acyclovir.
Right, sir. So
whether be it herpes simplex or herpes zoster, I always go for the mupirocin preparation.
Right, sir. There is no recommendation for any topical therapies of acyclovir currently now. Sir, any viral shedding to prevent? Viral shedding like, for example, acyclovir, tenofovir ointment, or any like Viva gel that was used in 2007?
I think no use of topical.
Yeah. Only, sir, tenofovir, in HIV patients, they have said that it reduces viral shedding for long, but as such, no other effective treatment till now to prevent viral shedding. Sir, suppose a patient with asymptomatic partner, suppose the patient comes to you, he said that my partner is having herpes and I am asymptomatic. Do you prescribe prophylactic acyclovir to them?
If there is active sign, then we can give.
If it is active, the partner is asymptomatic.
I don't think.
Yeah, asymptomatic partner only when we usually don't prescribe prophylactic acyclovir, except if the present partner is having an active lesions, then only we have to just plan prior to the contact. And even if the partner is active, we still counsel that to do a safe sex practice or avoid till the resolution of the lesions is there. So, sir, in pregnant lady, suppose patient comes to you with a single episode of genital herpes and in terms, she is now yet to deliver, she had a past episode. So what thing, are you going to start a suppressive therapy in this case?
No, not definitely, because in pregnant lady, we have to wait for, it may come or may not.
Yeah, yes, sir.
In the case of pregnancy, I don't think any medication has to be given in the first trimester. And if at all there is any history of this herpes progenitalis, but when at the time of delivery,
yes, sir,
at the tentative time of delivery, or we can see the EDD, around that, if there is any lesion, we are supposed to give the suppressive or even the real dose for preventing this herpetic eruptions, because in those cases, if there is normal delivery,
yes, sir,
if the seizure is not there in normal delivery, then the baby can have herpetic neonatal in his
yes,
eyes,
sir,
and it is very dangerous.
Very well, sir. So suppressive therapy can be given at 36 weeks, those who have an episodes of genital herpes prior, to prevent herpes, because this is another indications of doing a cesarean section when the patient have active genital herpes at the time of delivery. So another question, sir, do you follow reverse algorithm of doing in syphilis? Our traditional way of doing was that VDRL test we do, then we follow TPHA. And now a concept of reverse algorithm of doing test in syphilis. So in which conditions do you feel to do this?
Now the reverse algorithm is trending because all the microbiologists are also preferring to do this reverse algorithm. Mostly when the lesions are there, but the VDRL will not come positive, so we have to go for this.
So many times we think syphilis is there, but the VDRL, the first go may not be positive because we are in the early stage, or it can be a late latent phase where the no clinical symptoms can be there, but all of a sudden in blood transfusion we get this VDRL positive. And in cases of HIV, where VDRL can be negative, but TPHA can be positive. In such situations, we can follow the reverse algorithm. And what's the recent guideline? They says, this is the recent guidance from the NACO, where reverse algorithms should be preferred in cases of these scenarios, right? So, sir, how do you manage if a patient has, for example, you have treated a case of early syphilis, and after a few days, he again had a recurrence of ulcer over the genital penis. So how do you approach such case?
We will start from the primary syphilis treatment.
Yes, primary syphilis already the patient has been treated, and suppose he again, after 1 week again he has developed another ulcer, same primary chancre he has developed. So do you think of reinfection or re-exposure in such scenarios, or do you look for the VDRL titer again, which is increasing trend or not?
Yes, we can do VDRL titer, and we can start TPHA test and then start primary syphilis treatment.
Yes, if we are suspecting reinfection, definitely we have to retreat again. Do you prefer PCR or dark field microscope still today?
Yes, we prefer PCR over dark field.
Right. So PCR always we prefer when the ulcer is not present, or even it is a dry exudative ulcer where the exudates are very minimal, where the dark field cannot catch. So PCR is must, in that scenario it can be superior also. Even in HIV where dark field cannot detect, but PCR can detect the syphilis virus. IgA, treponemal IgA test. Do you do common routinely in your practice?
No, only for congenital, I think.
Yeah, so IgA, yes, congenital syphilis we commonly do, just to rule out whether, because IgG can transfer from maternal to neonatal case. So neonatal case we commonly do, as well as in early stages where VDRL can be negative. So in that scenario. Now case of vaginal discharge, right? So vaginal discharge, any sir clue towards the in clinical etiology that you commonly see among the vaginal discharge patients? If you want to approach a case of vaginal discharge, sir, any clinical clues that you can look for to classify on etiology basis?
What type of discharge we see first?
Yes, discharge, color and all. Any particular examination specific you want?
Specifically, when one patient will come to you to vaginal discharge, that's called vaginal discharge syndrome. So we have to categorize according to the discharge, what is the type of discharge. You can do a simple test, that is the litmus paper test, that is pH test you can do, and
yes,
see that whether this is, if the color is changing, then it is pink color, so acidic environment is there. So you can, from this you can classify that yes, there may be a candidiasis or trichomoniasis vaginalis. So you can do simple test. And if it is alkaline, no color change in the litmus paper, then you go for the endocervical collection of the specimen, and you can send for the cramp staining.
Yes. So currently the NACO 2024, they have highlighted one thing for examination, that is pars speculum, as ma'am said, cervicitis that you have to see, because the etiology just changes. So according to that, the treatment can be specific to the organism base that we can target. Now coming to vulvovaginal candidiasis, as we know, it is one of the most common discharge that we commonly get the patient. So do we differentiate complicated versus uncomplicated during that time when they present? Because the prognosis depends on that, and the recurrence also, and the treatment course.
In complicated, we see this is more serious and more erythema is there. In uncomplicated, slight or mild itching is there.
So severity as well as recurrence rate, that also varies. So suppose if the patient has more than 3 episodes, so in that scenario, sir, how do you approach the patient?
First of all, in recurrent BVC, we have to see that whether actually there is a candidal infection is there or not. Because
Yes,
so now the turning point is that there is a mixed infection.
Yes, ma'am.
So there are as the discharge, seeing the discharge, we can classifying the in the past, but now it is not like that. Also, the trichomoniasis can have the acidic environment, and also there will be mixed infection that may come from the also the status of the patient. So we have to culture the organism, because albicans is now in the trending and coming. So we have to see with culture.
So in such cases, ma'am, culture is another good option. So if suppose we get non-albicans, then how do you treat that patient, ma'am? Any treatment management is different, or it is just like we are treating with the same fluconazole topic?
Molecules we can try, and we can, because there's a
About boric acid?
although antifungals are costly,
Yeah.
what are the different options available? So we can treat accordingly like that, we can increase the dose, or we can treat it for a longer duration.
Yes. So boric acid is another nystatin that can be added.
Yes, the boric
Apart
acid
from
also,
that,
the cotrimazole we are not using, we can go back
back.
to the history also, we can use the patient.
Urethral discharge, ma'am. This is another topic where it is also the cases are very common. So, sir, do you differentiate between gonococcal, clinically, sir, clonococcal and non-gonococcal?
Yes, onset of lesion is very important. In case of gonococcal, you can see lesion, this discharge may come in days, but in cases non-gonococcal, it will take time. The discharge is, in case of gonococcal, it may be greenish in color, but there is no color differentiation in cases non-gonococcal. The patient may also come with fever in case of gonococcal, but there is no symptoms come with non-gonococcal urethritis.
Yeah.
Dysuria, this is very common in both.
So, just looking at the urethral discharge, the pattern, we can predict the common etiological organisms too. Suppose this patient, we had gram-negative organism, diplococci, that we can see over this picture over here. So we had treated with syndromic approach, and the patient now again had recurrence of the lesion just after 1 week. So, sir, now what are you going to do in this scenario? Are you going to consider it as a treatment failure or reinfection in that situation? So how are you going to approach this patient?
In that situation, most probably it is non-gonococcal, like chlamydia, and in those cases, we shall give the treatment choice like doxycycline, 100 milligram BD, or the minocycline, 100 milligram BD for 2 weeks.
2 weeks.
That will do.
Yeah, so this is another update. So treatment failure as well as reinfection, based on the history, we can again recollect that. And since gonorrhea is now, we have seen a lot of resistance to the standard treatment. So another, we can test the resistance pattern of gonorrhea also. So if we are getting treatment failure, we need to add treatment for Trichomonas vaginalis as well as M. genitalia. So M. genitalium is now another great organism that we are seeing in a higher frequencies. Even it has been much more reported in MSM patient as well as in Delhi area also. We have seen a lot of cases with Mycoplasma genitalium. So suppose if we get the same with M. genitalium. So M. genitalium, as we know, the treatment guideline is different from the kit 1. So the current guideline that they say that azithromycin followed by 2 to 3 days, again we have to taper the dose to 250, and then you have to continue for 2 to 5 days. So now this was another during my resident area. This is topic are less discussed. So a rape victim, suppose a patient come to you and we usually get a call. So now how to approach in that scenario? Most of the time we get a call for STI prophylaxis. So how in that scenario, what are the protocols of STI prophylaxis that we need to follow in that patient?
First of all, we will take the consent.
So definitely, sir, consent.
Then we will examine. Okay. After that, we will, if it is she is 18 years, then we will give the pill, contraceptive pill at that time, and then we will take the smear and examine it.
So any prophylaxis do you prefer? Any antibiotic prophylaxis that you can give? So according to the CDC as well as the NACO guideline, they have said that prophylaxis treatment can be given, but we have to take a proper consent. We have to not to examine, because already the forensic team as well as the gynecological team, they have already done the examination. So our main part will be to focus on the STI prophylaxis that they will be calling for us. So most of the time we have to just send all the tests that we have to routinely do, that we commonly do for our STI screening, and then we have to give the prophylactic treatment. Right, so this is emerging cases that we have recently seen. A pustular lesions that we can see that is painful over the genital area. So the patient was again had fever and inguinal lymphadenopathy. So what are the possible, he had a high risk behavior that can be, that we had elicited on the history. So how do you approach this case, ma'am?
mostly a postural lesion, so we have to see that first of all, we will not think that this is STI. First thing will come in our mind, simple thing, that is a folliculitis. Then we can think of that Behcet disease also have a neutrophilic folliculitis, so we can go for that. But now the trending infections here is the mpox.
Yes, ma'am.
So the ulcer at the central depressions also go towards that lesions typically. So in the thigh, genital area, we can think, but in the first instance, we have to think that this is a folliculitis case.
Yes. Any other opinion, sir? Yeah, so this was recently the postular eruption in the genitalial area. Commonly we diagnosed as an folliculitis and we just mistreat it. But the trend of STI for mpox that has been currently been in, so isolation of the patient and it resolves without any antiviral, but though FDA approved drug has been there, but it is still under evaluation. It has still not been available in India till now. So this was a case another, which was very interesting case of L.L. Hansen, which came to our OPD with type 2 reaction he had. He had a 15 days swelling over the bilateral inguinal area. So after that what we did a screening for STI, we got negative for syphilis as well as LGV. We did for Sankar also. But on gram stain, we can see multiple AFB positive bacilli. So how to think about this patient? How to go about whether it is an STI or non-STI? Presenting like an inguinal bubo-like swelling.
Non-STIs also can present in bubo.
Yeah, so this was a case of ENL with inguinal bubo-like presentation. We just had given MD-MDT treatment and we had drained the fluid, and just after 1 month of treatment we can see the scars has all resolved. So now another great topic that I wanted to discuss was, just with a few time, telemedicine scope. So how do you look forward telemedicine in STI? Because I have a lot of calls, sir, I had an exposure, what to do next? So do you think any clinical practice that we do front-to-front faces, can telemedicine be a replacement or can it be done in a better way?
Nowadays, telemedicine is very useful. In remote area, patient does not want to come to the STD clinic.
Yes.
This is the stigma. So they can upload their photo. We can manage this.
So yeah, telemedicine is another gray area where we need to focus, because STI, many people, they don't confront to us immediately. They want in a privacy setup.
Actually, I won't prefer, because the genital cases, the patient will not upload the photo.
Yes, yes.
Also
definitely.
the video. So if we have a secure app, then we can do this telemedicine. But otherwise, normally we could not.
Right. Last, we have 1 minute, ma'am. AI in STI. So how do you use AI in your STI practice? Raju sir, please. AI, how do you use now? Because AI is another upcoming topic on STI. So just I wanted to bring few things regarding that.
Nowadays, AI is very good tool to diagnose STI, because they can differentiate many patterns. We are usually learned about guideline of CDC to 2021, 2023, and they can provide more accurate guideline of WHO and CDC. So we can use AI.
Yeah. So how I use AI is just like diagnosis is not an issue for me, but sometimes the guidelines made me more tougher to approach. So we have CDC, we have WHO, we have NACO. So what I do is that I just compile all the PDF to one AI and just ask whether give me a summary on that details. So what is the current approach? They usually mention all the treatment guideline and comparative analysis also. So this trend currently does help me more rather than to just remember a lot of things.
Now AI mostly in scoring system, the new gen scoring systems. They are using this AI. Also there is other scoring system. We can use that one, and also for the STI guidelines. Only for this reason we can use.
Yeah. I will thank you everyone. Thank you my panelists also too.
That was a wonderful panel discussion on one of the most grey areas of dermatology. Thank you, Dr. Suvesh Singh sir and all our panelists. Moving forward, any more questions from the audience or panelists if they want to say something? Okay,
No,
okay.
no. Thank you.
Okay, moving forward to our next session, I would like to invite Dr. SKP Chaudhary sir and Dr. KK Jha sir to please chair the next session. This is the first session of pediatric dermatology. Dr. SKP Chaudhary sir and Dr. KK Jha sir.
I would like to invite Dr. Jaydev Betkarur, Professor and HOD Department of Penn Medical College, BHARAT. He was having more than 100 presentations and more than 50 publications. He has to speak on pediatric genital dermatosis.
Thank you. When this particular topic was suggested, I thought it was a simple subject, but then I realized that I'll have to talk entire pediatric dermatology if I continue to do that. So I'll confine myself to very few of the conditions and just to give you overview of genital dermatosis. Genital dermatosis are less likely in children, but they are also the same as adults also. The same diseases can affect, but there is a distinct difference between the two. That is, infective conditions are more common in children than in adults. In adults, you tend to see non-infective conditions. And girls are supposed to be more likely to have genital skin disease, and this could be due to genital abuse by self or by use of, without there being good hygiene. And of course, we need to consider sometimes sexual abuse among these patients also. The reasons for this infections being more prone to genital area is that it is warm, moist, and always most of the time occluded also. It is always most exposed to irritants like urine, feces, vaginal discharges, and very often to cleansers. And itching, of course, the external genitalia are very commonly present with itching and rashes. Scrotal skin in male child is also very prone for some of these diseases because it has got a high permeability and it provides an easy entry to foreign bodies, especially to irritants and allergens. Vulval skin, it was thought to be that the absence of estrogen makes it more prone for skin diseases, but it has not been proved beyond doubt. So these are some of the etiological agents that can produce genital dermatosis in children, and the red ones are the ones we'll have to concentrate that they are the most common presentations. Coming to nutritional deficiencies, vitamin deficiency, vitamin B deficiency, that is riboflavin and nicotinic acid deficiencies can produce some genital dermatosis, scrotal dermatitis in riboflavin deficiency and pellagrous skin in the scrotal skin in nicotinic acid deficiency. But we are concerned with the zinc deficiency that is usually presents with what we call the acrodermatitis enteropathica with severe itching and erythematous and oozing lesions around the genitals. Of course, the treatment, I'm not getting into the details of all the treatment of this. Probably all of you know about how to treat these cases. Coming to infections and infestations, the commonest are the candidiasis, especially the napkin rashes, scabies, of course, molluscum contagiosum. Unfortunately, molluscum contagiosum is not that common in children, as common as in adults. Impetigo and boils are very common in genital area of children. These are some of the cases of molluscum contagiosum, and dermatophytosis can also there. These are slightly adult patients. And you can see some nodular scabies on the genitals. Genitals in children, genital nodular scabies is less common compared to adults. These are the other impetigo and the napkin rash in children, probably due to continuous usage of napkins. I'll get into some of the common ones, or the probably the rarer ones, that is the genital LS. I think you'll have to forget about EA because this is not to be used now. It's a disease of unknown etiology. It is commonly seen in female children rather than in male children. Presents as pruritus, soreness and ecchymosis with atrophy and phimosis in males. It can spread to perianal area, causing pain and constipation also. The commonest differential diagnosis we need to consider, especially in children when the atrophy has not yet settled in, is vitiligo. Others can be there, but vitiligo should be considered because there is something called vitiligoid LS also. So in most of the children, especially in females, 2/3 of the cases heal spontaneously. We can try either topical corticosteroids, intralesional steroids, tacrolimus, and I believe that in all the cases whom I have seen, phototherapy has worked very well. So I would like to continue phototherapy in these patients along with topical steroids. These are the images I have taken from Dr. Atili's article in this one. I have quoted that. The phimosis there, and in the same patient, it has spread to the perianal area in a male child, almost causing phimosis due to LS. And this is again by the same authors, where the vulval LS is there along with affecting the upper abdomen and also the thighs. And that has led to vulval atrophy also. In children, in adults, in males, it can affect the scrotum also, apart from the penis, penile skin. This is another case of, it presents as vitiligo, but histopathology has to be done, biopsy has to be done to rule out LS in these cases. So this is a case of vitiligoid lichen sclerosis, which was misdiagnosed as vitiligo. So vulvar vitiligo can also occur. It's quite common. I have not seen much of vitiligo in children, male children, but I have seen quite a good number of cases of vitiligo, genital vitiligo in female children. And diagnosis, as I said, LS is one needs to be considered. Treatment is quite simple. I prefer to use handheld phototherapy in these patients because of the easy accessibility to the treatment, because institutional based phototherapy may not be that useful in these patients. So handheld home phototherapy is best for these patients. And topical corticosteroids, especially fluticasone, helps good in these cases. Now probably you can also use tofacitinib. Non-infective conditions like psoriasis, seborrheic dermatitis, atopic dermatitis can also affect the genital area in children. But again, the treatment remains the same as we do in case of adults. Now coming to the other one, that is the contact dermatitis, which is quite common in children, probably because of the scrotal skin being very prone to these agents. So some of the agents that have been proven beyond doubt are probably the fragrance that is present in the wet wipes. That is supposed to be more common to cause irritant or contact dermatitis in children. Some of the floor detergents, bleaching, cement, these also can cause. This one study was on the dogs, and they also opined that it may be a factor in children because they are also crawling and sitting on the floor. And ICD can also occur due to antiseptic bath emollients also, but it is not of a main, these are adult patients of contact dermatitis, so I will not get into that. Now coming to some of the very specific conditions of children being affected or with these. One is the juvenile gangrenous vasculitis of the scrotum. This was described in 1974. It is thought to be a case of a variant of pyoderma gangrenosum, but the some of the characters do not fit into it because it has a spontaneous cure and it does not recur as PG does. So it is characterized by pruritus, burning sensation, and it is rapidly progressive, but it heals. It's not associated with any systemic disorders, and histopathology is very non-specific. It is a self-limiting condition, and complete resolution occurs in 2 to 3 weeks. There is no relapse. So that is the rule in case of this condition. It was considered as thought to be an PG, but as I told you, various reasons are there to say that it is not but it is also thought to be a variant of ulcus actum volvae also. And there was some discussion about this being Behçet's disease. Again, that has not been proved beyond doubt. These are some cases of this case, that is the juvenile gangrenous vasculitis of the scrotum in children, and that is the other case is of pyoderma gangrenosum. The other one is the rare condition is the Fournier syndrome in infants, which is named after Fournier, who described it in 1883. It is nothing but a necrotizing fasciitis of the genitals. It is the circumcision or some of these diaper rashes can be the inducing factors for this. Medical treatment is usually successful. Some patients may require a debridement. Other one is the last one is the acute idiopathic scrotal edema, which was described in 1956. It is usually the scrotal, one part of the scrotum is swollen in these patients. There is scrotal discomfort and inguinal swelling may be there. Etiology is unclear, absolutely don't know what exactly causes this. Probably a type of angioneurotic edema. There is some amount of eosinophilia in 67.7% of these patients. It is nothing but a diagnosis of exclusion. You need to exclude some of the acute scrotal conditions like epididymitis, testicular torsion. So all these conditions need to be ruled out before you call it as this case. So there is a certain sign called fountain sign on color Doppler that can help you in diagnosing this acute idiopathic scrotal edema. These are from the net in images, not my own cases. So this is how it presents and usually resolves. Other reports have been there, various others like cytomegalovirus, CMV viruses, fig drug eruption can all occur on the genital area, especially on the scrotum. To conclude my lecture, where I have tried to confine myself to very limited conditions, the genital infections or genital disorders are more common in school-going children, probably more of infections because of the poor health or the poor health education of these patients do not know how to use, or it could be also due to abuse, also genital abuse. So we need to improve the health education of these children and also provide them toilet training and good nutrition to prevent some of these genital dermatosis of the skin. Thank you very much. I hope those 2 lines, please read that and please join DBL Welfare Trust to help all and help yourself. Thank you.
Thank you, Dr. Jaydev Betkeru, for nice and informative presentation. Any more queries or questions from the audience? No, okay.
That was an excellent session. I would request our chairpersons and speakers to please collect their mementos. For the next session, I would like to invite Dr. B.K. Sinha sir and Dr. Bijay Roy Chaudhary sir to please chair the session.
Now I invite Dr. Ram Gulati. He is consultant dermatologist at Gulati Clinic. He has number of presentation of more than 50. Former locum consultant NH Group of Hospital, Glasgow, UK. Former ordinary clinical teacher, University of Glasgow, UK. Former coordinator, SIG Pediatric Dermatology, IDVL. Editor-in-Chief, IDVL Handbook of Pediatric Dermatology. Book chapter, Dermatology Gulati, Jury C, etc. The topic is secondary infection in atopic dermatitis.
Thank you very much, sir. A very good afternoon. And I think we were just discussing the side effects of having a conference in Puri. So very few people stay and many people go to the beach. And that is what happens when you have a wonderful location for having a conference. Secondary infection in atopic dermatitis. I think atopic dermatitis is something which is so well discussed in almost every conference. It is one of the most common skin disorder that one sees. Even though it is largely seen in the pediatric population, nowadays in the adult also the incidence is rising. So this picture just shows the comorbidities of atopic dermatitis, and you can see infection as one of the comorbidities. So there is something in infection skin, in atopic eczema skin, that is making it more prone to secondary infection as compared to people who don't have eczema. There are multiple articles which show that there is an increased incidence of infection. So this is just one from 2018 showing an association between atopic dermatitis and not only serious cutaneous infections but also multi-organ and systemic infections. That's a US study. And it showed that there is an increase in cutaneous, respiratory, multi-organ and systemic infections, and that led to a significant increase in economic burden of atopic eczema on the society. So one can see eczema herpeticum, erysipelas, cellulitis, but then one can see endocarditis, encephalitis, and especially MRSA, which if you culture certain infected eczemas which are not coming under control with normal antibiotic that you give, you will find MRSA in the community to a great extent as well. The question is, why are these patients prone to secondary infection? Because if we know some pathogenetic mechanisms which is making them prone to secondary infection, we can probably rationalize our treatment to that. And that is what is happening today. If you see biologics, that has come out only because we knew more about the pathogenetic mechanisms. Once we knew that IL-4 and IL-13 are the ones which are causing an issue, we got dupilumab which can act towards it. Then we found that JAK inhibitors is kind of a final common pathway. We got JAK inhibitors in. So if we get certain pathogenic factors that we can stop, we can have some preventive strategies to prevent a secondary infection. Now this is looks like a very busy slide, but there are not many points in it. So this is kind of the rationale for why secondary infection happens. So if you just look at the top you can see that first is genetic mutation, toll-like receptor, structural proteins of stratum corneum. So in big it says disrupted skin barrier. So if your skin barrier is disrupted, then there is more chance that the microbial insult is going to go in and cause a secondary infection. So if you look at genetic mutation, the commonest one studied is filaggrin mutation. So filaggrin is a structural protein. So you have got other structural proteins like involucrin, loricrin, claudins. So these are, claudin is a gap junction protein. So these proteins, if they have mutation, then you have got a disrupted barrier. And it has been shown that almost 30% of not only European but even Asian descent people have been shown to have a filaggrin mutation. Then if you look at toll-like receptors, so these are the receptors which are found on many cells, and these are the ones which can sense the microbes like Staph aureus, and they can have an action against it. But it has been found that the sensing is deficient. So again, it is kind of a barrier defect. Now, if filaggrin is deficient, then what happens? Now, filaggrin gets broken down into certain amino acids, including urocanic acid and pyrrolidone carboxylic acid, or PCA. So these are all acidic in nature, and they contribute to the acidic milieu of the stratum corneum. And you need an acidic environment in stratum corneum. Again, it not only for the integrity of stratum corneum, but also it acts like a a prevention of infection rationale. So if the pH alkalinizes because the filaggrin is not broken down into its constituents, again that causes increased microbial insult. So there is over-colonization of Staph aureus and Malassezia seen in majority of the patients of atopic eczema. Now there is also a theory that there is a dysbiosis in the gut. So there is some communication between the gut microbes and the skin microbes, and that can happen through neural mechanisms, through endocrine mechanisms, through immune mechanisms, and that can contribute to increased load of Staph aureus and Malassezia on the skin. If you look at immune dysregulation, then definitely we all know that immune dysregulation again is going to cause reduced resistance to Staph aureus and other organisms. And there is an increase in IgE, which again has shown to be one of the factors which can cause increase in Staph aureus colonization. For example, if you see hyper IgE syndromes, they get a lot of secondary infections as well. So how does secondary infection present in atopic eczema? I think as far as this cartoon is concerned, we are going to probably, when we come to the preventive strategies, we will probably employ all these to see if they can be taken care of when we think of preventive strategies for atopic eczema. So when we say secondary infection, one of the commonest way the infection presents is by seeing that the eczema weeps, there are crusting, there are pustules, but then that is the common mode. But if you have eczema which is not responding to the treatment that it should, then think of a secondary infection, even if overtly you can't see the infection. And many of these eczemas, when you give an antibiotic, it responds because you can't see the overt manifestations of infection, but it is just the infection which is preventing this eczema from settling down. Again, rapidly worsening eczema where you can't find a reason, think of a secondary infection and employ an antibiotic. And if the infection goes bad, then definitely you get systemic symptoms like fever and malaise. Now, which infections are more common? And as we know that Staph aureus is the commonest one that you find. So you can mostly present either as bullous or non-bullous impetigo, or the eczema can just look like weepy and crusty, as you can see in this diagram, in this photograph. And it is this serous discharge with crusts and forms, this yellow honey-colored crust. And that is what his staph looks like. And then you can see in another photograph, this is a small area which probably was a bulla, and that has now settled down with crusting. So you can have a bullous or a non-bullous impetigo. Now, if you have a bullous impetigo, mostly it is staph. But if you've got a non-bullous impetigo, you get a strep as well, which can cause non-bullous impetigo. So whenever we are initiating an antibiotic, it is always worthwhile initiating something which acts against both staph and strep, because many times it is difficult to differentiate between the two. Again, if antibiotics which are effective against those like cephalexin, the cephalosporins, or you've got coamoxiclav is not helping, do think of MRSA as a contributory factor. So either we employ an antibiotic, or you can do a pus culture sensitivity and employ an antibiotic. Orally, clindamycin, doxycycline, cotrimoxazole, and linezolid are something which acts against MRSA. Now, it has been shown that patients who have got repeated secondary infection with staph are at a slightly higher risk for developing eczema herpeticum as well. Now, the second most common bacteria which can cause an infection is the strep, or Streptococcus pyogenes, and mostly it will present as non-bullous impetigo. But if it goes a bit deeper, you can see involvement in the form of erysipelas and cellulitis. So strep infections are usually deeper than staph infections, and you can have induration on the area. Now, this is one photograph I've taken from one of the articles which said punched out erosions with scalloped borders, group A strep pustulosis. Now, they published this one because they said that the picture almost looks like eczema herpeticum. So if you look at this dorsal of the hand, you have these kind of punched out lesions which you see in eczema herpeticum. So they said if you have these lesions and you've got pustulosis, then do think of strep as a contributory factor. So in this one, they did a culture and sensitivity and they found strep, but clinically they were not unsure that it may be HSV as well. So they actually gave both acyclovir and an antibiotic. And the rationale is that it looks clinically, what happens is that even if you do HSV PCR, there can be 10% false negative. So employing an antiviral medication is purely a clinical decision. It is not bound by the investigation. So if it looks HSV, do add acyclovir to your armamentarium. And now HSV, either it will present as a grouped vesicular lesions, which is something which you see periorally very commonly, and you can see a lot of eczema with the secondary grouped vesicular lesions. But many a times what happens is you just see these punched out lesions which are present in groups, and a lot of scratching there as well, because eczema herpeticum can be really itchy. You can do a PCR or Zank test, but again, as I said, the treatment has to go by the clinical rationale. We can't wait for the PCR and the Zank, the PCR to come. Zank, again, it depends. It's very, very subjective how you prepare the preparation. So the best is to actually start acyclovir orally, and if systemically unwell, definitely you admit and give IV acyclovir. The children who have got eczema herpeticum, usually it is seen that they tend to have more severe atopic dermatitis, early onset, high IgE, and they can have presence of other atopic conditions at the same time. The lower photograph actually it's not very clear, but this is actually a varicella involving the eczema. Again, varicella can be quite disseminated and hemorrhagic in children with atopic dermatitis. Coxsackie virus, I think we probably every other spring or autumn we get a lot of hand, foot and mouth disease, and they come in clusters because it is kind of an epidemic in schools that happens. And many a times eczema coxsackium is it is defined as an atypical hand, foot and mouth disease because it is the same virus, Coxsackie A16, which if a child has got eczema, then this can disseminate, but these children are usually not that bad as compared to eczema herpeticum, which can be life-threatening. So this is usually not life-threatening, but again, rarely it has been shown that Coxsackie A16 or atypical forms like A5 can have complications like aseptic meningitis, encephalitis, and meningoencephalitis, and carditis. So that is something which should be taken care of in people who get eczema coxsackium or even hand, foot, and mouth disease. Molluscum contagiosum, again, children with atopic dermatitis can sometimes develop, or on the contrary, sometimes children just with molluscum can have a ring of eczema surrounding the molluscum lesions. But children with eczema can have disseminated molluscum, and sometimes they can be almost multiple lesions of molluscum, as you can see on areas of eczema, even though you can see a couple of purely white lesions on the lower end of the photograph. But most of them have gone very red. So they can be very itchy. Again, you have to employ the treatment both for eczema and for molluscum. Once they are irritated and they are red, they are going to settle down on their own. So they are going to go. The only ones needing treatment would be the ones which will be purely white and left behind. So if you just leave it to there and maybe use some anti-inflammatory therapies for a few days, and if secondarily infected, you can have an antibiotic, they should settle in some time. If you have got a lot of molluscum and severe eczema which is not coming under control, do think of immune deficiencies as well. For example, hyper IgE, especially DOC8 deficiencies, they can sometimes present with multiple warts and molluscum contagiosum lesions, which should be thought of. Warts, I think it's a question mark, and the jury is quite divided as to whether a lot of warts are seen in eczema patients. So there are authors who say that there is increased propensity to have warts, and there are others who say that the warts is not something that you see a lot in eczema patients. And there has been one of the articles where there were a lot of diffuse warts with severe atopic dermatitis, and once the dupilumab was started, all the warts subsided as well. And there was a thought process that somehow the inflammation was impeding a defense against the warts, and as the inflammation settled, the body took over. Again, head and neck dermatitis, if you have, and it is not coming under control, do think of malassezia as a contributory factor, and it has been shown that growth of malassezia is much higher on the surface in atopic dermatitis patients as compared to normal patients, and itraconazole addition can help. Prevention of cutaneous infections, daily warm bath followed by, again, if you go back to the rationale, defective skin barrier is one of the reasons that these children get a lot of infections. So if you can have a reproduction of this barrier, so put the emollients and moisturizer. Application method is in the hair, in the direction of the hair follicles, and if they are applying from a jar, make sure that they don't put their hands in it, so there is no cross-contamination of the jar. And it has been shown that petrolatum, even though it's an inert moisturizer, does help in barrier repair and increases the antimicrobial responses. Treating staph colonization, the personal hygiene practices should be, I think there should be a session for how personal hygiene has to be improved, so that the hand washing, daily showering, avoiding or reusing the personal hygiene material, avoid contamination of the moisturizers. Nasal decolonization can be given in children who are getting infection again and again. So it is intranasal mupirocin 2% ointment twice a day for 5 to 10 days, and this can be repeated monthly for 6 months if it is recurrent infections. And then bleach baths for 15 minutes twice weekly for 3 months is something which can be used as well for recurrent infections. Now, anti-inflammatory treatments like simply topical corticosteroids and calcineurin inhibitors, they also help in reducing inflammation and they improve barrier. They improve the staph colonization, they increase the microbial diversity. And it has been shown that these products do not increase the onset of eczema herpeticum. Managing itch, definitely. If the child scratches less, there is less damage to the barrier. So in summary, what I would say that atopic dermatitis patients are at a higher risk for secondary infections. It is important to identify early and manage early, and there are a lot of prevention strategies which can be employed if you get these infections again and again. Thank you.
Thank you, Dr. Ram Gulati, for your nice presentation. It is the very common cases we found in children. Very much thank you to you. And now any question or query, suggestion from the audience?
Great. Thank you.
No, thank you, sir.
I would request our speaker to please collect his memento.
Now I invite Dr. Bhumesh Kumakar. He is professor and HOD of DVL, Osmania Medical College, Telangana. Program Director, Pediatric Dermatology Training Center. Honorary Secretary General, National IDVL 2024-25. Publication, total publication is 76, 16 books publication. He has received many awards, honor and achievement. Best outgoing, a student in DCH and MD DVL. Prestigious IDVL presentation found in Dharmakon, Pune 2020. Received National Award on National Dermatosis. Abdul Kalam,
thank you, sir.
Lifetime Achievement Award in 2020 and Pediatric Dermatologist of Year 2018. Now I invite you to start your topic. The topic is
Thank you, Chairperson.
Skin as a mirror of pediatric systemic disease.
Thank you, Chairperson, for your kind words. At the outset, I thank the organizers and ladies and gentlemen. Namaste to everyone. I am standing in front of you. Whatever the little experience related to my talk today is beyond rashes, the skin as a mirror of pediatric systemic diseases. We people are thinking that skin is for beauty. It is beyond. It is a marker of systemic diseases. How it will help, we'll see. Of course, health is not everything, but without health, everything is nothing. That health has to be initiated from the pediatric age group, whether it is a skin health or a genital health. And approach, because children are not just small adults. So their approach is totally different. I would say thank you to the organizing committee and scientific committee of the Bihar and EC having separate pediatric dermatology session even in the state conferences. I would expect the same all conferences. If the separate session is there, that will give more and more sensitization, because as on today the 50% plus of our OPD practice is the pediatric dermatology, but needs more and more sensitization. And we can learn two things from the children: always they are happy and always they are busy, which is lacking in adults. We never be happy, we never be busy. Always that is a problem. These two things we can learn from the children's, so always that will give some motivation to ourselves. And approach skin as a mirror of pediatric disease, pediatric systemic disease. The important step is the diagnosis based on the history. Always I will tell to my PGs, history is the king in the field of medicine. Spend time with the patient. Patient will give number of clues for the come to a conclusion of diagnosis and followed by examination. Laboratory investigations are rarely required in the pediatric age group until for the confirmation. And of course, the early detection and early intervention, which will reduces the emergencies in the pediatric dermatological conditions. Morning can be a benign condition, by evening it may be lethal. So the serial approach is very, very important. The understanding the morphological patterns, we have 6 types of morphological patterns that we need to observe the natural history of those 6 morphological patterns. What are the common conditions with associated connective tissue disease, vasculitis, all the conditions, but always the patient-centric approach is more and more important. This child, the 12 days neonate, the preterm underwent phototherapy, developed skin lesions on day 1. So the point to be noted is the day 1 phototherapy and a rash on that, and you could see pointer. Okay, so you could see here, this is a typical rash on here, and mother also suffering with the point. Yeah. And mother is also suffering with skin manifestations, and the mother is on the treatment. Almost you got the clue. So the typical of raccoon eye or oval eye. So that once if you label that, it is nothing but neonatal lupus. Once if you label neonatal lupus, the important step is this is the 50% is confined to the skin, but the remaining 50% may be associated with a marker of systemic disease with the internal involvement. The most important one is the involvement of the heart. So if it is involved, which needs a permanent pacemaker. So once if you label this, we go for investigation to rule out whether it is confined to the skin or a marker of systemic disease. So then these are the investigations we have done. Mostly the antila bodies, antila, SSA, SSB would be positive in neonatal lupus. But here this case, both are negative. NA is positive, but SSA and SSB both are negative. Even we could see the SSA, SSB negative neonatal lupus is the reality. And fortunately, these cases we have done the 2D echo, ultrasound abdomen, no organomegaly, no lymphadenopathy, no hepatomegaly, no splenomegaly, and hematological reports are normal, and 2D echo also fortunately normal, and just supportive therapy, assurance and symptomatic therapy over a period of 2 to 3 months, all skin lesions were subsided. And coming to the other conditions, specific skin lesions, if you see the molar rash is a marker of connective tissue disease, we have to think. Discoid rash, again acute condition or a subject. Even heliotrope rash in the Indian skin, mostly it's very difficult to appreciate. Heliotrope rash is nothing but the erythematous rash on edematous skin. That is nothing but it looks like a heliotrope leaves. You could see here, if you see the malar rash, the important point is malar rash, the sparing of nasolabial folds is a key. All malar rashes are not related to connective tissue disease. And another important point you could see here, the sparing of knuckles is another important clue to think of lupus. The involvement of knuckles, again, it would go in favor of dermatomyopathy. So simple analysis, if you detail skin examination, that will give a clues. You could see here, if you see the this child diagnosed as a connective tissue disease by somebody and it has referred to us. You could see the short history, and here there is a family history is there, the prodromal symptoms are there, and the fever which is there. That is nothing but erythema infectiosum, slapped cheek, or a fifth disease, just supportive and symptomatic therapy is sufficient. And if it is unilateral, mostly we have to think of infective etiology, this erysipelas. And if it is bilateral, sparing of chronic onset, chronic duration, and sparing of nasolabial folds, and we have to look for other manifestations of connective tissue disease. And this is I could say, the heliotrope rash. So not so classical in the period. This is not my photo. I have taken from the net. And this is the heliotrope tree. It looks like. And here again, the important feature is the involvement of knuckles. Gotter's papules is a feature in favor of the dermatomyositis, which is not seen. The knuckles is spared in lupus. Yeah, this is the difference. And vesicular lesions. Vesicular lesions, if you see in the dermatomal distribution since birth, again it is the commonly observed in the female infants. We need to think of beyond the skin, so mostly it is the diagnosis is pertinent incontinentia pigmentae. Once if you diagnose incontinentia pigmentae, whether it is isolated one or a marker of systemic disease, we have to look for the musculoskeletal condition system, the ocular system, and the dental and neurological. So if these are not there, mostly fortunately the child will be through. And the phases, the vesicular, verrucous, and hypopigmented, hyperpigmented. These are the stages which we will see. So after the 13 days, the same 32 days, the verrucous, then the hyperpigmented and the hypopigmented. The same, the sibling, the sister, elder sister also presented with the same manifestation. And in men generally they won't survive because it's autosomal dominant condition, X-linked dominant. And fortunately, this baby doesn't have other involvement of any internal involvement. So as a dermatologist, we have to look for whether it is confined to the skin or systemic involvement. This we have published a series of 6 cases of incontinentia pigmentae in that 2 conditions associated with some dental anomalies, other cases almost they are get through. The vascular nevi could be a vascular vascular of infancy or vascular malformation. So this is the vascular malformation which is present since birth. So once if you see the vascular malformations in the form of nevus flameus since birth, if it is on the face, especially involving the upper eyelids, always we have to look for the systemic any internal involvement. Here the history of seizures at the age of 1 year, and the child is on anti-epileptics, and there is the refractory errors. The vision was corrected with the lens under the supervision of ophthalmologist. So the diagnosis is a Sturge-Weber syndrome. So the nevus flameus on the face, if it is bilateral, always 100% there is a systemic syndromic involvement. Unilateral, there is a 50%. So associated follow-up of this nevus flameus, if it is on the face, to rule out Sturge-Weber syndrome is the important point to be noted. Yeah, so this is 16 months child, the itchy red scaly lesions in the body that started at the age of 1 month. And you could see the bilaterally symmetrical erythematous scaly plaques, bilaterally symmetrical on the neck, chest, shoulders, lower abdomen, groin and back. And you could see the scalp involvement. And what we have to do, we have utilized the third eye in the form of dermoscopy. We thought of either Netherton syndrome or erythrokeratoderma variabilis. And you could see dermoscopy shows the ichthyosis linear sarcoma, double-edged sorts. You could see here. So this is the importance of dermoscopy, which will help to avoid the invasive procedure like biopsy. And microscopy, we have seen the bamboo here. So classically, it's a case of Netherton syndrome. And fortunately, this supportive therapy and symptomatic therapy was given, and the child is doing well. And all Netherton syndromes may be associated with, may or may not associated with the erythroderma. That's another important take-home point. And cephalite macules, could see almost 10 to 20% is the physiological conditions, or maybe in some condition. These are the syndromes associated. The point to be remembered is congenital melanocytic nevus has to be differentiated. That is a dark brown and associated with the hair involvement. So these are the conditions associated. Important is the whether it is the smooth and regular, we need to think of neurofibromatosis. Whereas large irregular borders seen in McCune-Albright syndrome, that is unilateral, it can't be a bilateral. That is another important part. C for neurofibromatosis, whereas M for McCune-Albright. Another, this child, if you see the history of fever more than 5 days, which is not responding antipyretics, if you have the red eyes, red skin and red tongue, which is nothing but the Kawasaki syndrome. Always, all misdiagnosis of viral infection, where viral infection there is a prodromal symptoms associated with other family children. But here, there is no prodromal symptoms of cold, cough and conjunctivitis. Absence of prodromal symptoms of respiratory symptom is the key. And once if you diagnose Kawasaki, the first 10 days is the golden period. We need to initiate antipyretic therapy in the form of aspirin, as well as the IVIG should be initiated within 10 days. That decreases the involvement of the cardiac, because almost 20 to 25% there is a chance of involvement of heart in the form of the aneurysms, MIs, there is leads to mortality. And another child, fever 10 days, and you could see the rash, and you could see the white patches. These are nothing but white islands in a Red Sea. White islands in a Red Sea is a clue to think of dengue fever, because again dengue fever, it's a spectrum. If you miss the diagnosis, if you won't give supportive and symptomatic therapy, that can give to dengue shock syndrome, dengue hemorrhagic fever and dengue shock syndrome, which needs hospitalization and again the mortality. So not only that, any children persisting fever, just you palpate. There is a paleness. In some children, they will have this white islands. In some children, just if you palpate, if you see that white, the paleness of the skin, always rule out the dengue fever. So this is another child, they missed the diagnosis and landed into dengue hemorrhagic fever and in the form of purpura pulmonans. And the last case, you could see the 4 years female child born to consanguineous marriage, and white skin and hair lac, white forelock, and broad-based nasal bridge, hypertelorism, and light blue color iris, hypopigmented patches, the dystopia canthorum. So I'll take 1 minute. So just 1 minute. So that for your introduction, it took almost 1.5 minutes. So that I'll borrow that 1.5 minutes from you. So this Waardenburg syndrome. So this is very rare. So once if you see the Waardenburg syndrome, again we have types 1, 2, 3, 4. Whether other systems are involved, such as GIT system, all is important. Type 1, type 2, type 3, I won't go in all detail. So it is there in the books. And that child underwent the cochlear implantation. So you could see here the cochlear implantation was done. This is actually, this is a cap for that cochlear implantation which is there, and to avoid to prevent the visibility, so they have put the cap like that. So neonates, hyperpigmented macules and the nose. Any guess? Now also we are seeing the cases. Chick sign, 80% it is a chick sign. But even in the initial stage, this case has come, and even I was surprised what to do. Then the mother is coming. This baby has come with the grandparent, and the mother is later coming with a limping. Just then I got the message. So it's nothing but chikungunya fever. So what we have to do, once if you label the hyperpigmented, just give assurance and emollients, and the pigmentation will take place 3 to 6 months. So to give assurance, it won't go over a period of days or weeks. So, and MC on the face in adults, it's a marker of screening. But MC on the face in a children, it is not a marker, it's a common. But giant MC even in the children, it's always you have to look for the screening. The first child is the normal immunocompetent child, and this child, the giant MC, We have done the screening and the HIV was positive, the child is on ART. And the oral thrush, the first 6 months is a physiological condition. But persistent of oral thrush beyond 2 or 3 weeks, even in the first 6 months, always we have to look for the immune status of the child. But another important point, after 6 months oral thrush, always we have to do screening. And when you see the white patches in the mouth, we have to look for only the white debris or oral thrush. And if it is oral thrush, don't hesitate to see the uvula. If uvula is white patches on the uvula, then nothing but oroesophageal candidiasis is a marker of AIDS defining illness. Yes, so this again, secondary syphilis with just teeny attacks has to be differentiated. To conclude, the skin provides a visible clues to invisible diseases. So it is the healthcare provider, especially dermatologists, though our medicine is surface medicine, but our vision should be beyond the surface medicine. Our eyes, like a microscope, we need to use the dermoscope. The pediatric dermatology is not just about rashes, it's about the recognition. The collaboration between pediatrician and dermatologist is vital for the betterment of the child. Yes. So thank you very much for your kind listening and patience.
Thank you, Dr. Bhumesh Kumar, for your nice presentation with the detailed information. Any questions or suggestion or query from the audience, I invite.
Thank you.
Thank you.
I would like to thank our chairperson and speaker for such a fabulous session. For the last session of this pediatric dermatology session, we are having a panel. I would like to invite Dr. Shriparna Deb for moderating this session. She is consultant dermatologist in Patna.
A very good afternoon to all respected faculties. Without any further ado, I would like to call upon the stage our panelists, Dr. Bhumesh Kumar Katkam sir, Professor and HOD, Osmania Medical College, Secretary General, IIDVL National, Dr. Maitri Panda ma'am, Professor at IMS and SUMS Hospital, Bhubaneswar, Dr. Neeraj Kumar sir, Associate Professor and HOD, WIMS Power Puri, and Dr. Suganita Singh ma'am, Professor, HIMS Safedabad, UP. I would like to take a moment to say that I was very not confident with the topic because of such great panelists being here. But Dr. Vikas sir was the one who told me to go ahead and do it. I'll try to do justice to the session. And I am here just to clarify my doubts, not ask questions. With this, going to the first case. So this is the case of a 12-year-old girl who presented to my OPD with multiple annular plaques, as we can see, on the flexor aspects of bilateral lower limb, along with intermittent fever for the last 3 months. She complained of tightening and thickening of the skin, which started at the nape of the neck and gradually progressed over her face and abdomen in the last 2 months. She then also complained of difficulty in extension and sideways movement of the neck and decreased opening of the mouth. So I will like to start with Bhumesh sir. Sir, how will you approach the case?
Can we go to the images?
Yes, sir.
So the 3 months duration, so thickening of the skin.
Sorry, sir?
The skin,
Yes,
the thickening of
tightening
the...
started on the neck, nape of the neck.
So initially we need to think of the common conditions. So recurrence, lower limbs, pigmentation, even the xerosis of the skin. We can think of even atopic dermatitis or papillary urticaria, or we can think of, if you go to deeper, so the thickening of the skin, so we need to go for the investigations like a skin biopsy to rule out something beyond the skin.
Definitely, sir. So, like we asked about the recent infection, but she could not recall like any recent infection. but she had a history of recurrent papular eruption on the exposed parts of hand and feet, and which flared during the summers and rainy season. So from this, how will you proceed? Like what kind of investigations you want to do in this patient so that we can reach a diagnosis? Ma'am.
Dr. Sripanna, looking at the pictures, I could first think of morphia or some type of scleroderma or something, because you told banding down of skin and there is also a history of fever. Coming to this approach, and when you are telling recurrent papular eruptions, so maybe a child, maybe background atopy must be there, or recurrent insect bite reactions must be happening, and that can be related. If it is an atopic child having summer and rainy aggravation, there may be chances of secondary infections. So that commonly we see staph and streptococcal infections. So that may be a corroboratory finding. It's just my opinion. And recent infections, again, staph, any type of bacterial and viral infection for a pediatric age group, you would go around any condition, you have to take a history of viral and bacterial infections. So that is how I will start. But initially, my first line of investigation would be the CBC, the parameter which is very important, and just go for a ESR and CRP, just to see whether any type of active infection or any type of inflammation, which is an indirect marker. But if you look at the pictures, then definitely 3 months history, I would go to the biopsy also.
Yes. Coming to Neeraj sir, in this case, I think one thing that was present in the history was thickening and tightening of the nape of neck.
Yeah, definitely. Actually, person complained that there is a thickening and hardening of the skin, mainly over the nape of the neck initially, and did progress to involve the trunk as well as the face. And one important history that it after some infections. So it could be the post-infectious scleroderma also. Along with that, patient also have the flexor lesions, so that it would be associated with the atopic dermatitis.
Like ma'am has definitely told, she is an atopic child, had the history. Then these were the investigations we did in her. The hemoglobin was normal, WBC was okay, but her ASO titer was raised, which again pointed towards it being a case of post-infection scleroderma, which came to mind. We also did the blood sugar, which came normal, to rule out that it is not a diabetes-associated scleroderma. ANA profile was again done for ruling out scleroderma. ASO titer was done, which pointed us that it can be a post-infectious scleroderma. Blood sugar we did so that we can rule out it was not a diabetes-associated scleroderma. ANA profile was done again to rule out scleroderma profiles. So now that we are suspecting that it can be scleroderma, Sugandhita ma'am, will you go for this investigations like serum protein electrophoresis or urine protein electrophoresis, immunofixation, to rule out the other type? Or do you think that it's a child, so we can just avoid?
Actually, as we can see, ANA is just 1+. It's not even specific, and it's not even able to rule out any early scleroderma if it's starting. So we can just, first of all, we can, for the investigations, can you show me the other slide?
Yeah.
Which investigations? Yeah, we can just, because protein electrophoresis and all can be avoided, because if it is a post-streptococcal type 1 scleroderma we are suspecting, these are more common in the type 2 and type.
And because of our setup, we don't have the money thing is a thing that we also skipped this. Coming to the biopsy showed orthokeratotic epidermis with follicular plug. Eccrine glands and few hair follicles are still present. That ruled out morphia for us. And then there was mild increase in the dermal mucin, which was Elchian blue positive. Dermal collagen showed slightly increased intracollagenous spaces. So coming to this, I'd like to ask, do you think anything can be a predictor that a patient can land up in scleroderma? Or how would you differentiate it from a scleroderma? It's a scleroderma and not a scleroderma. What signs and symptoms you will get in these patients? Neeraj sir.
Definitely, we have to examine what is the distribution of the lesion, whether it is spared the hand or feet, or we also just see the consistency of the skin. Because in the case of a scleroderma, there is a non-PT woody induration, and for investigational predictors would be ANS would be negative, and Raynaud's phenomenon negative, digital scars would be negative to differentiate from the scleroderma.
Sir, I would like to ask, if we are thinking it's a scleroderma, like it has been biopsy proven, so will you treat the patient, or like you will think it's a self-limiting condition, it would go away?
Mostly the sclerodermas would present in the infancy, in the early ages. Could be a physiological conditions, could be a marker of the septicemia. Where if it is septicemia is there, we have to look for the activities, the vitals. In those conditions, we have to treat accordingly. So otherwise, if nothing is there, if it is no other involvement, the child is active, taking feeds, just assurance and supportive therapy is sufficient.
Like if the patients are not very happy with assurance and everything, will you still go for some therapy? Any therapy of that you want to incorporate? Ma'am, please opine.
Yes, I have encountered one single case till date of scleroderma following streptococcal infection. The patient was very healthy as such. Once we admitted the patient also just to rule out whether it was a case of scleroderma, which we eventually did the ANA profile, and the anti-HCl 70 and the Raynaud's and everything came out to be negative. And then we initiated steroids because the parents were very anxious. So with steroids, we could see a response. After 7 days, however, we discharged the patient with tapering doses of oral steroids. And my colleagues in pediatrics, they usually give also cyclosporin, because we have a pediatric rheumatologist in our hospital, which we usually discuss with each other. So they have given cyclophosphamide and cyclosporin as treatment of choice. And one of the patient, which was still some inflammatory markers were persistent. So in that patient also they had given IVIG. But personally, I do not have any experience other than steroids.
Sir, any like PUVA or any such NBUV therapy, do you think it has a role?
Actually, most of the time, the post-infectious scleroderma is self-limiting. We should not require treatment. But if it is causing any functional impairment,
She had functional issues. Opening of the mouth was kind of restricted.
then we can go for phototherapy as well. If the age of the child is higher than 12, and also, as ma'am say, we can try methotrexate or cyclosporin.
So yes, like sir has already said, Raynaud's and sclerodactyly was something that helps to differentiate. Treatment, as we can see the literature, IVIG is given as the best line of therapy, followed by corticosteroids and methotrexate, cyclosporin, as has been pointed by ma'am. Penicillin prophylaxis has been given in some patients, which shows recurrent episodes. These are case studies that have shown. Again, like associations, we already know type 2 is associated with diabetes, so endocrinal abnormalities. And again, association with paraproteinemia is present, but there are few other associations like Sjogren's syndrome, even systemic sclerosis and atopic dermatitis are said to be associated. So infection, ma'am and sir has already said, post-streptococcal, other HIV and is also a rare association. Prophylactic antibiotics can be given in a few cases, which has been tried. For our case, this was a case that was present in NMCH. We treated the patient with PUVA therapy, and by 4 weeks, she showed complete response. So coming to the second case is a 2-year-old male child. This was a case we encountered when I was a PG in PMCH. She was admitted in the pediatric dermatology with severe acute malnutrition as an inpatient management for last 1 month. She was put on micronutrient supports, but was non-responsive to the nutritional rehabilitation, and there was no weight gain. We were getting repeated dermatological calls because the child was having recurrent seborrheic dermatitis since the age of 6 months, which was initially just in the scalp. Later, it involved the body. Over the tongue, I'll show you the pictures. These are the pictures. First, it was just present on the scalp. Later, it involved other parts of the body, the post-auricular area, the groin. Whenever we'll treat the patient with steroids, the patient will have symptomatic relief. The moment we'll stop the therapy, again there will be a flare-up. And every flare-up was severe than the next one. On doing the systemic findings, we saw that there was hepatosplenomegaly, generalized lymphadenopathy, and failure to thrive. So how should we approach this case? Sir?
Yeah, to a child, the scaling, mostly the scaling with adherent greasy scales, seborrheic dermatitis. So if you think of seborrheic dermatitis, generally as age progresses, it will come down. So the recurrences would be unlikely. But here the child is getting on and off. So we have to think beyond the seborrheic dermatitis. So the seborrheic dermatitis with organomegaly, hepatomegaly, splenomegaly, we have to think of some syndromes. Could be a Langerhans cell histiocytosis. Or if seborrheic dermatitis associated with any recurrent loose motions and recurrent infections, we have to think of complement C3A, C5A deficiency in the form of Linus disease. Any history of loose motions in this case?
No, sir. Loose motions was not there, but failure to thrive was there.
Okay, so that we can rule out the Linus disease. So we can think of, because here hepatomegaly is there, splenomegaly, lymphadenopathy. So once if you see the Langerhans cell histiocytosis, whether it is limited or multi-system involvement. So fortunately in the pediatric age group mostly would be limited conditions, but here organomegaly. In pediatric, first 1 year, the 2 centimeters below the sternal class hepatomegaly and splenomegaly is physiological conditions. That we have to keep it in mind also.
Ma'am, can you just tell us about if we're getting recurrent seborrheic dermatitis in a child, what we should think, what we should rule out? Sir has already said, like, and few other things that we can.
As we can see, this child is getting recurrent seborrheic dermatitis-like lesions. So first of all, we have to rule out or just get investigations done for confirmation of LCH. And then if the patient is having diarrhea, loose motions, and the lesions are present in the acral, in the distribution perianally or periorally, we can see for zinc deficiency and acrodermatitis. And then biotin deficiency is also should be ruled out because they also present with seborrheic dermatitis-like lesions. And then severe atopic dermatitis can also be considered.
Sir, anything you would like to add? Or what would be the next set of investigations you want to go with this child?
To rule Chabi also, because in Chabi the seborrheic dermatitis looks like that. Also, we should rule out as atopic dermatitis as well as disseminated tinea.
Erythroderma deuteritinea, definitely. So this was the child. After we treated, we put him on steroids, and again there was response. So like ma'am has already said a few points. Another are like HIV of the child is of Down syndrome. He can have a recurrent seborrheic dermatitis. This was the biopsy of the child. The section showed epidermis had mild spongiosis with focal crusting. There were the coffee bean nuclei present. And later when we did the immunohistochemistry, it was positive for S100 and strong expression of CD1A was seen, which helped us with the diagnosis of LCH, as sir has already said. So why do some cutaneous LCH resolve? Like sir said, in child, mostly resolve, and others progress to multisystem disease. Like what can be the take? Why some just progress and some don't? Any role of mutations or anything?
Yeah, but generally it depends upon the biology of the clone biology as well as the immunity of the patient and the mutation. So it's actually LCH is the clonal malad disorder. So the all clones are not equivalent. So there may be the transitive to the multisystem disorder, and again the personal immune system, immunity of the patient and mutational. Important factor for if the person progresses to the multisystem LCH.
Ma'am, do you think there is a role of any dermoscopy or reflectance confocal microscopy if we are not doing biopsy?
No, actually this is a clinical diagnosis. I would like to add to the differential because a few months ago we had a diagnostic difficulty of a similar case, and that case came out to be Rosai-Dorfman syndrome. So it had multiple lymphadenopathy and the lesions were absolutely like the LCH lesions. So only by doing a immunohistochemistry, the S100 was positive, but the CD1A was negative. And that helped us to clinch the diagnosis. Otherwise, we usually, this is clinical, followed by biopsy, and if possible, a bone marrow, wherever there is systemic involvement. Other than that, we don't do any type of dermoscopy or other things.
Sir, will we treat anything about this patient, or we'll just refer the case as like a pediatric to
No,
be?
it's a multi-pronged approach. We need to take the help of pediatrician. We need to take the help of multiple. And the first question, why means it's $1 million question. We cannot predict which case is limited, which case is multi-system. We need to observe. We need so we cannot predict with this case is going to confine to the skin. This case, but fortunately in the pediatric age group, mostly the prognosis is good because it is confined to the single system.
Sir has rightly said even the localized one can sometime like spread and become malignant. So it can't be predicted, but high risk mutations if are present, there are more chances. But you can't say because it is present, it will spread. It's not present, it won't spread. So some warning signs, like if, like sir said, the crusting was very, like the crusting had some bleeding as well, or if there are purpuric papules in the diaper areas or ulcerated crusts, then...
Another important point, the day 1, if you see all 6 morphological type of skin lesions, mostly we may not observe, even the pediatrician, they may observe the macule, papules, vesicles, purpuric lesions in a child, and that will disappear, and later they presented with the seborrheic type of lesion. So that history would help to think and predict towards in the LCH.
Beautifully added, sir. And again, recurrent otitis media I found was a thing that can help us to diagnosis. Like ma'am said, dermoscopy has no role, but reflectance confocal microscopy, they say you can see the Langerhans cells, so it might help. Again, phototherapy, they says there is a response, but it has to be a multimodality treatment. Coming to case 3, it is again a child which was seen in the OPD of NMCH, 3 years old, brought with a history of single episode of yellowish discoloration of the eyes 5 months back. And then the purpuric rashes started, which started first in the postauricular area and was associated with lymphadenopathy. Later in the next 3 months, it increased to involve the trunk, the upper limb, the lower limb, both the dorsal and the ventral aspect. The parents also reported there was abdominal distension, bloating, failure to thrive, no any history of infection or bleeding manifestation apart the purpura. So this is the child. As we can see, there was abdominal protuberance, the rashes was present, and purpuric rashes were present on the trunk. There was subtle seborrheic dermatitis-like lesion on the scalp. As we can see, the hemoglobin was 3 and the platelets are 70,000. So in this case, how will you approach?
So again, it's beyond the skin. Again, the seborrheic features are there, purpuric features are there.
It started with purpuric rash, and by 3 months the child became like abdominal protuberance and everything. Nothing was there before that.
So again, when the purpuric rashes with the seborrheic, again we have to think of the other multi-system involvement, the thinking in terms of again LCH again, with the multi-system involvement, bone marrow involvement, because the anemia, the 3 below 5 always it's the very grievous sign. We have to look for our hematological system.
Investigation, again, biopsy showed us that it was an LCH. So here I'll ask, what number of cases do you encounter, sir? How many cases do we see in our practice?
Frankly
very
speaking,
rare.
Even I see just 1 case in last 10 years. Maybe cases are still present, but sometimes we are misdiagnosed. So I have experienced just see 1 cases about 10 years back.
Okay, sir, do you think it is a cancerous or just a reactive phenomenon? Like the last thing we said, like it's limited or it's spreaded. You do consider it to be cancerous, right?
Yeah, we have to consider because could be a pancytopenia also. The anemia would be there, thrombocytopenia and leukopenia could be the hematological.
So I'll just come to case 4. This child came to us.
What was the treatment was given?
Sir, it was LCH. I thought
No,
I
no,
was...
treatment. What treatment was given?
Sir, we referred the case. Actually,
Yeah, mostly
we
have to
referred
take
it
the
to
help of-
IGMS Patna. He came to NMCH and
We
we
have to
didn't
take
have the
up the
chemotherapy.
cancer hospital. We have to refer to the cancer hospital.
We referred then and there. We just took the biopsy.
Any follow-up? Follow-up of that
Sir,
case?
he didn't come back. So I don't have a follow-up for this case.
For curiosity, I'm asking.
So coming to the next case. Sorry for this. No, sir. Not yet. I'll still take some of your time. So there is this child who was apparently well till 1.5 months, and then she had one episode of loose stool and fever, for which she took medication. There was relief. After 2 weeks, there was this purpuric spots, which came on her face, then abdomen, then trunk, and there was mild itching. She had episodes of blood-tinted vomitus 1 month ago. And then when she came, she also said there was a bleeding from the nose. On history, there was no trauma, joint pain, altered sensorium, or urinary complaints. On examination, pallor and lymphadenopathy was present, and mild hepatomegaly was present. The hemoglobin was 7.5, but the platelet was really low at 3,000 without any giant platelets or blasts. So this is the child. What will be your probable diagnosis and next approach, sir?
Purpuric rash, the approach, how I approach the purpuric rashes on the lower extremities, the approach would be different. Purpuric rashes
Sir,
on
it
the
started from
upper,
the face.
yeah.
And then it involved the whole body. First on the face, then the trunk, then the hands.
Fever followed by purpuric rashes. There is
And
no
the
history of trauma, and we have to think of something idiopathic. So, whereas in generally these type of cases, it rarely come to us. Mostly it will go to the pediatrician where fever and all.
One thing was, this case was diagnosed somewhere else as leukemia, and she came to us for having a biopsy. But then as sir said, let's treat
Palpable, the purpura is palpable?
No.
So if it is non-palpable, that is idiopathic thrombocytopenic purpura. Because if it is palpable, it is vasculitis. Mostly could be a dengue or leukocytoclastic vasculitis or the meningococcal vasculitis. If it is non-palpable, this vasculitis has to be ruled out, and there is no history of trauma, the history of infective focus, and we can think of idiopathic thrombocytopenic purpura.
Definitely. So, ma'am, what would be the investigations you would like to do for the child if you are thinking an idiopathic thrombocytopenic purpura?
I would do the regular tests, especially the CBC, and go for a retic count and PS comment. So I think that will really help me to at least zero down that whether it is an ITP or we are dealing with some other condition presenting as purpuric macules.
Sir, I would like to ask, will you do anti-platelet antibody tests?
Yeah, it's a bit, this is not routinely recommended because in anti-platelet test, we test the antibody against the receptor of platelet, that is glycoprotein 2B and 3A. This is not routinely used, but this is actually done for the, if you have to differentiate immune versus non-immune thrombocytopenia, or any atypical thrombocytopenia, or sometimes post-transfusional thrombocytopenia.
So, Ganita ma'am, will you do coagulation factor or bone marrow, or you will go for a biopsy?
Coagulation factor, we can go for PTINR just to rule out whether there is any coagulation factor deficiency or such cases. But in this case, as we can see, the thrombocytopenia is there. So those will be all. And then bone marrow examination also, I don't think so we'll proceed for that. We can see various things. Just to rule out leukemia, these can be done, but we'll not be doing routinely.
As has been already said by ma'am, blood smear is the best thing that we can do. We'll get isolated thrombocytopenia, a little bit of anemia can be present because of acute mucosal blood loss was there, and there will be hemodilution. So anti-platelet antibody test has no such role, only supportive, sensitivity, specificity, all are low. Triggers can be any infection or vaccinations or URTI or gastrointestinal infections, and coagulation profile again to rule out. So bone marrow examination again, we won't do it we'll do it only if there is organomegaly or lymphadenopathy or any suspicion of leukemia. That's why the child came to us.
ITP in the pediatric age group, mostly it has a good prognosis, self-limiting condition as age progresses. So if it is recurrences, then we can go for the anti-inflammatory dose of the steroids.
That's what I'm going to ask you, sir. What is the treatment that you will plan?
The less than 1 mg per kg of the prednisolone would help. So not in an immunosuppressive dose. One important take-home point, as a dermatologist, we won't see this type of ITP. So as a pediatrician and a dermatologist, I have seen some cases. Once if you see the purpura by diascopy, if it is purpura, please don't hesitate to palpate the purpuric rash. So if the purpuric rash is palpable, this vasculitis can be ruled out. If it is not palpable, then we have to think of the hematological conditions or thrombocytopenia, preferably the idiopathic ITP.
Ma'am, do you think there is any role of platelet transfusion or activity restriction for?
Definitely, but we don't treat. My only, looking at your case, I would first refer it to a pediatrician for immediate management based on the clinical and CBC findings.
Platelet transfusion, if the thrombocyte levels are low, so immediately we have to give platelet transfusion. And to decrease the recurrences, we can give the immunosuppressives like anti-inflammatory dose of steroids.
Sir has rightly said, transfusion of platelets itself is not enough, but in case of emergencies, like if there are chances of intracranial bleed or something, we'll consider it. And again, the treatment would be, like sir has said, steroids, the first line. We'll go for methylprednisolone, then taper to oral corticosteroids. Second line, rituximab can be done, not generally used by us. This is post-steroids. We, like sir said, 0.5 milligram per kg body weight. Omnacotil was given to the child, and there was response in just 7 days. So monitoring again, it has to be done. You repeat the CBC. If you have given IVIG in 24 to 48 hours, you should see there is improvement. For steroids, it takes around 3 to 7 days. And activity restriction has only to be done if the platelet count is less than 20,000. So I think I have less amount of time and we can skip it. Thank you.
Yeah, thank you, Sriparna. Nice cases. You made us very active and vibrant. So we have learned so many things. Keep it up. Nice moderation. Thank you.
Thank you, sir.
That was a wonderful session. I would request our moderators and panelists to please collect their memento. For the next session, I would like to invite Dr. Ravi Vikram Singh sir and Dr. Radha Krishnan Nair sir to please chair the next session.
Can I start with the lecture? Okay. So my lecture got postponed because of a cancelled flight. So I'll be speaking on clinical signs in dermatology. Signs are very important because they help us in diagnosis, they help us in prognosis of the disease, and of course for the PG residents, they are questions in the exam. So this is for all from seniors to juniors. Signs are very important in dermatology. And it is said that it is to see with your eyes what lies in front of your eyes. So actually, if we don't know what we are seeing, then it is sometimes difficult to diagnose. So we have to know all the signs if we have to diagnose properly. So technically speaking, a sign refers to an objective physical finding which is observed by the examiner. Signs serve as important clues to primary skin disorders and sometimes internal disease as well. So I will go group wise, so it will be easier for everyone to remember. So first of all, in bullous disorders, the classical Nikolsky sign. This is for the residents. You can help, this will help you in the quizzes also, because often these questions are asked in the exam as to who described it, from where he was. So this was first described by Peter Nikolsky, a Russian dermatologist. So application of firm rotating lateral pressure over bony prominences. This causes a shearing force which dislodges the upper layers of the epidermis from the lower layers. This happens because there is acantholysis, and that is where you can slightly peel off the skin. There are two types of Nikolsky sign. The marginal sign refers to the ability to split the epidermis of the skin beyond the pre-existing erosion by pulling the remnant of the ruptured blister or by rubbing at the periphery of the existing lesions. A word of caution while you are for the residents, when you are eliciting Nikolsky sign, you don't have to do it every day, because you are ineffective, you are inducing new erosions also. So occasionally, as a sign of activity, you may do when the patient is admitted in the ward. The direct sign refers to the ability to split the epidermis on skin distant from the lesions by lateral pressure with the finger. So Nikolsky sign is mainly seen in pemphigus group of disorders as well as in staphylococcal scalded skin syndrome. It is generally negative in the subepidermal blistering skin disorders, and it indicates the activity of the disease or the effect of the treatment. Occasionally, when you don't have active blisters to take a biopsy from, you can induce a blister with the back of a rubber, the rubber of the pencil, and slightly you can induce and take a biopsy from there. Another concept is the Maserang phenomenon. It is a Nikolsky sign which is elicited in the ichthyosis bullous of Siemens, and Nikolsky phenomenon, which says that superficial layers of epidermis are felt to move over the deeper layers. There is no erosion immediately, but the blister develops after some time. There is also the pseudo-Nikolsky sign, which is seen in SJS and TN and in burns and in bullous ichthyosiform erythroderma. Here there is more like epidermal cell necrosis rather than acantholysis. Then there is a bulla spread sign, which is mainly seen in the, we mainly do in the subepidermal blister disorders. As you can see in the attendant photograph, a slow, careful pressure is applied over the top of the lesion. You have to first mark it with the pen so that you can see the extension. So if there is an extended bulla with an angulated border, that is seen in pemphigus group of disorders, pemphigus vulgaris, and with a regular rounded border is seen in the subepidermal blistering skin disorders. So these are the disorders where you can see the bulla spread sign. Then this is a classical cluster of jewels sign or a string of pearls, which is seen in chronic bullous disease of childhood, where newer lesions appear at the margins of the older ones and resemble a cluster of jewels. Then hypopion sign, this you can see in infective as well as non-infective disorders. So basically it resembles a hypopion which is seen in the eye, which is described by ophthalmologists. So here we are seeing a transverse fluid level composed of purulent material. It need not always be infective. If it is infective, it is bullous impetigo, but you can see it in other disorders also, predominantly in subcorneal pustular dermatosis and also in secondary infected vesico-bullous disorders. Coming to the papillosquamous disorders, Auspitz sign, which we have all learnt as resident, it has been attributed to Heinrich Auspitz, an Austrian dermatologist, but actually it was described by several dermatologists before Auspitz, so misplaced credit was not unusual in those times also. So here we are removing the scales correspond to the parakeratotic stratum corneum. When the scales are completely scrapped, then the red glossy surface is seen, which is equivalent to the Duncan-Berkeley membrane, that is the thin overlying epidermis over the rete ridges. On removal of this membrane, you will see the pinpoint bleeding points, which are because of the dilated blood vessels in the rete ridges. In the dermal papillae, not the rete ridges. So this occurs as a result of the removal of the parakeratotic epidermis followed by the suprapapillary epithelium, the thinned out suprapapillary epithelium, or the Duncan-Berkeley membrane as it is called. And when you scrape that off, the dilated dermal capillaries rupture, which gives rise to the pinpoint bleeding points. But it is not actually specific for psoriasis. You can see it in other skin conditions also, like Darier's disease, and it can be negative in inverse psoriasis, pustular erythrodermic psoriasis, and in gutted psoriasis. The hanging curtain sign is seen in pityriasis rosea. When the skin is stretched across the long axis of the herald patch, the scale is seen to be finer, and it is attached at one end, giving the appearance of the hanging curtain sign. The nose sign, this is described by Indians. It is called as the Pavitran's nose sign. This is a sparing or the absence of the redness or scaling on the nose and the surrounding areas, while other parts of the face are affected by a certain dermatological condition. So this was a patient who was in erythroderma. You can see that the nose is spared, whereas the rest of the face is involved. So it is seen in airborne contact dermatitis and in severe atopic dermatitis, or even in phytophotodermatitis also sometimes you can see it. Coming to collagen vascular disorders, we have several signs which the residents have to remember. One is this is seen in DLE, that is a carpet tax sign. So when the scale is removed, the undersurface of the scale shows horny plugs. So as you can see in the attendant histopathology photograph, I hope this is working. Okay, so this is the plug which corresponds to the carpet, this carpet tack, as you can see. I don't know whether this is working. Anyway, the photograph below shows you the carpet tags. So the hyperkeratotic scale which is there in the follicular infundibulum creates those keratotic spikes. So when you remove the scale and see the undersurface, you will see the keratotic spikes, and that is called as the carpet tax sign. So it is generally seen in DLE. It can be seen in seborrheic dermatitis, even in pemphigus foliaceus, lichen planus also. Ingram sign, which is seen in scleroderma, that is the inability to retract the lower eyelid, and it is a sign of systemic sclerosis. The scleroderma neck sign, it is a ridging and the tightening of the skin of the neck. This is very important for residents because you have to demonstrate these signs, you have to say these signs in the exam. Heliotrope sign is seen in dermatomyositis. This is quite classical of dermatomyositis. As you can see, the violaceous erythema. So this term actually refers to the purplish colors of the heliotrope plant flowers, because these flowers rotate to face the sun. That is why it is called as heliotrope, that is towards the sun. So this is strongly suggestive of dermatomyositis. Dermatomyositis, you have several other signs of photosensitivity, like the Gottron sign. This is also a feature of dermatomyositis. It's basically symmetrical confluent macular erythema, which can be seen on the wrist, mainly over the knuckles. This is in addition to the Gottron's papules. And this is seen in about 70% of the patients in dermatomyositis, but can be seen in SLE as well. The shawl sign, another classical sign of dermatomyositis, which is seen on the upper back and the shoulders and resembles a shawl. So it is a reddish or a purplish discoloration and is generally seen on the sun-exposed areas of the shoulder. V sign, again a sign of photosensitivity in dermatomyositis. Contrast this with the Castle's necklace, that is more of a scaly rash, again that is photosensitive, that is seen in pellagra. Holster sign in dermatomyositis, the confluent macular violaceous erythema corresponding to the site of hanging a gun holster on the sides of the thighs. That is why it is called as the Holster sign. Samet sign is dystrophic and ragged cuticles seen in dermatomyositis again. Then the round finger pad sign. This is important because this is an early sign of scleroderma. So the normal peaked appearance of the finger pads is lost, so it becomes more rounded, and you should actually examine the ring fingers and the last fingers, because the first two digits we generally use quite often, so there may be some changes on that. So generally you should examine the ring fingers for this early change of scleroderma. Coming to hair disorders, the Kudability sign, which was first described by Schuster in cases of alopecia areata. This is basically where the perilesional skin, perilesional hair-bearing scalp, the hairs are tapered at the proximal end, and it can be easily made to kink or bend. So that is the Kudability sign in alopecia areata. This is the friar tuck sign, which is seen in trichotillomania. So the patient tends to pull off the hair, and the hair only on the sides, on the borders of the scalp tend to remain. So people of my age may have read Robin Hood comics. So the below picture shows you how his hair is placed. So the center is lost, whereas this fringe remains actually. So that is why it is called as the friar tuck sign of trichotillomania. Coming to certain inherited disorders, buttonhole sign is seen in type 1 neurofibromatosis. This is due to the soft myxoid stroma. So if we push the neurofibroma towards the dermis, so it easily goes in because of the dermal defect which is there. So that is a buttonhole sign in type 1 neurofibromatosis. Then Crowe's sign, axillary freckling, one of the defining features of neurofibromatosis. Patrick-Yasudian sign, the Palmer melanotic macules, this is seen in type 1 neurofibromatosis, was first described by Yasudian sir, and that is why the name. The Gorlin sign, these are signs of hyperextensibility seen in Ehlers-Danlos syndrome. It is the ability of the patients to touch the tip of the nose with the tip of their tongue, as seen in the Addington photograph. Similarly, reverse namaskar sign, so they are able to fold their forearms at the back as like how you hold it in the front, they are able to do it on the back side because of the hyperextensible joints. Then the thumb sign in Marfan syndrome, where the thumb protrudes from the clenched fist beyond the ulnar border of the hand. So these are all signs of hyperextensibility. Another sign is the wrist sign, the Walker sign, where you can see that the distal phalanges of the first and the fifth finger of the hand can overlap when wrapped around the opposite wrist, again seen in Marfan syndrome. Coming to vascular disorders, this is a Kaposi-Stemmer sign, which is the inability to pinch up the fold of the skin at the base of the toe because of the thickness as seen in chronic lymphedema. Dermatographism, another common sign which we do in the OPD, using moderate pressure to gently stroke the skin. So there is also a synonym skin writing, so you can actually write something on the skin of the patient. So it's basically an exaggerated triple response. If you want a uniform pressure, then you can use a dermographometer, which is not very easily available. So you can do it with the blunt side of the pen also for simplicity in an OPD. And generally it becomes prominent within 5 minutes and persists for about 15 to 30 minutes. These are the types of dermographism. The important ones are the delayed dermatographism. This can be associated with pressure urticaria. Then there is follicular dermatographism, where you can see transitory discrete follicular urticarial papules. Cholinergic dermatographism, which consists of grouped urticarial papules characteristic of cholinergic wheals, seen in cholinergic urticaria. Then there is false dermatographism. This is important because white dermatographism can be seen. This is seen in atopic dermatitis, when the skin is stroked with a blunt object. Instead of erythema, a white line surrounded by an area of blanching appears due to capillary vasoconstriction. Pathogen sign, pathogen test we do in pyoderma gangrenosum and in Behcet syndrome. This is elicitation of new lesions or worsening of existing lesions, when it's generally performed by pricking the skin with an oblique insertion of a 20-gauge needle and generally read at 24 to 48 hours. Appearance of papule or pustule more than 2 mm in size is considered a positive pathogen sign. Coming to tumors, the Buschke-Allendorf sign, again a viva question. This is deep dermal tenderness on pressing the lesion with the pinhead. It can be seen in inflammatory disorders and in tumors. As you can see, we used to use the synonym, England, to remember the names of the tumors: eccrine spiroadenoma, neurilemoma, glomus tumor, leiomyoma, angiolipoma, neuroma, and dermatofibroma. Again, an exam question for residents. Love sign is the exact localization of tenderness. This is very classical of Gomes tumor. Then Fitzpatrick sign, the dimpling sign as it is called, quite characteristic of dermatofibroma. Darius sign, we see it in mastocytosis. Hutchison nail sign, very important because it can be an indication of subungual melanoma. Where do you think of a melanoma? These are the factors: width of the longitudinal melanonychia more than 6 mm, proximal width more than the distal width, multicolored or heterogeneous pigment, blurred or jagged edges, associated nail plate dystrophy, ulceration and bleeding are all indications of tumors. Because why this is important? Because this kind of nail sign can be seen in benign nevi also. So these are the features which should set the alarm bells for a malignancy. Then Deck-Chart sign seen in papilloerythroderma of Ophuji. Coming to few infections, Dory-Flop sign, this is seen in syphilitic chancre because of the indurated nature of the lesion. So when the prepuce is retracted, it generally flips over because of the induration of the lesion. Then scratch sign, this we are all familiar with, pityriasis versicolor. Hutchinson's nose sign, which indicates the involvement of the nasociliary branch and possible ophthalmic involvement in a case of herpes zoster. Some of the other systemic disorders which we can do, Prayer's sign, which is seen in diabetic chiroarthropathy, because the patient is unable to bring the palmar surface together. So that is when the Prayer sign is said to be positive. Cullen's sign, which is periumbilical ecchymosis, which is seen in cases of acute hemorrhagic pancreatitis or ruptured ectopic pregnancy. This we have learnt in MBBS level also. An important sign, raccoon sign, periorbital hemorrhage, which is an indication of systemic amyloidosis. This patient actually had, gone to several physicians for 2 years. She was just going around for weakness, and by chance the physician in our college referred to us, and we made the diagnosis of systemic amyloidosis after 2 years. The patient had a misdiagnosis of this condition. She had a multiple myeloma actually underlying. So that is how important signs are. So this patient who remained undiagnosed for 2 years, we made the diagnosis of systemic amyloidosis in this patient just on the basis of these lesions and a few translucent papules. Just 1 or 2 slides more. This is a classic breakfast, lunch, dinner sign which is seen in insect bites. There are some unnamed signs also which we do in the OPD, like application of heat or cold to identify physical urticarias, paring of the skin to differentiate between wart and corn, stretching the skin to make the submarine comedones evident, or blunt pressure to detect edema or assess capillary refill. These don't have names, but we do it in the OPD. So I would like to conclude saying that signs are really important. As you saw in that case of systemic amyloidosis, just the presence of the raccoon sign, and then we examined her closely for the translucent papules. We did a biopsy. We came to a diagnosis of systemic amyloidosis. Ultimately, she turned out to be multiple myeloma. So you can see how important our cutaneous signs are, even in diagnosis of systemic disorders. Thank you so much for a patient hearing.
Thank you, Dr. Sheetal Pujari, for a very nice presentation on basic dermatology.
Thank you, sir.
Any questions? Thank you.
Thank you, ma'am, for the wonderful session. And sir and ma'am, please correct the memento. And for the next session, I would like to call Dr. M.K. Sinha sir and Dr. Gopal Rajput sir for chairing the session.
Good evening, everyone. So we move on to our next session this evening. And we have with us today Dr. Ujjwala Verma. She has done her post-graduation MD in dermatology from Patna Medical College Hospital. I know her since his student days of MD. She is a consultant dermatologist, Ramakrishna Care Hospital, Raipur, and Dr. Ujjwala's Skin Clinic. She has, to her credit, more than 100 presentations and 5 publications. She is director of Ujjwala Skin Clinic, masters in cosmetic gynecology, and member of Indian College of Cosmetic Gynecology. She is vice president, Raipur Dermatological Society, and treasurer, IADVL Chhattisgarh. So we will be having her lecture, cosmetic gynecology. It may be very new to us, but it's a very interesting topic. She will let us know what she does in cosmetic gynecology and what areas she covers. Thank you so much, Ujjwala.
Thank you.
So now we can begin your topic.
A very good evening to all. I'm here to present about cosmetic gynecology, what a dermatologist should know. So what is health? A physical well-being, a mental well-being, an emotional well-being, and what else? An unspoken part, sexual well-being. So cosmetic gynecology. A woman's body keeps undergoing changes all throughout her life. These changes become especially evident during childbearing, delivery, breastfeeding, premenopause, menopause, and its aftermath. Aging too works in changes in her body. Her genitalia too may undergo changes in keeping with the rest of her body. However, sometimes women find these changes hard to accept. Some medical conditions too may necessitate genital rejuvenation. With age and life events like childbirth, the vagina and the labia often change in appearance and structure, which not only hampers the feeling of self-worth in a woman, but also prevent her from enjoying sexual activities completely and cosmetic gynecology emerges as the savior in such situations. Vaginal rejuvenation does not mean one has to go under the knife. There are minimally invasive ways of going about it. When might women need vaginal rejuvenation? A laxity of vaginal canal caused by natural childbirth, vaginal dryness, sagging of labia minora and labia majora, orgasm dysfunction, and inability to enjoy sex, vaginal atrophy, urine leakage, which we call stress urinary incontinence, which is very common in females post-pregnancy. So what are the benefits of vaginal rejuvenation? Vaginal rejuvenation can improve the tightness of vagina, help with incontinence or the leaking urine, increase lubrication and moisture, increase vaginal sensitivity and sensations, strengthen weak vaginal and pelvic muscles, improve painful intercourse, enhance the appearance of vulvar area like labia, clitoris, or vaginal opening. It has been seen that vaginal rejuvenation gives improvement in cases like LSCA and in recurrent STD infection, as the vaginal flora improves with the health of vaginal mucosa. Vaginal rejuvenation not only helps to do away with all these medical issues, but it also enhances the aesthetics of women's private parts. What are the non-surgical means of vaginal rejuvenation, which mainly consist of energy-based devices or energy-based therapy? As the name suggests, this treatment aims to undo vaginal damage by using heat. A beam of high energy rays is aimed at the site that need to be rejuvenated. It boosts the production of collagen, which is instrumental in healing scars and wrinkles, and promotes the growth of new tissues. Moreover, it also makes the tissues of the vagina shrink and tighten. There are a number of different treatments available that utilizes energy-based therapies. What are they? A radiofrequency treatment. Like we always use the radiofrequency device for our surgical interventions. Similarly, for bioremodulation or collagen boosting, we have different radiofrequency devices. So radiofrequency devices guide electromagnetic waves, and that heat raises the temperature of the surrounding tissue, thus leading to tightening of the tissue. Fractional CO2 laser. This treatment entails using carbon dioxide laser technology to heat up the lowest layer of the tissue underneath the skin. This triggers the secretion of collagen and tightens and make the skin of the vagina taut. Erbium YAG laser, which is non-invasive, 2940 nanometer. 1410 nanometer diode is also a non-ablative resurfacing laser. MNRF can be used with a vaginal probe. HIFU, high intensity focused ultrasound, can also be used for vaginal rejuvenation, and there is one more plasma, which is jet plasma for endocervical and ectocervical, with endocervical and ectocervical probe for cervical rejuvenation. And the cervical rejuvenation actually works for these vaginal secretions, especially when when they have that ectopic tissue. It helps to treat those tissue, and the secretion or the vaginal mucosa improves and the secretion decreases. If the damage done to the vagina is not extensive, then the exercises can work as an effective cure for the problem. Kegel exercises and pelvic floor workout can also help to tighten the muscles of the vagina. Electromuscular stimulation, or the EMS of pelvic muscle, which can generate up to 18,000 stimulation in 30 minutes. It has specific probe which can be placed inside vagina, like V-tone, HIFEM, or high intensity focused electromagnetic stimulation. It is designed as a chair where client can sit. Machine generates about 20,000 contractions of pelvic floor muscle in 30 minutes. What else beyond machines? As women ages, she might be faced with a number of sexual problems such as loss of libido, vaginal dryness, painful sexual intercourse, and inability to orgasm. Men too aren't immune to sexual complication, with issues ranging from premature ejaculation to erectile dysfunction. This might be a blow to their confidence, and marital discord may creep in. But all these issues may be circumvented with little help from medical science, and these are treatment available that can help you bid adieu to all your sexual worries. It is just 5 to 10 minute procedures, and what are they? A G-shot. The only way a woman can orgasm is through stimulation of either the clitoris or the G-spot that is located inside the vaginal passage, but the G-spot may lose its sensitivity over time. In such a scenario, a cosmetic gynecologist will administer the G-shot and injection. A G-shot is a hyaluronic acid which is introduced into G-spot. The area surrounding it becomes hydrated. This will help a woman achieve vaginal orgasm by making the spot much more responsive to the stimulation. Then comes C-lift. We can combine G-shot with the C-lift, where the same hyaluronic injection is used to lift the clitoral region. O-shot. Sometimes wear and tear of vagina and loosening of canal do not allow a woman to attain an orgasm through penetration. In such cases, platelet-rich plasma injection can help. This is called an O-shot or orgasm shot. Our body has an incredible ability to regenerate damaged cells and tissues. PRP consists of concentrated volume of platelets and protein that speed up the growth process. New blood vessel, collagen, and tissue are produced in vagina, and this also thicken the vaginal mucosal wall, and it improves the flora of the vagina so that the patient will also have less of the sexually transmitted disease, or the recurrent vaginal discharge of recurrent vaginal infection can also be controlled. O-shot ensures augmented vaginal lubrication, reduced or no pain during penetrative sex, a tightened or more elastic vagina. And there is the Kama Sutra shot, which is again a PRP injected around vaginal orifice, vaginal wall, and around the clitoral and the glands, which is called Kama Sutra because it improves the orgasm and arousal. The role of adipose-derived stem cells and fat transfer in rejuvenation and treatment of female genital area. So the stem cell therapy is a process of isolating autologous adult stem cells and injecting them at the site, which requires healing or regeneration. So recent reports have identified that adipose contains the highest percentage of adult stem cells in the body. The adipose-derived stem cells harvested from the patient's own body fail to elicit an immunological response, and therefore their administration into targeted site does not lead to rejection. It has a varied composition like mature adipocytes, extracellular matrix, and stromal vascular fraction, which consists of variety of cells including adipose-derived stem cells, endothelial cells, erythrocyte, pericytes, fibroblasts, hematopoietic cells, vascular, smooth muscle cells, and other immune cells. Fat transfer is performed for genital volume restoration, for rejuvenation of vaginal wall and vulvar skin, and vaginal recalibration by lipofilling techniques. Lipofilling procedure consists of reducing the vaginal caliber by thickening the vaginal wall, employing adipose tissue transplant. So anything else that can be done non-surgically? Yes. Aptos threads specially designed for vaginal rejuvenation are there, which can be used to tighten up the vaginal orifice. The surgical cosmetic gynecology. The 5 main procedures of cosmetic gynecology are hymenoplasty, which is creating an intact hymen broken by cycling, horse riding, or first intercourse. In most countries, intact hymen denotes virginity. Vaginoplasty, tightening of vagina or vaginal rejuvenation for sexual satisfaction. Labiaplasty improves the appearance of inner labia and reduces the vaginal lip size. Hoodectomy or clitoral unhooding, it removes the tissue that normally cover the clitoris. And monsplasty, it lifts, tightens, and shape up the pubis, the bikini bridge, which may be prominent when wearing outfits, and especially in athletes, when they have to wear monokinis or a bikini or the swimmers. These are minor surgical day procedures. The scar usually is imperceptible, but some amount of bruising, discomfort, and swelling is common. Thank you. Thank you, sir.
One thing, may I ask you?
Sure, sir.
So, you have not mentioned this surgical procedure, you know, female genital mutilation. Is this approved in India or it
So
is
female
illegal?
genital mutilation is a common condition, especially in some of the areas where they perform, like in communities where it is actually done. And for those, reconstruction of the genital area is very important. And in those cases, surgical genital mutilation is corrected through surgical techniques.
Is this an offense or it is legally approved in India?
Female genital mutilation?
Yeah.
Sir, in some communities it is done ritually, and for rest it is crime. I don't know about the legal aspect, but mentally it is crime for females.
It is very done commonly in the Parsi communities, and it is actually the offense. But offense is only has been legally tackled if it is reported.
Yes.
Since it's a ritual there, they don't report it.
Jesus.
So that's what. Any question from the audience? I have few questions to you. Just, okay, one is you talked about G-shot and C-lift. The HF filler used in that G-shot and this one, is that same rheology that we use in the face?
No, sir. HF filler, which is FDA approved for the G-spot, is actually cannot be procured in India. It has to be procured from outside, and bringing them inside India is also considered smuggling.
Yeah.
And using the word G-shot is also controversial because there is only, these terms are only used by some people who has learned the G-shot from the only pioneer.
Exactly, because finding a
It's-
G-spot is
the
itself
same
is very
hyaluronic
difficult.
acid is not used.
Exactly. Okay. The second thing is you talked about the O-shot. Where are the locations of injection of this O-shot?
So O-shot is basically, we can give around the vaginal wall interiorly and anteriorly, laterally, and circumventing the vaginal orifice.
So is it inside also and then outside also?
Up to certain extent, आप जहाँ तक जा सकते हैं, वहीं तक उससे ज़्यादा नहीं, up to 5 centimeter तक we can see if the vagina is very patulous. If it's very intact, then only the outer area is used.
Okay. And about the nanofat transplant. Now, I do the nanofat transplant for the acne scars and all that. But where exactly you put that nanofats and everything?
So nano-fat plasma is actually used for basically for Mons reconstruction, for labia majora reconstruction, because sometimes because of the loss of weight and also the labia is very or crinkled or wrinkled.
So basically for volumization.
And between the vaginal mucosa and the muscles, then it is placed so that there's some volume is created, so it reduces the canal.
Okay. Okay, understood. Second, the last thing is about pigmentation part. There's a lot of fad nowadays in the teenagers and everything that they want to get rid of the pigmentation in the vaginal side as well as on the underarm side. Do you do some peel or some procedure or some laser in
Yes,
whitening
sir.
of
Yes,
this?
sir.
Can you please throw a little bit light on it?
Yeah, for genital lightening, we use 2-3 things. First, if you do laser hair removal also, with 1064 nanometer wavelength, it gives us skin lightening property. We do pico laser for genital lightening, and there are intimate peels also, especially with the Akar people, they have intimate peel, or we can use mild peels. But because in females, the possibility of having irritation is more because of that menstrual cycle coming every 28 days. That can also give a little bit of irritation. But people who can manage with the peels, it is always good to have milder peels. So intimate peels, body lightening, the laser hair removal also works to certain extent. For major extent, it is always the pico laser which I use. And if the patient is also taking glutathione infusion, that will lighten up the genital area faster than the face.
Okay. Thank you. Thank you very much.
Thank
nice
you, sir.
talk. Thanks.
Thank you, sir.
So, I would like to call upon the next speaker, Dr. Rajneesh Kumar. He will be speaking on algorithmic approach to diagnosis of drug reaction from rash to severe rash. He has been ex-senior resident from DMCH Darbhanga and currently working as a SMO at the Bihar Health Services. For him, he has been number of administrative appointments to each credit, like Joint Secretary IDWL Bihar, Joint Organizing Secretary Damazon East. Then he has a very special interest in clinical dermatology, dermatosurgery and leprosy as it is flashed. He is also a fellow of ACDI. Okay. So over to you, Dr. Rajneesh.
Thank you, sir, for the kind words. Good evening to all of you. Myself, Dr. Rajneesh, and I will be talking on the topic that is drug reactions from rash to severe presentations. Now, starting with the definition, as per WHO, the World Health Organization has defined adverse drug reactions as response to a drug that is noxious and unintended and occurs at doses normally used in man for the prophylaxis, diagnosis, or therapy of disease, and also for the modification of physiological functions. Now, classification of drug reactions. There are many classifications. First, based on the severity, it has been classified into mild, moderate, and severe. In the mild type of variety, the symptoms are very mild. They do not require any antidote. In the moderate type, the adverse drug reactions require discontinuation of the drug, substitution of the suspected drug, and treatment by antidote. In this case, the hospitalization is generally not needed. In the severe cases, all features of the moderate type plus the hospitalization and intensive medical care is needed in severe type of drug reaction. Another classification is Rawling and Thompson classification. That is, it classified this drug reactions into two types, basically type A and type B. The type A are the pharmacological reactions. They are easily predictable. They are due to the pharmacological properties of the drug. They are dose dependent and the symptoms are generally mild. While in case of type B, they are the hypersensitive reactions. The hard to predict, occurs in predisposed individuals. The severity is very severe and it is very uncommon. Now, another clinical pattern classification of cutaneous adverse drug reactions. There are two main categories, the simple and complex, that is our serious patterns. In the simple, we have exanthematous, fixed drug eruptions, urticaria and angioedema, erythema multiforme, lichen white drug reactions, acneiform eruption, psoriasiform rash, bullous eruptions. While in case of complex patterns, the SJS stain, AGAP, DHS and erythroderma. We will be discussing regarding all this in the subsequent slides. First is the exanthematous drug reactions. The exanthematous drug reaction or the morbilliform or macular purpura eruptions are the most commonly encountered adverse drug reactions. It is characterized clinically by the bright erythematous macules which present initially on the trunks that progressively becomes confluent and spreads peripherally in a symmetrical pattern. It is generally accompanied by pruritus. The systemic symptoms and the systemic signs and symptoms are generally absent. Mucous membranes are usually spared. The onset, the lesion usually appears within 1 week to 3 weeks of initiating the offending medication and resolves spontaneously within 7 to 14 days, and it is followed by scaling or desquamation. The commonly culprit drugs are penicillin, cephalosporin, NSAID, HCQS, and antivirals. This is the clinical photograph of the morbilliform rash, most commonly by the nevirapine. So, another class of drug reaction is FDE. All of us may have encountered during their clinical practice. The hallmark of the disease is the occurrence of lesion at the same time, at the same site each time following administration of the causative drug, and the characteristic residual hyperpigmentation is there upon healing. The common sites are lips, genital, perianal area, but it can occur in any part of the body. Clinical feature, it is characterized clinically. The typical lesion of FD is a well-defined round to oval, bright to oval dull red macule ranging from few mm to over 10 centimeters in diameter, and it can appear on skin as well as on mucosa. As this lesion evolve, they may develop into edema with dark bluish or purple center. Even blisters can occur. Lesion heal with residual hyperpigmentation, and the shades of the hyperpigmentation gets darker with each subsequent exposure of the drug. The drugs which are commonly causing FD, antibiotics, in this the most commonly the ordinazole and metronidazole group, trinidazole, tetracycline, quinolones and amoxicillin. NSAID is another class of drug causing FD. In this, the diclofenac, piroxicam, acetaminophen, they commonly cause FD. Among the antipsychotic, the barbiturates, anticonvulsant, carbamazepine, they are more common culprits, decongestants and miscellaneous, in that carbocysteine and griseofulvin. These are the clinical photographs of fixed drug eruption. You can see involving the lip, upper lip, and in the hand, the pigmentation. Another class clinical diagram of FT. This is another photo of FT. Now, another class of drug reactions include urticaria and angioedema. As we all know, urticaria is a transient pruritic erythematous wheals of various sizes due to superficial dermal edema. The onset of reaction occur after the intake of a specific drug, its temporal association and the stoppage of reaction on withdrawal. History of similar reactions and exclusion of infection and other causes of urticaria and angioedema points towards the drug-induced urticaria. Drugs commonly implicated to cause urticaria. In the antibiotic, we have rifampicin, terbinafine, and among the antivirals, nevirapine, nalviravine, lamivudine. Among the cardiovascular group class of drugs, that is metoprolol and losartan, and antiplatelet like low-mercury heparin and pyridamol. They commonly are implicated to cause urticaria. The clinical photograph of the drug causing urticarial hives. This is another clinical diagram of patient showing angioedema. Erythema multiforme. Erythema multiforme is an immunological mediated hypersensitivity reaction characterized by the influx of CD8 T lymphocyte leading to the apoptosis of keratinocytes. The precipitating agents include a viral infection that comprises among 90% of the cases, while the drugs which comprise of 10% of the cases of erythema multiforme. It is characterized by the prodromal phase of itching and burning prior to the appearance of lesions. The lesion start as erythematous macule or papule over the dorsum of hand, extensors of extremity, palm soles and oral mucosa. In due course of time, they evolve into classic target lesion. A classic target lesion has three zones, that is the central zone of dusky erythema or purpura, the mid-paler zone of edema, and the outer ring of erythema which is with well-defined edges. This is a clinical photograph of that target lesion. In this you can see the central blisters followed by edematous ring and well-defined edematous borders. Now, drugs causing erythema multiforme, antibiotic, among the antibiotic group, the penicillin, amoxicillin, cephalosporin, ciprofloxacin and sulfonamides are commonly associated. Among the anticonvulsant, carbamazepine, phenytoin and barbiturates are important drugs. Antifungal, fluconazole, terbinafine and griseofulvin causes EM, and NSAIDs, in that we have naproxen and ibuprofen, and allopurinol and protease inhibitor do cause erythema multiforme like lesions. Now, lichenoid drug eruptions, the drug-induced lichen planus, they exhibit typical morphology of lichen planus, but they tend to be more generalized and they are present more symmetrically over the trunks and extremities. Drugs implicated in lichenoid drug reactions include the beta blockers, the AC inhibitors, antimalarials, heavy metals, anti-TNF inhibitors like etanercept and infliximab. They are more commonly associated while causing LDR, lichenoid drug eruptions. Now, few drugs are presentation regarding acneiform drug eruption. They are the inflammatory follicular reactions resembling acne, and they present clinically as papules or pustules. Any edge can be affected. They are monomorphic lesions. This is the classic presentation. The lesions are very monomorphic. They are resistant to the conventional acne therapies, and onset of acne after initiation of drug, improvement after drug withdrawal, and recurrence after reintroduction of drug are the pointers towards the acneiform eruptions. Few drugs which cause acneiform drug eruptions like neuropsychotropic drugs, in this the phenytoin, lithium, phenobarbital. In vitamin B6, B12 are implicated. Immunomodulating drugs like tacrolimus, cyclosporin, sirolimus are commonly associated. Among the anti-tubercular drug, isoniazid, rifampicin, and ethambutol do cause acneiform eruptions, and solarans are associated. Psoriasiform drug rash, they present as the development of new psoriatic lesions in a previously uninvolved skin. There is no previous history or family history of psoriasis. Withdrawal of causative drug arrests the progression of disease. Drugs causing psoriasiform lesions are beta blockers, lithium, AC inhibitors, NSAIDs, interferons, and benzodiazepines. Now, bullous drug eruptions. Drug-induced bullous disorders include pemphigus, bullous pemphigoid, linear IgA dermatosis, and pseudoporphyria. This pseudoporphyria are more common in patients with CKD, especially who are on hemodialysis. The self-resolution is common after drug withdrawal. Now, coming to the severe cutaneous adverse reactions, in this the two important diseases, that is SJS, Stevens-Johnson syndrome, and toxic epidermal necrolysis, are very common. They are serious, potentially life-threatening mucocutaneous reactions with extensive epithelial sloughing and systemic symptoms, most often caused by drugs. The common culprit drugs that cause SJS-10 include antiepileptics, sulfonamides, beta-lactam antibiotics, NSAIDs, allopurinol. SJS, when the epidermal detachment involving body surface area is less than 10%, when it is more than 30%, we call it toxic epidermal necrolysis, and when it is more than 10 and less than 30%, we call it SJS-10 overlap. Now, in this, first of all, there is prodromal symptoms followed by detachment of mucosal membrane like oropharyngeal, conjunctival, and anogenital membranes, followed by cutaneous features. In this, there is dusky erythematous macules or purpura which extends symmetrically on the trunk and proximal limbs. There is appearance of flaccid blisters followed by sheets like detachment of epidermis. The pseudo-Nikolsky sign is present, that is, sharing pressure on the involved erythematous skin may cause epidermal detachment, and systemic symptoms are usually associated. Now, coming to the Schouten criteria. Schouten criteria is a severity of illness scale with which the severity of certain bullous lesions can be systematically determined. It was originally developed for toxic epidermal necrolysis but can also be used with burn victims, sufferers of Stevens-Johnson syndrome, cutaneous drug reactions, or exfoliative wounds. Schouten criteria has been developed for determining the prognosis of SJS-10 patient. It should be computed within 24 hours of admission and again on the third day. This index identifies 7 independent risk factors. Each parameter is given a score of 1 and total score is calculated by summing up the number of abnormal parameters. These are the 7 criteria. In this, we have age more than 40 years, presence of malignancy, internal percentage of epidermal detachment. If it is more than 10, we give a score of 1. Tachycardia, it should be the heart rate more than 120 beats per minute. Blood urea nitrogen should be more than 28 milligram per ml. Bicarbonate level should be less than 20 millimole per liter, and the serum glucose, it should be greater than 252 milligram per dl. So these are all the 7 independent parameters, and that determine the score determine the prognosis of the patient. Few clinical photographs of patient of SJS-10. You can see the mucosal involvement and the detachment. Another patient of 10. Now, coming to the DRESS or DHS, drug hypersensitivity syndrome or drug rash with eosinophilia and systemic symptoms is a severe cutaneous adverse reaction characterized by a triad of fever, skin rash, and visceral involvement. The common drugs precipitating DRESS or DHS include dapsone, allopurinol, aromatic and anticonvulsants, NSAID, abacavir, cotrimoxazole, captopril, sulfasalazine, and lamotrigine. The unique features of DRESS: it has a long latent period between the onset of drug intake and appearance of symptoms, less severe involvement of skin and mucosa, high risk of systemic involvement, and prolonged treatment with systemic steroid is often needed. There is a Resigar criteria, study criteria for the diagnosis of DRESS. In this, there is acute skin rash, fever is more than 38 degrees C, enlarged lymph nodes at the minimum of 2 sites, involvement of at least 1 internal organ, and blood count abnormalities like lymphocytes should be above normal limit, eosinophil should be above laboratory limits, and platelets should be below the laboratory limits. Any of the 3 with suspected drug reaction is indicative of DRESS. Coming to erythroderma, erythroderma or exfoliative dermatitis is a serious skin condition which results in intensive generalized redness of the skin with scaling, that is more than 90% of the body surface area. And the drug commonly causing erythroderma include allopurinol, sulfonamide, cephalosporin, penicillin. Among antiepileptic, carbamazepine and phenytoin. NSAIDs are the common culprit. Early recognition and prompt withdrawal of drug is the cornerstone of the management of drug-induced erythroderma. Now, to summarize, cutaneous adverse drug reactions are one of the common preventable health problems and an under-recognized cause of morbidity and mortality. A drug reaction should be suspected in any patient who suddenly develops an itchy rash that subsides on withdrawal and reappears on the reintroduction of that drug. Early diagnosis of suspected drug reaction and treatment is important as it prevents morbidity and mortality and improves prognosis. Prompt withdrawal of drug, symptomatic supportive treatment, specific treatment in the form of corticosteroid and other immunosuppressives like cyclosporine or immunoglobulins, and avoidance of suspected drug in future is the mainstay of the management of adverse drug reactions. Thank you.
Thank you, Rajneesh, for summarizing every aspect of drug reactions. Thank you. You are one of my students too. Thank you, Rajneesh.
Any question? No questions? Okay, thank you, Doctor.
Thank you, sir. Thank you.
Thank you so much, sir. I would like our speakers and chairpersons to please collect their mementos. Proceeding forward for the next session, I would like to invite Dr. Ravi Vikram Singh, sir, to please chair the session.
Good evening, everyone. I hope you are enjoying whatever the scientific programs have been presented to you by our organizing committee through our scientific committee. And continuing with the same, I would like to invite a very eminent speaker, Dr. Svetlana Pradhan, who is Associate Professor and Head Department of Dermatology of the prestigious AIIMS Patna. She has 120 publications and presentations of over 150 to her credit. She is editor of book, Clinical Cases in Leprosy, editor-in-chief, Indian Journal of Pediatric Dermatology. She has had various awards. I will just enumerate a few. She has been awarded by Bihar government through the Ayushman Bharat Prime Minister's Yojana. And she has had IL scholarship earlier, and Vice President of IDL Bihar she is, and awarded Rising Star Scholarship by World Congress of Dermatology, Milan 2019, World Congress of Dermatology, Singapore 2023, and she has been awarded fellowship by Association of Clinical Dermatology of India. So over to you, Dr. Professor Svetlana Pradhan. Her topic is connective tissue diseases and cutaneous manifestations.
Thank you, sir, for the introduction. So, good evening, everyone. So, I'll be speaking on connective tissue disease and their cutaneous manifestations and few case scenarios. So, to introduce my topic, skin is the window of internal organs. Many systemic diseases present with various mucocutaneous manifestations that can be clue towards diagnosis. Among them, CTG, I think, tops the rank. So, among CTD, SLE, progressive systemic sclerosis, dermatomyositis are common CTD which present with specific signs in the skin. And being a dermatologist, we are the primary contact of these patients. Primary contact, I will say, we are the first to which the patient comes. So, the dermatologist most often diagnose connective tissue disease. So, if we can diagnose, we need to treat, of course, with multidisciplinary approach. So coming to straightway to SLE, that is cutaneous LE. So the skin lesions of LE has been classified by LE specific and non-specific ones. And the basis of this classification is presence of interface dermatitis that is exclusive for LE with or without systemic disease. And again, their specific lesions have been classified into 3 types: acute cutaneous LE, subacute cutaneous LE, and chronic LE. So the non-specific lesions include other cutaneous manifestations. Those are commonly associated with SLE. So this is a list of LE-specific lesions, like acute, subacute. This is a classification. It is there, then and there in the book. So I will be showing the cases, all the specific lesions. The first coming to acute LE, acute cutaneous LE, you can see it is present with malaras. You can see there is a fixed erythema and edema which spares the nasolabial fold. Sometimes it can have a ulceration leading to scarring also. So as acute LE, another type is generalized form, that is exanthematous, urticarial, or maculopapular rash, and predominantly photoexposed area in symmetrical distribution. You can see here the generalized, that is maculopapular photosensitive rash. It also can involve palm and sole. So next acute LE is TANE LE. So it's TANE in the name is because it resembles toxic epidermal necrolysis. Therefore, it's a TANE variant due to intense interface dermatitis, which leads to keratinocyte necrosis, leading to epidermal detachment. You can see here, so this is looking like a TANE, and skin is about to detach. So after acute LE, this is subacute cutaneous LE. So these are various types. You can see 3 types. Psoriasiform, you can see it looks like a psoriasis. So that will be present in the photo-distributed area, but the scales here are adherent, and they have a tendency to coalesce, polycyclic, upper back and lower back are commonly involved. Again, you can see pigmentation in subacute LE psoriasiform rash, which is absent in psoriasis. So the second photograph is annular erythema of subacute LE. And the third one is, I have downloaded from internet. This is not ours. So this is a Royal syndrome. You can see LE with erythema multiforme like targetoid lesions. If you do a ANA profile, you see Rho and La positive. So another variant is neonatal LE. So this is because of, transplacental crosses of antibody from the mother. It presents with classical sign is raccooneye, periorbital erythema. So it involves the periorbital area, but it also can involve into scalp, rarely trunk and limbs. So next is chronic LE, that is discoid lupus erythematosus. So we know it is a various, so classical variant, we know erythema, induration, telangiectasia, atrophy, follicular flugging, pigmentation. These are the 5 points by which we diagnose DLE. So it is the classical DLE, you can see. So this is a mucosal DLE, it can present the lip inside the mucosa also. When it's present inside the mucosa, it is always confused with lichen planus, but the difference, some soft clues is very well-defined lesion. So the third one is hypertrophic DLE. You can see there is a varicosity present, but this variant of LE. So it will, here it is confused with LPS, lichen planus hypertrophicus, and the scalp DLE presents with cicatricial alopecia, we all know. So this is lupus profundus or paniculitis, the 5th variant, and you can see there is a, on the sole of the patient, you can see there is a erythema ulceration which occurs mostly in the winter aggravation, so that is chilblain LE. And you can see very interesting, it is very rare to find, you can see the ears, you can see multiple erythematous indurated plaques, comedons, and it is a biopsy-proben comedonal DLE. And these are the chilblain. So almost this is DLE, classical DLE, everyone can diagnose, but you can be familiar with various morphological presentations so that you should not miss the diagnosis. So coming to the LE non-specific lesions, so these are classified into vascular, neutrophilic, undefined. So because they are commonly associated with SLE, but they are in the biopsy, they don't show the interface dermatitis. That's why they have been considered as LE non-specific lesions. So this you can see, this is the patient, you can see, so there is a oral ulcer, you can see patchy erythema about the forehead, retro follicular ear plugging, so this cicatricial alopecia, you can see the pigmentation of healed LE. So these are various non-specific palm and sole erythema, vasculitic lesions, nail fold erythema, you can see all the vascular findings which are very soft clues to a diagnosis of connective tissue disease. So this lady who presented, we can see patchy hypopigmentation on the palms, nail fold, forehead, hard palate. You can see she presented with this depigmented lesions. Not hypopigmented, depigmented lesions. But what is the interesting in this patient, you can see the pigmentary change, faint erythema over the face, and this pigmentation is precisely around the nail fold and palms, which are the healed lesions of LE, non-specific lesions of LE, which will guide towards the patient might be having some connective tissue disease. So again, the livedo reticularis, livedoid vasculopathy, urticarial vasculitis. So these are other the non-specific lesions of LE. If you see such kind of presentation in any female, so you should think of CTD, should evaluate for connective tissue disease. So next, this one is APLA. So this is a young girl, you can see it's a child who presented with this type of pigmentary change on our palms, bilateral palm sole, you can see a gangrene. So you see her face, there is only mild hyperpigmentation, nothing is there. So only the gangrene, and she gave a history of erythematous rash who subsided with depigmentation. So what mind doesn't know, eye cannot see. If you will not think of CTD, you will not take history, whether you had erythematous rash, how these white areas occurred. You can just diagnose her as a vitiligo and refer to CTVS, go for gangrene. So this was a case of childhood SLE who presented with Raynaud's and APLA. Because of APLA, she had a gangrene. And then she also had a history of rash on the non-specific lesion of LE on the palms and soles. So I'm not going to the criteria, so you are all well versed with the criteria of the SLE. So this is the case history. The 19-year-old female who presented with joint pain. So her INA and RA factor was positive and treated with prednisolone and hydroxychloroquine and some intermittently homeopathic medicine, presented to us with emergency with fever, oral lip erosion, dusky erythematous maculopapular rash, erosions on the bilateral eyes with mild discharge. So she took, for this she took paracetamol, she was on also thyroxine and homeopathic medication, and there was a history of abortion at 3 months of gestational age. So this is the basic history. You can see the patient, she's one of our staff. So she presented with this type of maculopapular rash. Then subsequent time they become dusky, you can see, leading to total complete detachment of the skin. So this is, patient was having NA positive on steroid already on HCQ, still she developed 10 LE. So this is a case of 10 LE, acute variant of LE. So investigation, there was anemia, leukocytosis, this one there was a mild proteinuria. So NA was already positive, 1:100 titers speckled, and NA profile UNSR and protein ROLA also was positive. So we finally, the patient was diagnosed as 10 LE. So because she was on 40 milligram prednisolone, still she progressed to 10 LE. So we gave her dexamethasone 80 mg pulse therapy, and subsequently discharge her on prednisolone, SCQ and azathioprine. Now luckily with the treatment the patient survived because it has a high mortality is almost 100% in 10 LE. So the 10 LE versus 10, you have to differentiate. Patient give history suggestive of CTD. Oral cavity erosion will be most on the outer aspect. Inside mucosa will be less, minimal involved. And periungual and nail fold capillary erythema, which I showed you all the non-specific soft clues of LE can help you to diagnose 10 LE. So this is another case. It's a case of dermatomyositis. You can see heliotrope rash in a child with Guttrun's papule, Guttrun's signs, heliotrope rash. The child presented with a severe itchy rash It was very interesting, severe itching, and you can see patient had eroded the chest area because of itching. So, but when we looked, patient was an erythroderma, but when you looked at the eyes, there was erythema and edema, and the fingers showed us the diagnosis of dermatomyositis. So other signs, you know, there is a sol sign, V-neck sign, so same erythema over the sol distributed area, V-neck area. This is Holster sign, that is erythema, and over the lateral thighs, which is a friction of, that is the gun, keeping gunman, which keeps the holster. So this is the name Holster sign. Erythema over the knuckles and IP joints. So it is a feature of dermatomyositis, whereas interphalangeal involvement is more in SLE. So this is how you differentiate. So linear erythema about the dorsum, inverse Gutton sign, which is opposite to Guttons and the palmar aspect. Then linear erythema about the dorsum of hand. So these are the signs of dermatomyositis. You can see hyperkeratotic papules, mechanics hand, and the nail fold, nail cuticle is ragged cuticular Smith sign. So coming to the case, 4-year-old boy referred from pediatrics department to do a biopsy from the ulcer on the elbow to see what is this ISR is of scrub typhus or not. So we got a call for biopsy, and we took the history. My resident does it, he saw the patient was having fever since 3 weeks, and these ulcers since 3 weeks, but there was a myalgia. So he was admitted in pediatrics for scrub typhus. All the panels were done for fever of pyrexia of unknown origin. So because the ulcer developed, they sent us a referral to do a biopsy. So the investigations patient had already done from the department of pediatrics, all negative. So we saw this patient now. You see the face, there is a periorbital erythema and edema. So the heliotrope rash was then and there. So if your mind doesn't know, I cannot see. This is my teacher, Dr. C.S. Sarka, who says this dialogue always. So it is always present, you have to just see it. So you can see there is a heliotrope rash, and you see all the frictional areas, the patient was having ulceration. So this was a erythema which is ulcerated. You can see the palms, even in the ankle area, friction area, the patient was having erythema. So there was a volvulus erythema. So what we did, we ordered, patient referred to us biopsy, we didn't do biopsy. So because the child, why to do a biopsy, what will come from this ulcer? So I told the resident, do a NA and CPK. So they are very much adamant, no, we have to do a biopsy. Still we didn't. When the report came and we diagnosed as juvenile dermatomyositis. So in children, the interesting is they are very prone for ulceration, and calcinosis and ulceration of skin lesion is very common in children, in juvenile dermatomyositis. So this is another adult patient. You can see she's having no hair. So there is a heliotrope, and you see the same erythema over all the frictional areas, but patient had developed ulceration. The child also developed ulceration, now adult also developed ulceration. If this type of adult dermatomyositis presents with ulceration, you always think this patient may be having paraneoplastic dermatomyositis. So this patient was having CA breast, and a diagnosed case rather. So I showed you because the hair is not there, so patient is already on chemotherapy. So this is paraneoplastic dermatomyositis. So in children, ulceration is common, but adult it is not common. If it is ulcerated, think of malignancy. So paraneoplastic dermatomyositis, clinical clues when to suspect: adult or elderly individual, sudden onset of severe muscle weakness, ulceration above the frictional areas and rash, constitutional symptoms, severe fatigue, weight loss, bilateral pedal edema, and this will be refractory to your treatment. Unless and until you treat the tumor, the dermatomyositis will not respond to the steroid. So the last, this is progressive systemic sclerosis. So we got, dermatologists only find this patient for color change, white area, tightening of skin, decreased mouth Raynaud's, shortness of breath. So these are the history we take, but they present mostly to dermatologists. So these are the signs you know how to check or binding down of skin. I'll just rush through. So there is a microstomia, pause leaves, there is a scleroderma neck sign, big nose, so Barnett sign, Ingram sign. So this is, I kept for physis, sclerodactyly, and this is rounded fingertip sign. Then the pigmentary change is diffuse hyperpigmentation, salt and pepper pigmentation, vitiligo-like depigmentation, telangiectasia, matte-like telangiectasia, Raynaud's, various stages of Raynaud's, then gangrene, amputation, calcinosis cutis, flexion contracture. Then you should not forget to measure chest expansion, do MRSA scoring. So coming to the case 8-year-old child, it is not common in systemic sclerosis, though uncommon, but we do see cases in child systemic sclerosis. So there is a binding down of skin pigmentary change. This patient present to us calcinosis cutis and telangiectasia. So we did a MRSA scoring. So HRCT was showing early ILD. So we gave rituximab to this patient and MMF for pulmonary findings. So to summarize, the skin lesions many a times precede systemic manifestation in CTD, so help in early diagnosis. So head-to-toe examination is a must. Early specific lesions help in diagnosis, and non-specific lesions both diagnosis and disease severity. That's why you should know early non-specific lesions, because they determine the disease severity. Though malar erythema or rash classical, but may not always present. Patchy erythema, hypopigmentation on face, ears, always check for other sites, take detailed history and subsequently investigate for SLE. Erythema suggests active disease, hypo and hyperpigmentation suggest the healed lesions of LE or dermatomyositis. Nail fold, oral mucosa, scalp, ear, retroauricular examination is a must. Ulceration of skin lesion can occur in juvenile dermatomyositis, but it's rare in adult dermatomyositis, suspect malignancy. So calcinosis occurs in both juvenile dermatomyositis and progressive systemic sclerosis. We have experience of rituximab, very good improvement in calcinosis cutis. Thank you.
Thank you, Dr. Svetlana, for that comprehensive and erudite presentation, as always. Any questions from the audience? If there are no questions, then I will move on to the second speaker. I would like to invite another eminent speaker, Dr. Professor Vikas Ranjan Kar, who is Professor and Head IMS in some hospital, Bhubaneswar. He has 134 publications to his name and presentation more than 150. He is convener SIG Psoriasis since 2021 and Guru Dharma member for 2024-25. His area of interest is psoriasis, atopic dermatitis and leprosy, and is going to present a very interesting topic, conventional therapy in psoriasis, where do they still stand? Over to you, please.
Excuse me. So good evening, Chairperson. Good evening, delegates. And at the outset, I'd like to thank Team Bihar for giving me this opportunity. So sorry for the technical glitches. We'll go through it. So I'll be speaking on conventional therapy in psoriasis, where do we still stand? And before we go to the topic, can you see how many of us are actually using biologics in today's scenario while dealing with psoriasis? I'm sure many of us are not into biologics, and very few selected people are into biologics. Current scenario, if you see, we have still a very good portfolio of conventional systemic drugs which are dealing, and most of us are taking care of our psoriasis patients with the available molecules. There are situations where we have to use certain specific non-biological molecules that we have in our armamentarium. For a very few, we have a first line of mild disease where we have to use. We do not rely on high-end biologics. Combination with biologics. Many times we see that biologics are not 100% effective, and once we treat a patient with biologics, they are left with certain areas which are refractory. So in that case, we have to either add conventionals or we have to use certain topicals. So again, proving that they are efficacious in today's scenario. They are affordable, and our patients love something which is affordable and suitable for patients. Many times the patients do not want to receive injectables, so they are again suitable in this scenario. Coming to special situations where again we have to use certain non-biologic agents, we know that acitretin is highly effective in pustular psoriasis. Acitretin is highly effective in a condition like hyperkeratotic psoriasis, elephantine psoriasis, rheumatoid psoriasis, or very thick palmoplantar psoriasis lesions where other molecules fail to act, including biologics sometimes. And sometimes patients with failed biologics where we have some residual lesions, there also we need to add certain conventional molecules. We have a strong data record of uses of all these conventional molecules in the form of methotrexate, cyclosporine, and acitretin, as well as the newly introduced apremilast. So we know what are the side effects that we are supposed to come across, and we counsel our patients accordingly. So knowing a patient in detail, knowing a molecule in detail, inside out, is what helps us in deciding what exactly is going to happen in that patient. So now the psoriasis treatment hovers around the body surface area, the severity of the disease, and for mild to moderate disease, we mostly treat with topicals, mostly topical steroids again. Then we have also calcineurin inhibitors, vitamin D analogs, topical retinoids, coal tar, anthralin, and few cases we also use targeted UV. Whereas moderate to severe, we have either we go for phototherapy where the logistics are not an issue, and then of course we have the systemic non-biologics in the form of methotrexate, cyclosporine, oral retinoids in the form of acitretin and apremilast. This is the network meta-analysis data which has compared or compiled all the data available comparing biologics versus non-biologics, and you can see that we have molecules in our armamentarium which are not biologics, something like cyclosporine, which is equally efficacious, almost equally efficacious like IL-17 inhibitors. We have also methotrexate, which has surpassed etanercept. We have acitretin again, which is performing better than etanercept. So many times, contrary to the belief that biologics are always superior, we have molecules in our armamentarium already existing, very old molecules, which are either equally or at least better efficacious than the so-called biologics. So non-conventional or conventionally, we use either a topical molecule or a systemic molecule. So topicals, special situations like nail psoriasis, scalp, palmoplantar psoriasis, psoriasis in children or immunocompromised patients or pregnant females, or psoriasis affecting sensitive areas like flexors and genitals. We tend to prefer topicals in those areas. And sometimes in patients who have extensive areas involved also, we need to add topicals along with the systemic agents. So this is the list of topicals, and we know which one to use. Tazarotene is down the list. Most likely we use it in the nail psoriasis, or rarely in the cases where a patient has already experienced topical steroid over a prolonged period of time and is left out with few steroid resistant areas where tazarotene helps. We also modified the formulations over a period of time so that the same molecule reaches the area of psoriasis more effectively through various gels, lotions, solutions, shampoo, so that a wider area of the skin can be addressed. Various new formulations like liposomes, microemulsions, nanoparticles are now being developed, which are more efficacious. And also the delivery methods have been modified so that a deeper penetration of the same molecule can be achieved, especially using antiphoresis, electrophoretions, and lasers. So phototherapy again is for the patient who are in the moderate category with almost 5% body surface area. most preferred phototherapy module is narrowband UVB. We also resort to UVA if the lesions are very hyperkeratotic, where UVB penetration is less. There are developments ongoing in the field of phototherapy. We have localized hand-feet units, home-based phototherapies, finding a lot of appreciation from patients because they don't have to travel to the nearest hospital repeatedly. Photodynamic therapy is evolving, various combination therapies, and there are also AI-driven prediction models as far as phototherapy outcome is concerned. So we also are using excimer-based lasers and lamps for residual lesions even after biologics. So systemic therapy, there are 4 pillars. One is methotrexate, the second one is cyclosporine, acitretin is the third, and fourth one is apremilast. These 4 are the approved molecules. Methotrexate somehow addresses both. It is the old gold standard molecule that addresses both skin as well as joint symptoms. Cyclosporine is the crisis buster in the armamentarium, and we know how fast it acts, and it's really a savior. Acitretin is non-immunosuppressive, is in the basket of the therapies available for psoriasis, and we know the side effects, hypertriglyceridemia, hepatitis can occur with this, but otherwise it's a very safe molecule, and it can be used for a prolonged period, and we know the indications where the lesions are refractory, hyperkeratotic, they do well with acitretin. Apremilast, again the efficacy is little bit on the lower side, but there are sites, something like scalp, palm and sole, which respond very well to apremilast. So we cannot discard the molecule just saying that they are not effective. They are effective in resistant areas where other molecules are supposed to be more active. In the pediatric population, methotrexate again can be used safely and is used since very early childhood. Cyclosporine, you know, we have our experience in atopic dermatitis as well since a very early onset, and cyclosporine has been in use for psoriasis also. And retinoids we have been using in collodion baby, harlequin fetus. So retinoids can also be used in pediatric population safely if you know how to monitor. Only caveat is we need to monitor their bone health at the baseline, and we can compare in case we are using it for a very prolonged period. Apremilast, there is very limited data. Somehow there is some data existing beyond 6 years. Below that, there is no data available in pediatric population. So methotrexate, we know the side effects. Apremilast, there is less data available. Somehow there is some data up to 6 years, beyond 6 years of age. So below 6 years, it's not yet used in plenty. So in pregnancy, if the patient has unplanned pregnancy, then we must advocate regarding the non-usage of methotrexate and acitretin. However, cyclosporine is found to be safe. There is no safety signal in apremilast, but again, there is not enough data as well. So we cannot say that apremilast is safe, though there is no safety signal so far. If the patient is planning pregnancy, then probably narrowband UVB is the safest option. If the disease flare-ups during the pregnancy, then we have either cyclosporine, which is category C, or again UVB. These are the 2 options available to us. So again, apremilast is not finding a place in the approval list of drugs for pregnant females. In lactation, again, apremilast and acitretin, they are not advisable for nursing mothers. Methotrexate is, if the consensus says that if a patient is breastfeeding and we are planning to give methotrexate, then breastfeeding has to be withheld for at least 24 hours. So that the peak methotrexate level in the baby is at least reduced by half. So it can be given, but in rare situations. Usually we tend to avoid. And regarding cyclosporine in breast milk, this is very less, but however, there will be issues with immunization, so better to avoid in case, and there is no other option available to us, we can. Elderly population is a growing population, and with that we also have our routine challenges of management of psoriasis in elderly. They usually deal with problems of hypoalbuminemia, anemia, polypharmacy, hypertension, and renal failure. So we need to be very cautious while using methotrexate. We know they are more prone to develop the methotrexate-induced toxicities. Cyclosporine, because of the low renal reserve, they are prone to develop cyclosporine-induced renal problems. Acitretin can induce a lot of eczematous lesions in elderly people, as well as there will be hepatic derangements and lipid derangements. So we need to keep those things in mind before we start prescribing. Apremilast, however, there is no safety signal as far as the elderly population is concerned. It can be used safely, but apremilast as monotherapy may not find or reach your expected efficacy level. So in that case, it can be combined, and that may help in reducing the dose of the primary non-biologic agent. The practical challenges we see in our day-to-day life is the duration of therapy. Like in biologic users, they say that never stop the biologic because psoriasis is a systemic disease. You keep on giving, otherwise the other damages, in the collateral damages in the other organs like heart and arteries and blood pressure, lipid derangements, those can keep it running in the background. So in case we have the guideline or the consensus till date is that if a patient has stopped or the disease has in remission phase for a period of 6 months, probably we can think of tapering the antipsoriatic, the systemic ones that are using, and try to stop it over coming 2 to 3 months. Then again, we can reintroduce if there is a need, which qualified as the DLQI of more than 5, BSA of more than 10, or global assessment scale of more than 2, and PASI of more than 5. So there is systemic management of psoriasis patients in Indian scenario. There is one Indian consensus, expert consensus, which says that most of our psoriasis patients are undertreated, even though most of us are still sticking to the non-conventional modalities, like non-biologic modalities as far as systemic therapy is concerned. Hardly 1/4 of the patients, they are exposed to the systemic non-biologic agents. So probably the reasons are long-term safety and tolerability. Many of our patients are lost to follow, and we do not know what is happening to them in a long run. So lack of specific guidelines and recommendations. So what that means is most of our patients are probably undertreated. So this is a rough psoriasis oral decision tree. This is akin to something which is developed for biologics. So biologics tree for psoriasis is already established. So this is a rough pictographic presentation of what is happening to the systemic agents which are non-biologic in nature for the management of psoriasis. So if you see, apremilast is being featured many times here because of the safety signal. So a lot of apremilast is very safe, as you all know. No monitoring is required or long term, and it can be used in patients who have associated malignancy along with concomitant psoriasis. It can be used in severe renal damage patients. That means up to GFR of less than 30 also you can give once daily dose of apremilast. It can also be used in patients with alcohol abuse and liver damage. In pregnancy, there is no categorization so far, but however, there is no data showing that this is detrimental to the fetus. So the take-home message so far is most of us are still believe in the conventional antipsoriatics. We are already experiencing the use of these molecules extensively over past few decades. Penetration of biologics is very less as of now in the Indian population. Specific situations require the molecules to be tailor-made for the individual, and biologics are not the holy grail of every psoriasis patient and psoriasis cases. So we need to use both biologics and systemic conventional therapy judiciously when required in combination. Thank you.
Thank you, Dr. Kar. Any questions from the audience? Very interesting topic, must be having many questions. So you have cleared every doubt, sir. Thank you so much. Thank you.
Thank you so much, sir, for such an enticing session. I would request our speakers and chairperson to please collect their memento. Proceeding forward for the next session, I would like to invite Dr. Kumar Satyaprakash, sir, and Dr. Ranjit Kumar, sir, to please chair the session.
Good evening, everyone. Next speaker is Dr. Sri Rupa, and she is consultant dermatologist at Cosmoderma Patna, and she had 5 presentations and 3 publications, and her special interest is cosmetic dermatology, injectable botox, fillers, threads, hair transplantation with liver surgery, and she is MD DVL gold medalist from BHU. Dr. Sirupa.
Good evening, everyone. So today's topic is current treatment approach in melasma. So we all know that melasma is one of the most common pigmentation disorder, and it is the most common pigmentary disorder in Indian women. It usually affects 3rd to 4th decade of women with Fitzpatrick skin type 3 and 4. The most commonly presented in premenopausal women, but postmenopausal women and men are equally affected. The typical clinical features is diffuse light brown to dark brown areas of pigmentation, and it can involve any area, be it centrofacial, involving forehead, nose, chin and upper lips, malar, nose and cheek involvement, or mandibular, involving mandible region and the ramus of mandible. Coming to etiology of melasma, it's not completely understood. There are multiple factors: UV radiation, hormonal factors, genetic predisposition, photoaging, solar elastosis. It leads to abnormal melanocyte activation. There is also increased vascularization, use of oral contraceptive pills, leading to excessive melanogenesis. What UV radiation does, it causes chronic dermal inflammation, activating fibroblasts to secrete SCF, leading to melanogenesis. The role of dermal components, mast cell, solar elastosis, and neovascularization is also in the pathogenesis. Treatment involves pharmacological treatment, chemical peeling, mesotherapy, photoprotection, and laser therapy. First and foremost is topical treatment. Sunscreen are the mainstay of treatment in melasma, we all know. It requires both UV and visible light exposures to cause pigmentary changes, and a recent study has shown that visible light induces a longer lasting hyperpigmentation. Thus, in melasma patients, we need protection from both UV and visible light. So various studies have been conducted, and it has been concluded that sunscreens with either iron oxide or large size titanium dioxide and zinc oxide are highly recommended despite their undesirable cosmetic issue. Next, topical skin lightening agents. They are the mainstay of treatment in treating melasma. There are various agents which act different at different stages of melanogenesis pathway. The first and foremost is hydroquinone. It has solidified for decades as a benchmark in the treatment of hyperpigmentation. What it does, it is a tyrosinase inhibitor. It enhances degradation of melanosomes, leading to decreased DNA synthesis in the melanocytes. Generally used as a 2% to 5% concentration cream, and in the starting of therapy, it can be applied twice daily, but it is usually preferred to be used at bedtime. The depigmenting effect is usually started seeing after 5 to 8 weeks, and it can be continued up to 1 year, but it has been seen that in concentration above 4% and in treatment courses longer than 3 months, it can be associated with a new onset uchronosis. So we have to be mindful with that. In melasma patient, the mean reduction in MASI score after use of a broad spectrum sunscreen and a topical 4% hydroquinone is expected to be around 30 to 40% after 8 weeks and about 45 to 55% after 16 weeks. So there is a dose-dependent decrease in the pigmentation in clinical examination when hydroquinone was applied onto dorsum of hands with solar lentigens at different concentrations, 2%, 3%, and 5%. But there are concerns regarding the systemic absorption of drug-induced carcinogenesis and exogenous uchronosis, limiting to its use. A double-blind study was recently conducted, and a 4% liposomal hydroquinone showed an equal effectiveness. Next, the most important is triple combination cream. It's a stable combination of fluocinolide, acetonide, hydroquinone, tretinoin, and is currently the only FDA-approved drug in the treatment of melasma. It has 3 components: hydroquinone, tretinoin, and a low-potency fluorinated corticosteroid. Hydroquinone, we all know, is a tyrosinase inhibitor. Tretinoin, it inhibits the melanin synthesis, transcription of tyrosinase enzyme. It also has anti-inflammatory properties, enhances keratinocytes turnover, leading to reduced melanosome transfer. Whereas the corticosteroids inhibit the prostaglandin and other inflammatory cytokines, which activates the melanin synthesis. And it also does the part of reducing the irritation caused by the other 2 components, hydroquinone and tretinoin. But we cannot use it because its persistent use can lead to skin atrophy and hypopigmentation. Long-term effect of hydroquinone is also well known to us. There was a study in which 77% of the triple combination treated patients had complete to near complete clearing of the melasma, and only 47% had 40% of dual combination treated patients had the very endpoints. So it's very clear that the triple combination cream acts better than other combinations. The next topical agent is cysteamine. What it does, it inhibits the tyrosinase activity and it decreases the melanocyte function, leading to reduced melanin production. Cysteamine is typically used in 5%, applied daily for 15 minutes during the night time, and its effectiveness was compared with modified Klingman formula. Although there was a reduction in the MASI scores, but the patient IGA and the patient assessment did not show much difference. And it also has side effects of erythema, dryness, pruritus, and dyspigmentation, burning, irritation. These are mild, better tolerated, and repeated use resolve these side effects. Next topical agent is kojic acid. It's anti-proliferative, anti-inflammatory, photoprotective. Kojic acid alone is not very effective. It is usually used in combinations with other, like hydroquinone or other depigmenting creams. The studies have shown that kojic acid 1% is safe, and it is tolerable for a period of 3 months to 2 years without much side effects. The only side effects seen were localized irritation, erythema, pruritus, and pain. Tranexamic acid, it's an antifibrinolytic agent, but in melasma, it has ability to inhibit the plasminogen activator, and it interferes with plasmin pathway, decreasing the melanogenic factors like prostaglandin, leukotriene, and alpha MSH. It also decreases the CD31 blood vessels and downregulates the endothelin-1, reducing the pigmentation. Tranexamic acid cream has been used in various concentration: 2%, 3%, 5%, twice daily application. Recently, it has also been used as a 5% cream in a liposomal vehicle, and it reduces the MASI score. It is also very well tolerated. Alpha-arbutin is also used in combination rather than standalone. It can be used in combination with other depigmenting cream. It inhibits tyrosinase and it is cytotoxic for the melanocytes. Arbutin was used in a study in a combination cream at a concentration of 3%, and alpha-arbutin was used at a concentration of 5%. There was reduction in the melasma score. 4N-butyl resorcinol. 4N-butyl resorcinol was used in a study with 0.1% as a cream and 0.3% in a serum. It did reduce the skin pigmentation in all the 3 studies, but its depigmentation effect increased until 8 weeks, then it plateaued. The adverse effects were mild, and there was improvement in the melasma. So it can be used for a short-term treatment of melasma because long-term efficacy is not very clear. Niacinamide downregulates the melanosomes transferred by melanocytes to keratinocytes, leading to decreased accumulation of melanin. Niacinamide 4% cream was compared with hydroquinone 4%, and there was improvement seen in the decrease in the pigmentation part, and there was no statistically significant difference between the group, and it is a good and safe therapeutic option. And it causes mild burning, erythema and pruritus, but it also improves with the continued use. Azelaic acid is a weak tyrosinase inhibitor, and it is safe to use in pregnant and breastfeeding patient. It is generally well tolerated. Mild stinging and itching can be there after the application, but it fades off in a few minutes. It is used in a 20% concentration twice daily application, and reduction in MASI score is by 50% at 8 weeks. Topical retinoids, we have discussed the mechanism before, and it is not a very good option. Longer treatment duration is required, and there is frequent occurrence of irritation. There are other topical agents in which the evidence is quite low, like mulberry extract, Rumex occidentalis. Next comes the systemic agents. The first and the foremost important is oral tranexamic acid. It is an anti-fibrinogenic activity, and we have discussed the mechanism before, but it also reduces the autophago system, which downregulates the degradation of melanocytes in keratinocytes. It is used at various doses of 250 mg 2 to 3 times daily, and there was a study in which it was used at daily doses of 500 mg, 750 mg, 1 gram and 1.5 gram. There was no significant difference in the MASI score, but faster results were seen at higher doses. The duration of therapy is more important than total daily dose. So the optimal doses of this drug should be about 250 mg 3 times daily for 12 consecutive weeks, but 250 mg twice daily can also be an acceptable option in poorly adherent patients. Various studies has been done. There are concerns of the thrombogenic risk, but the risk is very low in young adults without any underlying medical condition. Contraindications is cardiovascular disease and any current anticoagulant therapy. There are other oral agents, but the evidence is quite low, like pycnogenol, which has an antioxidant, anti-inflammatory effect. The usual doses is 75 to 150 milligram daily, divided in 2 to 3 doses for 2 to 4 months. Polypodium leucotomus, carotenoids. Glutathione, we all know its antioxidant effects, and it leads to tyrosinase inhibition. There was a study in which 250 mg glutathione was given twice daily for 4 weeks, and there was consistent decrease in the melanin index and reduction of lentogens. Chemical peels, these are secondary approach in managing the condition. The most commonly used is a glycolic acid peel, but it does not show any superiority over the topical treatments. Other agents are salicylic acid, trichloroacetic acid, and lactic acid. Laser and light therapies, these are third-line treatment in the management of melasma because of the post-procedure dyspigmentation, hyper or hypopigmentation. The most commonly used laser is the Q-switch ND-YAG laser. The laser toning is the preferred technique. Laser toning involves repeated use of 1064 nanometer Q-switch ND-YAG laser with a larger diameter of 6 to 8 mm and a lower fluence of less than 1. What it causes is subcellular selective photothermolysis. It causes dendrite shortening of the melanocytes. However, punctate leukoderma is a concern with frequent and repetitive sessions. So I end my presentation with this flowchart. So first line therapy is topicals. In case of mild melasma, you can use a topical agent consisting of hydroquinone, kojic acid, tretinoin, ascorbic acid. Review at 4, 8 and 12 weeks. If there is a response, then you can maintain it with intermittent use of hydroquinone up to 6 months and other topical agents. If there is a no response, or if there is a moderate to severe melasma, you can add a oral agent if there are no contraindication, and use a triple combination cream review it at 4, 8 and 12 weeks. If there is a response, continue with maintenance. If there is no response, you can go on to second line, that is chemical peels. If there is a response, you can continue with maintenance. If there is a no response, then you can go with third line therapy of Q-switch ND-YAG laser. And photo protection is the first and the foremost important part. Use a broad spectrum sunscreen with minimum 30 SPF and PA triple plus with inorganic filters like titanium zinc oxide and a physical barrier. Thank you.
Thank you, Rupa, for nice presentation on current treatment approach in melasma. Any question from audience? No question. Thank you, Rupa.
Thank you so much, ma'am, for discussing melasma in such a detail. I would request our speaker and chairpersons to please collect their memento. For the next session, I would like to invite Dr. P.P. Prabhakar sir and Dr. Anjishnu Prakash sir to please chair the session.
Good evening, doctors. Now a very important topic, cutaneous LE, is described by Geeti Khura. Please, doctor, come on the dash.
A very good evening.
Now over to Dr. Khura.
Thank you, sir. A very good evening to all. And at the outset, I extend my sincere gratitude to the organizers for having me here. So a part of my job has been done by Dr. Shwetlina, who recently presented her talk. I would be talking on the management. Before that, a bit about the cutaneous presentation, which has been detailed in the previous talk as well. So we all know that we have LE as specific and LE non-specific cutaneous lesions. This is important because the management would vary based on the type of skin lesions. And there are 4 basic categories within the LE-specific skin lesions, which are basically acute, subacute, chronic, and intermittent, which sometimes is included and categorized as tumid LE. So this classification, just to tell that the ones marked in the red are basically the ones which are associated with systemic disease, and the ones which are in yellow are pointer is not. The ones which are in yellow are relatively have a lower risk of associated systemic involvement. So screening for systemic involvement is a part of management in cutaneous LE, and that is important when we are dealing with acute cutaneous LE, and also when we have non-specific cutaneous manifestations, which include the vasculopathic lesions or the non-scarring alopecia or bullous lesions. While in subacute and chronic cutaneous LE, the risk is relatively less. But nevertheless, we need to screen these patients as well, depending on the clinical presentation. So just to highlight the EULAR ACR criteria, which includes these 4 cutaneous manifestations in the cutaneous domain or the clinical domains, and have been given the points of 2, 2, 4, and 6 each, the highest being that for the acute cutaneous LE. So this basically highlights the importance of recognizing the clinical manifestations and tailoring the treatment based on that. So this is on the photograph on the left showing the malar rash. I think the pointer is not working. The photograph on the right showing the SCLE rash, the papillosquamous rash of SCLE. Quickly going on to the disseminated DLE, which has these depigmented plaques with hyperpigmented border. Now coming on to the clinical evaluation. So the management basically includes a comprehensive history with all the system review, as well as complete physical examination to look for the systemic involvement. And the clinical assessment also should include disease activity and damage score. I know this is very tedious for busy OPD practice, but of course, if we have a trial or a thesis, we can always include doing CLASI, which is cutaneous lupus area and severity index, and revised CLASI, for the determination of therapeutic strategies and treatment efficacy. Brief on the histopathology, because this also comes under management. We have to confirm certain cases. Not all cases are straightforward. So basically, it shows interface dermatitis with features of the mononuclear infiltrate at DJ, basal degeneration, perivascular periadnexal inflammation, and mucin, which is the hallmark for LE. There are some subtle differences between various subtypes, which I will not go into detail because it is not in the scope of this talk. And of course, direct immunofluorescence, which shows multiple immune reactants in the DJ junction. So just to show these images, the image on the left, because of lack of pointer, just to show that this is basically showing the superficial and deep infiltrate, which is going around the follicles with follicular plugging, suggestive of DLE. This is basically a vacuolar degeneration, suggestive of interface dermatitis with a lot of pigment incontinence and basement membrane thickening. So these are pointers towards LE. And this shows mucin deposition, again a feature of DLE. So this may be resorted to when you have a clinical diagnostic dilemma between certain unusual variants of LE. Now coming on to the lab investigations, we all know that complete blood count, liver renal function test, testing for proteinuria, autoantibody profile, this is must for all our patients. Patients with CLE without systemic involvement do not have these autoantibodies. But of course, if these are present, then it can help you to support the diagnosis and also to subtype the diagnosis, or like we have ROLA in SCLE or other conditions, and also the prognosis. In patients with acute ACLE, most frequently which is associated with SLE and SCLE also, disseminated DLE, lab investigations are done to rule out or exclude organ involvement as well. And also these patients must be investigated for any side effects due to the systemic therapies that they are sometimes put on. Now coming on to the treatment part, neither topical, so there's no FDA approved treatment for cutaneous LE. So this is important because all the treatments which are approved are for SLE. Even the antimalarials are not approved and they are used off-label or maybe as a maybe used because we are using them in SLE as a FDA approved, so they are also used for cutaneous LE, but they are not yet approved. And the current treatment of cutaneous LE is based on a small number of randomized trials. The recommendations are basically based on the S2K guidelines by European consensus, which has first line, second line, and third line treatment options. And it includes the prevention measures, the protective measures, the control of risk factors, necessity of long-term follow-up, which is the basis for better treatment outcome. Now coming on to photoprotection, which is a must for all patients of LE. So use of protective clothing with tightly woven and broad-brimmed hat, generous application of sunscreen, which offers physical, chemical, both agents, protecting against UVA and UVB with reapplication every 2 hours. Sunscreens should contain titanium or zinc oxide, which are physical blocking agents, and of course, chemical blocking agents in the form of avobenzone or ecamsol, which have a sun protection factor more than 30. And it is important to treat these patients with vitamin D3 deficiency because most of these patients are following sun protection. They do not have sufficient vitamin D levels, and treating vitamin D may have a positive effect on disease outcome also. Now coming on to the topical treatments. So we have topical corticosteroids, which are the first line treatment and to be used for short term, maybe up to several weeks only for cutaneous LE, except on the scalp lesions where prolonged course may be required for more than 4 weeks. And medium potency to high potency steroid is generally used twice daily, recommended generally for 2 weeks and then only on weekends, except for the scalp where prolonged duration is necessary. Intralesional injections have also been advocated for localized lesions which are refractory to topical management. Now this was basically a series of patients that we had seen to highlight both the atypical presentation and then the management aspect. This was a patient, there were 2 patients. The first patient on the upper 2 photographs actually had pigmented lesions, which actually looked like lichen planus pigmentosus or ADMH, that is now known as acquired dermal macular hyperpigmentation. And the second patient had lesions on dorsum of hands as well, with some depigmented lesions on the forehead. So we had biopsied these patients considering LPP pigmentosus as the diagnosis, but what we got on biopsy was the dense perifollicular infiltrate, as you can see here. So there is a deeper infiltrate which is going around the follicle. Here also the second patient, deeper infiltrate, which is unusual for lichen planus pigmentosus, because in pigmentosis the infiltrate is usually sparse and very superficial. So the histopathologist suggested us the diagnosis of DLE and advised us to do a ANA for these patients. One of the patients turned out to be ANA positive, and DIF was positive in both these patients. So we actually concluded this as a form of pigmented macular variant of cutaneous LE and not as LPP, and managed them with topical steroids and oral hydroxychloroquine. So this is just to highlight the atypical clinical presentation in pigmented variant of DLE, which may not have the characteristic scarring or peripheral hyperpigmentation. It could be just macular hyperpigmentation mimicking other disorders. Now coming on to topical calcineurin inhibitors, they are also first line option for DLE, and usually for active edematous lesions like tumid LE. The facial lesions respond better than the other lesions, and they have a better safety profile because they are not associated with these common side effects of topical corticosteroids. In the EULAR recommendations, topical calcineurin inhibitors are given as first choice for cutaneous lesions of SLE. So this was a patient who had actually subtle edematous lesions of tumid LE on the face, which were highly photosensitive, and was treated with topical tacrolimus with very good effects. Now coming on to topical retinoids. Topical retinoids are generally a second-line treatment option for hypertrophic variants of DLE, and hypertrophic DLE is not very common. So it can be given in those patients who are refractory to topical corticosteroids and topical calcineurin inhibitors. And tazarotene and tretinoin in percentages of 0.025% and 0.05% have been used to treat hypertrophic lesions. As we know that retinoids inhibit the proliferative component as well as they have immunomodulatory effects. Now coming on to the systemic treatments. So we all know that antimalarials are the first line treatment of choice in all patients of cutaneous LE. Usually they are given when patients have widespread lesions, severe lesions, lesions which have a propensity for scarring, and it prevents the development of systemic disease and has higher rate of remission, fewer relapses with reduced damage. So in these patients, they have basically lower chance of progressing to systemic involvement if they don't have it at the baseline. So antimalarials have an added advantage of doing this. Now to avoid the risk of irreversible retinopathy, hydroxychloroquine is preferred in comparison to chloroquine and given in a dose of 5 or less than 5 milligram per kg body weight, or chloroquine, if to be given, can be given in the dose of 2.3 milligram per kg real body weight. But combination of both is not recommended because of additive risk of retinopathy. And it is advised by the American Association of Ophthalmologists that examination of the eyes should be done at baseline or within first 6 months, and then annually after 5 years of starting HCQ or chloroquine, or it has to be done annually every year from the starting only if there are risk factors for retinopathy. So what are these risk factors for retinopathy? These are pre-existing macular degeneration, renal insufficiency, that is GFR less than 50 ml per minute, tamoxifen co-medication, or if we are giving a high dose of more than 5 mg per kg, that can predispose to retinopathy. Now treatment for 1 to 2 years is recommended to fully suppress the cutaneous LE activity, and it is essential that these patients should be advised against the use of cigarette smoking because it decreases the efficacy of antimalarials. Now there is an entity called antimalarial refractory cutaneous LE, not very common, but yes, it does exist because response rate in cutaneous LE for antimalarials ranges from 31% to 91% for acute cutaneous LE, that is the malar rash, and it is higher for acute lesions than for subacute and chronic forms. In antimalarial refractory cutaneous LE, the literature suggests to add quinacrine, but we do not have quinacrine in our country. So we should basically, if available, we should measure the levels of HCQ or chloroquine in the blood levels of these patients, and then the dose can be increased above 400 to reach a concentration of more than 750 nanogram per ml. And this is only possible in those who have a cumulative dose of less than 1000 grams. Now coming on to the next systemic management, again this is FDA approved for SLE but not cutaneous LE. We do need to give it as a first line in patients who have severe widespread lesions of acute LE or 10-like LE, which was shown in the previous talk also, and LE paniculitis. And in patients who have, of course, SLE, the dose is 0.5 to 1 mg per kg per day, which is tapered and then finally stopped. Continuation of treatment with antimalarials and other corticosteroid-sparing agents is advocated, and systemic steroids should not be given in a long-term basis. So this was the patient who had 10 like Ellie. She had severe erosive lesions all over the body, involvement of the face, the malar rash that can be seen, and was treated well with oral corticosteroids. So 10 like acute Ellie, I will not go into the details. Now another patient who was treated, this was a patient who presented with an ulcerated, indurated plaque on the chin. And this was biopsied and confirmed to be a case of lupus paniculitis, an unusual site. Usually it presents on the cheeks or buttocks or arm area, and was well controlled with, this was the biopsy which showed the follicular infiltrate and presence of lobular paniculitis, suggestive of LE paniculitis. So patient had ANA positivity and anti-DNA negative. We started her on oral prednisolone along with antimalarials in view of ulceration of the lesion and the lobular paniculitis involvement. And at 2 months, the ulceration had completely healed. Now coming on to the second line systemic treatments after antimalarials and corticosteroids, what else can be given in these patients? We have thalidomide and lenalidomide, though they have a risk of neuropathy, but they have been tried in patients. But they cannot be given in women of childbearing potential. Most of our SLE patients or cutaneous LE patients are young females. So we have to have a caution in these cases. Then comes the oral retinoids, that is acitretin, isotretinoin, which have been again tried, as I mentioned, in hypertrophic DLE in doses of 0.2 to 1 mg per kg. And then is dapsone. So dapsone is effective for refractory lesions, which are particularly bullous, and in bullous SLE as well. And then, of course, our go-to drug, that is the methotrexate, which we all are very comfortable. So this has been taken from online. This was a patient who had extensive hypertrophic lesions all over the body and was treated well with isotretinoin in a dose of 20 mg, and the patient responded very well. So this was a hypertrophic DLE treated with systemic isotretinoin. Now, hypertrophic DLE, a word about it, because it may have basically a progression to SCC. We had one patient who underwent malignant transformation, and that can be the cause of therapeutic failure because of the potential to develop malignancy. So this was our patient who had this hypertrophic lesion on the periphery and this verrucous growth arising over the lesion, which was suggestive of SCC on biopsy. This was a case of bullous LE, which was treated with dapsone. The lesions can present both on photoexposed and photoprotected site, and they respond very well with dapsone. The other therapies which have been suggested are MMF, which is a third line for refractory cases, and azathioprine, cyclophosphamide, and cyclosporin are usually not used for cutaneous LE unless there is a systemic involvement. Even IVIG has been used, but the guidelines do not suggest the use of IVIG because of side effects and some flare of lesions that has been documented, and of course high cost. Now coming on to rituximab, there are small reports and clinical studies in cutaneous LE. Most of the reports are actually in SLE, and they have said that in refractory cases it responds well, particularly in 50 patients who have cutaneous LE, 76% showed improvement in the mucocutaneous lesions, and 15 patients required repeat treatment within 12 months. So we may try this agent if we have refractoriness to other agents already described. Belimumab, again, it is FDA approved for systemic involvement, maybe a fourth line treatment for refractory cases. So just to, this was from the literature, belimumab responding in recalcitrant cutaneous LE. JAK inhibitors are now the emerging therapies. Baricitinib, ruxolitinib, and tofacitinib have been reported in, again, recalcitrant cases. And there is a new therapy which is now upcoming for SLE and will be maybe used for cutaneous lesions as well, which is targeting interferon alpha, because interferon alpha is the main molecule which is involved in the pathogenesis of LE. So this is like anifrolumab and cifalumab, but clinical trials are still on. So I will not go into because of this lack of time. Just to summarize, in children, again, we have mostly these drugs which are already topical therapies are the go-to drugs and hydroxychloroquine. So to conclude, diagnosis is mainly based on clinical and histopathological manifestations. Exclusion of systemic involvement is essential in all cases. For localized cases, topical corticosteroids and calcineurin inhibitors are first line. For widespread lesions or cases resistant to topical treatment, we have to start them on antimalarials or short-term corticosteroids. And antimalarials are the first line for all age groups, whether it is pregnant patient, pediatric patient, elderly, or other cases. Second line would include retinoids, dapsone, methotrexate, depending upon the case-to-case basis, and MMF can be considered as a third line option. PDL surgery can be given as a fourth line cases for refractory lesions when there is cosmetically unacceptable areas. Belimumab has been used as fourth line also for widespread lesions in a patient who already has SLE, because it is a FDA approved drug for SLE and not cutaneous LE. So this is all, and if any questions, I'm happy to take.
Very nice presentation, Dr. Giti. Any question from doctor audience? Okay, thank you, doctor.
What's up?
Oh.
So basically when So there are changes in the macula. I may not be able to tell the exact changes. That may be better, they can be discussed with an ophthalmologist, but there is macular changes in the macula which actually are at risk after giving it for a long time. So maculopathy or pre-maculopathy, that is how they describe the changes. So we do send our patients for annual follow-up, and we get their advice regarding whether to continue further or stop it.
Thank you, doctor. Nice presentation.
Thank you, sir.
Thank you, ma'am, for such an enticing session. I would request our speaker and moderator, chairpersons, to please collect their mementos. For the next session, I would like to invite Dr. Om Prakash, sir, Dr. B.K. Singh, sir, and Dr. Hariram Kumar, sir, to please chair the next session. Dr. Om Prakash, sir, Dr. Hariram Kumar, sir, and Dr. Binod Kumar Singh, sir. Please come upon the dais.
Our next speaker is Dr. Indrasis Poddar. He's Assistant Professor, Department of Dermatology, College of Medicine in Sagor Datta Hospital, Kolkata, West Bengal. He has got many academic presentation, publication 190, presentation more than 100. Please, Dr. Indrasis Poddar.
Very good evening to all of you. So, of course, I thank the organizers for giving me this opportunity, and thank you, sir, for this kind introduction. So, I'll go straight to the topic that it's quite a good topic, that novel biologics in chronic urticaria and pruritus. These are my conflicts of interest, but this is free from any COIs actually. So this will be our agenda. Like, first of all, we'll just have a short introduction about urticaria. Of course, we are all aware of it. Then I'll just discuss about the current treatment landscape, what we have currently for urticaria. And then novel biologics we'll discuss in chronic urticaria. Now, chronic pruritus is a very, it's a very big topic. So everything has got pruritus. So I have restricted our discussion to prurigo nodularis because I think that's one of the very unique conditions which presents with chronic pruritus, and it's not often discussed. And then we'll end with some summaries and key takeaways. Now, what is urticaria? There is nothing to discuss. We all know that unpredictable wheals, there is an acute variety, there is a chronic variety. If it is more than 6 weeks, then it's called a chronic variety. Chronic variety can be either chronic spontaneous or chronic inducible. As you can see, more than 80% of the cases are chronic spontaneous. Now the question is that why are we discussing urticaria today in this late evening? Because traditionally, or even when we were students, urticaria was just a disease where you can just give a couple of antihistamines and just leave the patient. So what is changing? The thing is that about if we can just say the prevalence is quite high. On this graph it looks little, just 0.5 to 1%, but if you consider the population of India, so a lot of patients are suffering from urticaria. And another important reason is that it has this disease, though it's supposed to be a less serious disease, it has got a very severe impact on the quality of life. You can see that all aspects of the patient's quality of life are deteriorated by urticaria to the extent of some of the more important major diseases. So that's why treatment of urticaria is very important. And these days, it is not just enough to leave your patient with urticaria just scribbling down a couple of antihistamines. It is much more than that. So now this is the pathomechanism. We now know that there are two types of autoimmunity, that type 1 and type 2. Type 1 is mainly mediated by IgE autoantibodies, while type 2b is mainly by IgG autoantibodies against the FcR1 receptor. Now we will see how this translates into our biologic section, because like said, in type 1 autoallergy, which is mainly mediated by IgE autoantibodies, this subset of patients respond more favorably to omalizumab, which is an IgE autoantibody. And in type 2b, it's better responders to cyclosporine. And there are these key targets. You can see the different kind of cytokines are also there, because mast cells and basophils are the central cells in urticaria. And as you can see, IL-4, IL-13, these are mainly the Th2 cytokines. And we are having upcoming molecules targeting this cytokine, so that's why they are important. And IL-31 is also an important cytokine. This is what we have currently. We are all aware of it, that we start with antihistamines. We can updose it up to 4 times. If there is no response, omalizumab, we can updose it. No response, then you go to cyclosporine. And the current guidelines, in 2024, we met at Berlin. It was an international congress, and the guidelines have been revised. I think they will be there by the end of this year or maybe the early next year. So in India, what is the scenario? Omalizumab is the only approved biologic for use of CSU or chronic urticaria in India. It's a very nice drug with efficacy rates with almost 70%. But it's not a panacea. It's not like a one-size-fits-all approach. So there are almost 1 in every 4 patient who is not getting better even with omalizumab. The others are like, we have predictors of response. We have already told that type 1 autoimmune patients are better responders to omalizumab. So we can now predict the therapeutic response before even starting our treatment, or we can use such biomarkers. The others are cost and access challenges. Of course, for any biologic, it's when psoriasis, atopic dermatitis, urticaria, because most of these drugs are not covered in insurance, and there is an out-of-pocket expenditure, so it is very difficult for us to use biologics. And there are some clinical practice gaps also, like as Dr. Bikash Kaur also mentioned, that not many of us are still now convenient to use biologics. We still prefer the traditional medications. So then these are the Indian guidelines, almost similar, just there is the addition of, I'll just use this. So there is something called autologous serum therapy. I'll just have I think this is quite a good therapy, but almost 30% patients respond to it. It's like taking out the serum from the patient, centrifuging it, then separating the serum and injecting into the patients. So it basically helps to reduce, mainly in cases of autoimmune or type 2b urticaria. But there are international meta-analysis which say that it's not even more beneficial than placebos. Cyclosporine is of course another guideline recommended drug, but it works nicely in urticaria also, but we are all aware that there is this risk of adverse effects in almost 50% patients. So the ultimate thing is that we need more novel drugs in urticaria. So this was kind of that we have drugs, we have omalizumab, but omalizumab is not the panacea. Cyclosporin is there, but there is the risk of adverse effects. So we need in urticaria some novel drugs, novel biologics, or novel precision medicines which can be used more effectively and more safely. This is Professor Maurer. We unfortunately lost him last year. He's, you can say, one of the most glorious researchers of urticaria in the world. And he proposed this, that we can have a 360-degree, kind of control. Like, these are mast cell mediator blockage, like what we do with antihistamines. So histamine is a mediator released from mast cell, and we are blocking the action of histamine. So these are mast cell mediator blockage. Then on the right side, upright, you can see inhibitors of mast cell activation. Like what is omalizumab doing? So omalizumab is blocking the FcR1 receptor. So it's blocking the inhibition of mast cell, activating. Then we have newer things are mast cell silencing. So there are certain receptors you can see, and mast cell depleters like barvolzolimab. This is something which is upcoming. So this is a KIT receptor inhibitor. So what it does is that it depletes the mast cell. So the idea is that, okay, mast cells are the main cornerstone of urticaria. So if we can devise a drug which will actually cause the depletion of mast cells, so there are no mast cells, no urticaria. And number 4 are inside the mast cells there are some enzymatic pathways. So BTK, like Bruton tyrosine kinase, is one of the most important pathways. So if we can devise some drugs which can block this pathway, then even after activation, the mast cell mediators will not be released. Today we will be just showing you what is the status of the some of the newer drugs. So dupilumab, barvolzolimab, and the brutinibs. Ligelizumab is an IgE molecule. It was almost 50 times more potent, but unfortunately it was found that it is not much more beneficial than omalizumab. So trials have been stopped. I am focusing this that just to highlight that how rigid scientific trials are in the Western world. So this is basically a negative report. Novartis had put in a lot of money into this trial, but because the results were non-superior to omalizumab, this drug has been discontinued. So this is something we can learn from them. Dupilumab, it's of course approved in atopic dermatitis. So as we know that it blocks the IL-4 and IL-13 cytokines. Now being a Th2 disorder, these cytokines are also involved in urticaria. So dupilumab will also work in urticaria. These are some of the trial data. And very recently in 2025 April, US FDA approved dupilumab for use in urticaria. Remibrutinib is something which is much more promising, and trials have been, these are the REMIX trials, you can see. This is an oral molecule, so that's why it's so much promising, because it's difficult to give injections. And what it does is the BTK inhibitor. So what happens is that if you give this drug, this Bruton tyrosine kinase is inhibited. So even if the mast cells are activated, the downstream cytokines will not be released by the mast cells, and that's how we can get, treat this disease. Even this molecule has, this is very recent, in September 2025, remibrutinib received US FDA approval as one of the newer biologics for treatment of urticaria. And this molecule will probably come to India by the end of last year. So this is something of a very promising molecule. Barvolzolimab, still in phase 1, phase 2 trial, again a very interesting molecule. As I said, that this is a KIT inhibitor. So the basic rationale is that don't let the development of mast cells. Mast cells are the cornerstone cells, so block the KIT, so there is no development of mast cells, no urticaria. But we need to see that whether this translates into some adverse effects or not. So that's why this is also a promising drug, but it needs more research, currently in phase 1, phase 2. This is one of the reviews we did with an international team, that biologics for children. Again, the same story, that omalizumab is approved. Here is just one interesting thing we found, that omalizumab is approved in children more than 12 years in urticaria, but in asthma, it is approved for more than 6 years. So this is something we need to work on, that why this age gap is there. Now we move to pruritus. We know that, again, pruritus, there are many causes, but we will stick to prurigo nodularis. Again, a high burden, significant impact on quality of life. So what are the newer drugs? JAK inhibitors. I think you must be using all of them. JAK inhibitors or something. Again, the same rationale. So basically, those cells, inflammatory cells are there, which are the T lymphocytes, Th2 lymphocytes. Inside these lymphocytes, we have the JAK-STAT pathway. This pathway is necessary for the generation of the cytokines, which bring about pruritus. So these drugs are basically targeting that JAK-STAT pathway. And in the same image, you can see that there is interleukin 4 is again a cytokine which regulates this process. So if you have dupilumab, which can block the IL-4, IL-13 receptors, so that can also treat this prurigo disease. These graphs represent several studies, and this study is something which is very recent. There's a review actually, and which showed that upadacitinib and tofacitinib have almost similar effectiveness in prurigo compared to abrocitinib, but abrocitinib is, I think, better than atopic dermatitis. And you can also see the adverse effects rates are quite manageable. None of them are serious adverse effects. One thing to learn from this is that upadacitinib is a selective JAK1 inhibitor, while tofacitinib is a pan-JAK inhibitor. So there is this notion that selective JAK1 inhibitors are definitely better than pan-JAK inhibitors, but that actually is not supported by literature. So it is not supported by literature, it's a notion. Maybe there is some difference, but maybe that difference doesn't translate that much into clinics, that always a selective JAK1 inhibitor will be better than a pan-JAK inhibitor. Dupilumab, it's not yet US FDA approved, but it's the same rationale why it's used in atopic dermatitis, even in urticaria. It blocks the IL-4, IL-13 and the Th2 pathway. And this studies also showed that when you compare it with placebo, there has been a reduction, significant reduction. But there is some kind of conjunctivitis is concerned with dupilumab, and that needs to be taken care of. Nemolizumab, rather, I will say that it's a very interesting and a very good investigational molecule. It blocks the IL-31 axis. Now, IL-31 is a very specific mediator for pruritus. So that's why if we can find a drug which actually inhibits this IL-31 receptor, that will be beneficial, and that is what nemolizumab does. So, these are international studies, it's not yet approved, but you can see that when we found both NRS's numeric rating scale, which is the most widely used scale, and the global assessment, you can see that both of them reduce significantly with the use of nemolizumab versus placebo. This is a systematic review data, again showing that it's a good effective molecule with less side effects. This is another new molecule which is very nascent stage, more for, I think, a quiz question. Vixarelimab it has a dual cytokine blocking action. So on one hand, it blocks IL-31, and it also blocks the oncostatic AIM receptor signaling, which is something which is involved in the signaling for prurigo nodularis pathogenesis. This is in phase 1, phase 2 data, and you can see that there has been reduction in both numeric rating scale and improved global assessment of prurigo nodularis. This chart shows you several other molecules which are in different phases of investigation. We have already discussed Dupi, nemolizumab, vixarelimab, upadacitinib, all the JAK inhibitors we have already gone through. Benralizumab is an IgE, IL-5 blocker. It's mainly used in asthma. Trials have been done in urticaria also, but they have not been found to be superior to the existing molecules, so trials are ongoing here also, because as we know that eosinophils are the cells which are active both in urticaria, also in prurigo nodularis. Omalizumab already were affair, but there are just some case reports. And tralokinumab, these are IL-13 monoclonal antibodies, again in phase 1, phase 2 research. So to summarize, biologics, I'm sure you all must be agreeing to it, that biologics are transforming CSU and pruritus care, as in other disorders also, like psoriasis, atopic dermatitis. So basically, they are a great boon to us. Barbolzolimab, remibrutinib are likely future game changers. The order can be changed. Remibrutinib is there. It's at our doorstep because US FDA has already approved, and Novartis is trying to launch it by next year end, Remi. So these are likely, and Remi is an oral biologic, so that is something which is very interesting. JAK inhibitors have a promising role in chronic prurigo, especially in Indian settings. And one important thing is that don't shy from using pan-JAK inhibitors. The notion is not scientifically, validated that a selective JAK1 inhibitor is always better than a pan-JAK inhibitor. There are some India-specific issues which we need to take care of, like cost, access, comorbidities monitoring, like tuberculosis, especially for JAK inhibitors. And insurance coverage is something we can all discuss, that how these molecules can be made more affordable and more accessible to the patients. So what we need are India-specific guidelines and cost-optimized therapies. Maybe biosimilars will play a very important role, because currently omalizumab, the mother brand, is not available. We have a biosimilar only, and that's much cheaper. So I think biosimilars will play a very important role here. So the future, what lies is precision care with affordable biosimilars. And I think this is something which maybe in the next conference we'll discuss more about biosimilars in this disease. So that's all from my side. Our center is a Gallen certified UKS center. So it's a center of urticaria excellence. So if you have patients with refractory urticaria, you can just contact our center so that we can do, we can just extend the workup on them. So thank you very much for your patient hearing.
Thank you, Dr. Indrasis Podar. Any question from the audience? No question. Thank you.
Thank you, sir.
Now I invite Dr. Vikas Ranjan Kar, Professor and HOD, IMS and SUM Hospital, Bhubaneswar. His topic is breaking the itch inflammation cycle, role of selective JAK1 inhibitor.
I would request Dr. Om Prakash sir to please join as chairperson for this session.
So thank you, chairpersons. Good evening all. So breaking the itch inflammation cycle, this is what I am going to talk today. And we have a plethora of molecules, like the last speaker in Dr. Indrasis told, that we have a set of new molecules knocking at our door. Probably in coming 6 months to 1 year, we'll have plenty of molecules which will deal with itch. So we'll deal with atopic dermatitis and what is the role of specific JAK1 inhibitors. This is a chronic inflammatory skin disease. We have almost 60% of atopic dermatitis patients in the, who develop the disease in the first year of life. Highest incidence occurs between 3 to 6 months. It affects 10% of the adults. Indian data is now in the process of built up. AD affects 20% of children in high income countries. So global prevalence, if you see, then around 2% of the total population as adults, they have atopic dermatitis. The total global prevalence of atopic dermatitis in females is a little bit higher than compared to males. Indian data says that among all age groups range from 0.98 to 9.2%. In pediatric patients, it is hovering around 7%. So impact of atopic dermatitis, if you see, it ranks 15th among all non-fatal diseases. It has the highest disease burden among skin diseases, that is measured by DLY. The quality of life of patients with AD is impacted due to the chronic and relapsing nature of the condition. Patients experience dissatisfaction with life and their physical health is further impacted. So coming to pathogenesis, we know it's a multi-pronged thing. Earlier it was focused mostly on the epidermal barrier defect, but now it's into an autoimmune spectrum, and there is dysregulation of both innate and adaptive immunity that culminates in a leaky barrier, skin, and a lot of cytokines inflow to the site of inflammation that ultimately results in the dermatitis. So a lot of cytokines play a role as far as the final product is, final atopic dermatitis is concerned. So the key players are IL-34 and IL-36 and IL-1. So a lot of players are playing a role. So major targets are IL-4, 13 and IL-31. JAK-STAT signaling pathway is a very important pathway as far as the disease pathogenesis is concerned. The JAK molecules have to be triggered. The JAK-STAT pathway has to be inhibited to get relief from the itch cycle. So that is one of the major dominant pathways. So itch is one of the most common and burdensome symptoms for patients with atopic dermatitis, and almost all of the patients with moderate and severe atopic dermatitis, they report some degree of itchy, sore and painful or stinging skin. 80% of the adults reported more than one night of sleep disturbance every week. So the itch scratch cycle needs to be broken and at some point, and so that the vicious nature of the cycle is disrupted, and that is key to the improvement in the outcomes of the disease. So coming to the management approach, we have, this is the guideline by AAD. In all the cases, we have to counsel the patient, we have to ask them to avoid the exacerbating factors, we have to assess the severity of the baseline, and there are few baseline therapies like emollients and bathing practices. In mild to severe cases, mostly the maintenance therapy is what is required. In cases where there is flare-up, the topical therapy needs to be adjusted or titrated as per the requirement. Steroid, calcineurin inhibitor, crisaborole, ruxolitinib, and sometimes sweat trap therapy. The middle path is chosen in people who have a moderate variant of disease where they respond to phototherapy, whereas in moderate to severe cases, we have systemic therapy, and they are mostly biologics. Dupilumab, again, is not available in our place, followed closely by JAK inhibitors, which is again led by abrocitinib. We have abrocitinib in our place. Upadacitinib is recently available since last 1 or 2 months. Baricitinib is again, it was available during COVID, now it is not available. Immunosuppressant, again, because we have less access to the molecules, so we are now focusing mostly on immunosuppressive for the management of cases which are refractory. Methotrexate, azathioprine, cyclosporine, MMF, and corticosteroids for in short course for the acute flare-ups. So systemic therapy, the guideline says that the AD serves as important aid to orientation, but do not specify a clear sequence of therapy. So whatever guideline we have, there is no clear-cut definition when to use what. The choice of therapy depends on disease characteristic, the severity and course of AD and affecting body regions, what the patient has already been exposed to, patient's characteristic, the patient's the properties of avoidable medicines, and the physician-related aspects like the physician's experience and various prescription outcomes. So there is plethora of evidence which says that in atopic dermatitis, the molecules are very effective, and there are also evidence building up in Indian context. Most of the cases which are mild to severe, mild to moderate, they can be managed with topical treatments and or phototherapy. However, if there is need, then probably, or it's not possible, systemic therapy is recommended, particularly in moderate to severe disease where the quality of life is very poor. So if you see the preference, then probably the patients always want a itch-free skin. So they are concerned about the drug side effects majorly. So we need to have a session especially dedicated to counseling as far as the drug outcome is concerned. So the type of side effects as determined by this questionnaire study to the patient has to be explained clearly at the beginning of therapy. So methotrexate, cyclosporine, azathioprine, and MMF, if you see, almost all the molecules are not licensed except cyclosporine, and it can be used, mostly it is used in pediatric age group because that is where the disease is rampant. However, it is approved beyond 16 years. So JAK inhibitors, if you see, the Janus kinase proteins are group of 4 cytoplasmic tyrosine kinases, JAK1 to JAK3 and TYK2. They are essential signaling mediators. In atopic dermatitis, the binding cytokines, which are IL-4, IL-13 and 22, they activate JAK1. So JAK1 is one of the specific molecules which is usually used in atopic dermatitis. In Indian context, we use tofacitinib a lot because that also takes care being a pan-JAK inhibitor. So why a selective JAK? If you see the key cytokines in the pathogens of AD, then IL-4, 13, 22, 31, TSLP and interferon gamma, they are the predominant cytokines involved in this, and they ultimately culminate in type 2 inflammation associated with skin barrier defect and intense itch and inflammation. So we need to address these molecules, and JAK inhibitors modulate multiple key cytokines, the one in the boxes, and that is how they improve the itch scratch cycle. And once the molecule, the interleukin is attached to the transporter molecule, then the phosphorylation takes place and the downstream output of the cytokines which are involved in the process of pruritus, they are taken care of. So there are plenty of studies in the international scenario. If you see, there is JAD compare, JAD mono, mono 2, JAD regimen, JAD dare and JAD tin, and they have all established the safety and efficacy of the molecule abrocitinib in long run. And now the same patients who are available for the follow-up, they are on a study which is called as JAD Extend. This is a real world study. So why abrocitinib scores over tofacitinib? Because this is approved. That is the most important thing because of the safety evidence so far. The mechanism of action is this is a selective JAK1 inhibitor in compared to tofacitinib, which is a pan-JAK inhibitor. So obviously the side effect profile will be more. The type of cytokine inhibition is more selective in atopic dermatitis. The control of itch is again, there is dramatic improvement in the reduction of itch in 1 or 2 days. So the patients are very happy, though the molecule is very costly, though so efficacy is quite established. There is significant skin clearance at the end of 3 months, and even after end of 1 year, there is sustained clearance. The adverse effects are minimal. The very common adverse effects, they are nausea, headache, and acne. They are commonly encountered, but they are not going to let the patient discontinue the therapy. Minimal lab monitoring is required. In our context, we need to take care of the tuberculosis and hepatitis part, and safety is all established. If you see Indian patients, there has been a subgroup study where almost 200 patients from Indian continent they are included. That included 167 adults, 33 adolescents, and females outnumbered males. And efficacy and safety of the molecule, that is abrocitinib 200 milligram and 100 milligram, they were comparable at the end of 12 weeks. So almost hovering around 50%. There is a significant reduction in both EG as well as SCORAT, indicating that the molecule is highly effective. So both the strengths, they are highly effective. So the recommendation says that if you are dealing with an acutely inflammatory skin, then probably a 200 milligram dose. If the patient is beyond 60 kgs, that is the recommended dose. If the patient is less than 60 kgs, we can manage with a 100 milligram dose. So there is one Indian very small study taking 5 patients in each arm where they compared cyclosporine and again with abrocitinib. They found that they used all the 3 molecules that are available in our setup, that is abrocitinib, tofacitinib, and cyclosporine, and all of them they helped improve the EG as well as SCORAT as well as the NRS. But however, abrocitinib fared better than other 2 molecules. So compared to conventional therapy, abrocitinib was able to address patients achieving nearly clear skin. So that is a majority of the patients. Notable improvement by itching at the end of 16 weeks. And side effect profile, it was well tolerated with very minimal adverse events. Safety wise also, there are not many major safety signals. So by 16 weeks, abrocitinib showed a better response to treatment as compared to other 2 groups. So abrocitinib has changed the treatment landscape of atopic dermatitis, though not extensively used in our population because of efficacy and safety profile, rapid onset of action, convenience and adherence being an oral molecule, potential long-term management because the safety has been established in long-term 1-year studies. Cost is the major issue in our setup because the molecule is new to us and it's very costly right now. Thank you all for your patient listening.
Thank you very much, Dr. Vikas Ranjan Kar, for your good lecture. Any query from audience side?
Thank you.
Thank you so much, sir, for this wonderful session, and thank you to my chairpersons. With this, we come to the end of today's session. I would like to request our respected faculties and delegates that we are soon going to start our Amar Kanja Amar Oration program. So kindly join us for the same.
A warm good evening to all of you. Now we are going to start Dr. Professor Amar Kanjha Amar oration. Dr. Professor Amar Kanjha Amar was born on 21st June 1949 when the India got just celebrating her second independence. Since his early days, he was very laborious and meritorious. Born in a very small village of Bihar, at a time nobody knows that this little boy will one day become synonyms of dermatology in Bihar. After completing his MBBS from Darbhanga Medical College, Darbhanga, he completed his MD from Patna Medical College and Hospital, Patna. In 1997, he became the first person in Bihar to do PhD in dermatology. Serving for more than 34 years as an undergraduate and postgraduate teachers, he guided more than 140 PGs students and did MCI at that time, Medical Council of India, inspection in a different part of country for more than 16 times as a coordinator inspector. He served as a HOD dermatology in the department of Patna Medical College and Hospital, Patna, and he was awarded many awards, but the most promising was Guinness Book of World Record, Lifetime Achievement Award by AAD, AJD, IADVL, Glaxo Oration, IADVL Best Teacher Award. He published more than 100 articles in the national and international journal. He contributed 3 chapters in dermatology textbook. He authored 5 dermatology books, 4 Mathli books, and 3 Hindi literature books. His contribution to IIDVL is unparalleled. He served almost all posts of the state branch of Bihar IIDVL and in the state journal conferences. Not only state, he also served and contributed the national IIDVL as Honorary General Secretary 2 terms, National Vice President and a member of Constitution Committee of IIDVL, and was a very active Central Council member of IIDVL. He was also organizing secretary of Dermacon 1991. As an able IIDVL member, he attended almost all national conferences, meeting, prepared IIDVL National Directory, increased the membership during his tenure, gave IIDVL the life membership numbering system, and he also started the IIDVL newsletter, raised the Central Fund at that time, and many more. He was also interested in social service and free medical and dermatological camps. The national IIDVL program, IIDVL Chala Gaon Ki Or, was his brainchild. He organized countless rural medical camps along with all the IIDVL awareness day. He was the first to start the work and last to leave the venue. He was very humble, kind-hearted, and always helping person. With a long time serving, humble, kind-hearted, and always helping person, and with a long time serving IIDVLite at any format, with due advancing age, he worked as a dedicated IIDVL member. For Dr. Professor Jha, Dr. Professor Amar Kanjha Amar, the life principle was, Na tvam kamye rajyam na swarg punarghavam, कामे दुख तक्ता नाम प्राणी नामनी तीनाशीनम, अर्थात हे प्रभु, मुझे राज्य की कामना नहीं है, स्वर्ग सुख की कामना चाहत नहीं है, तथा मुक्ति की भी इच्छा नहीं है। एकमात्र यही इच्छा है कि दुख से संतप्त प्राणियों का कष्ट समाप्त हो. And the Dr. Professor Amar Kanjha Amar oration is conferred to none other than the renowned dermatologist of India, Dr. Venkat Raman Mysore. Dr. Venkat Raman Mysore is a unique combination of dermatologist, dermapathologist, and hair transplant surgeon. He is a fellow of Royal College of Physicians, diplomat member of Royal College of Pathologists, and an international mentor for American Society of Dermatologic Surgery, honorary fellow in the International Society of Hair Restoration Surgeon. He was over 30 years experience as a dermatologist, 20 years in teaching and 5 years of military services. He has authored 146 journal publication and chapters in 15 books. He is the author, editor of several books, Clinical Dermatology, Clinical Pathology, Cutaneous and Aesthetic Surgery, Hair Transplantation, Dermatological Practice, and Medico-Legal Issue, and Online Dermatology. He was listed in the top 2% dermatological scientists of Stanford University listed in the year 2025. He has been the president of 3 national associations, Indian Association of Dermatologists, Venereologists and Leprologists, Association of Cutaneous Surgeon and Association of Hair Restoration Surgeon. He has received 5 Lifetime Achievement Awards, including IADVL, Kandhari Award, and delivered 6 orations in different societies. Now it will become the 7th. He is the president of an international association, that is DASIL, Dermatologist and Aesthetic Surgeon International League, in 2019, and he is currently the director of International League of Dermatological Societies, ILDS, representing South Asia and Africa region. He presently is the director of Venkat Center for Aesthetic Health Center for Advanced Dermatology and Postgraduate Training in Bangalore, accredited for postdoctoral fellowship training to Rajiv Gandhi University of Health Sciences, Bangalore. One of the largest dermatological and dermatosurgical center in India, and has trained over more than 150 dermatologists around the world. So please welcome Dr. Venkat Raman Masur. Please, sir.
Thank you so much, Vikas, for that elaborate introduction. I want to start this oration with a tribute to our good friend Dr. Amar Khan Jha, who was a pioneering dermatologist from Bihar, a major contributor to IADVL, and very passionate about dermatology, and most of all, community dermatology. I still remember that I attended Bihar CUTICON in 2014, and then they had a program going called IADVL Bihar Chala Gaon Ki Or. I was so impressed with the zeal with which they were organizing it that I took it up at the national level and we called it IADVL Chala Gaon Ki Or. So my sincere gratitude and remembrance to Dr. Amar Khan Jha, and my sincere thanks to Bihar branch for inviting me for this. Now, I have called this lecture my journey of a wandering and wandering dermatologist. Dr. Kaushal was asking me about the title, and I said I got inspired from an article which was written by Dr. Lawrence Parrish long back. And he had written an article called Wandering and Wandering in Dermatology. So I think I have wandered to some extent. I have also wandered to some extent, and I want to show you what I did. Now, this is the journey of many of us. Dermatology progressed from lotions to lasers, and then so we wandered and wandered. It's also about being fit and friendly. I will explain the meaning of this phrase a little dermatology. This is also the journey of somebody who was an accidental dermatologist, an accidental dermatopathologist, and an accidental hair transplant surgeon. And this is a photograph which is there in our clinic now. And this is the wandering that I have done. So from military service to government service to service abroad to private practice. And these are the major milestones and the countries where I wandered into to learn these things. Now, And that journey has taken to this place, which is where we practice now, and this is where our hospital is. And this chart, which is present in our clinic, shows this particular journey. And this chart shows the journey in writing that I have had all these years. The book from simple dermatology, right up to hair transplantation, to medical legal issues and online dermatology. We, in my generation, I think we were and still are a very lucky generation. We became dermatologists at the right time. We became dermatologists when dermatology had very little, but there was a renaissance which was happening. We were old enough when that renaissance happened to have learnt enough clinical dermatology, but were still young enough to learn all the new things that were happening in lasers, aesthetics and surgery. And hopefully, we still are not too old to learn all that is exciting that is happening in drugs in dermatology with so many biologics and small molecules, which Dr. Vikas showed just now. So that's why I say my generation of dermatologists was a very lucky generation. And that generation has wandered in this way, and dermatology has changed in this way. But it was procedural dermatology around 2000s that gave respect and reputation to the dermatologist. And till then, till about when I passed out, cryosurgery was a big deal. There were hardly one or two people doing it. We were only doing microdermabrasion, some peels, dermabrasion, only a couple of people used to do it. And then I visited Dr. P.N. Behal, Dr. Sinha here. We were batchmates when we took together. But P.N. Behal was a pioneer at that time, and he was a master of vitiligo surgery. And we learnt it from him, and we were one of the first ones to learn it. And then things changed around 1999-2000. A relative of mine who was balding asked my opinion about hair transplant. But then to give him an opinion, I didn't know enough about it. So I started reading. And when I read, I was fascinated. FUT had just been repeated. Microscopic dissection had been just repeated. Mega sessions had been just reported. And so it was a very exciting time. And so I landed in a place called Daegu, which is in the north of South Korea, under this gentleman, Jung Chul Kim, who passed away recently. And from him I learned follicular unit transplantation. And that was the beginning of a major career in hair transplantation. The follicle unit concept, which said that hair follicles are bunched together by arrector spilorum, which meant that the size of the hair follicle is determined by the number of hairs within a follicular unit. And so the narrowest part of the unit is where the arrectors holds it. So if there is some way that you could just take out that hold of arrector spilorum, rest of it would come out very easily. So first came the strip technique, wherein we used to take a strip, we used to stitch it, and then that involved major skill to produce a scar that you see. This technique, which ruled almost till about 2011 and 12, is almost on the verge of disappearing, except a few of the previous generation like me doing it. Most young dermatologists and plastic surgeons no longer learn this. And this is how the scar would look if you did a good job. And then you kept the strip under the stereo microscope or a video microscope, and you dissected them to produce small slivers, and then you planted them, and you could plant them with a lot of dense packing, 40-45 units per square centimeter. This was a major advance at that time, and that gave way to splendid results for many, many patients. But then people became ambitious, and the scar that you would produce became wider and wider. So it gave way to what is now called follicular unit excision. You would make tiny, tiny holes, tiny enough to include the infundibulum, and go deep enough to cut the attachment of arrectors. And that would bring up the follicular unit up. It will pop up because the inferior segment is not firmly rooted. It is loosely held. And the hole that you make is less than a millimeter, 0.9, 0.8, and that would heal within 1 day. And that healing was dramatic when compared to the previous strip surgery. So this was a major advance because it took the fear out of surgery for patients. It also expanded the donor. You could take the hairs now from beard, you could take it from the body. So the limitation of occipital donor was no longer a limitation. It took the fear out, but what it did was, it took the fear out of everybody. With the result now, patients are not afraid, doctors are not afraid, even a barber is not afraid, and he feels that he can do FUE. And that's why now we have a major challenge of fighting quackery in this field. So this is how it would heal in 1 day, and it will look remarkably normal very, very quickly. So in terms of outcome in the donor area, FUE is definitely superior to the strip. But combining the two gives an advantage that you can harvest more from the occipital scalp. So stage 5 baldness, stage 6 baldness, this is one area of dealing with it. And with that, you can do very good results even for extensive baldness. Very natural looking, very dense looking appearance. So while this was happening, some patients still needed more grafts. And then, this was one of the first articles that I wrote after I came back from abroad. In fact, I think it was this article that brought me recognition in IADVL. Everybody came to know about me when I wrote this particular article because it was absolutely new. This is how each unit looks like. Then we progressed on to body hair. Now the body hair is different. It's mostly single unit. It grows slowly. It doesn't grow very long. But in a very important paper by Tommy Huang from Korea, who was my colleague when I went there, he showed that if you took body hair and put it onto scalp, it adapts to the scalp, and over 4 to 5 hair cycles, it grows longer and thicker. And that principle was the basis for doing body hair transplant. And this is what we did for this gentleman. In fact, this particular case, I was underconfident of doing it, but he was actually very persistent. He said, "Doc, I am a real estate agent. I sell one site in Bangalore every month. If this fails, I will lose that. I have lost the money of one site. No problem, go ahead and do it." And I did it. And then he proudly came, "Doc, look at it, how I look." And him so much so that when he went for a travel abroad, the immigration people didn't compare his photo, didn't like his, appreciate his look. And this we published it. This was one of the first articles on this particular topic. Then that led to a series of other articles. One of the major articles was how to make slits, what is the importance of different shapes of the needles that you have to use. And then there was another very important paper by an Indian dermatologist, which is a major contribution. And that is by Dr. Pradeep Sethi and his wife. They published on direct hair transplantation, and that was sent to me for writing a critique, and I wrote that in the Journal of Cutaneous and Aesthetic Surgery. And that became the basis for direct hair transplantation. So these are some of the other articles. And then my son joined me in 2017. Now, I want to say something here. Plastic surgeons seem to have brain in their hands. What it took several months for me to learn, my son learned it in about 2-3 weeks. And in 3 weeks, he was doing better FUE than me. And this I have seen with all the plastic surgeons who come. They learn it remarkably quick because this is child's play for them when compared to the complicated surgeries to do. Dermatologists struggle. They struggle from the very beginning. How to put on a glove, that's where the struggle starts. So they need to do some work before they come on to hair transplantation. Then there is another important paper that we wrote, and that is the use of oral clonidine as a pre-anesthetic medication in hair transplantation. This we borrowed from liposuction. Dr. Klein, the father of modern tumescent liposuction, was using clonidine routinely in liposuction. It has several effects, sympatholytic effects, and is a very good drug, and that we used in hair transplantation. And then we did something else. We tried to see if pranayam can help bring down the blood pressure and pulse rate due to the caused by anxiety of local anesthesia. Patients are extremely anxious, and you have to give multiple pricks. So they would complain of a lot of pain, the BP would shoot up, And so we did a study with our anesthetist of pranayam, controlled breathing, and we showed that if they do about 15 minutes of pranayam prior to hair transplantation, their pulse and BP do become better. And then we proposed a different classification of baldness. And finally, this was a nice paper that we did, how to use a simple, humble mobile telephone in identifying skipped grafts. When you make a few holes, when you have to pick it up, you sometimes miss it. Likewise, when you make holes in the recipient area and you have to implant, you miss some holes that can easily be picked up by a mobile telephone. And then along with Dr. Aniket, my son, we also tried to change the nomenclature. The holes were called coronal and sagittal. We said that's wrong. It should be called parallel and perpendicular. And then we wrote this paper, which was a hypothesis of how to use combinations and rotations in different therapies in androgenetic alopecia, medical management. So we proposed that every case should be managed in 3 phases. Phase 1, when the patient is still anxious, he is not wanting to use drugs, doesn't like finasteride, minoxidil is causing dryness and itching. At that time, use topical minoxidil, nutrition, pay attention to it, serums. Then after a couple of months, once he has settled it down, add finasteride if he is willing. If he is not willing, start PRP. And then when you have to maintain, finasteride can be given alternate days or can be given as a drug holiday. Give finasteride for 3 months and then give a break for 1 month for it to be washed out. And in that 1 month, you replace it with platelet-rich plasma. Now, we did some work in vitiligo also. This was a paper on cellular grafts, and that we still do, but there are much better exponents of this in dermatology, Somesh Gupta, Devendra Prasad, etc. But you can produce very good results with this, as you can see here. Now, we also wanted to see whether stability, the concept of stability, which is so vital for vitiligo surgery, should it be stable everywhere, or is it enough if that particular lesion is stable? So when I was the president of ACSI, we commissioned 2 multicentric studies, one of which was this. The other one I will come to it later. Is lesional stability more important than global stability? Imran Majid coordinated that, and we showed that lesional stability is enough, and you can still do surgery if he is getting some lesions elsewhere. Hidradenitis suppurativa has been one of the other areas of interest, and we're still working on it, and we are able to start a hidradenitis suppurativa clinic in our hospital. So we have a combination of plastic surgeon and dermatologist, so surgery becomes easy, and this is our current management. Initially, a combination of antibiotics, clindamycin and rifampicin. At this stage, interlesional steroid were needed, and laser hair removal for every single patient. I think that's one of the most important things. Surgery when there is a sinus tract, and then either adalimumab or upadacitinib long term. Liposuction was the next area that we focused on, and this was focused on by my wife, Dr. Jayashree. She was a gynecologist at that time, but if you remember, the first person who described liposuction, Dr. Fisher, was probably a gynecologist. And at that time, 1/3 of liposuctions in America were being done by gynecologists. Now, probably in these days of quackery, that would be called quackery. But at that time, it was accepted, and she was a pioneer. So now, till then, plastic surgeons used to do it under general anesthesia. Klein showed that if you give dilute form of xylocaine, greatly diluted, 3 to 5 liters, it will produce sufficient anesthesia, it will constrict the vessels, it will loosen the fat, and make the removal easier. So that's what was done, and that would do either through use of these machines called powered liposuction, and you could extract up to about 4 to 5 liters. And with that, you would get results like this in gynecomastia, abdomen, again flanks, buttocks again, and then you could also add laser lipolysis. So NDAG laser is what we had. This machine was from Photona, 1064 nanometers. This was a very useful tool. It would block the blood vessels, decrease bleeding, and produce some tightening also. So this we published in 2007, microcannular tumescent liposuction. This was probably the first paper of liposuction by a dermatologist in IADVL. And then there were subsequent papers on this. We also wrote a paper on use of tumescent liposuction in other dermatosurgical procedures, such as hair transplantation, vitiligo surgery, Mohs surgery, etc. And then standard guidelines of care were also drafted on this. Fat transfer was a natural extension from that. Initially, it was macro fat that we replaced with good results like this in acne scarring. And then it became nano fat. Dr. Aniket went to Dr. Philippe Tonard in Belgium, who is the father of nano fat. He learned it and came back, and we started doing this. And this was a case of morphia, acne scarring. And then around 2008 and 9, threads became available, and I became fascinated by it. So Aptos threads by Dr. Marlon Salmanier, who was from Georgia. So he was holding workshops, and I thought I would learn that. So I went to 2-3 different countries with him to learn it, and I started using the threads. Initially, it gave very good results. People were happy. But then disaster struck. I will discuss that a little later. In between, there was a very nice, simple paper published by one of my fellows of using a thali plate, what we use for lunch and dinner, where you could keep everything that is necessary for simple surgery in dermatology. So even till today, our nurses use this thali plate to keep everything and bring it. Now, we also used aesthetic tools for handling dermatological diseases. This was Hailey-Hailey disease. We treated it with radiofrequency, and it healed wonderfully. This was published. Likewise, lichen amyloidosis, we used erbium laser, and it healed very, very well. Acanthosis nigricans improved well with erbium laser. And a lot of pigmentation diseases that we normally see, which are difficult to treat, like frictional melanosis, nevoid lentiginosis, fixed drug eruption, all could be treated with Q-switch laser. Achronosis could be treated too, and it improved well with erbium laser. So, next was keloid. We tried Nd:YAG laser in keloid, and we found that it worked well, and we published that in a journal. Acne scars, by this time, you had erbium laser, carbon dioxide laser, MNRF was just making an entry, and we could produce excellent results. Now everybody does this, nothing outstanding about it, but at that time, this was something special. So multiple sessions, about 4 to 5 sessions, you will produce excellent results with these lasers. And this was published in an article in JCAS by one of my fellows. Likewise, depigmentation which is caused by Q-switch laser could be corrected by using narrowband targeted phototherapy. And we published soon an article on fractional microneedle radiofrequency also. And these are some of the other articles that we wrote on laser. Now this was an important step. Till about 2011-12, it was commonly held that you cannot do procedures for a patient who has been on isotretinoin. You should stop it at least for 6 months before you do any procedure. We disagreed with this, and when I was the president of ACSA, we commissioned a study, multicentric study, which you see here. It showed that we could safely use it, and based on that, we formed standard guidelines of care. And that made it possible for everybody to use lasers in a patient on isotretinoin. So now everybody does it routinely. And around 2010-11, we started the fellowship in aesthetic dermatology by Rajiv Gandhi University of Health Sciences. And that made a major difference for what we did subsequently. One of the things which happens is that with age, you tend to stop learning. But if you have young people around you, you automatically learn. And I am grateful to Dr. Sachidanand, who was the registrar of the university at that time. He was responsible for starting that fellowship, and we got it for our institute. At that time, we were the first institute to get it. Now is the trend of regenerative medicines for various types of diseases, particularly for androgenetic alopecia. And so we have been working on this. So this is use of platelet-rich plasma. And we published a paper on the use of platelet-rich plasma and showed that it works fairly well. This was published in JCAS. And then fat transfer for alopecia. So we have written an article on this. We have been trying it also. But what you are seeing here is use of non-ablative RBMAG laser for androgenetic alopecia. There is particular long pulse RBMAG, what is called smooth mode, and that is useful for androgenetic alopecia. So it does work, and we use it in patients, particularly those who do not want PRP for fear of injections. Cosmetic gynecology was yet another field. So since we had a gynecologist at home, so we started using it for patients for post-menopausal women, and then stress incontinence. And again it works, not a very big difference, but it works. One more use for same laser, smooth mode RBMAG laser, is snoring. My daughter-in-law is an ENT surgeon, and so she uses RBMAG laser for snoring. It tightens the submucosal dermis, particularly in the soft palate, prevents its vibration while sleeping, and that decreases snoring. So this has been the evolution. As you can see here, we have evolved, dermatologist has also evolved. But there is a very important thing. I had an MD in dermatology, like all of you have. But it is also important to get an MD in adversity, because you face that challenge multiple times in your life. So unless you have had difficult cases, unless you have had complications, the journey is not complete. So this is a typical example. One of my patients, he had a HT. He was very happy. After 3 years, he sent an email. Doc, I have been very happy. You did a good job. But can you take off all my grafted hairs? I want to go back to my original look. So hair transplantation for this reason is called psychiatric surgery. This is Dr. Manoj Khanna's term. Now, I told you that we learned thread lift. Now, this was the problem with thread lift. The threads migrated, resulted in abscesses, and then patient developed multiple abscesses. And then I had to take the help of a plastic surgeon to take out the threads. So at that time I learned that it is not enough if you do a procedure. You should be able to handle the complication of a procedure. So if you cannot handle the complication, you shouldn't be doing it. So after that I stopped doing this thread lift. Then this is something which you commonly see, bruising, and these patients can be very, very anxious. And then this was the scar that I was referring to. When you become aggressive, you have wound tension after a strip excision, you will produce a wide scar like this. And this is what brought the technique of FUT with strip into disrepute. And then I read somewhere at that time, 2008 I think, monocryl was a better suture material than Vicryl. So I started using it, and this is what I had. Took almost about 6 weeks to heal, healed with a wide scar. Now when you have young people working or training, you're bound to get some side effects. So it's a corollary, you have to accept it. So this was a patient who burnt after a chemical peel. This was a patient who burnt after Q-switch Nd:YAG laser for hyperpigmentation on the face. And then when you try to do so much, somewhere you also have a medical legal case. And I had a medical legal case, I think it was 2009. This patient had a transplant, got a good result, but refused to take drugs. And then he balded behind the area of transplant, wanted me to repeat the transplant. I suggested that he wait and take drugs, which he refused, and so he landed in the consumer court. But I won that case, but that case was an important lesson because of the importance of documentation. I had his signature in 8 places in 5 different consent forms. We still have at least about 10 or 11 consent forms for hair transplantation. Every type of procedure, we have a consent form. And in one place where he had refused, I had taken it in writing from him that he refuses to take the drugs and is responsible for the consequences. So the lesson is, there is only one thing that saves you, and that is documentation. And of course, I won the case. So bad can sometimes be good. A complication is an alarm. It leads to introspection. It teaches you humility. It wakes you up and kicks you out of your comfort zone. And for that reason, you need to have some complications. I would worry if somebody didn't have a complication. That means that that person is not trying enough or doing enough. Along the way, it's also important when not to do. It is said that a surgeon learns when to do in the third decade, when not to do in almost the fifth decade or sixth decade. So learn when not to do, learn when to say no. I had a patient who came for a second hair transplant after a botched up first hair transplant. He was so frustrated that I told him, and incidentally he was from Bihar. I told him, you please wait a little bit, I will treat you after a month or two. And I sent him back. His father was a doctor, he called me from Bihar. He said, Doc, thank you for not operating my son. I wish the first doctor had done the same. So sometimes it is better to say no. So MD dermatology is fine, but get a degree in adversity. Now this brings us to the question, why do doctors fail? Why do complications happen? Why do we make mistakes despite all our knowledge, all our hard work, all our efforts at learning? The reason is best given by Atul Gawande in his book Complications. He says, we look for medicine to be an orderly field of knowledge and procedure, but it is not. It is an imperfect science. It's an enterprise of constantly changing knowledge, uncertain information, fallible individuals, and at the same time, lives are on the line. There is science in what we do, yes, but also habit, intuition, and sometimes simple, plain guessing. The gap between what we know and what we aim for persists, and this gap is responsible for all the complications, side effects, and failures that we have. And so, that's very important to keep reading, keep abreast, because science progresses very rapidly. But there is one more mistake for such mistakes. Science is there, we have learnt it, but we do not apply it properly. We skip steps, we search for shortcuts, and that is what is called ineptitude, lack of application of knowledge. And that can be prevented by checklists. And Atul Gawande has written a book, The Checklist Manifesto. And that is something which has fascinated me. So with the result that I have been writing checklists and guidelines many times over. So as you can see, there was one here. And then there was one on standard operating procedures for energy devices, isotretinoin and dermatological procedures, hair transplant guidelines, liposuction guidelines, dermatological procedures amidst COVID, when and how to do it, and then virtual consultation in the practice of hair transplantation surgery, standard guidelines of care for recently administered patients with isotretinoin, and then we produced in IADVL, when I was the convener of SAG, 18 different procedures for which it was done, and it was published as a book. It must still be there, though it has been revised recently. Now I am coming to the end of this talk, and I want to talk about something which I am passionate about, tennis, though I am not a great player. And this autobiography by Andre Agassi, if you have read it, is one of the best autobiographies by a sportsman. And he writes this: it's no accident, I think, that tennis uses the language of life. Advantage, service, fault, break, love. All these terms are what we use in our daily life. Because every tennis match is a life in miniature. The structure of tennis mimics the structure of our days. Points become games, become sets, become tournaments. And any point can become the turning point. It reminds me of the way seconds become minutes, become hours, and that becomes life. Any game, any hour can be our finest or can be our darkest. Likewise, every day, every patient, every procedure, we meet a challenge. Every patient comes to us because he has a challenge, and that patient becomes our challenge to treat, to cure, to heal. We do it favorably. Most times, we succeed most of the times, but sometimes unfavorably. We are in a constant struggle to make most of these challenges favorable and make those unfavorable challenges rare. Any patient can be our success, any patient can be a failure, and it is not our choice. There is something beyond. And so when I look back in dermatology, I have all these emotions. And most of all, I'm very grateful for being a dermatologist. And I'm reminded that to be successful, it's not the strongest of the species that survive, nor the most intelligent, but the one most responsive to change. So what is needed is to adapt to change, which always happens. We all know this, survival of the fittest. But is fit being is enough? Tiger is very fit, but it almost came near extinction. Dog is not fit, but it survives everywhere. So it's not enough if you are fit, you also need to be friendly. To be friendly is to adapt, to reinvent, and to move ahead with time. And that is what being friendly. And that's what we have done. Thank you very much.
Thank you, sir. To confirm the oration award, I would like to invite our organizing chairperson, Dr. Abhishek Jha, sir, scientific chairperson, Dr. Vikas Shankar, sir, our president, Dr. Virendra Kumar Singh, sir, and our president-elect, Dr. Ramatar Singh, sir, and our past president, Dr. Om Prakash, sir. Please come on the dais, sir. Thank you all. Soon we are going to start our inauguration ceremony. Kindly stay the conference hall. Thank you. आज के इस उद्घाटन समारोह में चूँकि हमारे पास समय की थोड़ी कमी है, इसलिए मैं चाहूँगा कि हमारा कार्यक्रम थोड़ा सीमित रहे। इसके लिए मैं सबसे पहले अपने चीफ गेस्ट डॉक्टर कौशल वर्मा सर को मंच पे आमंत्रित करना चाहूँगा। मैं अपने गेस्ट ऑफ ऑनर डॉक्टर मैं अपने गेस्ट ऑफ ऑनर ऑनरेबल जनरल सेक्रेटरी नेशनल आईडीबीएल डॉक्टर भूमेश कटकम सर का मंच पे स्वागत करता हूं। मैं अपने अगले गेस्ट ऑफ ऑनर सेक्रेटरी नेशनल इलेक्ट डॉक्टर शीतल पुजारी मैम का मंच पे स्वागत करता हूं। हमारे अगले गेस्ट ऑफ ऑनर ज्वाइंट सेक्रेटरी नेशनल डॉक्टर राजीव ठाकुर। अब मैं मंच पे आमंत्रित करता हूं अपने प्रेसिडेंट डॉक्टर वीरेंद्र कुमार सिंह सर का। सर हाँ। हमारे प्रेसिडेंट इलेक्ट डॉक्टर रामअवतार सिंह सर। हमारे पास्ट प्रेसिडेंट डॉक्टर ओम प्रकाश सर। हमारे ऑर्गेनाइजिंग चेयरपर्सन डॉक्टर अभिषेक झा सर का मैं मंच पे स्वागत करता हूं। हमारे चीफ साइंटिफिक एडवाइजर डॉक्टर रवि विक्रम सिंह सर। हमारे साइंटिफिक चेयरपर्सन डॉक्टर विकास शंकर सर। हमारे ऑर्गेनाइजिंग को चेयरपर्सन डॉक्टर सुतिलना प्रधान। हमारे ऑर्गेनाइजिंग ट्रेजरर डॉक्टर रजनीश कुमार। हमारी साइंटिफिक सेक्रेटरी डॉक्टर श्रीपर्णा देव। और हमारे ज्वाइंट सेक्रेटरी डॉक्टर शिवानी शेखर एंड डॉक्टर मुबारक हुसैन। आप सभी अतिथियों का मैं हार्दिक स्वागत करता हूं बिहार डाइट डिबेट की तरफ से।
I would like to invite Dr. Punkesh Kumar sir to join the dais. Join the stage.
हम अपने अब कार्यक्रम की शुरुआत लैंप लाइटिंग और सरस्वती वंदना से करेंगे। हम अपने सभी अतिथियों से आग्रह करते हैं कि कृपया वे लैंप लाइटिंग और सरस्वती वंदना के लिए आ गए।
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि। गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुदैवसताराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डकण्टकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेश।
पीछे करवाइए, पीछे करवाइए। आराम से। For welcome speech, I would like to invite our organizing chairperson, Dr. Abhishek Jha, sir. Sir.
Good evening, everyone. Welcome to the city of Mahaprabhu. Jai Jagannath to all of you. In the beginning, when I came to Puri and took the blessings of Lord Jagannath, and with the permission of the IDWL Bihar, we just wanted to have a conference of IDWL Bihar in Puri. But when the banners came from the event, it was written 39th CUTICON 2025. Bihar was not written. It is true that now I can see that from almost from around every corner of India, even from Nepal, Dr. Dharmendra Karn sir, Dr. Ramgyan Yadav sir, and others, they have joined us. तो मैं सबसे पहले शुरुआत में अपने चीफ गेस्ट डॉक्टर कौशल वर्मा सर, जो कि डीन हैं, एचओडी हैं डर्मेटोलॉजी ऑफ एम्स के, उनका बहुत व्यस्त समय था, वो जाने वाले थे, लेकिन जब मैंने उन्हें कहा कि सर आपको चीफ गेस्ट बनना है, तो ही एग्रीड. So thank you so much, sir. Our national team, National IDWL Committee, my brother, Dr. Bhumesh Kumar Katkam, he was very much like, he's very busy, everyone knows, but he agreed to come, so thank you, Dr. Bhumesh. Our secretary-elect, who is going to be very busy from, I think, after 2 months, so thank you, Dr. Sheetal Pujari, for joining us. And my younger brother, Dr. Rajiv Thakur, he is Joint Secretary, IDWL. So I welcome you, Dr. Rajiv. And our Bihar team, our President, Dr. Birender Kumar Singh, sir. Our President-elect, Dr. Ram Avtar Singh, sir. Our immediate past President, Dr. Om Prakash, sir. Our Chief Scientific Advisor, Dr. Ravi Vikram, sir. Our Scientific Chairperson, Dr. Vikas Shankar ji. Our Scientific Organizing and Scientific Co-Chair, Dr. Svetlana Pradhan. Our Treasurer, Dr. Rajneesh. Our Secretary-elect, Dr. Shriparna Dev. Our Dynamic Secretary, Dr. Punkesh Kumar. Our Joint Secretaries, Dr. Mubarak and Dr. Shivani. And all the senior members present here, our senior most from Bihar, Dr. O.P. Chaurasia sir, Dr. K.N. Singh sir, Dr. Hare Ram sir, from Jharkhand, Dr. A.N. Singh sir, A.N. Jha sir, A.K. Jha sir, my friend from Northeast, Dr. Barua, our ex-president, Dr. Bhatkarur sir, our president-elect Manoj Ram, our Sudip Das sir, Y.A. Lal sir, all the dignitaries present in this hall, I welcome you all. And I know that Dr. Kausal Verma sir has to leave, so I will request Dr. Kausal Verma sir. I know that chief guest speaks at the last, but just we will make an exception, and I will invite Dr. Kausal Verma sir for his speech. Thank you so much.
Thank you. Thanks very much. Honorable President of IDWL Bihar State, Dr. Singh, Chair of the Organizing Committee, Dr. Abhishek Jha, Chair Scientific Committee, my so many friends, without naming them, who are decorating the dais today, eminent faculty, ladies and gentlemen, it's my profound honor and privilege to be part of the Bihar State IDWL meeting here at holy city of Puri. And also, it's my honor to be the chief guest, which I came to know today only. But I could not say no, despite I had to leave around 7 o'clock in the evening for another event at Bhubaneswar. I told them that I am going to be delayed because I didn't want to miss this occasion and didn't want to lose the opportunity. This is my first participation in Bihar IADVL meeting. It's not that I didn't want to come, and it's not that I was not invited. I had an invitation on several occasions in the past, but it so happened that I could never make it. Maybe it was the wish of the God that yes, I was invited to join here and witness this magnificent event at Puri, where the dermatologists, not only from Bihar, but across the country and abroad have participated. You know, I was just listening to Dr. Venkatraman's oration a few minutes back, who has told as to how his journey in dermatology has been. In fact, this is the journey of not only him, it's the journey of the dermatology. Dermatology has seen the exceptional change in the last 2 decades. The medicine as such has changed. And probably the dermatology has changed more rapidly than other branches of the medicine. And the impact that it has created is because of the cosmetic dermatology and the procedural dermatology. Dermatology used to be one of those subjects which considered to be the orphan subjects or the neglected subjects, and it was thought that the dermatology is chosen by the people who are not serious, probably not meritorious also, and also the people who are wanting to escape work. Our surgeon friend used to comment at that time when I joined dermatology, which I did consciously, because I was chosen for dermatology at PGH Chandigarh. I stayed there for some time, but then I decided, no, since I graduated from AIMS, I said I will come back to AIMS. And I left that without having anything and came back and joined dermatology here. So such was my feel at that time, and now the dermatology is one of the top rated and most sought after specialties. In my institution also, within the first 10 candidates, the dermatology is gone. So such has been the magic of dermatology. And dermatology has several advantages in the sense that yes, it's a medical specialty. You can practice surgical specialty. You can focus on a particular area that you want to practice, or you want to offer the care to your patients. And also, it has got so much of now social reputation and the eminence. When I joined dermatology, there were few hundred dermatologists. Now, just now, Bhumesh was telling me now there are about 14,000, or maybe 14,000, 18,000. He says 18,000. Well, 18,000 dermatologists, so the dermatology community as such is growing. But at the same time, the concerns are also arising. The cosmetic dermatology clinics are mushrooming. What is we are seeing that as the core dermatology practice is missing. We have the eminent people like Dr. K.N. Singh here, who has been the core of dermatology practice, not only in Bihar, but I think probably in the country. And maybe he is very eminently known dermatologist, not only in North India, but I think across the country and abroad. So what we need to see that, yes, we don't lose out on something which is the pillar of dermatology and which is the clinical dermatology. No matter what you do, but I think the clinical dermatology should remain in the focus in your thoughts and in your actions also. And also, even if you are practicing cosmetic dermatology or procedural dermatology or dermatosurgery, the important aspect is that we should continue to adhere to the ethics, which is sometimes is seen in the places like our hospital that we come across the patients who are landing up with the complications of the procedures, or sometimes the unnecessary procedures are being done which may or may not be warranted and probably not warranted at that point of time. The contribution of Bihar state dermatologists at the national level and at international level also has been significant. It has been immense. And right from Dr. Amarkant Jha, who happened to be a good friend of mine, and who actually invited me on 3 occasions to Bihar state meetings, but I could not make it. the young generation people are also making a significant impact at the national level in different areas. And I want to congratulate and compliment the young team, Rajiv, of course, Vikas and Abhishek, who are now holding the flag. And I'm grateful that yes, you have invited me to this meeting and also invited me to be the part of the inaugural function. And I think we should collectively thank the Bihar government also for having facilitated bringing the meeting to Puri. And with this, I thank you all for bearing with us, and I may have to leave and seek your pardon. Thank you very much.
थैंक यू सर। अब मैं अपने प्रेसिडेंट और प्रेसिडेंट इलेक्ट से आग्रह करूंगा कि हमारे मुख्य अतिथि को वो सम्मानित करें। इनसे ही सबको दिलवाते चलते पहले भी, ठीक है। तो अभी भूमेश कटकों मैं पुनः अपने प्रेसिडेंट और प्रेसिडेंट इलेक्ट से आग्रह करूंगा कि वो कृपया करके हमारे गेस्ट ऑफ ऑनर डॉक्टर भूमेश कुमार कटकम सर को सम्मानित करें। मैं पुनः सर से आग्रह करूंगा कृपया हमारे गेस्ट ऑफ ऑनर डॉक्टर शीतल पुजारी मैम को सम्मानित करें। डॉक्टर राजीव ठाकुर सर से आग्रह करूँगा कृपया हमारे गेस्ट ऑफ ऑनर डॉक्टर राजीव ठाकुर का सम्मानित करें। इसके बाद आप बुलवाएंगे सर ओम प्रकाश सर और इनको विक्रम सर को, दोनों प्रेसिडेंट को बुलवा दें। धन्यवाद सर। अब मैं आग्रह करूंगा अपने इमीडिएट पास्ट प्रेसिडेंट डॉक्टर ओम प्रकाश सर और अपने चीफ साइंटिफिक एडवाइज़र डॉक्टर रवि विक्रम सिंह सर का कि उनसे वो कृपया करके हमारे प्रेसिडेंट डॉक्टर वीरेंद्र कुमार सिंह सर को सम्मानित करें। रामत अब मैं अपने इमीडिएट पास में डॉक्टर ओम प्रकाश सर और चीफ साइंटिफिक एडवाइजर डॉक्टर रवि विक्रम सर से आग्रह करूंगा कृपया हमारे प्रेसिडेंट इलेक्ट को मोमेंटो देकर सम्मानित करें। बोली थी हाँ रामतार सर को अगला बुलवा रहे हैं सर आपको। अब मैं सर से आग्रह करूंगा, कृपया कर डॉक्टर अभिषेक झा ऑर्गेनाइजिंग चेयरपर्सन। आपको तो बुलवा लेते हैं सर। ठीक, धन्यवाद सर। अब मैं आग्रह करूंगा अपने गेस्ट ऑफ ऑनर डॉक्टर उमेश कुमार कटकम सर और डॉक्टर शीतल पुजारी मैम का कि वो हमारे ऑर्गेनाइजिंग चेयरपर्सन डॉक्टर अभिषेक झा सर को सम्मानित करें। विकास शंकर, इसके बाद नहीं विक्रम सर का होगा। अब मैं आग्रह करूंगा डॉक्टर सर प्लीज कृपया करके हमारे मैं अपने चीफ गेस्ट डॉक्टर उमेश कटकम सर और डॉक्टर शीतल पुजारी मैम से आग्रह करूंगा कृपया हमारे चीफ साइंटिफिक एडवाइजर डॉक्टर रवि विक्रम सर को वो सम्मानित करें। उनके बाद विकास सर को। सर और मैडम से पुनः आग्रह है कृपया हमारे साइंटिफिक चेयरपर्सन डॉक्टर विकास शंकर सर को मोमेंटो देकर सम्मानित करें। धन्यवाद सर। अब मैं आग्रह करूंगा हमारे चीफ गेस्ट ऑफ ऑनर डॉक्टर राजीव ठाकुर और ऑर्गेनाइजिंग चेयरपर्सन डॉक्टर अभिषेक झा सर से कृपया हमारे ऑर्गेनाइजिंग को चेयरपर्सन डॉक्टर सत्यना प्रधान को स्मृति चिन्ह देकर सम्मानित करें। सर से पुनः आग्रह है कि वो हमारे ऑर्गेनाइजिंग ट्रेजरर डॉक्टर रजनीश कुमार को सम्मानित करें। सर आप लोग उनको बुलवाना है। डॉक्टर विकास शंकर सर को नहीं, शिवानी और तुम्हारा शिवानी और मुबारक तुमको दिलवा दिलवा दो। विकास और अभिषेक सर से दिलवाना है। स्मृति
Now I would request Dr. Vikas Shankar sir and Dr. Abhishek Kumar Jha sir to kindly present the memento to Dr. Punkesh Kumar sir. I would request Dr. Abhishek Kumar Jha sir and Dr. Vikas Shankar sir to kindly present the memento to Dr. Shivani Shekhar.
सर से पुनः आग्रह है, कृपया हमारे जॉइंट सेक्रेटरी डॉक्टर मुबारक हुसैन को स्मृति चिन्ह दे के सम्मानित करें। ओम प्रकाश सर को दिलवाए हैं? अच्छा, मैं आग्रह करूंगा हमारे प्रेसिडेंट डॉक्टर वीरेंद्र कुमार सिंह सर एंड प्रेसिडेंट इलेक्ट डॉक्टर राम अवतार सिंह सर से कृपया हमारे पास्ट प्रेसिडेंट इमीडिएट डॉक्टर ओम प्रकाश सर को स्मृति चिन्ह दे के सम्मानित करें। सर से पुनः आग्रह है, कृपया हमारे साइंटिफिक सेक्रेटरी डॉक्टर श्रीप्रनाथ देव को स्मृति चिन्ह देकर सम्मानित करें। धन्यवाद सर। अब मैं अपने प्रेसिडेंट डॉक्टर वीरेंद्र कुमार सिंह सर से आग्रह करूंगा कि वे इस आयोजन के लिए 2 शब्द कहें।
नमस्कार, सबको प्रणाम, जय जगन्नाथ। First of all, I welcome Honorary General Secretary Dr. Bhumesh Katkam. I welcome Dr. Sheetal Pujari ji, and I welcome our friend's son Dr. Rajiv, and I welcome all the dignitaries on the dais of the dais. I particularly our very senior teachers. I want to congratulate the entire organizing committee, including organizing chairperson Dr. Abhishek and organizing secretary Dr. Punkesh, for organizing such a grand CUTICON here in the place of Lord Jagannath. And I congratulate the whole scientific team to arrange such beautiful and scientific programs. Thank you.
Thank you, sir. अब मैं आग्रह करूंगा अपने साइंटिफिक चेयरपर्सन डॉक्टर विकास शंकर सर से, कृपया
जय तू जगन्नाथ। सर्वजन हिताय सर्वजन सुखाय दिव्य कृपा प्रसादयुत, अर्थात भगवान जगन्नाथ हम सभी पर अपनी कृपा दृष्टि बनाए रखें और इस पावन धरती पुरी में आयोजित इस सम्मेलन को सफल और सुखद और कल्याणकारी बनाएं। माननीय मुख्य अतिथि इन एब्सेंसी, गेस्ट ऑफ ऑनर डॉक्टर भूमेश कुमार काटकम सर, डॉक्टर शीतल पुजारी मैम, डॉक्टर राजीव ठाकुर, आदरणीय बिहार स्टेट ब्रांच के प्रेसिडेंट डॉक्टर वीरेंद्र कुमार सिंह, प्रेसिडेंट इलेक्ट डॉक्टर रामतार प्रसाद सिंह सर, प्रेसिडेंट इमीडिएट पास्ट प्रेसिडेंट डॉक्टर ओम प्रकाश सर, चीफ साइंटिफिक एडवाइज़र डॉक्टर रवि विक्रम सर, सभी ऑर्गेनाइजिंग चेयरपर्सन डॉक्टर अभिषेक कुमार झा सर, सभी ऑर्गेनाइजिंग कमेटी के मेंबर्स एंड साइंटिफिक कमेटी के मेंबर्स, फैकल्टीज, डेलीगेट्स, पीजीज, इनके साथ आए हुए सभी परिवारजन, आप सबों का हार्दिक स्वागत है। आज 39th क्यूटिकॉन बिहार 2025 के साइंटिफिक चेयरपर्सन के रूप में मैं आप सबों के सामने खड़े होकर अपने आप को गौरवान्वित महसूस कर रहा हूँ। इस पूरे सम्मेलन की वैज्ञानिक रूपरेखा हमारे साइंटिफिक टीम द्वारा तैयार की गई और हमने ये खासकर ध्यान रखा कि हम डर्मेटोलॉजी के हर एक पार्ट को, डर्मेटोलॉजी कोर्स के हर एक क्षेत्र को इसमें सम्मिलित जहाँ तक हो सके उसको कर पाएँ। और मुझे प्रसन्नता और गर्व है अपने टीम पर कि उन्होंने दिन रात मेहनत करते हुए इस सम्मेलन को सफल बनाने में तन मन और धन तीनों से योगदान दिया। कभी रात में 2 बजे, कभी 12 बजे मीटिंग करके, कभी व्हाट्सएप मैसेज करके, अभी आज ये ठीक करना है, ये करेक्शन करना है, ये नया रिक्वेस्ट आया है, और ये लास्ट मोमेंट तक चलते रहता है। मैं खास करके अपने सभी ऑर्गेनाइजिंग और साइंटिफिक टीम को एज ए साइंटिफिक चेयरपर्सन के रूप में मैं धन्यवाद देता हूँ। खास करके डॉक्टर श्वेतिना प्रधान, डॉक्टर श्रीपर्णा देव, डॉक्टर शिवानी शेखर और डॉक्टर मुबारक हुसैन, और मंच के नीचे बैठी 2 डॉक्टर आकांक्षा और डॉक्टर सान्या, जो मैं देख रहा हूं कि पिछले 2 दिन से लगातार मेहनत करती जा रही हैं इस सम्मेलन को सफल बनाने के लिए। मैं चाहूँगा कि आप इनके स्वागत जोरदार तालियों से करें। इस सम्मेलन का हर शख्स इस सोच के लिए तैयार किया गया है कि यहाँ से निकलकर हम सभी सहभागी के ज्ञान में वृद्धि हो, दृष्टिकोण व्यापक हो, हमारे देश की त्वचा चिकित्सा सेवाओं में एक नई दिशा मिले। मैं उन सभी फैकल्टी सदस्यों को हृदय से धन्यवाद करता हूं जिन्होंने दूर से अपना समय निकालकर अपने ज्ञान का अनुभव और शोध के साथ हमारे बच्चों और हमारे डेलीगेट्स के साथ साझा किया। यह योगदान बिहार एवं भारत के डर्मेटोलॉजी को आगे बढ़ाने में अत्यंत महत्वपूर्ण साबित होगा। प्रिय डेलीगेट्स एंड पोस्ट ग्रेजुएट स्टूडेंट्स, आपकी जिज्ञासा, उत्साह और लगन इस सम्मेलन की असली ऊर्जा है। आपकी सक्रिय भागीदारी और इस मंच को और जीवित बनाती है। जब हम इस एकेडमिक सत्र की शुरुआत कर रहे हैं, मैं भगवान जगन्नाथ से प्रार्थना करता हूं कि हम सबको ज्ञान, विवेक, ऊर्जा और सद्भाव का आशीर्वाद दें। ईश्वर करे कि यहाँ से मिली सीख, विचार और संवाद आगे चलकर हमारे प्रोफेशन में और समाज में दोनों के लिए उपयोगी साबित हो। आप सभी को 39th क्यूटिकॉन बिहार में हार्दिक स्वागत है। आपका समय यहाँ लाभदायक और सुखद और यादगार रहे, यही कामना करता हूँ। जय जगन्नाथ।
धन्यवाद सर। अब मैं आग्रह करूंगा अपने गेस्ट ऑफ ऑनर डॉक्टर राजीव ठाकुर से, कृपया वो मंच पे आके अपने बहुमूल्य विचार व्यक्त करें।
जय जगन्नाथ। जय जगन्नाथ सभी मंच पे बैठे हुए अतिथि, हमारे वरिष्ठ सीनियर सर, रेस्पेक्टेड सर लोग और सभी मेरे कलीग्स और जूनियर, ये मेरे सौभाग्य की बात है कि इस साल मुझे भी मौका मिला IIDVL बिहार के गेस्ट ऑफ ऑनर बनने का। IIDVL बिहार हमारा परिवार है, हम अनडिवाइडेड थे साल 2000 तक, उसके बाद झारखंड बना, फिर बाद में झारखंड ब्रांच बना, लेकिन अभी भी बड़े भाई और छोटे भाई का रिश्ता चलता है। बड़े भाई बिहार हैं, उनको हम लोग फॉलो करते हैं और ये गर्व की बात है कि हर साल IIDVL बिहार बढ़ता ही जा रहा है। बिहार केवल बिहार तक नहीं सीमित है, ये पूरे इंडिया, हम तो बोलेंगे इंटरनेशनल, बिकॉज नेपाल से भी सर लोग आए हैं, बहुत सारे आए हैं, तो उसको हम लोग भी फॉलो करते हैं कि वो सारा चीज़ हम लोग भी उतने लेवल तक ले जाए। जहाँ तक साइंटिफिक की बात है तो साइंटिफिक प्रोग्राम ऐसा कुछ नहीं है जो डर्मेटोलॉजी में छोटा है। इतना अच्छा प्रोग्राम, इतना अच्छा सारा चीज़, स्पीकर्स हैं, तो ये नॉलेज गेन होते रहता है, इसका भी सबको फ़ायदा मिलता है। और यही नहीं, IIDVL के तरफ से एक मेगा कैंप हम लोगों ने रखा। एक कोशिश थी कि एक दिन में ही पूरे नेशन वाइज एक कैंप किया जाए जिसमें मरीजों का फ्री इलाज हो और उन्हें दवा भी उपलब्ध कराया जाए, जो कि गिनीज बुक ऑफ रिकॉर्ड में भी दर्ज किया गया। और सबसे गर्व की बात है कि उसका जो मेन सेंटर था वो हमारा बिहार में ही था, पटना से दूर एक गांव में था। मैं भी उसमें मौजूद था और पेशेंट्स तो इतने थे कि फिर हम लोग को जल्दी जल्दी करके हम लोग लगभग 20 डर्मेटोलॉजिस्ट थे और मोर देन हमको लगता है 800 पेशेंट से ऊपर की गैदरिंग हुई थी। और वही नहीं, पूरे नेशन में, मतलब ये एक तरह का रिकॉर्ड रहा जो कि फैमिली हेल्थ, मतलब हेल्थ एंड फैमिली वेलफेयर मिनिस्ट्री से भी उसकी प्रशंसा की गई कि इस तरह का कैंप किसी एसोसिएशन ने, हमारे इंडिया में इतने सारे एसोसिएशन हैं लेकिन किसी ने ऐसा ट्राई नहीं किया था। और उसका जो सबसे बड़ा बेनिफिट मिला वो पेशेंट्स को मिला, जो गरीब ज़रूरतमंद पेशेंट्स थे उनको फ्री कंसल्टेशन और फ्री दवा मिली। बहुत जगह से ये भी फीडबैक था कि इस तरह का कैंप हमेशा किया जाए, तो वो हम लोगों ने कोशिश कर रहे हैं कि फिर से उस तरह का किया जाए। इसका सारा श्रेय जो है अभिषेक बॉस और मनोज बॉस और पूरी टीम को जाता है। और IIDVL के तरफ से ये बहुत बड़ी कोशिश थी कि उसको किया जाए। IIDVL अब हमारा 18,000 प्लस मेंबर्स का है, 18,000 प्लस मेंबर्स हैं हमारे IIDVL में अभी नेशन वाइड, जिसको कि हम और बढ़ा ही रहे हैं। और बहुत सारी तरक्की है, बहुत सारे प्रोग्राम्स है जो हमारे सेक्रेटरी सर भूमेश सर जिसके बारे में डिटेल से बोलेंगे। बाकी मैं आप लोगों से फिर से एक बार धन्यवाद करूंगा और विदा लेना चाहूँगा। आज ही रात में मेरी ट्रेन है, मैं निकल रहा हूँ। और हम लोग, मैं सारे अतिथि को, सब कोई को इनवाइट करना चाहूँगा। हमारा झारखंड ब्रांच का क्यूटिकॉन जो है इस बार पतरातू में है, पतरातू में हो रहा है, तो मैं एक बार सबको अपनी तरफ से इनवाइट करना चाहूँगा। थैंक यू। जय IIDVL, लॉन्ग लिव IIDVL।
थैंक यू। अब मैं अपने गेस्ट ऑफ ऑनर सेक्रेटरी, नेशनल सेक्रेटरी इलेक्ट डॉक्टर शीतल पुजारी मैम से आग्रह करूंगा, कृपया वो 2 शब्द बोल के हमें अनुग्रहित करें।
Good evening to all my respected senior teachers and my dear friends. I'm extremely grateful to the IIDVL Bihar team for holding it in this divine place. And I would like to congratulate first of all IIDVL Bihar for an extremely successful conference. Any conference has 2 basic pillars, the organization and the scientific. And on both these points, IIDVL Bihar team has scored 10 stars, I would say, 10 on 10. And as I take over next year, I look forward to working with you. IIDVL Bihar has always been, since the days of Dr. Amarkant Amar, I think it has been on the forefront of community dermatology. I look forward to the IIDVL Bihar team working again on community dermatology during my term also. And I look forward to the youngsters also from IIDVL Bihar team to work at the national level. So thank you all for inviting me here. and look forward to the conference for the rest of the days also. Thank you so much.
थैंक यू मैम. अब मैं अपने गेस्ट ऑफ ऑनर नेशनल सेक्रेटरी डॉक्टर उमेश कुमार कटकम सर से आग्रह करूंगा, कृपया अपने बहुमूल्य विचार हमारे से साझा करें.
जय जगन्नाथ. नमस्ते IADVL family. Namaste IADVL Bihar. Dignitaries on the dais and of the dais. Namaste to everyone. I'm proud member of IADVL. In fact, we are the proud members of IADVL. As on today, the strength of IADVL is 18,755, which is the biggest dermatological association in Southeast Asia, which is the second biggest dermatological association on the globe. IADVL is committed for members, IADVL is committed for the subject, as well as IADVL is committed for the community services. We the IADVLites, we the skin specialists are the custodians for skin health. We are the custodians for managing skin diseases, managing hair diseases, genital and nail diseases. This year, the World Skin Health Day theme is No Health Without Skin Health, which is true. The skin health is a prerequisite for the body health and subsequently for the national health. What we need for this, recently we had a meeting with ILDS at Cape Town. They proposed 2 A's to maintain the skin health: availability and affordability. Availability of the dermatologist should be equal in all the areas, as well as affordability. The patient should seek the treatment at all the levels. On behalf of IADVL, we propose 3rd A, the awareness. Unless until we create the awareness, the dermatologist or the custodian for the skin health, this availability and affordability will be lacking. So that's why the awareness, which is the forefront to create tomorrow, today, any heart problems, how they'll go to the cardiologist. Eye problems, they'll go to eye specialist. At the same time, to have a skin problem, they'll go to anywhere. So it is a time to sensitize by ourselves. We are the skin specialists, are the custodian for the skin health as well as managing the diseases. So in this continuity, the community awareness, the last year, the IADVL has took the Guinness World Record attempt under the guidance and of President Dr. Manjunath Sinai, as a Secretary General, myself and all the EC, and within 4 hours we have achieved the pledge. The getting the Guinness World Record is the tip of the iceberg. But that has connected among ourselves, connected to the community. That is the most important thing. And this year, under the supervision of the President Dr. Rajiv Sharma and EC, the International Book of Record has taken place, which is the all-time record in the history of IADVL. In the 8 hours, 754 medical health camps were conducted all over India, along with awareness. And for that we have achieved again the International Book of Record. And this message has reached the Parliament. First time the word of IADVL has entered in the history of IADVL at the Parliament level. And from the Parliament has asked the Secretary General and EC, can you provide the last 3 years of your awareness activities? And we have submitted all the documents and related activities. So this is the all-time record. So we are, that's why I would say we are the proud members of IADVL. So I would say happily for these two activities, the inauguration, the starting point is the partner, is the Bihar. Last time the Vikas Shankar and his team, and this time Abhishek Jha as the community dermatology chair and convener Dr. Manoj Ram, all the team, they have worked tremendous work, and both were initiated from the state of Bihar. So the strength of Bihar is as on today 197, but you are more than 1900, more than 19,000. The way you have worked for the association at the community level, it is laudable. So in this juncture, it's a high time. So all the Bihar state needs a standing oration for this activity of all at the IADVL level for these two Guinness World Records. Hearty congratulations to whole team. I know all the members, all the names of all Bihar, because in my phone, more than 10,000 phone numbers are there with a note in those who are sitting on the stage and the outside of the stage. Because of the time of Lakne, I would not mention all the names. Please excuse me. But I know all the names of all the members on the stage and off the stage. So with this, once again, I congratulate the team of the 39th IADVL CUTICON for wonderful hospitality, the scientific content, which is giving a lot of take-home messages from the podium to the patient. That is ultimate. We all are depending on the patient. Patient is our God. If you serve to the patient, patient will serve to us. That is our motto. So I request all the younger generations, try to sensitize. We are the custodian for the skin health. Everybody has at least one person to take the responsibility of to sensitize 10 members, let them sensitize another 10 members till it reaches the community for skin health and subsequently body health and national health. The custodian is the IADVL qualified skin specialist. So that's why always IADVL is beyond the academics. Every academic activity, we will go for the community activities. So let us spread this message till it reaches the community. So thank you very much for the invitation, and long live IADVL. Jai Hind, Jai Jagannath.
Thank you, sir. For the Lifetime Achievement Award, I request our President Dr. Birendra Kumar Singh sir and President-elect Dr. Ramatar Singh sir to present Lifetime Achievement Award to Devesh Sinha sir. To give Dr. Binod Kumar Sinha sir for the Lifetime Achievement Award. Dr. Binod. Let Dr. Ellen Sinha, born in 1934.
This Lifetime Achievement Award is given in the name of late Dr. Lakshmi Narayan Sinha sir, and he was born on 1934, and he was a professor and head of department of Anugrah Narayan Magar Medical College, then Magar Medical College, Gaya. And next slide. And he joined Bihar Health Services on 1/9/1959 at Vajinagar, Gaya, and retired on 31/3/1992 from the Dermatology Department of Skin, now Anugrah Narayan Magar Medical College. And his contribution is, he is organizing and founder secretary of at the first conference of Bihar branch of IADVL in 1982 at Gaya, and past president of Bihar branch of IADVL twice, 1993 and 1999, and president Bihar branch of Indian Association of Leprosy in 2002 to 2021. Next slide. and participated as a senior consultant at Sinai Skin Clinic at Gaya, and actively participated in many national and international conferences of dermatology, and he was a fellow of American Academy of Dermatology and member. So the Lifetime Achievement Award is now conferred to.
And the Lifetime Achievement Award goes to Dr. Vinod Kumar Sinha sir, served the Bihar Health Services at District Hospital at Chhapra more than 29 years. After VRS, he is leading dermatologist of Chhapra. He is actively involved in social services through various organizations like Rotary Club, where he was president. He is IMA Central Executive Member at IMA Central Saran. Dr. Vinod Kumar Sinha sir, please come on the dais sir. तालियां बजती रहनी चाहिए.
जोड़ देना हमारा आइडियल का ट्रेजर
बुलाना है शिवानी मैम को.
क्या
शिवानी मैम को बुलाना है.
कौन शिवानी? अच्छा हाँ उसको पुंकेश को ही करना था. रख के आ जाओ पुंकेश. शिवानी वाला कर दो. शिवानी है ना? तुम बोलो बोलती ना तुम जाओ बोलो बोलवा लो.
In the cherished memory of Dr. Abhijit Kumar, on behalf of IIDVL Bihar, I would like to request Dr. Abhishek Kumar Jha sir, Dr. Vikas Shankar sir, and Dr. Punkesh sir to respectfully invite Dr. Shivani ma'am to receive memento of remembrance as a tribute to the life, service, and contribution of Dr. Abhijit Kumar sir.
कागज निकालो बुलाते जाओ. पहले जो है ना ये सब का तो हो गया है. यहाँ से शुरू पंकज कुमार ऑर्गेनाइजिंग चेयरपर्सन ये तब तक अनाउंस कर दो.
किससे दिलवाना है? आप लोग प्रेसिडेंट
सब में अलग अलग करो, वैसे ये क्विज का पहले और कोई नहीं है, क्विज पे करो,
क्विज का करवाते हैं, प्रेसिडेंट इलेक्ट बोलते हैं. For the PG quiz winner award, I will write. I request our President and President-elect, Dr. Virendra Kumar Singh sir and Dr. Ram Avatar Singh sir, to give prize to our winner. The third prize winner is Dr. Rishabh Raj and Dr. Sarabjit Singh from MG MMC. I request our quiz master, Dr. Gopal Rajput, please come on over the dais. Come on the dais. सेकंड ये पार्टिसिपेंट को बोल दिया.
हाँ, ये पार्टिसिपेंट
आप सेकंड रनर हो गया, आप सेकंड रनर को बुलाएंगे.
विनर फर्स्ट सेकंड इन तीनों का
ये तो पार्टिसिपेंट दोनों पार्टिसिपेंट को पहले बुला लेते हैं. विनर भी नहीं बुला रहा. Our next participant from AIMS Patna, Dr. Joya Nasrin and Dr. Rishabh Sanghi, please come over the dais. अभी आप बोलेंगे सेकंड रनर. हाँ तो आप सेकंड रनर से स्टार्ट करेंगे.
ये तो सर है ही नहीं इसमें.
कोई बात नहीं, इसको सेकंड रनर से स्टार्ट करेंगे. Second runner from NMC Gaya, Dr. Sumit Saw and Dr. Mahir Taneja. First runner from RIMS, Dr. Sana Naj and Surbhi Baghel. देखते चलो अब आप इसको विनर को बुला रहे हैं. हाँ ठीक है, विनर बुला लेते हैं.
पहले इसको एम्स को दिलाओ, पहले पार्टिसिपेशन सर्टिफिकेट.
अच्छा ये तो दिलवाती हैं पार्टिसिपेंट एम्स को. जो नसीम हम बोले दिक्कत नहीं. I request our PG quiz participant from AIMS Patna, Dr. Joya Nasrin and Dr. Rishabh Sanghai. नहीं है, विनर आते हैं सर, विनर आ रहे हैं. हाँ सर, हाँ तो वेट क्यों कर रहा है सर, थोड़ा कोई बात नहीं, ठीक है. विनर बुलाते हैं, विनर बुलाते हैं. and winner of our PG quiz from PM.
फर्स्ट रनर बुला चुके थे सर, यहीं पे बुला फिर से सनानाज एंड सुरभि को.
First runner-up from RIMS, Dr. Sananaj and Surbhi Baghel.
बुलाए हैं सर सबको, सबको बुलाए हैं. बुलाओ गया को. डॉक्टर सुनीत सौ एंड माहिर फिर से बुलाओ.
Second runner-up from ANMCH Gaya, Dr. Sumit Sao and Dr. Mahir Taneja.
जल्दी आओ, हो चुका है. ठीक ठीक, कोई बात नहीं. क्विज मास्टर विनर के बाद